adiponectin anti-inflammatory molecule, small molecule agonist, improves insulin sensitivity and glucose metabolism through these pathways. It has a hepatoprotective activity and low effective dose compared to adiporon, which is first-in-class drug. So ADP-355 is a first synthetic peptide adiponectin receptor agonist. It activates both the receptors. It's derived from globular domain of adiponectin. It phosphorylates and activates these pathways and results in reduced necroinflammation, liver necroinflammation, suppressing hepatic stellate cell activation and macrophage-mediated inflammation by these mechanisms. Adiporon is a first-in-class drug which is extensively studied in diabetic and high-fat diet mouse models. In short term, it has a promising oral bioavailability and insulin sensitizing effects. This is the branched dimer peptide. It has a 20-fold improved cellular activity and it has the role in CML and breast cancer cells. This is benzomorphin derivative which has a dual agonistic action over adiponectin receptors and mu opioid receptors. So neuroprotective effect as well as analgesic effect. Another interesting thing is adiponectin paradox. So far we have seen hypoadiponectinemia seen in obesity and associated metabolic syndrome, but there are few studies have shown high adiponectin levels in obesity and associated metabolic syndrome, where the possible explanation being imbalance between the clearance and the production. So delayed clearance of the adiponectin, and also it has a positive effect over the GP phospholipase D, which is
Doctor, time up. Time up. Okay.
Which has an effect over the D-catherine. Again, the cardiovascular mortality is dependent on that. It is interestingly seen in human prospective studies rather than the rodent animal studies. These are the factors responsible for adiponectin levels, and these are the challenges because we lack clinical data. These are all the on the preclinical stage only. Thank you for your attention, your curiosity, and the dedication in improving human health. Thank you, sir.
Thank you, Doctor. A nice presentation. We'll take up the question at the end.
Thank you, sir.
But you have taken a lot of time to go through the adiponectin rather than adiponectin analogs, because we want to know more about adiponectin analogs.
So analogs are in the preclinical stage,
yes,
so that's why.
We'll go to the third talk for the day. The topic is dual hormone closed loop pumps by Dr. G. Arun. Dr. G. Arun, Assistant Professor, Department of Diabetology, CMCH.
Good morning to all my delegate professors, chairpersons and audience. I'd proceed with the topic. It's an interesting topic, newer innovation topics, dual hormone closed loop systems. A step towards we aim for something called artificial pancreas. So why do we use this? What's the scientific rationale? We use insulin. Commonly we have a single pump, but now they want to add glucagon also. Insulin has a slower action. Insulin has 10 to 15 minutes. It has a longer action over 4 to 6 hours. Glucagon has a rapid onset of action. It's ideal for preventing hypoglycemia. So these dual hormone systems allow more aggressive insulin dosing while also preventing the patient from going for hypoglycemia. That's the main rationale for developing a dual hormone systems. So on the left you can see the present technology. That is a single hormone system where there is a sensor which detects the glucose. It's sent to the machine pump and the pump delivers the insulin. Now on the right side you can see the latest thing just on the innovation side. This is a triple or double hormone system. The double hormone system has actually a continuous glucose monitor, CGM, which senses the glucose. And there is an algorithmic controller, a machine program controller, or a deep research learning controller, or a hybrid controller. And then there is a pump, which acts as a reservoir for insulin, plus glucagon or even pramlintide. This is also under research. So dual hormone not only means insulin and glucagon, it also means insulin and pramlintide. It's also under research. So what are the clinical evidences on trials shows there are a lot of trials ongoing and those showed a lot of short-term successes. In randomized trials, dual hormone systems increase the time in target. You don't just see the HbA1c, the time in target, it is around 70.7% compared to a single hormone system, and they reduced hypoglycemia markedly compared to a single hormone system. And also the overnight control and overnight hypoglycemia. In a hypoglycemia unaware patients, dual hormone systems reduce the time below threshold to 0% compared to some hypoglycemia in the single hormone system. The main advantage of having a glucagon as a second hormone is it prevents the patient from going into hypoglycemia. And a lot of meta-analysis also showed dual hormone systems has a 16 times more time in range compared to a standard insulin pumps. So a reduction of hypoglycemia compared to a single hormone system. Against conventional pump therapy, both single hormone and dual hormone, they show a good glycemic control. And dual hormone system has a fewer hypoglycemic episodes. And a lot of analysis also showed that both the single hormone, that is insulin alone, and dual hormone, insulin plus glucagon, they have a similar time in range profile. But when compared to the hypoglycemia events, they have a better advantage. Dual hormones has better advantage. And when you compare dual hormone with a single hormone system or the conventional system, they have a better time in range and also better hypoglycemic reduction. So what are the choice of the first hormones? So it is no more regular insulin. Now they are also trying aspart, lispro and glulysin as a single hormone system machines. So they are also infusing these hormones into the single system. So we have other options also now. In source of second hormone, we can either try with the glucagon or we can go with pramlintide. So now there is a variety of permutation and combination where you can combine lispro with glucagon. You can combine glulysin with pramlintide. So these kind of various combinations are there, and a lot of trials are going on, and they are all comparing all these combinations, which is acting better and which is having a more physiological control. So comparing to the pros and cons of each one, the first hormones, that is instead of rapid, if you use aspart, lispro or glulysin, they have a more physiological insulin time profile. They have a reduction of early postprandial hyperglycemia and late post-meal hypoglycemia. Their single con is they have a possible risk of early postprandial hypoglycemia. So compared to the second hormone option, glucagon, they have a lot of pros. They reduce the frequency and duration of hypoglycemia, reduced need for carbohydrate ingestion, reduced patient's interaction with the system, that is a machine, reduced post-intervention hyperglycemia, and the potential role in preventing weight gain. And the cons are, there is an inter-individual variability in hepatic glucose production. For the same amount of glucagon, each individual will produce a different amount of glucose, and potential hepatic glycogen depletion on chronic glucagon infusion, potential risk of development of glucagon resistance similar to insulin, and there are side effects because of glucagon like nausea, vomiting and headache. So if you take a pramlintide, which is an amylin analog, which is also coming from the beta cells, it has a pros of reduced postprandial glucose excursions and glucose variability by slowing the gastric emptying, and it is having a lot of cons like there is a stable co-formulation is very difficult to develop for amylin. Similar to glucagon, there is also occurrence of nausea and GI symptoms, and occurrence of postprandial hypoglycemia is there. So what are the limitations and barriers in developing a dual hormone system is the drug stability. Liquid glucagon, liquid pramlintide, they are all lacking a long-term room temperature stability, and they have to be replaced every 8 hours. And they require a complex system, not a simple system like insulin pumps. They require dual pumps, more maintenance and increased user burden. A lot of adverse effect like GI symptoms as discussed. And the commercial availability is not yet successful, and the cost is very high, and still there is no fully commercial available system. Only trials are going on with the home systems. And AI has also come here. Apart from a reinforcement learning, research learning, there are a lot of AI-enabled machine program controlling algorithms have come into this system, where it's a complex, actually it's a complex system. So AI is analyzing the patient's requirement of glucose, insulin and glucagon, and they are delivering these dual hormones at an appropriate level. And these AI-enabled machines are on the research level. They are going to come very soon. So future is on this insulin pumps are called the closed loop system. It has come a long way. Now we are in the 5th generation where we have a fully automated insulin closed loop system. Now the research is going on the 3rd generation, that is a fully automated multi-hormone closed loop system where they want to incorporate insulin, glucagon, pramlintide and also the other analogs of insulin. So now it is in the research phase. So development of stable glucagon is possible. It is called a dasiglucagon. It is underway, and ultra-rapid analogs are able to address the postprandial sugar controls, and a lot of AA is come into the play. So in summary, the advantage is better hypoglycemia prevention in dual hormone system, improved time in range, more natural physiology, but the challenges is system complexity, patient's adherence is difficult, drug stability, and limited reach for the patients. And latest innovations like AI has come into play and multi-hormones are there. And in future, we can definitely aim for a good closed-loop artificial pancreas system. So it is a promising next generation approach with a strong clinical and simulation data, significantly enhanced glucose control and reduced hypoglycemia events. Ultimately, patients with the type 1 diabetes, they will have a good quality of life in future, and I hope these systems will become more cost effective also in the future. Thank you so much for your patient listening.
Thank you, Dr. Arun, for an excellent talk. Since we got 2 minutes, I'll clarify my one important point.
Yes, sir.
So we have the dual hormone, single hormone, closed loop system. And here glucagon, and here only insulin alone. So glucagon, we normally think it minimizes the risk of hyperglycemia. But there are occasions wherein it was reported that hyperglycemia has been recorded because of the variability with reference to blood pressure that triggers the release of glucagon. What's your comment?
Sir, actually, there are a lot of studies which show the similar results as you said, sir, but due to the time constraint, I didn't show all of them. There are events which showed glucagon is not effectively in controlling the hypoglycemia. There are events of hyperglycemia also.
With reference to TBR, yes.
Yeah.
Next is, we know the TIR. In terms of TITR, is there any difference?
No,
Tight
sir.
range.
Yeah,
Time
they
in
study only the time in range, sir. Whatever studies I have analyzed, they study only the time in range, not the TITR.
Similar, but there is a difference with reference to TITR. That is tight range.
Tight range.
It scores over.
Okay.
Thank you very much.
Thank you,
We'll
sir.
take up the question at the end.
Thank you, sir.
That is a good talk, Dr. Arun. So we'll go to the last speaker talk of the day. It's about small molecules and diabetes therapies by Dr. D. Ramesh.
Very good morning, one and all. At the outset, I would like to thank Dr. Balamurugan sir and Dr. Rajendran sir and other scientific committee panel for giving this opportunity. So I am going to give an overview about small molecules in diabetes therapy. We all know the ominous octet of type 2 diabetes, that is pathophysiology of diabetes involves various target organs. Even though we have so many drugs, we need more drugs to control the glycemia. Not only control the glycemia, we need more benefits, especially in terms of cardiovascular, renal, and other organ benefits without any complications. So for that, one of the innovations are small molecules. What are the small molecules? What is the difference between small molecules and other biologicals? So the small molecules are low molecular weight compounds which is less than 1 kilodalton size. So this is synthesized through the chemical processes. Whenever the molecular size is more, which the structure will be complex and the molecular mass and degree of complexity will be more. So it leads to the more complex and also the stability, everything will be changed. So the key difference between the small molecules and biologicals, the size less than 1 kilodalton and the biologics more than 5 kilodalton. The structure of the small molecules are very simple, well defined through the chemical synthesis. Typically it avoids the intravenous admission. So typically all the small molecules are oral administration. Stability is generally stable. So whenever we take the biologics, it is a living cells system, production through the living cell systems. Usually it is in injectables, so it is temperature sensitive. So the advantage of small molecules are very targeted therapy without any complications. So the advantages of small molecules, the oral bioavailability, it enhances the patient compliance, especially through the oral administrations, avoid the injections. So we can improve the adherence to the medications. The manufacturing and cost efficiency, it is scalable through the chemical synthesis process, low production cost compared to the biologics, especially whenever needs it, like diabetic management therapy, we need more amount of production. So better tissue penetration, especially it is a small molecular size, it allows the penetration into the tissues and cells, so we can reach the target and access the target which is not accessible by the biologics. And also is low immune risk and antibody formations compared to the biologics, and also the formulation flexibility. We can give a combination therapies and controlled release preparations to achieve a good control. So what are the disadvantages? So it can cause us off-target effects, especially it has a low specificities compared to biologics, which can lead to unintended interactions with other molecular targets, which causes some fewer complications like gastrointestinal disturbances, hypoglycemia, drug-to-drug interactions, especially cytochrome P450 system involvement. And also it has a shorter half-life, so we need more and more the drugs as compared to biologics, like weekly once or monthly once regimes. We have the limited biologic complexity because it cannot mimic the three-dimensional structure and functions of protein, so the efficacy is limited. So already we have FDA approved small molecules, that is SGLT2 inhibitors, already approved the empagliflozin, DAPA, CANA and ER2, and also the bexagliflozin approved in 2023. And there are the sotagliflozin, which is a dual SGLT2 and SGLT1 inhibitor. The DPP4 inhibitors are approved by the FDA are sitagliptin, linagliptin, saxa and alogliptin, thiazolidinones, 5 and rosiglitazone. These are the newer oral small molecule anti-diabetic agents. That is, one is the oral GLP receptor 1 agonist semaglutide, and GPR4 agonist, that is FFA1 receptor agonist, free fatty acid 1 receptor agonist, and bile acid sequestrants, that is polysavalum, so which is the advantage of controlling the glucose, the cholesterols also. So another small molecule oral GLP-1 receptor agonists are, these three are, the drugs are approved by the FDA, danuglipron, orforglipron, and aniglipron. These studies show that not only it controls the sugars, it also controls the weight, so it is an added advantage. We can give an oral, not as injections. So other newer drugs like incretin-based therapy, we can take an dual and triple agonist, that is GIP, GIP and GLP-1, GIP and GLP-1, GLP-1 and glucagon, GIP, GLP-1 and glucagon. So there are drugs, and another class of drugs are glucokinase activators, which is enhance the glucose phosphorylation in liver, pancreas, and increase the insulin secretion and hepatic glucose uptake, that is dorsagliatin, and acetyl-CoA carboxylase inhibitors that inhibit the acetyl-CoA enzymes and reducing the fatty acid synthesis and increase the fatty acid oxidation and improve the insulin sensitivity. Next class of drugs are Situ activators, that activate the NAD dependent deacetylases, that is mimicking the caloric restriction effect, improves the mitochondrial function and insulin sensitivity. The next class is AMPK activators, AMP activated protein kinase, which is a cellular energy sensor that regulates the glucose and lipid metabolism. The next class of drugs are FGF21 analogs or mimetics, that is mimic fibroblast growth factor 21, it improves the insulin sensitivity, glucose uptake, and also act on the lipid metabolism. There are another technologies, that is nanotechnology and small molecule delivery, that is PLGA coated nano insulins, that is coated for oral or patch delivery and implant delivery, which reduce the required dose for efficacy and improved pharmacokinetics. there are ongoing trials for nano-encapsulated insulin and GLP-1 mimics. It is potential for once a day or long-acting oral regimens. It is a newer therapy are smart nanotech insulin pumps. And another oral insulin on non-peptide insulin mimetics. This is a nanocarrier-based oral insulin. Clinical trials initiated in 2025. It is liver-targeted delivery for higher efficacy and less hypoglycemia. Insulin mimetics, that is non-peptide drugs activating the insulin receptors. New chocolate capsule insulin delivery explored in primates. That is significant future promise in type 1 diabetes and type 2 diabetes. What is the future? We have seen all the class of drugs. What is the future? So, as the ADA and ESDA says that each diabetic patient need a personalized diabetes management. So, we need to have a personalized diabetes medicine in the form of pharmacogenomics. Identify the genomic variant that predicts the drug response in individual patients' efficacy and adverse effect to guide the optimal therapy selection, and also patient stratification. We have to classify the patients into subgroups based on the pathophysiological mechanisms, comorbidities and biomarkers we have to tailor according to. There are rational combination therapies. We have to combine therapy we should give to achieve the therapeutic target. And also emerging approach like drug repurposing. Identify the existing approval small molecules with potential anti-diabetic effects through the computational screening and mechanistic studies. And also we would to include the AI and machine learning in drug discovery. So the conclusion, small molecule anti-diabetic therapy drugs are continue to evolve with an improved efficacy, safety profile and novel mechanisms, actions which is beyond the glycemic control alone. So we have already approved drugs, SGLT2 inhibitors, oral GLP-1 receptor agonists, demonstrated that which achieves not only glycemic control and also cardiorenal protection, weight management. There are few unmet needs. So beta cell preservation and regeneration remain a critical target for future small molecule development to address the progressive nature of the diabetes. And also personalized medicine approaches are needed to optimize the therapy based on the individual patient characteristics, comorbidities and genetic factors. So the future is multi-target, small molecules and rational combination therapies will likely dominate the future development to address the multifactorial nature of the disease. So these are my references. Thank you very much for the patience listening.
Thank you, Dr. Ramesh, for taking all of us. So orally available, non-expensive, non-peptide molecules, small molecules, currently under clinical evaluation.
Yes.
You have started with ominous octet, Western Banting lecture, and Dr. Diffron, so he made a presentation on that. Now, recently he has passed one comment. Apart from 8 factors, yet another factor is hypercortisolism, and he's going to rename it as noxious 9 from ominous octet. And this was also highlighted in one of the recent ADA presentation, where Dr. John Booth as well as Vivian Fonseca, they made a presentation on concept catalyst study. They have established hypercortisolism as one of the risk factors for hyperglycemia patient with the type 2. Nice presentation. Now I invite all the speakers onto the stage so that now the forum is open for discussion. So let me initiate discussion. Doctor, please come. Ramesh, Arun, please come this side. Yes, Dr. Yamuna. So we have insulin-mediated glucose uptake, and you have also told adiponectin receptor analog that can also responsible that can also increase the glucose uptake. Is there any difference in action? Both will stimulate AMPK pathway as well as phosphoinositol, AKT pathways. Insulin-mediated glucose uptake.
Actually, adiponectin.
But you have clearly made a mention. Not only acts through the AMPK, but AKT pathway, ERK pathway, as well as PPAR gamma-mediated effect. Whereas insulin binds only with the insulin receptor. So phosphoinositol-mediated action. So glucose uptake. So if we come across adiponectin receptor analog, what will be the chance of hypoglycemia?
Sir, actually, these analogs are in the preclinical stage, sir. So only clinical trials can tell us more about the adiponectin receptor analogs and efficacy and all those side effects. Everything can be studied in that only, sir.
Okay, no problem. Now the forum is open for discussion. So these are all very latest and important topics. All the speakers, they have covered this particular topic in an excellent way, and in fact, we learned some of the newer points, starting from Dr. Surendran up to Dr. Ramesh. Yes. I think the speakers, they have delivered the presentation in an easily understandable way, and you all have understood the concept behind it. So I thank the organizing committee member for having invited to moderate this session. I also thank my co-chair, Dr. Ranjit, who is the senior physician and diabetologist from Nagarjuil.
Thank you, Dr. Shanmuel. Appreciate the great talks by all the speakers today. And you actually discussed quite a bit about the future of management of this complex disease of diabetes as well as metabolic derangements. And all four of you had handled their own topics in a very nice, understandable way. Congratulations to all of you. Thank you very much.
Thanks a lot, chairpersons, and good morning to everyone. Anuj sir, Mohan sir, Rajendran sir, Sunil sir, and Mahesh Babu. So I welcome you all once again. And after this presentation by our youngsters, which we call in Tamil Valiba Pasanga, so youngsters who focused on the future, we now go ahead on our next theme, pregnancy. And for this session, I'll invite our chairpersons, Dr. Okay, I'm so sorry. Check. Yeah. Okay, so we are waiting for one of our speakers for the next session. So before that, we will move on the debate. So for the debate, I will invite our balanced view, Dr. Srinivasan sir. So are we all ready for the debate? A very interesting one.
So as we move on to the next session, the session will be on debate. It is going to be app-based weight loss program in diabetes care. May I request Dr. Venkatesh, Dr. Prem Kumar, Dr. Srinivasan to the session, please.
Good morning, everyone. At the outset, I want to thank Dr. Balamurugan and Dr. Rajendran for inviting me for this session and making me a treasurer for TRAC 2025. So we'll move on to the session as a lack of time. What it is we have diabetes in an epidemic proportion in India, and this is because of our lifestyle. So whenever you ask a patient whether they go for a walk or do physical activity or control their diet, they say there is no time, they can't concentrate, things like that. Everyone has smartphones now, and whether it can be used for useful
way to change lifestyle, instead of having Instagram or Facebook, YouTube. Other than that, can we have it for a useful way to change lifestyle is the question. And we have an interesting debate where Dr. Venkatesh is going to say there is hope in using the app for weight reduction, and followed by which Dr. Prem Kumar is going to say that it is a hype, and I'm going to have a neutral view on it. Thank you. Over to Venkatesh, please.
Thank you, sir. A very good morning, everyone. I welcome you all for this scientific debate discussion. At the outset, I would like to thank Dr. Balamurugan sir and the scientific committee of RSDA for giving me this wonderful opportunity. So today's debate is, as what the moderator has said, that is the app-based weight management. Is it really useful, or it's a humbug, or it's a that's a hope or a hype? I am on the side of hope. It's a app-based weight management. It is really useful for us. So I am in the next 10 to 15 minutes, I am going to narrate the salient points of the mobile app features. This is my agenda. Before my presentation, I also thank my competitor, Dr. Prem Kumar sir, for sharing his slides. He only prepared both hope as well as the hype slides. Thank you, sir. And also my special thanks to our moderator, Dr. Srinivasan sir. Why I am mentioning special thanks means we all will know at the end of my presentation. Okay. Today's agenda is the rising obesity epidemic globally. We are going to see about that. And traditional weight loss program often fail long term. That is the even though the traditional weight loss programs are many suggestions are there, still we are not able to achieve the weight loss, significant weight loss. And also apps, the healthcare apps as a new tool for the weight management. Is there any evidences regarding these apps are helpful in the weight reduction? Yes, there are evidences we are going to see in the further slides. So obesity, we all know that obesity, the prevalence and incidence of obesity is rising globally. Even the childhood obesity, everything is a significant public health concern nowadays. And also it causes multiple health hazards to the person, and also causing multiple significant cardiovascular morbidities and mortalities, cancers, and every metabolic changes may because of the obesity. So we have to tackle the obesity to prevent the complications. So coming to the statistics, India has the third largest population with the obese people, next to US and China. And according to the recent ICMR data, around 25 crore people of adult population in our country is having the generalized obesity, and also around 35 crores of people having abdominal obesity, more prevalent in the women's. So the prevalence of obesity is around 24% among the women's and around 23% among men, but the abdominal obesity is more prevalent in the women also. So for reducing the abdominal obesity, definitely physical activity is a main cornerstone in the management. Diet as well as the physical activity is the main cornerstone in the management of controlling the central obesity. So childhood obesity, approximately 12.5 million children in our country were obese by 2022, which shows a dramatic increases in the numbers compared to the past decade. So for a successful weight loss program, we need a fundamentals of nutrition or a medical nutrition, guided medical nutrition therapy, and exercise and physical activity, which also needs guidance. And self-monitoring, which is very, very important. Self-monitoring and assessment, which is very important in the weight management. and also the weight maintenance. Why? Because means reducing weight but not able to maintain the weight. That is the main problem in most of the people. So weight maintenance, that is the preventing the relapse. That is also very important. So for the successful weight loss, we need these components which must be needed. So for a weight reduction, many of our patients says that I am going for a regular walk for a 30 to 45 minutes, but still not able to reduce the weight like that. But for a successful weight reduction, one may need a high intensity, comprehensive lifestyle intervention, which is very much needed. It is an high intensity exercises are needed, but for the diabetic patient, needs a professional guidance is must for that, whether the patient is able to do the high intensity exercises or a patient can do like that. Professional guidance is very much important. So professional guidance along with that high intensity with multiple visits, patient may lose a weight up to 8% over a period of 6 months. With a proper guided therapy, patient may have a weight loss of up to 8%. We can over a period of 6 months therapy. And behavioral therapy, it is one of the very good supportive tool in the management of healthcare. Not only obesity, in management of the healthcare, it is one of the very important tool. Why? Because means behavioral therapy is we have to need to modify ourselves. That is that we need to look on all the things, diet recall, everything, reminders, everything we have to look on that for the successful weight reduction program. So coming to the components of the behavioral therapy, it's a cognitive behavioral therapy and self-monitoring of food intake, physical activity and weight, stimulus control, slow eating. These are all the some of the changes we have to do for the very significant weight reduction. And goal setting, that is the realistic goal setting. So just we want to reduce 10 kg in 6 months like that. We have to from the baseline 3 to 2% for 3 months, and next 3% for next 3 months like that from the baseline. That is the realistic goal setting. They are all very, very useful in the management of the obesity. And problem solving instruction and social support. But these all things, all components can be taken care by the health apps. They will take care of these components like social support and goal setting and self-monitoring of our food intake, physical activity and weight, everything. They will make statistic and show us data to us, and the behavioral support by the app is enormous, and we can utilize that. Thereby, we can make a weight loss program a successful one. So, for the proper weight loss, definitely in the diabetic patient as well as the non-diabetic patient, definitely it's a team approach only, team care, multidisciplinary care is very important by the physician, psychologist, nutritionist, trainers, nursing practitioners, educators, and surgeon and anesthetist if they undergo the bariatric surgeries. So multidisciplinary team, but it's a collective approach and collective approach. But in reality, whether it is possible means nowadays it is possible, but still there is a lag in that. There is a shortage of the specialist. So though the doctors' ratio is increasing, but still the consultants and specialist ratio is still not able to meet our growing demands. And also the paramedical professional support is also lagging in this kind of management. And all the overcrowded OPs, which leads to we can't able to allot a quality time for the patients because of its overcrowding of the OPs, which leads to we only able to make it out the salient points like that only. We can't able to do much better consultations due to lack of time. So these are all some of the pitfalls in our physician's side as well as the paramedic side. So even though to get rid of these pitfalls, nowadays the many clinics, specialized clinics are arising. That is obesity clinic, cosmetic clinic, diabetic clinic, everything is arising. But by recruiting all these paramedics, which leads to increased expense of this, which can't be afforded by many of our population. So definitely, though the specialty clinics are there, but in a small number only, but can't be afforded by all of the people. So is there any cost effective management in the weight reduction? Is there? Means definitely yes. It's a mobile digital media is one of the mass communication media. It is one of the easy way of creating awareness in the over the health. So nowadays everything app based or everything the digital based is the main criteria nowadays. We are changing towards digitally only. And also in our country there is around 70% are having the mobile phones, and the internet usage is around 60%, and also social media usage is also around 60%. And the smartphone users also more than 50% in our country are using the smartphones. Definitely by these health apps we can able to change the with some risk also there, that he will discuss about that. And 60% of the smartphone users seeks health information through the online, and also 30% of the social media persons follows the fitness and weight loss influencers. So with proper guidance, with professional guidance, definitely we will able to make it out. So weight loss management apps can be useful, but their effectiveness varies. It shows aid in weight loss and improves the health behaviors, but having some limited or no significant impact. It depends on the individual engagements, app features, and the user's commitment to the programs. So what are the benefits of these health apps? It creates awareness, definitely we all agree with that, and improves the adherence. That is the features like self-monitoring, reminders, and social support, which enhances the adherence to the diet and exercise plans. Accessibility and convenience. The apps are readily available. It is easy to access and convenient for many of us. And personalization, some personalized meal plans, exercise routines, and feedback, which leads to a better outcome of the persons. And the effectiveness, evidence-based, there are many studies we all will see later. Coming to the, though it is a much benefits, definitely it is having certain limitations. Engagement adherence is crucial, and some individuals may struggle to maintain the consistent. We all see in our mobiles we are having multiple apps, but we don't use much of the apps. We download that, but we don't. Consistency of usage of app is somewhat is the main point in the success of this kind of apps. Effectiveness varies, and limited only short-term data are available. Long-term results are not available. It is definitely not a replacement of a professional guidelines. Okay, that's all. So these are all some of the apps. That's final sense. So these are some of the apps which has been used globally by well-known apps. Coming to the evidences, its recent studies shows that app-based interventions can be effective for the modest weight loss, 2 to 5% of the body weight over 6 months. Apps are more effective when paired with the behavioral therapy and professional support. That is more effective when paired with the behavioral therapy and professional support. Long-term adherence and the user engagements are the critical for the success. These are all some of the studies. 6 months data are available. This is done in the Australian study. This is one of a US study which shows a significant modest weight loss of up to 8% over a period of 6 months data. So coming to the final features of the weight loss app, self-monitoring of the diet and personalized menu, which is really helpful for many of the persons. Self-monitoring of exercises and goal setting, that is that realistic goal setting, time frame, feedback on the daily activities, daily reminders, personalized and AI-driven advice, and health-related text messages or call from the providers. And to conclude that app-based weight loss programs can be a useful tool for most of the individual, but they are not the one size fits all the solution. That is that success depends on the factors like users engagement, app features and individual circumstances. It is important to choose an app that aligns with your needs, goals and consider combining it with other healthy lifestyle strategies and professional guidelines. That is that just looking on the app is not useful. We have to work it out along with that our professional guidance. So these are the futures. If in future, the last one is the digital therapeutics. FDA approved app-based treatments are upcoming mode of treatment. So definitely these app-based treatments effective in not only in obesity, in healthcare sector itself. So finally, the best motivational example for these activity apps is our moderator only, who regularly uses these health apps and such a. For example of this, clear example of this fit person is that our moderator Dr. Srinivasan, who regularly uses these kind of apps and regularly upload it and in the WhatsApp status. It's clearly he is a motivational for everyone. Thank you everyone.
Thank you, Dr. Venkatesh. And it is, to say it is hype, it is going to be Dr. Prem Kumar.
Yeah. Very good morning to all. And I extremely thank Dr. Venkatesan for talking on my behalf. And he told that short-term data are there, no data beyond 6 months, and it's modest efficacy, 5 to 6% weight loss. But he failed to mention the cost associated for each weight, 1 kg of weight, which is lost with this app. Can I have my slides, please? Yeah. So topic is actually weight loss app in diabetes care. So he told it gives a lot of hope. That means it's efficacious, and I would like to differ from it. I would like to the motion. It's hyped. It's overhyped than what actually it is, and it's misleading in many cases. So these are my rebuttals. It's basically money, money, and money. Presently, it worth $4.5 billion. In 5 years, the worth of this weight loss app will be $7.8 billion. That's the thing. So it's basically money, and money makes them to do a lot of advertisement, a lot of things, attractive things, and get as many users as possible in a short period of time. Because after 6 months, 1 year, they go away and away. Another thing, new app comes. So these are the widely used apps. MyFitnessPal, Noom, Weight Watchers, and all these are paid up. So if you tell any efficacious weight up, it's paid. Right? None of them are free. Of course, some of them are free, but most of them are paid apps. These are the claims. They say it's AI-driven. They give personalized coaching, and they say that they modify the behavior. Let's see whether it's actually true or not. So the reality is, most of the apps, in fact, none of them are recommended by any guideline. That we should say, because we practice evidence-based medicine, and we should say do what the guideline says. And they are minimally validated. Very few apps like Noom are validated in studies and published in peer-reviewed journals, and they lack evidence-based efficacy. The efficacy is modest. It's not like great. And their target audience is often healthy obese people, not obese people with comorbidities. In obesity with diabetes, obesity with hypertension, obesity, OSA, data is not there with these apps, right? So, and they lack supervision from the medical team. Of course, there is one doctor, namesake, he doesn't interfere in the proceedings of that app, because he is just to show that one doctor is there in the app, that's all. And this is a publication from Lancet which shows they promote unsustainable, harmful activities. There are more bad than good what we can see from the survey that was done. And they promote fat diet, quick fixes, ketogenic diet, they promote rapid weight loss, and they also lead to complications. Like say, a patient with obesity and diabetes uses this app. Right, they have not told about the adjustment of medication. He is vulnerable to hyperglycemia, precipitation of ketosis, anything can be there. So basically they target short-term outcomes. Long-term plan is not there with these apps. And personalized medical history and examination is lacking with this app. They ask, of course, whether you have diabetes, hypertension, but other things are lacking. So no personalized evaluation of a patient when they are included, and vitals are not being monitored regularly. Blood tests are not run in most of the apps, and drug-to-drug interaction, especially in diabetes, hypertension, obesity, this issue is not addressed at all with these apps. And they promote eating disorders. Many people with obesity have got borderline personality disorder. They are very vulnerable for eating disorder like anorexia nervosa. They promote a concept called as thinnification. And they get obsessed with eating, clean eating, and orthorexia is the terminology for that. And people, when they develop eating disorder, nobody monitors it. It goes unnoticed and leads to complications, metabolic complications, psychological, and amenorrhea and other things, bone health. And they lead to overemphasis on calorie counting. They don't talk about the quality of food. It's only calories, and how much calorie you take. And nutritional value doesn't have any place. They don't take into account the insulin resistance of the patient and also BMR of the patient. And they promote this type of phenomenon, yo-yo eating. You go for a crash diet, you reduce your calories, rapid weight loss you achieve, the weight loss plateaus, you go back to the old eating, you gain weight. The yo-yo dieting is very common with these apps. And they promote short-term weight loss, not long-term weight loss. What we need is long-term weight loss. And if you look at these data, long-term studies, more than 80% dropout is there with these apps. And maintenance algorithms are effective. They lack human empathy, all these algorithms, and they give them a false sense of progress. And behavioral therapy is not actually what they claim, doesn't happen. And there are many ethical issues when it comes to app. A person comes and asks you, doctor, can I use this app? What will happen if you say yes? Let's see. See, there is conflict of interest. There is one app called as MyFitnessPal. It includes doctor nowadays, and it advocates GLP-1 therapy. So there is a conflict of interest. They use your name, they initiate them on GLP-1 therapies. Okay, so the patient may not need it, patient develops some complications. That is like you will be penalized for it. And data privacy is not there. You expose your patient data to a private company, it can, anytime it can be sold. Yeah, and you know about the Meta and Facebook. They are facing a lot of lawsuits because of the data theft that has happened. Even MyFitnessPal, the data has been recently hacked. More than 150 million users' data were been hacked. Right? So, these are the things you should remember. And misinformation. Any people can post anything on weight loss. You are answerable. So misinformation that happens in this app, the doctor is responsible. Patient will ask you, you told this app, they told this, I did this happened. You are penalized. So you are liable for your reference to these labs, and you should be very much concerned. And ethical and psychological things are there. So I have time? Yeah. Okay. It encourages extreme dieting, which goes unmonitored, and no mental health screening is done for these apps. Main thing is validation, whether these apps are clinically validated. The results, whether these results are biased or it's overinflated. These are the questions. Only few RCTs are there with the labs, but long-term studies are very few. Even in long-term studies, the efficacy is modest. No, data is not there beyond 1 year of usage. Most of the claims and weight loss, their placebo effects are over-elated responses by, because they don't have any body to say that the patient actually lost 10 kg. So there are many biases in reporting with these apps. So inconsistent results with respect to many apps, and they are involved in influential marketing. What is influential marketing? Let's see. They say 10 kg weight loss in 2 weeks. We have AI powered, and we do 100% guarantee. And they will say that this particular celebrity is using this. They use the celebrity name to promote the app. This is called influential marketing. Then a lot of scams are going with these apps, and they promote many placebo products, saying that it's a miracle cure. And nobody can question them. You use it, you don't lose weight, nobody can this one refund it. And they also have a subscription trap because they have auto refund. They take your number and every month your money is debited. And cancellation is very difficult with these apps. And initially they say it's free, but only the basic features are free. But all the other things, they come under the premium category. So there's no other way that you have to pay and get everything done. Yeah. And no refunding. It targets people who are emotionally labile and they use it. And it's not culturally sensitive. They promote Western diet in these apps and they assume that everybody has got uniform access to all the food. But we know about the socio-economic power for people. Some people only can afford those foods. Not everybody can purchase a protein powder. And yeah. And no customization when it comes to religion or culture. And they also give a false hope of empowerment. Just because you check your weight daily and blood pressure, everything doesn't mean that you are going to have a long-term change in your behavior. And over-reliance on texts. Only tech service can use it, not all people. And even this one language thing is not there. It's not there in Tamil and other national languages, state languages. And no accountability. They promote weight loss as a game, what we call as a gamification. They give you some thing to target, you do this, you do this. So gamification is what is happening. And short-term fixes doesn't address the main cause of obesity, stress, sleeplessness, depression. They don't address this. Yeah. So to conclude, sorry for taking time, app-based weight loss lack medical vigor. And there are a lot of ethical issues, psychological issues, and scientific issues in that. Risk outweigh benefit. That's what I want to say. And health professional initiated weight loss is the need of the hour, and they are better than these apps. Thank you.
Thank you both the speakers for giving us an excellent view about the app-based weight loss for and against. Now I'm going to have a neutral view on this. And as you all know, the common reasons for diabetes is sedentary lifestyle, overweight, and high-fat cholesterol diet. This is unpreventable. Now we have, our lifestyle has changed completely in these recent days. And we are more sedentary. I am in the 3rd floor now in the hospital. And I try to take steps all the time, most of the time. And whenever I ask my patient, young or old or anybody, they say they stand in a queue and take a lift. So we are more sedentary now, and this is looking like a habit now. And when you ask a young person with diabetes why he has not done anything, or why did he develop diabetes at young age, he says it runs in the family. So it is because nobody runs in the family. You see everyone big in the whole family. And even though there is lifestyle genes there, lifestyle plays another important role in development of diabetes. And 1 in 4 people lead a sedentary lifestyle, especially young people now having IT job, sits there and 12 hours in a chair without moving. And if they are doing a home work from home, probably they don't move at all. And lifestyle modification definitely improves the blood glucose. If they lose weight, you see they can reverse diabetes. Physical activity, healthy eating, stress management, and blood sugar monitoring all helps in controlling the blood sugar and reduce obesity. Joining gym, whenever you ask a patient, have you started doing physical activity, they say, no, I've just joined gym. Joining gym is not only thing which will make them lose weight. The gyms, as Dr. Prem said, it is not the apps alone. The gyms also give attractive offers. They give whole year subscription. They go only for 10 days or so. They don't go after that. saying, they give promise that they go regularly, but they don't do it. If they ask, if you go for a walk or if you're going for a gym, they say, I'm too tired, too cold, too hot, it's raining, it's too late. And it is that they have to have a motivation, whatever you are doing, whether it is app-based or you're going to a gym. So excuses don't kill the fat, it is exercises. They have to realize that these are very important than, having a motivation is more important. So some say, I haven't gone for a gym today, but it is for years together they have not gone to the gym. So they say some reason or the other, and Dr. Prem has mentioned there are many apps now which are available for weight loss. You have to choose the right one. Money is there for everyone. We have VNCC, Colors, and various gyms also gives good offers. Take money, and you ask the patient who goes to Color or VNCC, they mostly are unhappy. So if you follow, then it is not much of a problem. The other thing is there are many papers now from 16 to recent. There are many papers which also says that weight loss apps can help patients lose weight if they are adhering. In that study, actually, there's an interesting thing. Whoever there are weight loss, they lose weight anyway if they use the app. About 40% of patients, at least you lose about 5 to 10%. And if you see, and more than 5%, there are more males who are losing weight when using app than females. And whenever we are using the app, you have to enter the data, whatever they are saying. They are asking you to put the weight input frequency, breakfast input frequency, or lunch input frequency, or the other frequencies, dinner and calorie intake, physical activity input. People who are entering the data usually have a good weight loss and good blood sugar control. It is the same for diabetes as well. Even if in your clinics you would realize that patients who are coming to you regularly have a good blood sugar control than a person who doesn't come to you regularly. So this is the one which I use during COVID period. I was walking regularly, and a policeman stopped me and said, why sir, you are walking, nobody is walking, why are you doing this? So then I realized I have to do something else. And I went through all the YouTube and apps, and this is what I got, Team Body Project. It's a very interesting one. If you could try that, can use 10 minutes or 15 minutes or 30 minutes of your time using this, and it is very useful. If you do 30 minutes of this, it is like running 5 kilometers in a row. I tried myself for my patients. I started a YouTube channel and started Dr. Srini's Walk and Talk, but I didn't continue it. It is on the hold with my assistants, doing for 15, 20, 30 minutes. But great, patients appreciated it, and they said that they are using it. As both the speakers pointed out, there are advantages and disadvantages. They have gone through everything together. So the main thing is you can access it remotely everywhere. Last week I went to a conference to Chennai. I couldn't go to the gym, so I used it in the room for 30 minutes, and it was useful. You can on it in a TV, YouTube channel, can do the physical activity and also follow their dietary advice to a certain extent, not to a great extent. So it is cost effective. Paying to a gym for 1 year, if you're joining an app, it is less than that. If you have motivation to continue or continue with the app, it will be useful. So long-term potential also there. So it has personalization, as Dr. Venkatesh has mentioned. There are a lot of features and functionality which can be used in an effective manner. So disadvantages are also there, as Dr. Prem pointed out. the data privacy and security is one of the important things where you can be sold to other people, or they can have access about your private data easily. It is also available in the EMRs as well now. So, research and regulatory needed. You can have a long-term studies on it about the tool and support for individuals. Apps can be effective as an adjuvant to traditional programs of low intensity intervention. And addressing, if you address the limitation, it is going to be a useful tool in future. And it is a useful tool if you use it properly. That what would be my conclusion. Thank you all.
Thank you, sir. Thank you, sir. We will move on to the next session. Thank you, sir. Now we will move on to the next session. May I request Dr. Usha, Dr. Sadasiva Rao to take on to the next session, please.
Yes, let us move on to the therapeutic symposium on pregnancy. Now I request Dr. Bhavadharini Madam to take over the session. Thank you, ma'am. We welcome you on behalf of RSSDA. Over to you, ma'am.
The respected chairpersons and my dear colleagues, very good morning. Welcome you all for the TRAC 25 at Coimbatore, our place. And coming to obesity and pregnancy, nowadays it's a day of obesity everywhere. If you take obesity as such, you can see obese people being metabolically obese, and also some obese people are metabolically healthy, keeping themselves fit. And again, during pregnancy, if you see, majority of the females, they put on more weight, gestational weight gain. That is again causing all the problems like obesity. So in this way, and not only this, even the normal weight people, if you take, they may be, by weight they may be normal, but still they'll be metabolically unhealthy. In such a way, they'll have some visceral obesity, which is causing all the problem. In this way, all this should be out to say that she is metabolically healthy and not obese. It's not only obesity, so it's either way. And you see, every tree, every growing thing as it grows says this truth, that you harvest what you sow. It's also again in pregnancy, your children will be what you have done. And the mother, whether she has a fat-free mass or fat mass via placenta, it is all transmitted to the fetus in the fetal growth as fat-free mass or fat mass. And also it is expressed in the amniotic fluid. Not only that, during pregnancy and birth outcomes, like it has consequences during pregnancy, on delivery, and also increases the maternal morbidity, mortality. And what happens after the child is born also, it is carried over. that is the lactation milk formula is changed, and it has weight retention, postpartum weight retention, and also causes postpartum depression, which is very common, which we are not thinking about it. And also it has long-term consequences both in the mother as well as the fetus. And starting right from the early development, that is in the oocyte blastocysts itself, the genome-wide and DNA methylation, if we say, it causes epigenetic changes, programming of the stem cells, and it causes placental changes. The transcriptome and epigenetic analysis shown that there is alteration in the nutrient transport to the fetus. All gets changed, and there is increased inflammation, lipotoxicity, and affecting the programming of the neonate. That is the microbiome is totally altered. As I said earlier, the milk composition is altered, and not only that, it programs the metabolism of all that is fat amino acids and proteins, and causes all cardiometabolic risk later in life. And if you take the risk as such, because of obesity to the mother and fetus, and also at birth, if you take, of course it causes gestational glucose intolerance, any form. It can be in the form of GDM or pre-diabetes, and also it causes, because it is the insulin resistance is the basis, so it can also cause gestational hypertension, preeclampsia. It can cause increase the thromboembolic phenomena, and it causes pelvic pain during late pregnancy because of obesity, and there occurs obstructive sleep apnea and post-cesarean wound infection not healing, and postpartum complications like anemia because of dilution, depression, as I said, and weight retention. It is not reverting back. And there is lifetime risk of cardiovascular diseases. And again, it has problems like structural birth defects causing congenital anomalies in the baby, and also big baby, prematurity, preterm, and hypoglycemia, stillbirth sometime in the extreme, and NICU admissions, asthma, autism, attention deficit and hypersensitive disorders, and early development of metabolic disease. That is the main thing caused both in the mother as child, and it has also a problem during delivery, that is increased rate of cesarean section, failed induction, uterine rupture, and as I said, metabolic mobility is increased, and also neonatal injury. It can affect any way. All these gets affected. What is the mechanism lying behind? It is the nothing but the insulin resistance. Starts from adolescent age, and as PCOS, and again continues during pregnancy as GDM, and later life it affects as IGT, early IGT, pre-diabetes, or diabetes as such, which are all of the NCDs. And of course you have more of inflammation, which affects the placental function and fetal development. This affection of fetal placental function and this thing causes less nutrient and oxygen supply to the fetus, and also causes epigenetic changes to have long-term effects on the offspring. Thus, this overnutrition causes dysregulation of the maternal and placental metabolism and transport of all, not only glucose, lipids, and amino acids, all leading to epigenetic manifestations and effects later in life as increased weight and all NCDs. So this obesity, the mother causes fetal dysregulation of glucose, insulin, lipid, and amino acids, and this causes increased placental macrophage infiltration and pro-inflammatory cytokines, like increasing the interleukin-6 and tumor necrosis factor, and leading to increased insulin resistance, which again increases the leptin, tumor necrosis factor, and decreases the adiponectin, and increasing the adipose tissue lipolysis, and increasing the placental fatty acids. This again gets increasing further the insulin resistance, and all this becomes a vicious cycle. So in this way, it affects every, causes problem everywhere, like in the intrauterine environment, increases all these factors, leading to increased oxidative stress and overactivation of the placental macrophages. And in the fetal epigenetics, it causes differential expression of microRNAs, DNA, hypomethylations, and brain-derived natriuretic factors silencing, and it again affects the milk, breast milk composition, like increasing the interleukin 6 and also decreasing the neuroprotective factors. That's again very much critical for the cognitive function. And fetal microbiome, it's again very much altered, and in the brain it impairs the serotonin signaling, impairs the dopaminergic signaling, and peroxidase lipid buildup, and microglial overactivation, increasing the oxidative stress, pro-inflammatory cytokines and oxytocin. And if you see the placenta, if you compare the placenta of the normal and the obese, here again in obese pregnancy there is reduced placental cell turnover. You can see that there is lower detected levels of apoptosis marker, that is cytokeratin M30, which may contribute to the overall large size of the placenta, and there is also alterations in the vessel causing vasodilatation, affecting the vasodilatation, and mainly affecting the nutrient and oxygen supply to the fetus. And as we said earlier, it may go up till stillbirth also. There is a higher rate of maternal inflammatory response lesions consisting with chorioamnionitis. So you can see the difference between the both obese and normal weight. So how much weight gain is normal during pregnancy? Of course, we see most of the girls putting on more weight. That's again not good. Maximum they can go up to 12 kgs. And again, a lady who is having a BMI of more than 30, she's again considered as obese. And this much of extra weight is due to the growing fetus and storing of fat to make the breast milk later, all that. But of course, it should not exceed 12 kgs. And again, not only that, it gets transmitted from generation to generation. And first and foremost, this obesity causes difficulty to conceive initially itself, and there is a greater risk of pregnancy complications and adverse birth outcomes in the subsequent pregnancy also. Not only with this, it affects the next also. And the metabolic syndrome in the offspring is transmitted from one generation to other. So we are facing a lot of obesity nowadays. It's because of the transgenerational transmission which has occurred through many generations. So we need to fight for again so many generations to get back the thing what we had later. And again, coming to the fetal DNA, there is increased cell turnover and apoptosis of the adipocytes. So what happens? Again with the dilution, greater plasma volume of this obese mothers, which leads to lower placental fraction of this cell-free DNA in the maternal blood. So how to manage? It's very simple again. If she's obese, she should limit her diet, but this is not the time for weight reduction. She should go for her balanced, nutrient-rich diet along with exercise. That is, you change. Instead of more carbs, she can go for increased protein and more vegetables and greens, all that. Like our ADA plate model, what we say, half the plates full of greens and vegetables, and reduce the carb to just quarter plates, and increase the protein equal to that of carbohydrates, so that the carbohydrate becomes a lengthy carb, and again having more of complex carbohydrates. In this way you should go, but don't try to reduce your weight. You should not do weight reduction. Of course, in the initial trimesters, we don't need extra calories. And of course, 1,800 calories in the early, and you need to increase further. That is in the second and third trimesters. And again, another studies by Must et al. Again has shown that this gestational weight gain is again associated with postpartum diabetes, metabolic disorders, affects the mental health, causes hypertension, dyslipidemia, cholelithiasis, coronary artery disease, osteoarthritis, sleep apnea, stroke, and certain cancers also. So again, you see this via the lipotoxic environment in the placenta. It increases the pro-inflammatory cytokines, increases oxidative stress, and causes alterations of free fatty acid transport. So what happens in the fetus? There is hypothalamic inflammation and more of lipid accumulation, alteration of the fatty acid synthesis and fatty acid oxidation, and there is high adiposity and alteration of the myogenesis, insulin signaling, adipogenesis, oxidative, all these gets transmitted to the fetus. And of course, as I said earlier, there is actually usually the obese women, they lactate the babies only for a shorter duration, and the composition, milk composition is also getting affected. There is more of lipid content, and the immunological factors are not that much like normal weight. So we can take this obesity as a prenatal problem and take it as a game changer, because as I said, it causes more problems in the mother, in the fetus, and during delivery. And not only that, it doesn't stop with that, it causes long-term effects. Again, as I said, it's getting transmitted again and again through generation to generation. So you preconceptionally, you discuss the subfertility and also obesity associated risk, and recommend some lifestyle and weight loss interventions, assess the need for treatment or treat the pre-existing condition, and refer to the specialist if necessary, and provide folic acid supplementation, and educate about the pregnancy risks, and screen for the comorbidities, and give continuously the weight loss advice, and take adequate pregnancy care. It should be a multidisciplinary care, and cardiovascular surveillance, blood pressure monitoring, gestational diabetes screening, and pregnancy weight gain and nutritional advice, and also put them on low dose aspirin. And after delivery, postpartum is equally important like preconceptional care. So maintain high suspicion for the complications, what I have mentioned already, and offer breastfeeding support early and to continue for a long time, and counsel on risk associated with obesity for women as well as the newborn, and counsel on family planning. As he said, it has effect on the subsequent pregnancy unless otherwise she becomes metabolically healthy, and recommend this lifestyle and weight loss interventions postpartum. A word about this anti-obesity drugs. This metformin are sometimes considered for obese, overweight women, that is obese women planning pregnancy, especially those with fertility issues. And most of the anti-obesity medications what we see are contraindicated to the potential teratogenic effects or other adverse outcomes. Our GLP-1 receptor analogs, which is a hero today, is like other anti-obesity medications, are not recommended for use during pregnancy due to its potential risk, but still studies are being going on this GLP-1 receptor analog for reduction of weight during pregnancy also. So what we need to do as an intervention strategy, first ask every problem, then assess and advise what we have said already, and make the patient agree what they have, and also keep assisting continuously to get a good outcome. Thank you.
Thank you very much, Dr. Bhavadarini ma'am, for your crystal clear presentation on prepartum, intrapartum and postpartum care on the pregnancy and obesity with the fetal complication. And at last she has made a best attempt that it will precipitate NCD disease due to insulin resistance. Thank you, ma'am.
Thank you.
Yeah, next topic is on early GDM by Dr. I. Periyandar. Welcome you, sir.
Thank you, sir. Thank you. Respected chairperson, respected senior colleagues, my dear junior colleagues, it's my great pleasure in sharing some of my views on early GDM. The topic early GDM is a wide, and I should cover A to Z of GDM itself, except the third trimester management. And my sincere thanks to scientific committee for giving me this opportunity. And my flow of talk will go like this. Topics may be vary, but 2 minutes I will try to finish off 15 minutes. Thanks Dr. Bhavadarini for giving me 1 minute extra. And our Professor Samji P. Moses used to say, no field in medicine has highest level of controversies like that of medicine. And our professor, Dr. Seshaya, used to say, no field in diabetology has highest level of controversies like that of GDM. You take into all the diagnostic criteria, treatment, everywhere there will be controversies. So I will be touching every one of them. So, coming to the topic, pregnancy in the life of a woman is a well-awaited and glorious event. The event has become more sensitive nowadays because of one or two child policies of couples as well as late marriage. And a lot of infertility clinics are coming out, and to give safe outcome is our importance in the management. And for the definition, it's GDM is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. So coming to the prevalence, worldwide the incidence is 10 to 25%, and in high risk groups up to 30% of pregnancies may involve diabetes. And IDF itself repeatedly says Southeast Asia is the hub for GDM. And coming to the individual countries, UAE has highest prevalence with 36%, followed by Norway, Netherlands 27%, Japan minimum. And there is a steady increase in prevalence of hyperglycemia and pregnancy, and 1 in 7 births is affected by gestational diabetes. And in Southeast Asia, 1/4 of all births are affected by high blood glucose in pregnancy. Coming to India, so different parts of India. So Kashmir has lowest 3.8%, Lucknow more 41%, Punjab 35%, West India 9.5%, Tamil Nadu 17.9%. Our professor Dr. Seshaya has his statistics. Overall prevalence of GDM was 13.9%. And coming to the classification of diabetes, so just for refreshment for the youngsters, it's classified as pre-gestational diabetes type 1, pre-gestational diabetes type 2, and secondary diabetes, and gestational diabetes truly coming IGT of pregnancy, and undiagnosed pre-existing diabetes, and true GDM. Why we should treat, why we should give importance to GDM is, it's a beautiful word. Hyperglycemia, however trivial, is teratogenic in early pregnancy. This is what repeatedly various studies says. So this is a very popular slide. Every one of us knows first trimester, implication of first trimester hyperglycemia and second trimester hyperglycemia. And as HbA1c advances, the congenital anomaly incidences are going up, and less than 5 in this particular study, less than 5.3 normal, and between 8.9 microcephaly, like that caudal regression syndrome and truncus arteriosus, like that various complications comes. And coming to, there are, one more importance is, 2 generations are at risk of developing diabetes in the future. And diabetes complications become worse during pregnancy in all pregnant women. Though hypoglycemia is very rare, DKA can occur in type 1 diabetes patients marching through pregnancy, and retinopathy and nephropathy, that is proteinuria, may worsen during pregnancy, and retinopathy may worsen pregnancy. So these 2 complications are the real nightmare for all type 1 diabetic patients, or some of the chronic type 2 diabetic patients as well. So these many studies, as I mentioned earlier, so as HbA1c increases, the complications goes up. And like this HAPO study also, I think this will be covered elaborately by Dr. Sunil Gupta, and HAPO study, as HbA1c goes up, the complication goes up. And this is one more HAPO follow-up study also, the prospective follow-up study. The risk of abnormal glucose tolerance, obesity and adiposity is high at 7 years of age in the offspring, and more evident among girls, and increased association with pre-hypertension and hypertension. Coming to the pathophysiology, so pregnancy is normally accompanied by progressive insulin resistance. The insulin resistance arises from combination of increased maternal adiposity and increased insulin desensitizing effects of hormones secreted from placenta, like estrogen, progesterone, cortisol, and HPL. and the increased level of plasma tumor necrosis factor and the low levels of adiponectin, everything which was covered by Dr. Bhavatarini in the previous lecture, they are also coming through that. So these are the other hormonal changes. As pregnancy advances, the estrogen, progesterone, human placental lactogen and insulin, hyperinsulinemia, everything will increase during the normal pregnancy. So to compensate for the insulin resistance, pancreatic beta cells undergo hypertrophy, hyperplasia, and but in GDM the compensation fails and decreased insulin secretion, thereby hyperglycemia comes. This is a popular slide for UG students. We used to say this in non-pregnant adults there will be some amount of insulin secretion, some amount of insulin resistance. During pregnancy both will be more. Insulin secretion will be more as well as insulin resistance also will be more. So insulin secretion matches insulin resistance to maintain the maternal glucose is maintained normally. But in GDM, insulin resistance will be high, but insulin secretion will be impaired. Thereby the hyperglycemia will take place. Then coming to the screening. So screening, two varieties of screenings are available. One is selective and universal. In yesteryears, 1 decade back, only selective screening was available, was recommended. So that to select high-risk patients like older age, high parity, pre-pregnancy weight gain, BMI, polycystic ovarian syndrome, they will be screened for GDM. Not all. But nowadays, so universal screening, all pregnant women should be screened because the incidence of is going up and the incidence of hyperglycemia and pregnancy is very rampant in first trimester itself, early pregnancy itself. So universal screening, and that is taken by our government of Tamil Nadu also. So coming to the diagnostic criteria, so it is also a little little time and changes. So before 1964, no diagnostic criteria, and O. Sullivan Mahan was one of the first to lay down guideline, and the next followed by National Diabetes Diagnostic Group criteria 1979, then Carpenter-Couston criteria 1982. It's with the two-step in USA, WHO criteria in other countries, and WHO criteria, DIPSI criteria, IADPSG criteria. And even in the senior gynecologist from USA also, nowadays they are practicing this, they are well versed with the two-step procedure of Carpenter-Couston. And this is a cutoff point for the juniors. So these are the targets for the management. So fasting, all the guidelines says, including ADA, fasting should be less than 95 and 1 hour postprandial less than 140, and some authors say less than 130, and 2 hours postprandial should be less than 120, and HbA1c target of less than 6% is optimal during pregnancy if it can be achieved without significant hypoglycemia. This point should be very clear. So how to monitor? Monitoring, so usually it's individualized. So every patient should be monitored either once in a week or twice in a week or once in 3 weeks, at least once in 3 weeks with the venous plasma glucose, fasting and postprandial target. I told you, we follow fasting target of less than 90, and 2 hours after breakfast it should be less than 120. And SMBG is a very good thing. Only thing we should advise our patient to get good quality glucometers, because some glucometers are not standardized. So it should be very standardized. So most of the patients require in early GDM, because early GDM is it can predispose to congenital anomalies. So we should have round-the-clock control. So for them, we give 6-point profile, 7-point profile, and 8-point profile like that. Pre and post breakfast, pre and post lunch, pre and post dinner, late evening, night 10 o'clock, and midnight 3 a.m. or 4 a.m. according to our individual. So role of HbA1c, the HbA1c has almost no role except in the early pregnancy to diagnose whether it is a pre-gestational diabetes or true GDM. The HbA1c is used, and the levels are little false. High will be more because HbA1c, majority pregnant women are having anemia, and there will be increased RBC turnover. And CGMS also, in some of the type 1 diabetics, it will be useful. But we should be beware that CGMS, it takes values from the subcutaneous tissue fluid. So we have to calibrate periodically with venous plasma glucose as well as your good quality glucometers. Coming to the management, primary goal is safe outcome, I told you already, and to provide adequate calories to achieve and to maintain normal fetal growth and development. And no definite consensus guidelines are formulated, and flat recommendation will not work. So I put before you the two cases. One case, structured medical nutrition therapy. One case just randomized. You avoid sweets like that. If you tell majority patients for avoiding insulin or reducing insulin, they take very less food intake, calories, subnormal calorie intake. So what happens, case 1, where it was underweight, those who had less food intake, baby was admitted in NICU, and on retrospective analysis, diet pattern, under-eating to avoid insulin. So if you give structured diet, so baby gets good glycemic control, good weight. So typical meal plan, we should tell them every 2.5 hours. So we should emphasize on mid-morning and mid-evening snackings. And good carbohydrate, protein, fat should be there. This is not a pregnancy is not a time for weight loss, or not a time for either ketogenic diet or your paleo diet. So good quality fiber is very, very important. And the exercise, so mild exercise can be permitted, vigorous exercise to be avoided, and high risk individuals exercise should be avoided. Coming to the medical management, insulin remains the mainstay of pharmacotherapy for GDM. However, there has been considerable interest in using oral anti-diabetic therapies, and insulin initiation, when there is severe hyperglycemia, straight away we can start insulin. Otherwise, start with a medical nutrition therapy. If it fails to achieve target, we can start with insulin. So OHAs, lot of controversies. There is a growing interest in the use of oral drugs. There are at least 3 drugs which are studied in pregnancy. One is glibenclamide, second is metformin, third is acarbose. And glibenclamide, of course, out of question, because it's many studies has it's teratogenic, and it crosses blood placental barrier, and it produces obesity in the child. Okay, so OHAs can produce macrosemia. There are many studies regarding metformin. One I should highlight about is MIG-TOFU clinical trial, which concluded children exposed to metformin had larger measures of subcutaneous fat, but overall body fat. This is a MIG-TOFU follow-up study. It concluded metformin or insulin for GDM was associated with similar offspring total and abdominal body fat percent, and metabolic measures at 7 to 9 years, and metformin exposed children were larger at 9 years. So with this only, our ADA has now, it's recommending only insulin. And there are long-term studies also concluded prenatal exposure to metformin is associated with increased offspring weight, but not height or BMI. So studies comparing glibenclamide and insulin, and so as I mentioned, glibenclamide should not be given at the present point of time. Alpha-glucosidase inhibitor, it has been studied, and almost all the guidelines, ACOG, ADA, and IDF, they give insulin as a drug of choice. So we have to start with minimum dose of either 30-70 or 50-50 pre-mixed insulin, and if there is postprandial plasma glucose is high, we can give rapid-acting insulin analogs like Aspart, Lispro has been approved. And usually women with GDM require less than 20 units of insulin only, but pre-GDM women, which is very difficult to control, they require more than 100 units of insulin, or sometimes 50 units per day, 40 units per day, like that. So hypertension should be addressed effectively from the early GDM itself. And dyslipidemia, it should not be corrected during pregnancy, because statins are having conflicting reports. Only omega-3 fatty acids we can think of, and other drugs also we should avoid. And a few words about primordial prevention of pregnancy, because it's a diabetes in pregnancy, it's a vicious cycle. Mother in diabetes, infant of diabetes mother, and child or woman with diabetes. And now our Professor Dr. Shesha is addressing in all the conferences, and his long research, it shows primordial, we can prevent diabetes at the earliest. So maternal 2-hour postprandial plasma glucose should not cross 110 milligrams at the 10th week, as fetal beta cells start secreting insulin around 11th week of pregnancy. And if you address intervening with medical nutrition therapy or metformin with the grace period of 2 weeks, and 11th week, if it is high, sugar levels are more than 110, and after following weeks, so we should think of not enough time is available to achieve 110 milligrams. So the fetal beta cell starts secreting and increasing insulin. So hyperinsulinemia will be there. So many studies has proved hyperinsulinemia is present in the even cord blood itself. So in the embryonic stage, we should try, and if sugar levels are more than 110, we should start with metformin, which is safe in embryonic stage, is over after 8th week of pregnancy, and in the rest of the time, metformin can be continuous. So his aim is to produce diabetes-free generation. 2 hours postprandial should be maintained at less than 110 milligrams. To summarize, pregnancy is a state of high metabolic activity. The mechanisms involved are complex. Management should be individualized. Ultimate aim should be safe outcome without any complication. With this, I conclude my talk. Thanks for patience.
Thank you, Dr. Periyandavar. A great talk on early GDM, though it takes a lot of time to discuss about it. I think as time is short, we'll go on to the next speaker.
I now request Dr. Sunil Gupta to talk on GDM clusters. Over to you, Dr. Sunil Gupta.
Good morning, Chairperson, Dr. Sadashiv Rao and Madam. And my today's talk is on GDM clusters, newer perspectives. And my humble thanks to the organizer, RSJ Tamil Nadu chapter, which includes Dr. Vijay Vishwanathan, Dr. Shanmunga Velu, Dr. Rajendran, Dr. GVK, Panir Selvam, Dr. Babatarani Shanamungam, Dr. Ravindrantham. I had wonderful hospitality at Trichy with him very recently. And of course, Dr. Chandrasekhar and Dr. Arthikan and Dr. Balamurgam and everyone here. There's no conflict of interest for this particular session, and my journey for the pregnancy diabetes started long back with the blessings of Professor Sheshaya, which then continued with Tamil Nadu. Relations have continued and strengthened further after that with my mentor, Dr. V. Mohan sir, Dr. Ramchandran, Dr. Vijay, and Dr. Anand Moses, and of course Bhavatarani and the team, and by Dr. Balamurgam and Dr. Muruganathan. All this team has stimulated me to come back to Tamil Nadu more and more, and since last, I feel this is the third visit in last 1 month to Tamil Nadu. So thank you very much, and of course Dr. Shanmunga Velu. So this is the evolution of definition. If you just see, diabetes appeared in the patient along with the pregnancy, and at the very same time, while the pregnancy lasted, it lasted. As the pregnancy developed, it developed, and it terminated soon after the pregnancy. Now this is Benevit's 1824, almost 200 years from now. It was diagnosed that is possibly it is GDM, and this was his thesis topic of Benevit's was diabetes, a symptom of pregnancy. That was the thesis topic of this guy. And this was mentioned in Diabetology in 1989, this original publication, first record case of diabetic pregnancy from the University of Berlin. I feel everyone knows, and this has been repeated multiple times by Babatarani and also the next speaker. And then we have GDM, 2 generations are affected, and both of them can be protected by glucose control and early diagnosis and the treatment. And you have now the data, like you talk about DCCT in type 1 diabetes, type 2 diabetes, talk about UKPDS. Similarly, HAPO is one of the study where we talk about the importance of hyperglycemia control in pregnancy. So almost twice, if your blood glucose doesn't get control, almost twice the risk of having LGA, large for gestational age babies, increased fetal adiposity, neonatal hyperinsulinemia and preeclampsia, and 50% higher risk of having preterm delivery and the shoulder dystocia to these women who have GDM versus those who don't have GDM. And they now have come out with the HAPO follow-up study, like you have DCCT for follow-up study, you have UKPDS follow-up study, and you have your MIG tofu trial just have been shown by Perinder sir. So we now have even HAPO follow-up study, which has provided evidences regarding the adverse impact of GDM on the long-term maternal and the infant health. I'll not be able to go into detail of it, but I'll just tell you this is HAPO FUS study, some concluding conclusions of this. It's around 4,160 children of around 10 to 14 years of age of this follow-up. And what is the conclusion, what they said here is, the association of the maternal GDM with child IGT, impaired glucose tolerance, and not IFG, was independent of the child's family history. Even if you do have family history, you don't have family history, but there is high risk of developing pre-diabetes, that is IGT. Together, this data demonstrated that GDM associated an independent risk of offspring to our IGT, suggesting fetal programming may contribute to the observed association. Although additional factors, example may be shared environmental factors and shared genetics not captured here may also contribute. Importantly, the study also demonstrated the risk of IGT in the offspring diabetic mother occurred with lesser degree of hyperglycemia. So the cutoff which is being mentioned, even if it is below the cutoff of the diagnostic criteria, even those patients, this IGT was seen in these children. Insulin sensitivity was also lower in the offspring of GDM mothers, suggesting that it was in the part independent of the child BMI and adiposity. Insulin resistance is an early abnormality in these children. It was also found that positive association of these children at 30 minutes, 1 hour and 2 hours, but not fasting. That means impaired fasting glucose was not the part of the pathology in these offspring of GDM mothers. Similarly, with high risk of IGT, but not IFG in the as per the ADA. So isolated IFG is thought to reflect a high hepatic insulin resistance with relatively normal insulin sensitivity at the skeletal muscle. Now, whereas those with isolated IGT typically exhibit insulin resistance in the skeletal muscle. That means GDM may preferentially impact the offspring skeletal muscle as opposed to the livers. Maybe that we have peripheral insulin resistance more common in the offsprings versus the hepatic insulin resistance. This is the systematic review and the meta-analysis to show that those who did not have GDM versus those who have GDM about mothers. So relative risk is very high, 1.9. Meta-analysis says GDM remained an association to 56% higher risk of future cardiovascular disease, 2.3-fold increased risk of CV event, and in the first decade of the postpartum. Now, any earlier definition was any degree of glucose intolerance that was first recognized used to be called as GDM, but then people realized this is not a complete definition. We now realize when we understand they're different, like we have heard about early GDM from Dr. Professor V. Mohan, as well as we know some more terminology which have come. That means it is not simple that any hyperglycemia, it could be a pre-existing undiagnosed diabetes. So GDM now they say diagnosed in the second or the third trimester. That was not clearly overt diabetes is GDM. Still, I feel little refurnishing is required. These are the FIGO guidelines that you have umbrella term as hyperglycemia in pregnancy, subdivided into two, that is GDM and DIP, diabetes in pregnancy, those who are known type 1 or type 2, or those who are diagnosed for the first time, but during pregnancy, but have cutoff values of pre-existing or non-pregnant state in normal individuals. So, if you have that cutoff, then you call it as overt diabetes or a DIP category. So now, if you talk about the different classes of or different clusters of GDM, you have conventional GDM, which I'm not going to go in detail of it. You have overt GDM, overt diabetes or overt diabetes in pregnancy, and that is what pre-gestational diabetes or diabetes in pregnancy DIP category of FIGO. EGDM has already been covered. Now we have mild GDM, which is called a gestational glucose intolerance. And what this is, when you give glucose, and if your value is between 120 to 140, above 140, you call it as GDM. 120 to 140, because their cutoff is 120. Every day your pregnant woman is going to celebrate her pregnancy if you say she is negative. And you will cut off of 120 will further cross every day. So if you have 120 to 140, that's a warning sign to you, and you call it as GGI, gestational glucose intolerance. DIPSI has classified in 2006. And now then we have papers from, with Canadian guidelines call it as if you have single test negative, you call it as IGT of pregnancy. Canadian government, then Australia and New Zealand, they say call it as borderline GDM. Netherlands, they call it as mild GDM. So different classifications by different countries, different names. India, we call it as JGI. Earliest to call it as IABG. So we have a small data, early detection of mild GDM, its treatment can substantially reduce the fetal losses. So those women who has history of fetal losses, if you just isolate them from the total group of GGI, we have found around 209 women, 75% had positive family history, past history of abortion, 25% having single abortion, and 10% had multiple abortions, which has come down to 3.3% and hardly one IUD, and it was statistically significant just by a single diagnosis of blood glucose above 120, less than 140, and having BOH have been benefited. So mild GDM, meta-analysis we have now, and I'll just go for the conclusion. The risk of severe adverse neonatal outcome, including small for gestational age and neonatal mortality, are not increased in mild GDM, but increased risk of most of the adverse maternal neonatal outcome were observed, and the risk have similar magnitude of for all mild GDM diagnostic classification versus the classical GDM. So mild GDM has to be respected now, and this is another data which was published in American Journal of Obstetric and Gynec. And this again says that if you have mild GDM, that also have the higher risk of having NI admissions and all. And the author has concluded that now, fortunately, we have some data and large-scale multicentric trial, randomized treatment trial, to provide an evidence that treatment of even mild GDM is important. With simple dietary interventions, sometimes insulin is necessary, and that can work for these patients. Now, are there any benefits of GDM in treating the lower level of hyperglycemia? Another Canadian study, they again says that the milder form of hyperglycemia has to be treated. And if you go through the CGM data in non-diabetic pregnant state, what is normal in non-diabetic pregnancy? 1 hour fasting never crosses 80, 1 hour never crosses 120, 2 hour never crosses 110, and 24 hours average is around 100. So if you have these figure in non-diabetic pregnancy, why should we go above this figure? If you go through the St. Vincent Declaration in 1985, what it says we should try to achieve the glucose control of diabetic pregnancy to the non-diabetic pregnancy level. And these are those non-diabetic pregnancy level, and that's why possibly this 90 and 120 figures may need to brought down further in future. And I feel this has already been discussed about this new terminology, early gestational glucose intolerance, or EGGI. So there's another cluster which now Dr. Seshaya sir is working on, that you have metformin if given if you get someone of more than 110 blood glucose at 2 hours postprandial. I'm not going to go in detail of it because this was already covered. I'll have some small data from our group. This is about insulin in twin pregnancy. This is possibly one of the rarest data of this part of the country. And what we have seen, actually, one paper has come from type 1 diabetes from US, and that says insulin requiring in type 1 diabetic pregnancy, twin pregnancy, is almost double that of the singleton pregnancy. So we have a cohort of around 30-35 pregnancy. We also have cohort of around 8-10 pregnancies from Pune. So 2 centers have come out with the data, and Dr. Sanjay Gupta and Nagpur, and what we have seen, we had around 44 132 singleton pregnancy from the 800 records, and 44 twin pregnancies have been, they're all GDM. And what we have, with 3:1 ratios, and what we have found that GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and insulin doses. So that does not mean that if you have twin pregnancy, your insulin requirement will double. So insulin requirement need not be proportionate to the number of fetuses, and treatment should be planned to achieve the glycemic control similarly as that of the singleton pregnancy. There is another cohort which was got published last year in 2024, GDM neonatal and the maternal outcome in women treated with insulin versus diet therapy. And this cluster, you can understand that which kind of women will require diet therapy alone throughout the pregnancy, and which woman is likely to require insulin along with medical nutrition therapy. There are the highlights. Women receiving insulin had a low risk of preterm low birth weight and macrosomia. This is very important. That means if you treat them intensively through insulin therapy, if they're requiring it, you can certainly reduce the morbidity and mortality in these children. Neonatal hypoglycemia was more common in insulin treated group. That was expected because they were more severe hyperglycemia. 2-hour, this is important, 2-hour blood glucose values above 162.5 and fasting value more than 90 may require insulin therapy. This is at the time of diagnosis. Individual with the propensity score of more than 0.7 required higher insulin doses. So we have that data. I'll share with you what that propensity score is. There is another thing which is here, around 800 pregnancies. First trimester, 13.5 have been diagnosed. Second trimester, 36.5%. And third trimester, 50%. So it exactly matches with the global data as well as other Indian data you have, that almost 13-15% are being diagnosed in the early pregnancy. And then if you see which women is likely to require insulin, those who have elderly women, those who have bad obstetric history, positive family history, and higher pre-pregnancy BMI, these are the women they might need insulin therapy versus the other women who require only diet therapy. Neonatal hypoglycemia is more common in insulin treated group, and PIH was also more common in insulin treated group. Macrosomia, it's a neonatal hypoglycemia after the adjustment. Sir, I'll just take 1 minute more here. And this is risk of IUD was lower in the insulin treated group. Now we have initially the full term doses of the insulin was calculated, and these two they have called it a love plot has been created just to match the population. And we have 4 cohorts of 4 different quarters. And what they have seen is first 3 quarters insulin requirements almost similar at the time of beginning as well as at the time of delivery. But the 4th quarter with higher risk factors of higher age, higher parity, BOH, family history and pre-pregnancy BMI, higher fasting, post-pregnant HbA1c required almost double the dose of insulin, 1.5 times double the dose of insulin. So if you have this, then these women may require higher dose of insulin. That has been shown. So this is about different cohort we can learn from the Indian population. National GDM Day is 10th March, which is birthday of Professor Shia, and India is the only country in the world which we have National GDM Day. We should have awareness on these lines. We do this Prega talk now, the 3rd cycle has been started now in we have 22 languages in the Constitution of India, and we do this program. And yesterday we had Friday, and it was in Telugu, and earlier we had in Tamil as well as in other languages. So we have completed around 57 such programs. This is the Tamil one. We started the 3rd cycle, and Telugu we had yesterday. Focus on the fetus for the future is the mantra. There are some rewards and all, which I'm not going to tell much about. And with this, I stop here. Thank you very much for patience.
Thank you, Dr. Sunil Gupta, for your elaborate talk on GDM clusters. Any question from the floor?
Dr. Bavadharini, to your question. This is purely academic. That is adipocyte expandability in obese women, obese pregnancy without GDM versus obese with GDM. That is obese pregnancy with GDM. And what happens to fetal subcutaneous thickness? Obese versus, obese pregnancy without GDM and with GDM.
So in obese pregnancy with GDM, even if the baby's weight is normal, you can see increased subcutaneous fat thickness. Weight of the baby may be normal. It may not be macrosomic at all, but still it will have more of subcutaneous tissue, and you should expect all the problems what I said in obese GDM in future.
If there is
This is regarding the metformin. On one side, like we mentioned, metformin is associated with obesity at the age of 7 and 9. and RSSDI is recommending not to use metformin, but use the only insulin. And, can you just clarify it, please?
Should I speak or you want to speak or? See, there are some absolute contraindications for metformin. One should remember that. If you have placental insufficiency, missed abortions, oligohydramnias, polyhydramnias, you have any complication, PIH, in such patients, IUGR, then metformin is contraindicated in such patients. Rest of the patients, unless it is contraindicated, those women who tolerate, we can give metformin. It has been now, if you go through the NICE guidelines, they have clearly said that we can continue metformin from the preconception till delivery after the MITI trial they have published recently. So on that basis, but Government of India guidelines are yet to be updated. We still say 20 weeks. DIPSI guidelines have last year changed from 20 to now it is 12. So 12 onwards we can give metformin to GDM. That's what we say. Again, on the basis of the MITI trial.
And another endocrinologist from New Delhi, Dr. Satyajit Bhattacharya, he has followed the children who were on insulin as well as metformin up to 11 years. He has shown that both are equal. There's no difference between the two. And again, he has shown that it can be used.
So all the studies which we have mentioned, that MICTOFU, HAPO, everything is not India is not included in the studies. Okay, though it's a multi-centric, multinational studies with a large number of patients, that a HAPO study. So India, China, they are not included. So our gene, our genetic pattern is little different. So our people, they tolerate well metformin.
But most important message for all the clinicians, insulin remains the drug of choice because insulin doesn't cross the placenta. All oral drugs, they cross the placenta. So that has to be taken in consideration very strongly. Insulin remains the drug of choice.
Thank you, sir.
And if you listen, what he has told is from PP 110 to 119. Up till that, this is useful. As sir said, beyond that, it becomes GDM and they may progress to insulin requirement.
Thank you, sir. And thank you, ma'am, for your good talk on GDM. Now, since we are running short of time, we will close this session and we.
Thank you, chairpersons and speakers. Thank you for the high intensity academic discussions. For the next session, I would like to welcome and hand over the session to Professor N. Rajendran sir and Dr. Dharmarajan sir.
Check.
Good morning. Hello. Now let us move on to the next sessions. And this is, the first topic is monogenic diabetes, what is new. Say the monogenic diabetes is a terminology that is become popular in the recent days, which occurs due to some aberration in the genes and result in MODY, neonatal diabetes, and syndromic diabetes, etc., etc. And so far, because of late previously, about only some 5 to 6 genes has been elaborately studied, and now till recently 40 genes have been studied well. In fact, the same topic with the same speaker, actually 2 years back in the Future of the Diabetes conducted by the Government of Tamil Nadu, and Dr. Mohan only, he spoke about this topic. In fact, during today's breakfast time, I said thing, but Dr. Mohan said, yes, sir, but in between, so many new concepts have arisen, and the details of which Dr. Mohan is going to talk. And regarding the speaker, Dr. Mohan, I need not elaborate.
You can skip the introduction.
So, he is very popular and he is well known to everybody. So, I will hand over the mic to Dr. Mohan to go ahead with his topic.
Thank you, Dr. Rajendran and Dr. Periyandavar and Dr. Dharmarajan for chairing the session. And I'd like to express my heartfelt thanks to all the organizers, names are shown here, for organizing this wonderful TRAC 2025, which is very well attended. And thank you for asking me to talk on monogenic diabetes, what is new. I have no conflict of interest to declare, all these are government-funded studies. So let me straight go into the topic, what is monogenic diabetes? Monogenic diabetes is not the commonest form of diabetes. Only 1 to 2% of all diabetes that we see. However, the problem is that it is misdiagnosed. It is missed in about 90% of cases. Usually it's diagnosed as type 1 diabetes. Now that's where the problem comes, because if you don't have type 1 diabetes and you diagnose monogenic diabetes as type 1 diabetes, you'll start treating them all with insulin 4 times a day when they don't need it at all, when they can be converted to tablets. That's why I'm talking on this. I first heard about monogenic diabetes when I was just entering my final year of MBBS. I'd already been working for a few years with my father before that, and I saw this report by Stefan Fayans and Robert Tattersall published in Diabetes. I used to read all the diabetes literature as a medical student. They described 26 cases. Now at that time, the term MODY, maturity onset diabetes of young, is MODY, not MODI. So MODY was first introduced at that time. And why it was introduced was because anything below 40 years was called as growth onset diabetes, and anything above 40 years was called as maturity onset diabetes. Equivalent, supposed to be equivalent of type 1 and type 2, which means anyone in the world diagnosed below 40 years was thought to have type 1 diabetes at that time. So Stefan Fayans and Tattersall said, no, we have got cases, they had 26 cases at the time, which are young, occurs in adolescence and early adulthood, but they are not at all on insulin. So they said not everybody below 40 years is having growth onset or type 1 diabetes, and so they gave a new name for it. They can't call it maturity onset because it's below 40 years, so they said maturity onset diabetes of young people. So MODY, that's how the term was coined. This is the criteria which they set down. Obviously it has to be below 25 years of age. It goes through 3 or 4 generations. So autosomal dominant inheritance, no ketosis, therefore it's not type 1 diabetes, no beta cell autoimmunity. At least 5 years you should be able to control without insulin, which doesn't happen in type 1 diabetes. Insulin secretion is the main defect. They don't have much of insulin resistance, and there's no obesity. So it's not type 2 diabetes as well. So very clear criteria. Of course, these criteria were valid then. After the genes were discovered, you cannot diagnose MODY on clinical criteria anymore. You have to do genetic testing. The first gene for MODY was described in the year 1992. So until then, nobody even accepted the diagnosis of MODY. They said there's something like type 2 diabetes, it was called NIDDM at the time. There's nothing but NIDDM. Why are they calling it MODY and so on? But since the criteria of Tattersall and Fayans was there, just after my MD, I started publishing a series of publications on MODY from India. And I said this kind of diabetes occurring at young age, if you're calling it MODY, it's highly prevalent in our country. Actually, it turned out that many of them actually had type 2 diabetes because we didn't do the genetic tests at the time. So a series of publications I published at that time. Then the first gene for MODY was described, MODY1, in 1992. And by 1993, 94, 95, several MODY subtypes. In fact, 14 different MODYs were described. More recently, MODY 7, 9, 11, and 14 have been dropped. They are no longer MODY, we cannot diagnose them. So that left 10 MODY types. of which Modi 1, 2, 3 are the most commonest, and they will be about 90% of all Modi will be in the first 3. Modi 1 and 3 are very important because both of them respond to sulfonylurea. They're usually diagnosed as type 1 diabetes. If you make the right diagnosis, you can stop insulin and treat them with tablet. Modi 2 is even more interesting because they don't need any treatment. They can be treated just with diet and exercise. They don't need any pharmacotherapy. I'm not going to the other Modi types. You may say, well, if you suspect Modi, why don't you try sulfonylurea? You can't, because in Modi 10, it's an insulin gene mutation. It behaves like type 1. They need insulin. So you really have to make, this is what precision diabetes is all about. So we published a series of publications. Those were without the genetic finding of Modi. With the genetic confirmation of Modi, I then published a series of papers on Modi 3, Modi 1, Modi 2, Modi 5, and then we did a whole genome kind of analysis of all the Modi genes that is published in BMC Medical Genetics. But the latest paper was published in June of this year. This is a pan-India study. So I wrote to all the members of RSSDI and said, if you have any Modi cases, you can collaborate. And something like 65 people from all over the country send me samples of Modi. So this became the first pan-India study of Modi. You can see from all parts of the country, the cities and the number of centers from which these samples came. And this was just published, and we found 120 new cases of Modi which we found in this series, of which Modi 3 is the commonest, Modi 1 is the next common, Modi 5 is the next third commonest. So Modi 5 has genitourinary problems. So you will find either one kidney absent, or a horseshoe kidney, or uterus being absent, or some such congenital abnormality of the genitourinary tract you will find. Modi 12 is also important because that is one type of Modi which behaves like Modi 1 and 3, and we discovered that it responds to tablets, just like Modi 3. The other Modis are of more of academic interest because they don't respond. I'm not going to talk about the genetic syndromes like monogenic forms of diabetes. Now, since only some Modi respond to sulfonylurea, as a clinician, we are more interested in Modi 1 and 3 and maybe Modi 12. So my PhD student R.K. Ramaswamy, she wrote this paper saying that why we should call them as actionable Modi, that is, these are the Modi which you really need to pick up as a clinician. The others are of academic interest. Now, how do we identify when a patient comes to us? Using what criteria do we decide who to send for genetic testing? Genetic testing is expensive. We try to do it free of cost for everybody wherever possible. But whoever pays for it, somebody has to pay for it, and it's not cheap. So how do we identify? In the world, there was no such criteria that you do this, and then you clinically select who to send for genetic testing, especially since type 2 diabetes is very common in our country. Whom do you decide how to go? So what we did was, in this large study, we took Modis who were genetically determined to be to Modi 1 and Modi 3. We are more interested in that. So only Modi 1 and Modi 3 genetically confirmed. Nobody can doubt that this is Modi. And then compared them with about 1,000 type 1 people of the same age and about 1,600 type 2s of the same age, and looked at all their clinical parameters. How do we diagnose it? Looked at age, BMI, HbA1c, HDL cholesterol, fasting C-peptide, stimulate C-peptide, looked at a few others as well. We tried to see which separates out the Modi from others. What we found was, it doesn't come out clearly here, is that the fasting C-peptide and the stimulated C-peptide, better shown here, was a much better predictor. The others were not having good sensitivity and specificity. The fasting C-peptide is quite good, but the stimulated C-peptide, for which just have breakfast and 90 minutes later take one blood sample, which is what we do in the clinic anyway, postprandial sample. Along with that, you see whether it goes up or not. Beautifully, as you can show you in the previous slide, you can see the stimulated C-peptide. The dotted one is type 1, the green is type 2, and the red is Modi. So Modi is able to sit somewhere in between, and so with a very good sensitivity and specificity. So we concluded that in a clinical setting, if you have a C-peptide that's too low, don't bother, it's type 1. If it's too high, it's type 2. If it's in the middle, then you, and if they have 3-generation transmission, then you can think of Modi, if the antibodies are negative. while we are doing all this, we get these samples from all over the country. We are a national center, ICMR Center for Monogenic Diabetes. So we get hundreds of samples every day, and now we have started doing it free for almost everyone. So one gene which we are very interested in is the ABCC8 gene, because that is the one which produces MODY12. Because the KCNJ gene, which is also next to that, is also a beta cell gene. Now what happens is this ABCC8 gene is very interesting. I told you about MODY12. Now if you have a mutation in ABCC8, it can be of two types. One, it can be a gain of function mutation, or it can be a loss of function mutation. If you have a gain of function mutation, this can occur in newborn children, and then we call it as neonatal diabetes. 2-month-old child, 3-month-old child, it has a gain of function mutation, it's neonatal diabetes. And that's the best thing to do, because that child can then be taken off insulin and treated with tablets. This can also occur in adults when you call it as MODY12. This is also a response to sulfonylurea. So if you have a gain of function mutation, it produces diabetes. Now there's an opposite thing. If you have a loss of function mutation, you actually get hypoglycemia. And we're getting hundreds of children like this. Newborn children going into hypoglycemia all the time, developing fits. They don't respond to glucose, they don't respond to anything. That's because they have a genetic defect. They need to be treated with diazoxide or octreotide, and we've got a large series of that. But when we were screening some of our adult patients, young adult patients for MODY, we found that they had ABCC8 mutation. So we said, oh, it must be ABCC8 MODY12. But when we looked at it carefully, they had a loss of function mutation. We were very confused because they should have had hypoglycemia and not hyperglycemia. So we did some studies, and then we reached out to the best people in the world, which is the University of Washington at Seattle. They have separate functional assays where you can look at loss of function and gain of function. And we wrote to them and said, we are confused, sir, because we are getting a loss of function mutation which is producing diabetes instead of hypoglycemia. Can you confirm this? So they took about a year, and they came back and said, you made a discovery. This is the first time in the world that a loss of function mutation has produced diabetes. So we published this in Diabetes. It became very big news because a big discovery from India that a new type of MODY, MODY15 we call it, has been, so we called it as paradoxical MODY arising from loss of function in ATP. It's the first time that a new type of diabetes has actually been described from this country. Now why does this happen? See, when you have a loss of function mutation, you get hypoglycemia. Why do you get hypoglycemia? Because you're producing more and more insulin. The beta cell is producing more and more insulin. So it will produce hypoglycemia. What we are saying is, and that leads to congenital hyperinsulinemia. What we are saying is that because of, it's not moving. It's not moving. Can you just make that move, please? It's moving in my, yeah, okay. That's good. Go to the next one. Yeah. So what we are saying is that when it keeps on hypersecreting like that, after some time the beta cell fails because it's not able to produce so much of insulin. Then what will happen? You'll get diabetes. So that's the new type of diabetes due to a loss of function mutation. It's the first time in the world that this had been described. So we are now calling it as MODY15, and this is one of the new discoveries which we're very happy to be associated with. Before I end, I want to talk about an even more exciting finding, and I'm purposely talking to all of you because any of you can pick up these cases, and I'll talk about one story before I end. So this is neonatal diabetes. I already talked about it. It occurs in the first 6 months of life. Some of them have transient. That means they'll get the diabetes, but by the first birthday it's gone. You don't have to worry about it. The second one is more permanent, and that's the one which gets referred to us. So let me talk about this girl, this child, about whom I've spoken earlier, but it's so illustrative that I should talk about it. This is a 3-month-old baby called Ivana Das, who was referred to us from Calcutta. The physician there diagnosed her and started treating her as type 1, but she was not responding to insulin. So 14 units of insulin for a newborn child is very high. She's not responding. So they said, you go to Chennai and let them evaluate you. For us, anybody below 6 months of age, we have to do genetic testing. So we did it. We did it free of cost for her. And we found that she had a KCNJ11, just like the ABCC8. This is neonatal diabetes. And this is one which responds to sulfonylurea. So we started her on glibenclamide. The dose of glibenclamide is slowly increased. The dose of insulin shown in red came down to 0 by the 4th day. And the blood sugar, you can see in blue, when the child was on insulin, sugar is not coming under control. But after the insulin stopped and the sulfonylurea was given, glibenclamide in this case, the sugars came to complete normal. You can see the blue line, completely normal. So after 3 days in the hospital of complete normalization, we discharged the child, sent the child back to Calcutta, where she's following up at our Calcutta branch. So the next question that will, of course, this made big news because we wanted people to know that you can take children off insulin and treat them with tablets. Now this is Ivana Das when she first came in 2014, when she was 3 months old. Her mother is carrying her. When Professor Andrew Hattersley came and visited us, he's a kind of god of monogenic diabetes, you know, from Exeter. When he came, we called Ivana Das back. She's now following up for the last 9 years at our Calcutta branch, getting complete free treatment there. And so she came back. It was a pleasure to see her now grown up. And from the time she left her hospital, our hospital, 9 years ago, now it's 11 years, it's 2023. For the last 11 years, she's not had one single shot of insulin. Okay? And that's because the genetic testing was done. So if the genetic testing was not done, by this time we calculated she would have had 16,060 unnecessary insulin injections. If you use the cheapest insulin, she would have spent about 2 lakhs on that. Cost of glucose monitoring, obviously she would have to do, even if she spent 1 or 2 a day, she would have spent 1 lakh on that, and she would have spent 3 lakhs. The income of her father is 20,000 rupees a month. He can no way afford insulin. Okay? Thanks to genetic testing, insulin stopped, she avoided 16,000 injections. Cost of neonatal diabetes testing, we do it lowest in the world. If at all anybody charges, is charged for it, we just charge 2,000 rupees. Sometimes a rich person will come, we'll say, okay, you pay 2,000 rupees. But in 99.9% of cases, we do it free of cost. So if you have any child who is diagnosed before 6 months of age, send it to us, we'll do free genetic testing. I'm promising here, we will not charge 1 rupee for it. Now, why we should talk about it? When we last had a meeting some months ago, I had a very interesting case presented from Madurai Medical College. This was a 19-year-old boy who had uncontrolled diabetes with a foot infection. So this person who was treating, the Department of Diabetology there, they had heard my talk. So when they're taking the history of this boy, sugar was not getting controlled, infection not getting under control. So they asked the history, when did you get diabetes? And the parent said, when he was 3 months old. And they said, can this be neonatal diabetes? Already 19 years old now. So they contacted us. The boy is now 19. Can you do genetic testing? They said, we'll do. We found out that it was a neonatal diabetes, which is wrongly treated with insulin all these years. So we said, why don't we just add sulfonylurea to that? The moment sulfonylurea was added, the sugar got under control, the infection healed. So even at age 19, we are able to pick up a wrong diagnosis made 19 years ago. Imagine 19 years he's been taking insulin and is not responding at all. So all you have to do is, when any child comes with type 1 diabetes, just ask, what age were you diagnosed? And if it's below 6 months of age, just send the blood sample to us for testing. You may say, then if it is below 6 months of age, why not we just stop insulin for everybody and give them sulfonylurea? The child can die because only KCNJ11 and ABCC8 neonatal diabetes will respond to sulfonylurea. If you have an insulin gene mutation, you have a GATA mutation, you have GLUT mutation, GLUD mutation, they will not respond and the child will die. And therefore, you have to do genetic testing if you want to take. How common is ABCC8 and KCNJ? It's 50%. 50% of all neonatal diabetes children will have one of these two. So 1 in 2, you have a chance of doing it. So the child saved so much of money, and if genetic testing is not done, she would have been on insulin even today. You may say maybe Ivana Das is just one case. It's not one case. We've got 432 such cases from all over the country. Another 175 who were neonatal diabetes, but they had other genetic syndromes, various syndromes we pick up. For example, if you take thiamine responsive megaloblastic anemia, TRMA, which has the SLC19A2 mutation. If you just give thiamine, the cheapest of all drugs, B complex, the anemia will go and the diabetes will go. Can you imagine? 2 birds with 1 shot. Diabetes also gone and anemia also gone. So this is the value of precision diabetes. Instead of just treating everybody as type 1, everybody as type 2, you have to pause and think, what does this child have? We also have large number of MODIs, congenital hyperinsulinemia is also equal number as NDM. We set up a monogenic diabetes registry where all of you are ready, I mean, you are welcome to participate. So to conclude, ladies and gentlemen, the diagnosis of Modi has helped many people to go off insulin. Neonatal diabetes can also be treated with sulfonylureas. This is a miracle of sorts for the child and the family. Hence, all children before 6 months of age must undergo genetic testing. And if you want to take a picture of this, you can scan this, and all you have to do is to send the blood samples to us, and we're very happy to do everything completely free of cost. Thank you.
Thank you, Dr. Mohan, for having elaborately said about this Modi and neonatal diabetes. And also, we have to thank, on behalf of all, for having found out a new diabetes, that is a Modi 15 to this world. And many more things we expect from you. I think the problem is how to go ahead with the genomic studies because of its cost. So, of course, we know that we are coming across with the people, young people with diabetes. We do just the C-peptide. In some patients, we do this, the GAD antibodies, insulin auto antibodies. With that, we are stuck up. And of course, if at all we want to send the sample, we have to send it from the government hospital, and they are doing free of cost. But take that to the practitioners if really want that the cost factor alone is that the hidden factors. I think you have to find out a
No,
way.
we are quite happy to do it completely free of cost, sir. Cost is not at all a problem. 0 rupees.
In your centers.
In our center, this is a national center. We are an ICMR center now.
Okay, thank you.
Anytime anybody wants to send, just send it. Money is not a problem.
Okay, thank you. So my co-chair, Dr. Dharmarajan, he wants to ask few things.
Every time we listen to you, sir, we understand something new, in the sense we are able to relate what you describe to some of the cases that we have seen before. In fact, one of the cases that we have seen in our hospital, now I'm able to exactly fit into how she might have been a case of ABCC8 mutation with the loss of function, subsequently developing diabetes. So I would like to co-partner with you and send the case to you for further evaluation also, sir. We should be doing that.
Thank you, sir.
Thank you
so much.
Sir, one question, sir. So my question.
Oh, yeah.
Yes, sir. So gain of functional mutation or loss of functional mutation with reference to ABCC8. So one child presented with diabetes neonatal. Another child presented with the diabetes relatively late. What decides about the onset neonatal or at the later age group?
So if the mutation is there and it is at the childhood itself it presents, if it's a gain of function mutation, it will present with neonatal diabetes during childhood, and the sugar can be very high, 400, 500 as you saw in Ivan Adas's case. So they'll immediately go to a doctor who will treat them as type 1. They won't think of genetic, they won't do anything. That child is doomed to be, we should be having at least 10,000 children with neonatal diabetes. We've got only 400. So where are the other children going? They're all treated wrongly, like this Madurai boy, all treated wrongly. That is why I'm passionate about it, pick it up. Congenital hypoglycemia, on the other hand, it can be severe, in which case they die. It's not so easy to treat CHI. Neonatal diabetes, just give glibenclamide or any sulfonylurea and they're done. CHI is more difficult, diazoxide is not available, it's very expensive, octreotide is even more expensive, and the results are not good. And not all respond. A small percentage even need pancreatectomy. So CHI is not so easy to treat like neonatal diabetes. In this case, this person must, these 20 people whom we reported, must have had milder CHI. So they had some hypoglycemia, somehow the child would have been overfed. And then eventually by a few years, the insulin levels would have dropped. And that is why they developed diabetes later. When they had diabetes, somebody thought of Modi and they referred it to us. Then we found out that it was this thing. As you keep doing more and more, you discover new things. Thank you.
Sir, in ABCC8 mutation, sir, I'm here. Yeah. So sulfonylurea, they did with glyburide.
Glibenclamide.
Yes, sir. Yes, sir. Is there any specificity to use only one sulfonylurea, or we can go with any other sulfonylureas?
No. So glibenclamide is the time-tested one, and from all the original studies it was there. There was one study by Ewan Pearson and Andrew Hattersley in the Lancet where glycoside has been used. So in our Modi study, the All India study, we are actually using glycoside. and it's giving good results. I think even glimepiride will work well. Even some DPP-4s are shown to have some effect.
Sir, it's been an excellent presentation. I learned a lot about Modi, sir, right now. The thing is, just on the academic interest, sir, like insulin receptors and all that. Here we are talking about gene that is deleted or added, it functioning. So insulin is the primary requirement. So here, what is the mechanism, and is that a total, we have to change our learning of diabetes and insulin secretion receptors? And
Yeah. So
thank you.
Here, why insulin doesn't work is because there is a defect on the beta cell. The genetic mutation is on the beta cell. ABCC8 receptor is nothing but a sulfonylurea receptor. So if that mutation is there, what happens is the potassium channel doesn't close, the calcium channel doesn't open, insulin doesn't enter, and you get diabetes. In the opposite thing, more of calcium will come and you will get hyperinsulinemia. That is where the defect is. That defect can be corrected by giving a sulfonylurea, because the receptor for sulfonylurea is also there. By giving insulin, you may get some reduction in the sugar, but it doesn't work so well because you're not correcting the defect. The main defect is on the beta cell. So if you just give insulin, it's like a temporary kind of a solution, not addressing the defect. When you give the sulfonylurea, it goes and closes the potassium channel, it opens a calcium channel, and the sugar gets under control. So that's the physiological way of treating. Thank you.
Thank you, Dr. Mohan, once again. For having thrown light on the management of the young diabetes, so far having been treated as type 1. But now you have thrown light. Thank you once again on behalf of the organization.
We will take it later, madam, in the interest of time. I'll come to you.
So let's move on to the next topic for the session. It will be on prevention of diabetes complications. Will be delivered by Dr. Vijay Vishwanathan. He is the chairman and chief physician of ME Diabetes and ME Diabetes Hospital in Raipuram, Chennai. He is the national president of RSSDI. Honorary President and Board Member of DFood International, Belgium. So again, Dr. Vijay doesn't require much of an introduction. He is a well-known speaker and faculty in both nationally and internationally. So we'd like to call upon Dr. Vijay sir for his talk.
Dr. Rajendran and Dr. Dharmarajan, and I would like to thank Dr. Rajendran and Dr. Balamurugan sir for inviting me to this talk this afternoon. I'll take only 12 minutes to finish this talk on prevention of diabetes complications. We know that heart is talked about at length. So I'm not going to talk about heart in this talk. I'm talking about the kidney, the foot, and the mental status, the brain. So next slide. I'll have to show it here. So we know from John Cockcroft that diabetes is a vascular disease. It affects the eyes, it affects the kidneys, the brain, the heart, and the nerves in the feet. And diabetes doesn't start from day one. It starts from at least 5 to 10 years before diabetes is found out. Now, prevention in diabetes, we call this as primary prevention when you prevent the impaired glucose tolerance or early glucose intolerance. Or the 1R value is given importance now to prevent it from progressing to diabetes. The secondary prevention is diabetic with complications, and the last is tertiary prevention. Now, the elevated 1 hour fasting blood plasma glucose has been given importance by RSDI and WHO and IDF. And we published this data some years ago, where we found the 1 hour value is abnormal and the fasting and the 2 hour value were normal. Then we found out that even after, in the United States, people came home and they coached people to do exercise and so on. So we wanted to see whether in the real world setting it can prevent diabetes. And we found in this paper which we published recently that prevention of diabetes is possible in a real world setting in South India. Next I'll move on to kidney. Kidney, don't think that the kidney failure is a very slow process. It is a slow process, but you have to measure the albumin and the GFR, and this is from the KDIGO classification, and you have to measure the albumin and the GFR. We have drugs which can impact the kidney, the blood vessels and the heart now, and the standards of care of the ADA and ESD show that it can be treated at a very early stage if we measure the albumin and the eGFR. We recently published in the Indian Journal of Nephrology, Dr. Shivashankar is here, and she's presenting tomorrow, and we found that body mass index is independently associated with CKD among people with diabetes. Therefore, we wrote up the global IDF guidelines for kidney some years ago, along with Sally Marshall, which has been modified by Dr. V. Mohan and Antonio and others recently. In the 2005 guidelines, we wrote standard of care, minimal care and comprehensive care. The minimal care is about practiced in rural Bihar or rural Uttar Pradesh. Standard of care of where it is practiced in our clinic, in any diabetology clinic, and comprehensive care is where you do kidney biopsy to diagnose diabetic nephropathy. I'm talking about kidney in particular. So minimal care for the kidney is using beta blockers and treating the hypertension to 130/80, not bothered about the ACE inhibitors or ARB. Standard care is where you give ACE or ARB, and comprehensive care is where you do a kidney biopsy and try to find out the reason for the proteinuria and rule out non-diabetic kidney disease, which constitutes about 30% of the kidney disease which you see in practice. Next is our publication about the mind. We found out for the first time there's an entity called diabetes-related distress, DDD, which is particular to diabetes in particular, and it is not associated with any other condition. So this was the first paper in India, assessment of diabetes-related distress among subjects with type 2 diabetes. And more recently, we found out how to avoid by using muscle relaxation technique. This was published in IGMR, Indian Journal of Medical Research. The effect of progressive muscle relaxation on the mind, and you can take the stressors away from you by using the method used in yoga. Yoga is quite useful. Pranayama is quite useful, meditation. And last entity is the lean diabetes, which is called type Y, type 5 diabetes. It is not type 5. Dr. V. Mohan has published recently in the DRCP that lean diabetes is a special variant of type 2 diabetes, whereby the failing beta cell cannot even cope with the small amount of insulin resistance. And this is the classification what we came up with. several years ago. We have anybody about 23.5 as overweight and anybody about 25 is obese. And lastly, I'll talk about diabetic foot, which is close to my heart. Diabetic foot is a condition which is associated with a lot of comorbidities, high direct and indirect cost, potential amputation is there. And the first two categories is where we physicians are involved, the normal foot and the high risk feet. And the last 1, 2, 3, 4 stages of the surgeons. And it is quite costly to treat non-studded foot, infected foot, necrotic foot, unsalvageable foot. The cost was described in JAPI. It is the most expensive complication of diabetes you can think of. And this is diabetes without complication amputations if they are present. We have in this paper looked at the cost of expenditure for the last 2 years. You can see the difference between the two, $930 versus $3,000 if you have several amputations. So we have this innate responsibility of preventing amputations, not only saving the feet, but preventing amputations. And lastly, for the RSDI, we did the early screening of foot problems in people with diabetes, and Tamil Nadu was the highest. And we found that 1/3 of the patients had a high-risk feet who walked into the clinic. And this was published in the British Medical Journal 2 years ago. Lastly, I would like to talk about what we have done. If you import footwear from Italy or from Europe, you have to pay customs duty, and it costs about 14,000 rupees. So we published in the International Journal of Diabetes in Developing Countries, which is the RSDA journal, a study where we looked at a in-hospital made footwear called MV Surgi boot, and we tested it out in some patients. You can see that it healed, and it healed. It's mostly useful for 4-foot ulcers. And lastly, the 2027 guidelines are going to be written up, and it's already started. And I have been placed in 2 IWGDF guidelines on interventions to enhance wound healing and also in offloading. So I think it's possible to prevent diabetic complications, and I would like the chairpersons to ask any questions, if there are any, before I finish and hand it over to the President-elect, Anuj Maheshwari.
Thank you, sir. Thank you, Dr. Vijay. Given a broad topic of diabetes care, prevention of diabetes complications, I was wondering what he was going to talk about, this broad macros, like so many complications, but then he stuck to specific complications of diabetes related to kidney, musculoskeletal system, and the foot. So thank you, Dr. Vijay. Is there any questions from the floor with regard to the topic?
Or we can have at the end of the session, sir.
We can have at the end of the session.
Yeah, sir.
Dr. Anuj.
Anuj.
Thank you, Dr. Vijay. And the message as given by him is, long live despite diabetes without the complications. That is the message as given to this audience. Now let us move on to the next topic, that is diabetes care in rural India. Of course, most of us have been practicing in urban areas. Now I welcome Dr. Anuj Maheshwari to give these deliberations. Please.
Thank you. Thank you, chairpersons, for the kind introduction. Thank you, team, Tamil Nadu chapter of RSSDI, for this wonderful invitation. And I really feel privileged and having in last 4 months 4 times in the Tamil Nadu. Thank you, Dr. Shanmugavelu, for this wonderful experience of me. Started from, and I think out of those 4, 3 times in the Coimbatore only. So, and despite I missed 1 or 2 invitation by Dr. Narsingan, still I could make it 4 times in Tamil Nadu. So next time I will definitely not going to miss your invitation, sir. So in next 20 minutes I shall be telling you about a vision which I really look forward during my tenure of being president, because you people have elected me, so I must tell you something. What is the preamble in the next 2-3 years we shall be going, and I'm really grateful of President Dr. Vijay Vishwanathan, who given me this opportunity to start these activities in his presidential tenure, and we are still started working in many states. About 1 month back, we did a similar activity in Darbhanga at Bihar, and now on 17th of August we are going to have the similar activity at the Jharkhand. And very soon I believe that we shall be getting an opportunity to start this activity, rural outreach program of RSSDI at Tamil Nadu also. So let's talk about the challenges and opportunities which are there in diabetes care in rural India. So if we talk about the challenges, the 2 biggest challenges always remains in our mind. One is the rising trends of the diabetes in India. Despite so much of the efforts, despite so much of the tools in our armamentarium, our prevalence of the diabetes is increasing in the last 20 years. It is proportionately very higher and higher. Means when it was, what was the speed of the first 5 years, 2000 to 2005, in 5 to 10 it was more speed, and then currently also we are having a higher speed in spreading of this diabetes. And another important thing what remains in our mind, that diabetes occurs 2 decades earlier. It started occurring 2 decades earlier in Indian population. If we really look for in the background of these 2 things, obviously the rapid urbanization comes in our mind, which is in the roots of so many evils. But if you look over the Indian population's status right now, still 64% population of India is living in the villages. Still we are largely in the rural India, not the urban India. When we talk about the diabetes, it is more focused about the urban population. It is always our all efforts to stop diabetes, for the prevention of diabetes, for the diabetes care, CGM, whatever we wish to do, that is targeted towards the urban population. Rural population is always missed by one way or another. For the first time, we could get an authentic data of the rural diabetes in the ICMR in diabetes study this time. But before that, we were not having a pan-India authentic data for the rural diabetes in India. And another important thing which would be more important here, now our villages are also getting influenced with the mass media. Physical inactivity is also starting in our villages also, because a lot of facilities, a lot of luxuriousness is reaching there also. They are also changing their dietary pattern, which have significant altered lifestyle patterns. And of course, the smoking, alcohol consumption, refined carbohydrate, rich diet, and all these things are also being more and more popular in the village population also. And because of what, a lot of people remains with the hidden diabetes, which is not usually caught when we do not know the people. Obviously, we do not treat them, and many of those people reach to the complications like kidney failure, like cardiovascular disease, much earlier than their urban counterparts. So if we look for the risk factors of the type 2 diabetes in the rural India, of course the socio-economic factors remains the biggest base for that, which is incorporating the limited healthcare access, poor health education. At the same time, people, those who are living in the lower socio-economic strata, are suffering more with these lifestyle diseases like diabetes and hypertension as compared to the others. Of course, the physical inactivity, changing dietary pattern, genetic predisposition is common with the urban population. But the additional risk factors which are getting more and more troublesome, like tobacco and alcohol use, poor education level, people don't know about their disease, so whenever their diabetes level comes to the normal, wherever glycemic level comes to the normal, they stop the treatment. Obviously, the diabetes self-care essentials, which includes the healthy eating, healthy coping strategies, problem-solving skills, regular physical activity, blood sugar monitoring, medication adherence, these are very poorly followed by the rural population. But most of the time, the biggest challenge comes to the blood sugar monitoring and medication adherence, because most of the people doesn't know about their diabetes. Obviously, the monitoring is not that much good, and at the same time, as I said, they stop their medications once they become the normal glycemic. If we look over this rising prevalence of the diabetes in the rural India, you can see here this rural India diabetes is following just the urban India, and it is 10 years ahead of the urban India, or you can say 10 years behind of the urban India. So when in 1990, 5.5% was the prevalence of the urban India, the same prevalence we could achieve in the rural India after 10 years in 2000. 8.1% was the prevalence at that time in the urban India. We could achieve the 9.1% prevalence after 10 years in 2010. And similar, you can see same prevalence which was 12.4 in the urban India, which has been achieved by the rural India after the 10 years, 2020, about 12.5%. So this is the trajectory, very interesting trajectory of the population which is rising towards the diabetes. So regional variations which you could know about the ICMR in diabetes studies, that southern regions are having more prevalence for the diabetes, northern regions are having comparatively lesser prevalence of the diabetes, but despite there is a disparity, like J&K is having 26.5% prevalence in the urban area and 14.5% prevalence in the rural area. Similarly, the Goa is having around 26% prevalence. Central and northeastern region, if we talk about, they are having relatively lower prevalence states, highlighting the need for the region-specific diabetes intervention. So as I already said, that a lot of undiagnosed diabetes is behind the hidden crisis. 36.7% percentage of the rural individual with diabetes who remain undiagnosed compared to the 22.8% in the urban area. 2.3 times increase also the having undiagnosed diabetes for rural residents compared to the urban counterparts. And if we talk about the treatment gap, 2.3 times treatment gap of what we could see with the rural participants, but 2.3 times more likely to have untreated diabetes than their urban counterparts because of the less exploration, less known about their disease status. So national control rates, if we look forward, that it is reported that only 7% of the individuals with diabetes in India have the condition under control, with the rural population having even lower treatment and control rate. This poor control significantly increases the risk of developing serious complications that can severely impact quality of life and increases mortality risk. The reasons of obviously the awareness gap. If we compare it with the urban awareness, we have the rural awareness much lesser than that, 33.7%, the urban awareness with the rural awareness 23.9%. Financial burden, annual cost of the managing diabetes in India ranges between 8,000 to 46,000 in a year, creating significant financial strain for the rural population. Treatment disparity, of course, the urban treatment rate is 27.8% and rural treatment rate is much lesser than that, 17.7%, that highlights unequal access to the diabetes care. Only 45.2% of the rural individuals with diabetes have access to the adequate diabetes care compared to the 68.5% in urban India. So states with lower human development indices have higher proportions of undiagnosed diabetes and poorest diabetes care. The cost of regular glucose monitoring, medication poses a significant financial burden for rural population, leading to a delayed and inadequate treatment. This is again a very interesting chart to show before you. If we look for the poorest level of our poorest population of our society and compare it with the richest population of the society, you will find there is a 14.1, there is a big gap in the awareness. 14.1% is the poorest population is aware about the diabetes, 37.3% are aware of the richest population. And 9.9%, almost more than half of them are taking the treatment. And around half of them are getting control. But if you go for the richest population, you will find that about 75% are taking the treatment, but only 1/4 of them are getting control. So this is the biggest, you can say, paradox scenario. in rural, difference between the rural population, sorry, I must not say rural, poor population and richest population of the country. So if we talk about the rural area and the limited healthcare infrastructure, we have the 80% percentage deficit, 80% deficit in the required community healthcare centers in rural area, 31.4% rural sub-centers, which are 52,116. They are lacking proper infrastructure with no dedicated buildings. And most important thing, our specialists are much short. 4,413 specialists are there in our country, which is much lesser than the required number, which is 21,964. So one of the biggest hurdles in the rural diabetes care is limited access to the healthcare facilities and specialists, the shortage of trained endocrinologists, diabetologists and diagnostic facilities in rural areas, delays diagnosis and treatment in initiation. Elderly residents in rural area were 7 percentage points less likely to utilize healthcare services compared to their urban counterparts. So key government initiatives which have been started for the diabetes management. In 2025, we could see that Ministry of Health and Family Welfare aims to screen and provide standardized care for the 75 million individuals with diabetes or hypertension by 2025, integrating diabetes management into the primary health care. National Program for the Prevention of Control of NCDs. This is running for a long time, and we know that it has expanded to include over 700 districts, NCD clinic emphasizing infrastructure, strengthening health promotion and awareness campaign. Ayushman Bharat Health and Wellness Centers, free medications and generic drug access. A lot of hospitals are giving the free medications to the diabetes individual. Apart from that, a lot of low-priced medicine centers have been established by the government, Jan Aushadhi Pariyojana, Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana, a lot of other names with that. Apart from that, there are individualized efforts also, organizational efforts also, like Rural Diabetes Initiative. Rural Diabetes Prevention and Control Campaign, which has been started. Coming? Yes. Right. Rural Diabetes Prevention and Control Campaign, which has been initiated in 2021. This campaign focuses especially on diabetes prevention and control in rural areas, exemplified by its launch in the Purana Ramnagar village, Varanasi, and this activity has been done by the RSSBI Uttar Pradesh chapter. Another activity, the Chunampet Rural Diabetes Prevention Project, which has been started by Dr. V. Mohan, and in the morning he was saying that he is going to have a big presentation on this under this year ESD. And this project implements comprehensive diabetes screening, prevention and treatment using a combination of telemedicine and personalized care in rural area. And really, this could be the place where we can get the inspiration for our rural outreach program of the RSSBI. RSSBI Village Adoption Program, which has now the name given to the Rural Outreach Program of the RSSBI. And this is started in many in Uttar Pradesh and few more states, but now we are taking it up in a comprehensive and structured manner with the SOPs in all the states, and very soon we shall start in Tamil Nadu also. Apart from that, there is a lot of increasing awareness and education is required for that. The community health program, which are combined with the local village events, local health fairs, radio broadcasts to educate the people for type 2 diabetes symptoms, prevention and management. Local language resources, it is again an important thing because India is a country where we can see the unity in the diversity, and this diversity really could be very much helpful in the disease prevention if we can do our work in the local languages, which may be better understood by the population. Training and local health workers like ASHA, Anganwadi workers, community health volunteers, basic knowledge of diabetes to help villages recognize symptoms and adopt preventive lifestyle changes. Effective education must emphasize medication adherence using visual aids, reminders and educational workshops to ensure patients understand the importance of taking medication regularly. Expanding the screening and early detection like mobile screening camp, point of care diagnostic, household screening program, region-specific approaches could be made. Strengthening the primary healthcare infrastructure, this is the biggest need of the hour, because in our country, tertiary healthcare is very, very strong that other countries are also going to attract towards our country. But as far as the primary healthcare infrastructure is concerned, this is really very poor, where we cannot manage even a patient of diabetes, and where we cannot detect a patient of diabetes, people are not having enough awareness made with the primary health care center or community health care center. So reliable glucometer testing, supply basic laboratory facilities for the HbA1c testing, consistent supply of the essential diabetes medications, and educational material in local languages. All these things are needed to be done. But more important, making the people educated and more educated. Last few years, I had an experience in Uttar Pradesh when the new government came. It has made available a lot of new insulin analogs in all the primary health care centers. But no one was knowing to use that, so they remained kept there for 1.5 years. Nobody has started using them. They continued with the conventional treatment. Then they requested us to give them the education, and we started the educational workshop for them. So what is the most important? If the person knows that what is needed, then only he can start that particular treatment. Of course, the telemedicine integration, it is one of the most important things. And in South India, I have seen that Dr. Mohan in Chunampet and Dr. Jyoti Dev in Kerala has used this thing very nicely. Even before we were using, and we have been introduced to this telemedicine during the COVID period. Promoting lifestyle intervention by culturally tailored diet and its counseling in the people, those who are having their cultural beliefs. Physical activity programs are to be more and more popular. Engaging local influencers, like we can use village leaders, sarpanch, and we can use gram pradhan, we can use spiritual leaders, like in Uttar Pradesh, the village adoption where we have done. One of the spiritual leader of that locality has given his ashram for running the centers there, and at the same time, whenever we do activity in the village, we always involve the gram pradhan and sarpanch in our team, so that people listen better to them. So lifestyle intervention should discourage consumption of refined sugars and processed carbohydrate while promoting traditional healthy diet. It's not necessary to celebrate each and every event with sugary items. Culturally appropriate dietary recommendations are important. Not going into the details because of the paucity of time. Improving medication access and affordability can be done by the help of the government and government subsidiaries, which are already in the process. But what we can do with the public-private partnership, what we can do with the non-governmental organization and our organization like kind of the RSCI. Affordable access to the diabetes medication, insulin is crucial for effective management. We can really help them reaching to them, to every beneficiary. It could be the most needed things to be done. And enhancing monitoring and follow-up, that is by the mobile health solutions, implementing the SMS-based reminders and mobile applications for medication adherence, telemedicine use, as already discussed, peer support group, like establishing the local diabetes support group where the patient can share experiences, exchange knowledge, and motivate one another to maintain healthy habits and treatment adherence. Regular monitoring and follow-up are essential, and that can only be encouraged by using all these things. Leveraging policy support, integrate with national program, incentivize the healthcare workers by one way or another way. Data-driven approach, develop a national diabetes registry for rural areas to monitor disease trends, evaluate the effectiveness of the interventions, and inform future policies which are based on the real-world outcome. Policy support is crucial for creating sustainable improvement in rural diabetes care. And RSCI kind of organization help the government by creating those policies, by integrating diabetes management into existing health program, incentivizing the healthcare workers and adopting the data-driven approaches. Policymakers can maximize the impact of the limited resources and ensure that interventions are targeted and effective. But for that purpose, RSCI should be very much active in collecting the data, getting the data from across the country to help making the policies. Community engagement strategies with village health community, health-focused community event, school-based program, trusted leaders involvement, technology-enabled solutions in the form of the digital health record, AI-assisted screening would also be helpful here, and addressing the gender disparity. India is known for the gender disparities, and we need to help the population, supporting the women-specific challenges, especially in the diabetes. Women diabetes is very much different to handle. And a lot of things are there which are required to be taken care when we are looking for the control of diabetes in the women. So we should be more and more empowering female caregivers, and we should be more careful about the women-led initiatives and women-specific challenges. Addressing diabetes in the elderly rural population, again, this population is increasing nowadays in our country. Now, life expectancy has gone up in our country, and we can see that a lot of people are having forgetfulness, Alzheimer's in the end of their disease, and they are to be treated very differently. They are not staying with their families, they are staying alone. So integrating traditional and modern medicine would be very much helpful here, evidence-based traditional practices, combining with the collaborative care models where we can see that the traditional practices should be combined with the modern medicine, like I discussed sometimes back in Dr. Mohan's meeting about the functional food. If we can take up the help of the functional food, combining with the modern medicine, it can definitely help our people keeping more and more healthy, and can help in the prevention also. So conclusion, the path forward could be the urgent public health challenge to be taken care of very seriously, and this diabetes care in rural area remains significant public health challenge requiring long-term sustainable intervention tailored to the unique needs of the rural population. The increasing prevalence highlights the urgent need for improved screening, early detection, and accessible treatment options. Region-specific strategies to be made across the country, because everywhere the diabetes is not the same across the country, and collective action is required. The future of diabetes care in rural India depends on the sustained effort in innovative healthcare delivery models and collective action from both and public and private sector, ensuring that no community is left behind in the fight against diabetes. So by working on these three parameters, I believe in the next few years RSCI will be contributing to the diabetes population of the country in very positive manner, and probably we could be able to reduce the increase in prevalence of diabetes, as well as we can stop a lot of our population going into the complication. Thank you very much for your kind listening.
So thank you. We are running short of time. Thank you. At the outset, I would like to thank all this greatest session of this conference, Professor Jay sir, Mohan sir, and Anu sir. Thank you. Any questions in the audience? And over the Rajendran sir, any questions?
Thank you, Dr. NH, for having highlighted the problems faced by the rural people with reference to that the number, with reference to that the socio-economic status, with reference to that the diagnostic inadequacies, and with reference to the management deficiency, and with reference to that the follow-up. And over a period of time, I think that the scenario is getting changed with reference to the lifestyle in the rural area. In no way they are inferior to the urban areas, because the logistic improvements have occurred, and the things is totally different in the villages nowadays. Even that the socio-economic status, their per capita income is also has increased. In this juncture, I would like to point, because you have elaborated that is the role of that the private to public partnership, and what is your plan as a president-elect to do it on behalf of RSSDA, how to counter that the increase in the number of the diabetics. Already in the state of Tamil Nadu, that is, they are already having a program called Makkalai Thedi Marutvam. That is that the people, the government goes to that the doorstep of the peoples. They deliver that the anti-diabetic drugs and anti-hypertensive drugs for 1 month free of cost. Number two, our healthcare personnel, they also periodically go to the people and check that the blood pressure and that the blood sugars by that the glucometer. With this, according that is, of course, this is being happening for the last couple of years. Certainly, there is a decrease in that the complications at least. We are not able to decrease that incident. At least we have decreased that the complications. Because as you said, that is RSSDA combines with that all that the state government, of course, your dream will come true. The date is not very far away. Thank you once again for your elaborate lecture. Thank you very much.
Thank you, Chairs, Dr. Rajendran and Dharmarajan, sir. Any queries in the audience? We will allow 5 minutes.
Here one thing I would like to say, as sir has said, that we should, he said about the free medications of the 1 month for the hypertension in some project what he is running. We are not really going to pre-medications to be implemented in this project because pre-medication gives an idea to the beneficiaries that their health is our responsibility. They should understand that their health is their responsibility. We should try to reduce the expenses of the monitoring. We should try to reduce the prices of the medicine. We can try to make them available at some low price store. But it should never happen that we should give them free of cost. If you give them the free of cost, sometimes if your supplies did not reach and it has been delayed even for 1 week, people won't take the medication for that 1 week. They will wait that after 1 week once it will come, then we will take. So keep remember that at the same time we should also generate a self-reliance among the population of our country because now such a big population is going to be diabetic in the coming future. 35% has already suffering with the hypertension for which you are talking about. How can you make the 35% people dependent on the free medication or some subsidiary which is either coming from the government or coming from some NGO or something like that. We should support, we should make them a self-reliance feeling in them that we should avoid disease, we need to control, we have to do something for that. It is not the responsibility of the doctor or NGO or government.
Thank you, sir. I think we can move to the next session. Thank you for an elaborate discussions. Thanks a lot.
Thank you for kindly.
Once again, I thank all the speakers and also thank the organizing committee for giving us this wonderful opportunity. Thank you very much.
Thank you, sir. For the next session, I would like to invite Dr. Srinivasan and Shanmugam sir to chair the session as chairpersons. And the speakers would be Dr. Krishna Sheshadri and Ravindranath sir. Over to chairpersons.
Okay. Good afternoon, everyone. As you all know, type 2 diabetes is epidemic in India, and we are leading in the diabetic population as well. And this is mainly because of lifestyle problems, and eating is one of the important factor which plays an important role for obesity, insulin resistance, and other comorbidities as well. Whenever we ask a patient about their eating habits and ask them to எவ்வளவு இட்லி சாப்பிட்றீங்க அப்படின்னு கேட்டால் they used to say 6 இட்லி அப்படிம்பாங்க. கொஞ்சம் கம்மியாக சாப்பிடுங்க அப்படின்னா இல்லை 6 இட்லி கூட சாப்பிடாம எப்படி சார் இருக்குமாங்க. So there is some problem there in eating, and Dr. Krishna Sheshadri is here to tell us why they eat more than they need. Over to you, sir.
Thank you. Take it up. Can you hear me? Okay, thank you very much. Here's my conflict of interest. I do have a weakness for food, especially when I come to Coimbatore. I run off the Anandas or Annapurna to get Ekliya. Hello? Take it on. Okay. Right. Let me start with the Tiruvallur, of course. Tiyalavinri Theriyan, Peridunni. Tiyalavinri Theriyan, Peridunnin, Noyalavinri Padum. Whenever time deduct பண்ணீங்கன்னா திட்டுவேன். போயிடுச்சு. ஸ்லைட் போடுமா? Just for those of you Hello? Those of you who read Tirukkural, one suggestion is please use the Parimelazhagar Surai, because without Parimelazhagar you can't understand Tirukkural. All the others are just, explanation. But if you listen to Parimelazhagar, he will tell you, தன் பகுதியும் அதற்கு ஏற்ற உணவும் காலமும் ஆராயாது வேண்டியதோர் உணவை வேண்டியதோர் காலத்து வயிற்று தீ அளவின்றி ஒருவன் உண்ணுமாயின் நோய் அளவு இன்றிப்படும். I have never seen, whenever you read Tirukkural, please read Parimelazhagar, because without it, I always think Tirukkural is a sutram. It is not a marai. Marai means மறைத்து சொல்வது. Sutram is a small two-line thing to give you a hint on what to understand. And without Parimelazhagar, it's difficult to understand Tirukkural. So how do we eat? When you think about eating, there are two reasons we eat. One is well-being, which is promoted by the body's sensors, and reward. Otherwise, we won't feel like eating. And these are maintained by some drivers. One is desire, the second is the emotion and the cognition that goes with it. The third is the body's metabolic and homeostatic sensors. And lastly, we are increasingly learning about it, and something that I keep talking about all the time is the clocks are internal and external clocks. Now, the most important part of the metabolic and the homeostatic sensor is to promote well-being. The most important part of desire and cognition and emotion is to provide a reward sensation. Right? Now, remember that the metabolic and homeostatic sensor also works through the desire, and it can also promote reward. Why? Human beings need a motivation to survive and do things. That is why eating is wired in as a reward. And I'll show you other examples as we go in. Now, there are two other concepts that we need to understand. Memory. For example, your mother would all the time, whenever you ask for food, give you bread. As you get older, you said, சின்ன வயசு முழுக்க பிரெட்டே சாப்பிட்டு வளர்ந்துட்டேன், I don't want bread anymore. That's memory. Your aversion or your desire based on a childhood memory. I talk about it. And of course, wiring. Why are we different? Because we are all wired differently. Now, this is run by 5 important concepts of what happens when you take food. One is our sensations. In Sanskrit, indriyangal. Right? And then perception. So you take these both together, it becomes karmendriyam and jnanendriyam. Then anticipation. Sometimes, the other thing that we all do for reward is basically more anticipation than the actual act. The anticipation of love, the anticipation of somebody. காக்க வைப்பதில் சுகமுண்டு, காத்திருப்பதில் சுகமுண்டு, காக்க வைப்பதில் சுகமுண்டு இல்லையா? அதே மாதிரி anticipation is a desire, is a pleasure of its own. Ingestive. As you eat, there are signals and of course metabolic. Now, the metabolic and the homeostatic work pretty much through sensory and perception. And let's go through each of these. The external environment, two parts. One is food. The second is the cue for the food. It may be a thought, it may be a smell, it may be a sight. Right? But each of us is wired differently for food. Let me talk to you about a minute. One is genetic. Very interestingly, taste itself is very different. The first time I understood this was in the US, our department had a get-together, and each of us brought some food. And I had gotten to Diwan Street and then I made some food. But I bought some jalebis from Diwan Street. Everything was completely finished, but the jalebis were left untouched by the American friends at that time. They said, Dr. Seshadri, Indian sweets are too sweet for us. But much later you realize that how we perceive sweet depends on our taste receptors, and there are polymorphisms for these taste receptors. I just give you an example. This is a TAS1 promoter. There are elite polymorphisms that give us a difference in the way we perceive sugar itself. So Europeans have a lesser taste for sweet, and that's why your Italian and other sweets are not that sweet. On the other hand, you come down south, we have the payasams and this thing. I have a feeling it's also tropical, but that's very, very important. The second part is our epigenetic wiring, meaning what happens, for example, in childhood. For example, in the Netherlands, when they faced a lot of famine, people actually looked at it, that there were mitochondrial modifications that later brings about a hunger. For example, if this also has memory. For example, I remember very well, my father came from a very poor background. One of the things that would be important for him is that he eats well, and he also feeds the people around him. So it's somewhat epigenetic. But the third part, I'm sorry, I forgot to put that, is sex. For example, if you're a woman, you like sweets better. You ask women, they'll tell you chocolates are not sweets. Right? But men, yesterday we were sitting up in one of the rooms, and it's my fault. I had asked for Ananda's chips and mixture and everything. Just got finished in a minute. Men like salty stuff. Similarly, women crave sweets premenstrually. So there is also a sex-based or a gender-based wiring that's there. So this is one part. But let us look again, go back to Thiruvalluvar, because he helps us understand many things better than we do. Miginum kurayinum noi seyyum nulor vadimudala enniya moondru. This moondru is, and again you need Parimel Alagar, because he will interpret Parimel moondru as Ayurveda murai udayaral vada mudalaga ennapada moondru, meaning he recognized the wiring. When Ayurveda talks about Pitta, Vata and Kapha, they don't mean Pittam, Vatam and Kapham. It's a kind of genetic makeup. And the wiring determines how you respond to food. Okay? So I talked about these. Let's talk about clocks. Clocks have a very, very important way on how the metabolism is perceived, the homeostasis is perceived, and the reward is perceived. Let's give you some examples. So these are homeostatic inputs. So basically, from the time you start eating, there are stretch, there are endocrine cells, there are metabolic cells. All of these integrate in two places. One is the corticolimbic system, and then in the ventral hypothalamus. So ultimately what really happens is, in the ventral hypothalamus, there is a balance that occurs. On this side are the orexogenic peptides, which are NPY and CART. On this side, the anorexogenic peptides, which is AGRT, alpha MSH working through M4CR. So depending on the metabolic and the reward-based inputs, there is a determination of, do you want to eat? Should I eat? Or is there more to eat? Now, these are controlled both short-term and long-term. Short-term is by ghrelin. If I start talking about food, you start getting a little hunger. That's ghrelin working. On the other hand, the long-term sensors are leptin and insulin. Now, interestingly, till now we do not know the influence of clock on this. But it appears that the clock, the internal clock, what time do you eat, how do you eat, the internal clock, that sets it working at the AGRP neurons. So clearly, the clock bit is a very, very important determinant of how much you eat. You FAFO the clock, you start eating at all times, odd times, and eat more. So This is the neuroanatomy of food intake. There are sensory, perceptive, and anticipatory signals. These go to the corticolimbic system. Then there is the hindbrain which brings in the digestive and metabolic. These are integrated in the hypothalamus. All right? What happens next? How do we sense reward? Now, when you sense reward, there are two parts to it. One is feeling nice about it. That's endorphins. The second is a motivation to action. I may like something, but I need to go get it, right? I may like Aishwarya Rai, but my body says, no, you don't want to go get her. You'll get killed by somebody. So dopamine is the motivation to action. The opioid is the pleasure sensation. Right? And this motivation to action is a continuous process to get to eat. As you're eating, should I continue to eat? When should I stop eating is all determined by dopamine. So again, just to put this together. Now, to sort of bring this to a circle, there are two other parts, cue and trait. What is a cue? Basically, I talked to you about cue and I also talked about gender. The reward system is maintained at this particular part, the ventral tegmental nucleus, the nucleus accumbens, and the striatum. But also memory. I remember sitting in my home. My mother would make boli on today's Avni Avitam. I would take some honey and ghee with it. Long after my mother is gone, I would tell my wife, if I had that food today, I would be very, very happy. Isn't it? Chandelian Solma, life is very interesting. The beauty of life is youth. You spend the first half of your life anticipating it, and the second half of your life remembering it. It's all it is, it's memory. So the memory is at the hippocampus and amygdala. That senses a reward. If, for example, in your childhood, your father took you to Annapurna and you ate, anytime you come to Coimbatore, you say, let me go to Annapurna because that's where my father took me. Now, to whether you want to eat depends on four things. Whether you like it, whether you want it, have you learnt it, or is it a habit? So let's look at this. Whether you like it intrinsically is by the opioid receptor. But whether you like it consciously is at the prefrontal cortex. Liking is not just taste. It is condition. It is the environment. It is your growth. It is your development. Now wanting is basically dopamine. It's a mesolimbic dopamine system that is projecting to the nucleus accumbens. Now, but what happens, okay, I may like something, as I eat it, you know what, this morning I had a heavy breakfast, but I see Adapradaman there, but you know what, maybe I should not eat it. That is called devaluation, where your dopamine system is telling your opioid system, you know what, not a good idea. But some of us can't control that. So one more bout and one more bout in the wash basin. Learning is hippocampus. You know what? I was with Rajesh this morning. So I love hash browns. So I had hash browns ordered, but Rajesh told me, I gave it to him. Sir, no sir, if I have potatoes of any form, I will regret it later. So that is learning. But habit, okay, it doesn't matter. If I come to Coimbatore, my breakfast has to be in Annapurna only. It will be pongal, 2 puris and vada. That's my standard. Excellence is a habit. But I've said so many things about homeostasis, reward. All of this even animals can do. Let me talk about something. So far we've been talking about Western civilization and how they have understood biology. I'm going to talk about Eastern civilization and how we have understood the mind. Last part. The Western guys call it executive function. Our ancestors have a better word for it. It is called mana, indriya, mana, chitta, and viveka. The mind, the intellect, the self is the ego, but above all is discrimination. The senses tell you, this is fantastic, it's beautiful. Yeah, the mind tells you it may be beautiful, but it may have good or wrong. But the intellect can fool you and tell you, you know what, it may be bad, but nobody is looking, therefore let me go do it. But where does viveka come? The discrimination comes. No, even if nobody is looking, I shouldn't be doing something that is wrong. It is discrimination that is cultivated that allows us to overcome. When we go to the Western concept of no, we don't blame people, don't do this, I think we're going too far. Discipline is the most undervalued word in the world. It is cultivated, it is practiced, it is ingrained. Without discipline, there is no liberation. The Vedanta text will tell you that Chadushya Chatushtam, meaning, Sadhana Chatushtam, meaning, unless you have these four, you can't go to the next level. Similarly, if you want to overcome obesity, you want to overcome diabetes, you need to learn this viveka, the discrimination of eating. Whether we like it or not, obesity is largely a disease that has occurred because we have not learned how to eat right, on time, the right amount, and be able to say no when it's important. So, let me go back to Thiruvalluvar and then I'll close. Sendra idattal selavida thidori nandrin paal uittadu arivu pulattin nanmai theemaigalai aaraindu thiyadani neeki nalladan kan seluttuvathu arivu. What does he mean? Discrimination, vivekam. That viveka is what drives. And how do you get viveka? By practice. The Gita says, Abhyasatu kaunteyaha. It doesn't happen in one day. You'll slip, you'll fall, you'll slip, you'll fall. But each time you need to get up and learn. So with that, let me summarize. The wiring, the clocks, the environment contribute to the need and the reward sensation. Balancing them helps the metabolic sensors suggest our need to eat. And imbalance of any of these and all of these leads to disordered eating. Disordered eating leads to obesity, leads to diabetes. To summarize, go back to Thiruvalluvar and I'll use the Gita. Atral aravarindu unga. Adudambu petran nedi tuikum aaru. Aaru na vadi, Tamil. Not aaru, vadi. Mun undadu atral, pin unbadanai alavu arindu, alavitraga unga. How do you do that? By practice. Eat together. Take what you need. Think whether you need it. Think. And you will make mistakes, you will fall. This morning I had breakfast which I haven't had for many days. But I'll go back and I'll tell myself, you know what, you made a mistake today. Let me change myself. After all, we are not meant to be perfect. We have this lifetime and several lifetimes to become perfect. But we need to start now. To close, the Gita says it much better than anything else. Yuktahara viharasya yukya cheshtasya karmasu Yukta swapno bhavodasya yogo bhavati dushkaha. Rather, everything in life needs to be moderation. Yukta ahara, small amount of food, modest amount of food. Yukta vihara, even poi ellare anachi kattikannum illa, jaan vittu padagiradhu. Yukcha cheshtasya, at 40 I think I want to become a marathon runner. Doesn't make sense. Do the right amount of exercise and the right amount of sleep and dreams is a yoga that reduces unhappiness. So this is my little spiel on eating. I hope you have a good lunch. Thank you so much.
Thank you, sir, for your excellent talk. We'll have a discussion at the end, is that right? Yeah, later. Thank you.
I will call upon Dr. Ravindranath to give a talk on tirzepatide head-to-head with GLP-1 receptor agonist. Over to you, sir.
Thank you. A very warm good morning to everybody, and first of all, thank the organizers, Dr. Balamarajan and Dr. Rajendran and the scientific members for giving me this opportunity, and thank the LLE for the nice opportunity given to me. Now, my topic is tirzepatide head-to-head with the GLP-1 receptor agonist. After listening to Dr. Krishna Sesha's lecture, probably Thiruvalluvar will become the first enemy to Delhi. So, let me go to the topic now. Tirzepatide is a dual GAP and GLP-1 receptor agonist, recently introduced by LLE group. The prime aim of the study is to analyze the mechanism of action of the tirzepatide molecule and the clinical trial data, what they have given, and to analyze the tirzepatide molecule with semaglutide in 2 trials. One is a SURPASS-2 trial and the other one is a SURMOUNT-5 trials. Both are, one is looking after the glycemic reduction and one is looking after the weight reduction. So this is the main thing that I'm going to talk to you, this topic. This is the disclaimer and the rules and regulations of the Lilly Group. This program is sponsored by, and speakers are presenting on behalf of the Lilly Group, and disclosures. Yes. GIP, the forgotten hormone for a long time. You have been seeing the molecule GLP-1 for a long time, pretty high, more than a decade back, we had the GLP-1 molecule. Initially, about 30, 40 years back, what we had, the incretin system, so that is the insulin secretory capacity, was mainly governed by 3 main hormones. One is the secretin, and gastrin, and cholecystokinin. So these are the 3 things that we were modulating those days. And of late, we came across these 2 specific peptides that acts upon the GLP and GIP. Though the GIP was discovered in 1970, and the GLP was discovered only on 1980, 10 years later only, but this GLP-1 receptor only agonism only has gained momentum because a lot of trials were undertaken on GLP-1 receptor agonists than the GIP for no reason. We do not know why they have not done much research on the GIP, and now that Lilly has come out of this thing. So to say, which hormone is best, whether the GLP-1 receptor or the GIP is best, this is one of the million-dollar question, which they have got some answers after doing some researches and clinical trials. So they were analyzed whether the GLP-1 acts very nicely or the GIP-1. Further, what they have done is they have given a 75 grams glucose load to the patient, and they given a GLP-1 receptor antagonist extendin for a patient. And another trial was done, the GIP, to analyze the GIP effect. The patient was given a OGTT and given a GIP receptor antagonist, that is a GIP amide groups. So they seen the glycemic output, how the glycemic controls are there, and how the insulin sensitivity has improved, and how the glycemic excursions has occurred. On seeing this, they found out that the GIP has got a better effect than the GLP-1 with respect to what I have told you, with respect to the glucose reduction, insulin sensitivity, or the glycemic excursions. But of late, again, they have done with the IV glucose tolerance test, where they found almost equal effect. Both the hormones, GIP and GLP, has got same type of glycemic reductions in this IV glucose tolerance test. So to say, both the molecules has got almost the same type of actions on the glycemic reduction. What happens to the weight reduction on actions of the GIP, and some other aspects also is now gaining momentum with the GIP. So what they say, both the molecules, GIP and GLP, both are step siblings. They're called as step siblings rather than the monozygotic twins. They got almost same type of actions, but subtle differences are there. And coming to the proposed rules of the GIP and GLP, both activity, GAP activity and GLP activity. GAP activity is almost similar to the native GAP hormone, whereas the GLP activity is less pronounced than the native GAP. This is the main aspect that we have to understand now. And coming to the central nervous system action, both they got an action on the reduced food intakes, no doubt about it. Both has got a suppression of the appetite system, no doubt about it. But GAP has got something extraordinary in that these GAP systems, they got peculiarities in that they are almost pronounced in the various regions of the CNS systems. They're expressed in almost all the CNS tissues than the GLP molecule. They are present where the GLP is there. They are present where the GLP receptors also are not there in this. So these are present widely in the CNS concept. And second thing, they are easily able to cross the blood-brain barrier because their actions are more pronounced with the arcuate nucleus, where the arcuate nucleus and the other nucleuses like a ventromedian or dorsomedian or the lateral nucleus or the paraventricular nucleus, everything is situated near the blood-brain barrier, where the blood-brain barrier is incomplete. So that there's the easy diffusion of glucose, insulin, leptin and other things are very easily possible. Thereby, the GP also easily can enter into the circulation via the incomplete blood-brain barrier and act on the arcuate nucleus. This is one of the things that has got a more pronounced action for the reduced intake of food. And of course, if we come to the nausea also, GAP has got a decreased nausea vomiting sensation than the GLP. GLP has got a increased nauseating feeling, but here the GAP action is bit less. Decreased nauseating feeling. So that's why when these two molecules are combined, the nauseating feelings are very less and the patient's complaints improved. That is why there was a greater reduction of body weight when these two molecules were combined. Then coming to the pancreatic system, there's an increased insulin secretion in both the hormones, GAP and GLP. But if we see the GAP receptors, by means of the virtue of the presence of the diacyl fatty acid chain, that prolongs the half-life period. Along with that, it has got some more action also of insulin secretory effect also, and increases the insulin sensitivity also. And of course, one more thing we have to notice is a weight independent factor. Because in weight dependent factor, we got an insulin sensitivity. But this molecule has got a weight independent action. And both the molecules, when they combine, they got some more pronounced action on the beta cells. What is that? It has got an increased gene expression. And of course, you can see the other things, the PDX molecules, that's the beta cell enhancing action factor. That is also increased with the GAP molecule. And of course, the prolongation of the beta cell's life, the beta cell survival also is much more with the molecule. So this is the subtle difference with the GAP and GLP with respect to the increased insulin secretion. And second thing coming to that, increased glucagon in a glucose-dependent way. That's the peculiarity of this hormone. GLP-1 has got an insulinotropic action. It increases insulin secretion. Of course, some amount of glucagon suppression is also there. But with the GAP, if you see, it has got an insulinotropic action and gluconotropic action also. When the sugar levels are high, the insulinotropic action takes over. When the sugar levels goes down to hypoglycemia level, the gluconotropic action is more pronounced. So it has got both insulinotropic and gluconotropic action. So all these actions are almost more or less similar to GAP and GLP activity. What it differs is only from the adipose tissue. See, adipose tissue action is at GAP levels are very, very pronounced, and GAP tissues are more expressed with these GAP receptors more. So as a result, it has got an increased blood flow, and increased insulin sensitivity, and increased storage capacity also. By means of this, the storage capacity of the adipose tissues are increased. And with the result, it has an increased lipid buffering capacity. What happens when the food is ingested, large amount of food is ingested, we get the triacylglycerol more. And GAP has got a tendency to increase the lipoprotein lipase activity. When this LPL activities increase, what happens? The TAG, that is a triacylglycerol, is broken down into fatty acids and the glycerol. And these fatty acids enter the circulation. Once it is utilized, and the rest of the fatty acids are stored in the adipose tissue. because of the help of the GAP hormone, which has got a tendency to imbibe more amount of, the adipose tissue has got a more tendency to imbibe the fatty acids into this as a storage. It's a storage site. Adipose tissue is a storage site for the excess fatty acid substances. So it stores, and whenever it is needed, it is released into the circulation. So it is got such a beautiful lipid buffering capacity with respect to the GAP hormone activity. Of course, even the reduced pro-inflammatory immune cell infiltration, when the cells enlarges, the adipose tissue enlarges to a greatest level, and no longer it can accommodate the fatty acid, what happens? Immediately, the pro-inflammatory cytokines enter into the site, and it will destroy the adipose tissue, and it will cause a fibrosis and cell death. So this will be prevented by the GAP hormone. So these are all the extra benefits that the GAP hormone has got with respect to the adipose tissue level. And if you see the unique action of the GAP at pancreatic level also, the contribution of insulin secretions is by all these three factors. One is the substrate absorption, which amounts to almost 33%. And with respect to the GLP-1, it has got 22%. See that hormone GAP, it has got almost 44%. So contribution of insulin secretion is more with the GAP than with the GLP hormones. Of course, you can see not only with the contribution of insulin secretion, but also the insulin mediated glucose clearance is also very good with the GAP hormone. So having said about all these things, the beneficial effects of the GAP with respect to the central nervous system action, pancreatic action, and then adipose tissue action, let us now go to the trials, what they have done. So these company people, they want to have a trial, head-to-head trial with the other GLP-1 molecule, semaglutide. What they have done, they have done two trials, head-to-head trials. One is how the molecule is superior in glycemic reduction, and how this molecule is superior to in the weight reduction. So these are the two parameters they had in their mind, and they focused on these two trials. So let us go to the case history. The Anjali, she is living with obesity without type 2 diabetes, non-diabetic obese individual. Why should we consider Mounjaro for your patients? This patient has got a triple tried with the multiple times of the weight reduction programs, and successful at losing weight and maintaining a weight reduction over time. So what we are going to consider for this Anjali, whether you're going to put her on GLP-1 receptor agonist or this tirzepatide molecule, dual GAP and GLP. So what you are going to do for this patient, non-diabetic obese individual who has been unsuccessful in weight reduction programs and other by means. So this is done in the SURMOUNT-5 head-to-head trial, where this trial is a phase 3 multi-center randomized parallel arm open label active comparator control trial. So this trial has got two arms. One is a Mounjaro, and the second is a semaglutide arm. And the people selected were the obese patient with a BMI of more than 30, non-diabetic patient, BMI more than 30 or BMI more than 77 with some comorbid conditions of the obesity, like hypertension or dyslipidemia or sleep apnea syndrome or even the cardiovascular disease. So these are the things the patient is selected. The secondary endpoints they have, the exclusion criteria they have done is the patients with the weight reduction programs that they have attained, whether the patients have attempted any weight loss programs or going for any surgical procedure interventions, all excluded from the criteria. So they have done this trial with a slow escalation of these drugs. So Mounjaro was given the total targeted dose was 15 milligram, but they didn't give it 15 milligram at the stage initially immediately. Why so? It means initially when this molecule was invented, that molecule was compared with the dulaglutide molecule. It was 1.5 mg of dulaglutide was compared with 15 mg of tirzepatide directly. And so patients went for severe vomiting and severe weight loss and a lot of side effects. So what they thought, okay, this molecule cannot be given at a loading dose of 15 mg. We had to slowly up titrate the dose from 2.5. So that's why that all the trials have conducted with a slow escalation of doses from 2.5, 5, 7.5 and 10, so 12.5 and then 15, 10 or 15. So like that they went to each 2.5 milligram of increment every month. And the same thing happened with the semaglutide also. They are given 0.25, 0.5 and 1 and 1.7 and 2.5. So this is the way they updated the dose of the semaglutide and the tirzepatide. So this Mounjaro and semaglutide were administered subcutaneously as an adjuvant to the reduced calorie diet and increased physical activity. The primary endpoint, percentage of change in body weight. They want to assess the body weight mainly. So they have gone to the trial data. We'll just see this. What happened at the end of the 72 weeks of the trial. So Mounjaro has, at the maximum tolerated dose, demonstrated superior reduction in the body weight compared to the semaglutide molecule. Almost you can see 21.6% of body weight reduction seen with the Mounjaro, whereas in semaglutide arm it is 15.4% of the reduction at the end of the 72 weeks. Yes. So whether it is only the weight reduction that has occurred, it's not only that, but 1 in 3 participants taking Mounjaro achieves more than 25% of weight reduction. 1 in 3 patients, 25% of weight reduction. Whereas in semaglutide arm, 1 in 5 persons only taken, they have reduced to almost more than 25%. So with respect to semaglutide, tirzepatide has got an edge over the molecule of almost 1 in 3 patients achieved more than 25% of the weight loss. Of course, not only the weight loss, even the waist circumference is also much reduced with the tirzepatide molecules, almost 20 centimeters. See that, 7.9 inches. They wouldn't have gone. Almost all the dresses would have gone, definitely waist. They would have changed to all the new dresses only. So waist circumference has gone almost 20 centimeters less. Waist circumference has gone down drastically. So the BMI has reduced. Even 1 in 3 patients achieved with the weight reduction of more than 25%, and waist to hip ratio also much reduced. So with these trials, they have concluded that tirzepatide molecule is not only inferior, but also it's superior to semaglutide molecule with respect to the weight reduction. Now, the second trial, that's the SURPASS 2 trial. So far we have done about the weight loss. Now we will see how the glycemic control is superior with the tirzepatide molecule when compared to semaglutide molecule. So Janvi, she is concerned about her future with type 2 diabetes. She is concerned about unsatisfactory HbA1c control and future implications of her excess weight also. So she is concerned with both aspects, not inadequately controlled blood sugar level and also the weight gain also. So why should you consider Mounjaro for this patient instead of other GLP-1 receptor agonists? What are you going to choose for this patient? She is concerned about glycemic reduction and even weight loss also. This is done with the SURPASS 2 trial. They compare these two molecules, head-to-head trial. So the patients, type 2 diabetes patients with A1C of more than 7 to 10.5 was chosen. The baseline BMI was more than 25. And the secondary endpoints of the exclusion criteria as well. The patient with any retinopathy was not selected. They were excluded from the thing. EGFR of less than 40 was excluded. So these are the exclusion criteria. With this trial, you can see overall mean baseline A1C was 8.3 and mean duration of diabetes is 8.6 years. Baseline BMI is 34 kg per square meter, and the patients enrolled almost 1,879. It was 1:1:1:1 ratio. They formulated 5 mg, 10 mg, 15 mg of tirzepatide 3 arms, and the fourth arm is the semaglutide molecule. As I told you, the same type of dose escalation was done. 2.5 starting with every month, increasing to 2.5, attaining up to 15 mg. Semaglutide also 0.25, 0.5, and then 1 milligram they're gone. So the primary endpoint was mean HbA1c reduction, change from the baseline, and secondary endpoint was a weight reduction also. And of course, how much of 10%, 15%, 20% weight reduction has occurred. All these things came as a secondary endpoints. So the results were, there was a superior mean HbA1c reduction across all the 3 doses of tirzepatide molecule versus the semaglutide molecule. You can see 5 mg has reduced to 2.1, and 10 mg 2.4, and 15 mg 2.5. Semaglutide is almost reduced only 1.9. So even the lowest maintenance dose of tirzepatide 5 molecule demonstrated superior mean HbA1c reduction versus the semaglutide molecule. Even the least dose of 5 mg has got a more reduction of HbA1c than the semaglutide arm. Of course, significantly more patients achieved with all the doses across the semaglutide molecule, and superior mean weight reduction also has occurred in all the 3 doses of molecule. So superior weight reduction that did not plateau over the study period of 40 weeks with the semaglutide. You can see the study period of reduction that doesn't attend any plateau. So going on reducing with the tirzepatide molecule. Of course, the more patients achieve the composite treatments also. 5 mg, 2 mg, 10 mg, 15 mg, almost 32, 51, 60%, and semaglutide is 22%. So if you see the tirzepatide 15 mg, almost 3 times that of the semaglutide molecule it has achieved. So what are the adverse reactions? You know, all these things are common: nausea, constipation, diarrhea, vomiting, fatigue. All these things are almost common with almost, they compare with the Mounjaro with the semaglutide molecule is almost same only, except the vomiting is slightly higher with the Mounjaro group 10.4 and semaglutide is 12.1. But other adverse reactions are almost same with the SERMON 5 trial. The overview of AE reactions also almost the same with the TAEs and the SAE, serious adverse reactions and other things. The most AEs are the nausea, diarrhea, vomiting, dyspepsia, decreased appetite, constipation, abdominal pain, which is common with you expect with all type of GLP-1 receptors. So summary: tirzepatide MT demonstrated superior weight reduction. Tirzepatide demonstrated the superior HbA1c reduction. So weight reduction was more with the tirzepatide molecule when compared to semaglutide molecule. Of course, instead of hypoglycemia is very less with this molecule. And going back. Yes. Now, the starting dose, we had to go from 2.5, step up slowly as I told from the studies. And probably if the patients are already on metformin, metformin and SGLT2 can be continued, but the patients on sulfonylurea and the insulin, the dose has to be reduced, and no dose adjustments needed for the age, gender, and no dose adjustments required for the people with hepatic or renal impairment. Only thing, ESRDs and severe hepatic impairment, the drug should not be given. Acute pancreatitis, pregnancy, breastfeeding to be avoided, and even patients with retinopathy also, who is request treatment, should be avoided. And if you can see how you are going to manage eating small amount of foods for the patients you are going to tirzepatide prescription, you have to give this kind of
Can you conclude, sir?
And what is your patient's?
Ravindranath sir, it's almost time. Can you conclude, sir, within 1
Yes.
or 2?
Thank you.
Thank you, sir. I would like to invite Krishna sir for the discussion. Please, Ravindranath sir, please join us in the desk. The floor is open for discussion if you have.
Are there any questions for the audience? Meanwhile, I would like to ask Dr. Krishna sir about, see, you've explained very well about why we eat and our desires and things. Is it really possible to make our eating habit change without pharmacological intervention?
Absolutely. So, two parts. One is pharmacological intervention is to, it's like going and drowning in the Ganges, I mean, taking a bath in the Ganges. It is to pay for your old sins, right? It will help you bring your weight down. But ultimately, if you want to escape the clutch, but also remember, pharmacology is a subscription model. It is not a buy and forget it model. It is a SaaS. It is obesity control as a subscription. You have to pay for it for the rest of your life. But if you notice all these studies, they will tell you that when you stop the drug, your weight goes up. What they don't tell you is, there is a subset of patients who only gain weight minimally, including the SURMOUNT 3. There are people who will not gain weight. What has happened in them? They have learned the way to change their life. So after your weight is lost, you have learned a discipline to maintain weight. Why should you gain weight? But it takes an effort.
Next question is a follow-up question from him. Actually, whenever you try to start a patient on tirzepatide, the next question they ask is how long to continue. And you said that they develop a habit after taking this to change their habits, stop eating or eat less. How long do you think you need to continue the medication to make them realize?
Actually, this was done in Salman 4 trial. When the patient stops taking the injection, what happens? Whether patients will go on maintaining the weight loss or they are going to regain the weight. So in Salman 4 trial, they have clearly shown the patients were taking the tirzepatide for almost 9 months time, and one arm was continuing the drug, and some certain patients were discontinuing the treatment. And after the period of almost 12 months, that is 1 year, what they got, they regained the weight, but the regaining of weight is not very much, they are not gone to the original weight, but only 10% they reduced the weight, gained the weight. So even if you stop the drug, it almost the drug's actions was there for almost more a period of 3 to 4 months time. But definitely, as such, the indication is we cannot stop the drug. We have to go on giving the drug only. If the patients are very much strict in their dietary habits and exercise program, probably we can give a trial for some time after 2 or 3 years time.
So last question.
Yes, Dr. Ravindranath, and this is a basic, very basic questions for the benefit of the delegates, right? So non-obese, non-diabetic obese patients you are giving. At the same time, this patient can have normally secreted GIP and GLP. So what will happen?
Normally secreting?
See, this particular drug,
yes,
the trial was conducted in non-diabetic obese individual. On the top of naturally secreted GIP and GLP, you are giving this combination of dual agonists in high dose. What happens?
So usually in even obese patients also GIP secretions was less, not only in diabetic patient, even the obese secretions also the GIP secretions goes down. It is not same as the normal persons, definitely.
Actually, if you look into this study conducted by Dr. Anup Mishra and an article published by A.K. Singh, they have clearly made a mention that in obese individuals, the DPP-4 levels are very high, they are upregulated, they are overactive. So that brings about degradation of the naturally secreted GIP or GLP. So when you give this particular dual combination, so this gets increased. Not only that, this GIP prevents internalization of the GLP that occurs inside the cell. Thereby, it allows high dose of GLP to act for a long period of time. Another thing, the resultant nausea is also less in this particular combination GIP, because if you look into the area posterior as well as nucleus tractus solid areas, we have inhibitory neurons as well as excitatory neurons, and this GLP activates the excitatory neurons, so it causes vomiting. Whereas GIP that suppresses excitatory neurons and stimulates the inhibitory neurons, thereby minimizing the vomiting. So because of this, we are getting very good response with this particular.
I'm not so sure. I think one of the things that we need to understand is that the GIP action is not very well understood, because the GIP action in the mouse models are very different from humanized and human mouse models. What is more likely that is happening is is a phenomenon called biased agonism. Meaning, normally when GLP acts, what it does is there is a stimulation of cyclic AMP, there is also a recruitment of beta arrestin. When in tirzepatide, there is recruitment of cyclic AMP but no recruitment of beta arrestin. The function of beta arrestin is to remove cyclic AMP from circulation and the GLP-1 from circulation. So what it does is it sort of prevents receptor desensitization. That's really what beta arrestin does. But when you give GLP-1, when you give tirzepatide, what it does is it prevents beta arrestin activation. Only cyclic AMP is activated. Therefore, it pretty much behaves like a super GLP-1. Therefore, there are pharmacological levels of GLP-1, suprapharmacological levels, even higher than semaglutide that are seen. So while GIP does have some action and mostly on the fat, the majority of the action is GLP. What is probably even more important in the action of the drug is that it dissociates the dopamine centers from the opioid centers, which means that food is no longer perceived as a reward that needs to be pursued. If you look at my thing, there is a liking and there is a wanting. It prevents that wanting to happen. And that's really how these work, and that is why these drugs are now being slowly started being used in addictive disorders. So there is a link between that entire talk that I gave and what is actually happening with these drugs. This reward motivation segment is cut off. Now, to go back to the first question that Srinivasan asked, can you do it on your own? Yes, but it takes effort.
Thank you. Can we conclude this? You have a question? Yeah. Gauri, can we conclude? You asked us to conclude the session.
Yes, sir.
Yes, we conclude the session. Thank you.
Thank you, sir. Thank you, Chairperson. Thank you, Krishna sir and Ravindranath sir. Now, as we move on to the next session, keynote address, may I request Dr. Nandakumar and Dr. Vijayaraj to chair the session. And people who are interested in the prelims of the quiz can stay back after this session. It will happen over here. So 1:30, 1:40, the prelims of quiz will be here. So please stay back for the quiz. Quiz prelims for the postgraduates. Quiz prelims. Yes, sir. Yes, sir. We have exciting process, so please participate in the quiz prelims and get selected for the mains. Over to the chairperson.
Good afternoon to everybody. I thank the organizers for giving me the opportunity to share this session. So, this topic, first topic is by diabetes and sleep by Professor Chandrasekhar, Professor HOD Stanley Medical College, and recently got a Master Teacher Award from APA Telangana. So now the management of diabetes now is based on the circadian rhythm, and I hope Sir will address this in diabetes and sleep. Over to Professor Chandrasekhar.
Thank you, sir. Thank you. Good afternoon, ladies and gentlemen. Thank the organizers for having me here. I just quickly go into the stages of sleep cycle, which we all know. So it has got a stage where the person is wakeful and non-REM sleep. That is the N1, N2, N3, and REM sleep. So what is the importance of these sleep? So normally a person after 10 to 15 minutes he goes to the sleep. So that is the latency. Once he goes to the sleep, like he is arousable. That is that lasts for a few minutes. That is a N1 stage. N2 stage is somewhere like the patient goes into a light sleep where your temperature slightly drops down, heart rate drops down, BP drops down, respiratory calms down. So all these things can happen. Whereas the N3 is the most important part of this non-REM, where it accommodates almost to 25 to 40 minutes in a sleep cycle, one single sleep cycle. And this is the stage where the tissue repairs itself, the restorative process, the growth happens. So in N3 stage. And this is followed by a REM sleep. REM sleep initially it is a smaller sleep. But when the sleep cycle progresses, usually a person, when he goes to sleep, he may have 3 or 4 cycles. So when it goes into the further cycles, the REM sleep's duration is becoming more and more. So what is the importance of REM sleep is? REM sleep is the sleep pattern where the memory is, regenerated. And more importantly, like the dreams also can happen during the REM sleep only. So as the duration of the REM widens, so usually that's why the people get the early morning dreams. So that usually happens in the REM sleep. So this is a little bit about the REM sleep. Of course, we all know the importance of sleep as a risk factor for developing so many diseases, including obesity, diabetes, cardiovascular disease, your Parkinson, Alzheimer's disease, even bone health, immunity. So there are so many conditions that have been implicated to the sleep health. Now let us dwell on the importance of diabetes on sleep. So patients with chronic diabetes or elderly patients, they don't sleep at night time, they'll sleep more in the daytime. So that is a circadian misalignment that happens. The duration will be less and the sleep initiation will be difficult, particularly a patient is having a peripheral neuropathy, burning feet, or pins and needles, or restless leg syndrome. They may have some difficulty in initiating the sleep. And because of the polyuria and nocturia, they may have sleep fragmentation also. Sleep latency, that is a person goes to bed, the time taken for him to go into the sleep, that is called a sleep latency. That is usually 5 to 10 minutes, that's all. So that also increased because of the anxiety, because of various other complications and poor control, early wakefulness, easy arousal, and micro sleep. So the sleep will intrude into the wakefulness in the daytime. Somebody is driving, so if the person sleeps for 3 seconds, then if he closes and sleep, he may meet up with an accident. So that is the importance of it. And of course, the common denominator of the diabetes is obesity, where OSA is common. This is a study, population-based study done in Korea, which has clearly shown that the patients have been studied for 16 years. So the whole period is 20 years. They were divided into a person who sleeps less than 5 hours, 5 to 7 hours, and more than 7 hours. And they have shown clearly that the person who sleeps less, that is less than 5 hours, they are at risk of developing diabetes, particularly in non-obese individuals and in young individuals. Please remember, less than 5 hours. That's what happened with our youngsters. And people who sleep more than 7 hours, they are at risk of developing not only diabetes but also obesity. After this several study, 2024, the first time ADA has released a statement on sleep health with regard to the diabetes management. They have concentrated more on the quantity of the sleep, quality of the sleep, and the time, that is the chronotype. So that is the thing which they have concentrated. Of course, the regularity is also one thing that is missing here. Similarly, they have given some suggestion on how this circadian misalignment happens, particularly in patients who do night shift, having sleep disorder, or social jet lag. Social jet lag is something, jet lag we all know that. If sometimes like we go to some parties, patient go to marriage or function or movies, instead of sleeping at 10:30, they'll sleep at 1 o'clock. So there is a lag. That is called social jet lag. So these are all the things which can make the person to develop a circadian misalignment. So this is a slide again shows when a person sleeps for lesser duration or doing night shift, what will happen. So when a person sleeps for less number of hours in the sleep during night time, they have a hormonal imbalance. I think Dr. Krishna has nicely alluded how the hypothalamo-pituitary adrenal axis is being disrupted while the patient is having a short duration of sleep. But more important is they will have more ghrelin. So ghrelin is the appetite hormone and the less leptin or leptin resistant. That is the satiety hormone. So that's why the people who are having less sleep for less number of hours, they will have a bizarre eating pattern. They indulge in binge eating. So why? Because of the high ghrelin and the less leptin. And maybe because of the less number of sleeping hours, in the daytime they feel groggy and they may have physical inactivity, and there is a risk of overweight, obesity, metabolic syndrome, and diabetes. Of course, the hypertension also. There is yet another connection between sleep and diabetes with related to the cardiovascular disease, that is nocturnal dipping. When we go to bed, at least 5 to 10% of the baseline BP comes down during sleep. So this doesn't happen in certain subsets. Like say for example, patients with obesity, CKD, or in patients with diabetes, it doesn't happen. Instead, the BP goes up, or early morning surge, which is directly related to the cardiovascular risk, which we all know. So this is OSA is not in the era of diabesity. So we have a endemic of the OSA also, like almost to the tune of 9% to 33% of prevalence of OSA in various Indian studies, particularly the moderate to the severe OSA is seen with 13 to 19% of the Indian population, please remember. Of course, we all know that the anatomical narrowing of the upper airway because of the fat deposition and the muscle tone comes down, it collapses, so patient gets hypoxia, and there is activation of the RAS and the sympathetic nervous system, and thereon it creates an inflammatory milieu and hormonal disruptions and poor metabolic control. These are all the risk factors which we all of us know for the OSA. And OSA doesn't come alone, it always comes with uncontrolled hypertension. How? Please remember the activation of the baroreceptor, carotid body stimulation, increased oxidative stress, altered baroreceptor activity, and increased RAS activity, which results in the increased arterial stiffness, and the nitric oxide availability goes down, and eventually because of the sympathetic surge, the patient develops hypertension also. Of course, we all know that like every 10% increase in the body weight, the risk of OSA goes up by 32%. Of course, now we have some treatment aids in the form of CPAP, mandibular assist device, and of course the newer the weight losing drugs, GLP-1 receptor agonist and dual agonist. All these things can bring back the severity of the AHI. Of course, the OSA treatment also improves the glycemic part of it. There is a small study which is conducted which has shown people with OSA who took treatment with CPAP have shown reduced reduction in the fasting blood sugar levels. In general, how do we diagnose polysomnography? How do we diagnose this sleep disorder? That is by the polysomnography. So these are all the parameters which we see, EEG, EOG, and EMG. Of course, the ECG, airflow, the respiratory effort, saturation, heart rate, and body position, snoring, all these things are being recorded in polysomnography. The problem is we don't subject these patients with a suspected sleep disorder for a confirmatory test, that is polysomnography. But this is evolving science where we have almost 800 sleep labs in India. Almost 15% of them are the level 1. And these sleep disorders definitely have got a role in the poor metabolic control. Not only that, diseases like insomnia and OSA are directly linked to both micro and macrovascular complication. How do we treat? Like I already alluded to how we can treat OSA, and these are all the pharmacological agents which are available. When a person is having difficulty in initiating a sleep, like a benzodiazepam would be of helpful, or melatonin would be of helpful. If the patient is not able to maintain the sleep cycle, then we may have some drugs like the orexin antagonist. So these are all some of the drugs which can have. Suppose patient with anxiety, we can add some antidepressants also, anxiolytics also, in addition to that. I'll go with a case study. Here is a 34-year-old newly detected diabetes working in a MNC. The wife noticed the recent onset of anger and profound decrease in the skills. They thought like the patient is having a personality disorder. But on probing, the patient has got a sleep disturbances in the form of he sleeps for only 3 to 4 hours for the previous 4 months. If somebody is having this sleep disturbances for at least 3 days in a week for 3 months, it's called insomnia. So the patient is diagnosed with insomnia, advised CBT for insomnia, and the benzodiazepines and the lifestyle measures. The second woman is a very highly motivated girl working in night IT and having obesity, a bit stressful and worried about her diabetic status. She is a pre-diabetic, and she has been advised about the change of the duty time. She is advised, in addition to the weight reduction, she is also advised about the change of her, the occupation as well. Why this is important is like the shift workers are at risk of developing diabetes, then the non-shift worker by 10%. The third case is a female entrepreneur, again an enthusiastic woman, diabetes for 3 years. On routine evaluation, she is found to have recent onset of fatigue, poor concentration, and glycemic control is also variable, despite strict adherence to the lifestyle intervention and OHA. In fact, she is a swimmer. But on probing again, she was found to have some perimenopausal related sleep disorder, anxiety, difficulty going to the bed, and she is advised to CBT and the benzodiazepine with melatonin, and she became better. And the fourth case is an elderly female having diabetes for 18 years with a HbA1c of 8.1, living alone. A daughter in USA, she is also a doctor, said like my mother is having the increase in the fatigability and creepy sensation in the legs. Must be she is, living alone in Chennai, like probably that's the reason. But on probing, like she is found to have a respiratory leg syndrome and started on pramipexole, just a small dose, 0.125, and she became normal over a period of time. The another case is 32-year-old male, pre-diabetes. He says, I have not slept for the past 4 months. And he has been addicted to screen, and evaluation is found to have the HbA1c of 7.2. He has jumped from pre-diabetes to over-diabetes. Of course, sleep deprivation is one of the strong risk factors for the conversion of pre-diabetes to diabetes. Another gentleman, a businessman, is again a passionate man, passionate about cars. He met with an accident, having a reasonable control of 8.1, and he felt very bad. That like he admitted that something happened to me. I think I have slept briefly. So that is called a micro sleep. So though he had a minor RTA, like he is advised about the importance of sleep health and given some placebo and CBT. And here is another gentleman, a 28-year-old fit gentleman, and newly detected diabetes 7.1 on regular master health checkup. He could not believe that he has got a diabetes. So he say, my father, mother, nobody is diabetic, and I'm pursuing a regular disciplined lifestyle, and my exercise is also reasonably good. That's what he said. But only thing which we have found is like he's got the habit of going late to the bed and getting up late. He sleeps by around 1:30 and getting up by 11 o'clock in the morning. So again, these things can increase the risk of developing diabetes by 2.5-fold. My last case is a 55-year-old male, diabetes, hypertension, stable CAD, developed a angina. He admitted that he has got a recent relationship conflict with his wife and acute sleep loss for 4 days, just 4 days. And remember that acute sleep loss can provoke precipitate a cardiovascular event like angina or even a heart failure also. Ladies and gentlemen, sleep is an important thing, and restoring it helps us to restore the health, metabolic control, immunity, cognition, and facilitating recovery from diseases. Of course, a good laugh and a long sleep are the two best cures for anything. This is my last slide. I want you all to practice. I appeal all of you to practice. This is something about sleep hygiene. Go to bed at the same time every night and wake up at the same time, even on weekends and holidays. That is more important. Bedroom should be dark and quiet with a comfortable temperature, and bedroom is only for the sleep and intimacy. Avoid gadgets, avoid the late night or late evening feast, caffeine, cigarette and alcohol. Do some breathing exercise, warm shower, reading books if you don't get into your sleep. If you have any trouble in falling into sleep for more than 20 minutes, come back, leave, do some gentle activities, then enter if you feel again sleepy again. So that's a very important thing about the sleep hygiene. So with this, I again thank you all for the patient listening. Thank you.
Thank you, sir. It's an excellent presentation. Usually we, in diabetes, we usually concentrate on diet and exercise. How sleep is important and sleep hygiene. It's a wonderful presentation. How sleep deprivation leads to the glycemic worsening. It's a good awareness for the audience. Thank Dr. Chandrasekhar. So any questions will be in a later part of the session. Thank you, sir.
Yes, thank you.
Now Now we invite Dr. S.N. Narasimhan sir, Vice Chairman, Lipid Association of India and Vice President, World Hypertension League and Medical Director, Armora Heart Care in Chennai. Regarding management of diabetic dyslipidemia, should we focus on lipid levels or risk-based approach? Welcome, sir.
Thank you, Chairperson. Good afternoon, everyone. I would like to talk on management of diabetic dyslipidemia. Should we focus on lipid levels or decide as per categories? The cardiovascular disease is the leading cause of death in the world. It claims more lives each year than other non-communicable diseases globally. It is estimated that about 31% of all deaths occurring globally are due to cardiovascular disease. CVD is also a leading cause of death, particularly premature death between the age of 30 and 70 years. If you look at this data, in 2025, it is estimated that about 20.5 million people are dying globally due to cardiovascular deaths. And then it is estimated, if it goes in the same trend, probably, we will be seeing about 35 million people dying due to cardiovascular disease. There is an increase in the cardiovascular prevalence by 90%, increase in the crude mortality by about 73% by 2050. Having seen this record globally, I need to tell you that ICMR India study not only evaluated the prevalence of diabetes in India, but also concentrated on other parameters. It is estimated that the prevalence of dyslipidemia in our country is about 81.2%. The various forms of dyslipidemia, hypercholesteremia is only 24%. The typical hypertriglyceridemia 32%. The low HDL cholesterol is about 67%, and a high LDL cholesterol is about 20.9%. It is clearly seen that all of us probably are having high triglyceride and low HDL in general. Hypertriglyceridemic states are always accompanied by the elevation of non-HDL cholesterol, small LDL particles, high LDL particle concentration. The non-HDL cholesterol is the greater predictor of cardiovascular risk than LDL cholesterol. If you remove the HDL cholesterol, which is containing about the ApoA, which is an anti-atherogenic, whatever is remaining is considered as a non-HDL cholesterol, and it is just calculated by subtracting the HDL cholesterol from total cholesterol. You get that number, and that is non-HDL cholesterol, which contains LDL, IDL, VLDL, VLDL remnants, lipoprotein little a, chylomicron remnants. LDL is an independent and modifiable risk factor for atherosclerotic cardiovascular disease. It has been proved beyond doubt. I need to emphasize that LDL plays a crucial role in atherosclerotic process. If you look at this particular projection, it gives you an impression about the cardiovascular health highway, and one has to decide what to implement during the primordial prevention. One has to decide about the primary prevention. If we don't do that, probably people will land in the problem of acute coronary syndrome, where you need to introduce the secondary prevention strategies. But there is a narrow street where people probably can get blocked there and get problems of acute coronary syndrome or sudden cardiac death. That should not happen. So we need to probably have this sort of marathon, not only for prevention of atherosclerotic cardiovascular disease, but also for LDL cholesterol lowering. All the ways you need to have this sort of LDL cholesterol marathon. So what to do, when to start, what to start, and how intensive it should be. These are the things which need to be decided by the so-called healthcare provider, who probably teaches the patients. If you look at 1 millimole of LDL cholesterol reduction, that is about 38.7 milligrams of LDL cholesterol. If it gets reduced, you get a benefit. At the end of 3 years, you get a reduction of 20%. At the end of 5 years, the reduction in the cardiovascular events to the extent of 25%. If somebody continues to have for a period of 40 years, you can expect that the reduction comes down by about 50 to 55%. Amazing information that probably should prompt you that we need to adopt the technique of lowering the LDL cholesterol to the maximum extent possible, at least by 1 millimole of LDL cholesterol reduction by 38.7 milligrams will go a long way to prevent the atherosclerotic cardiovascular disease. So ladies and gentlemen, our attention must be lowering LDL cholesterol and keeping it low throughout our life, even in people with diabetes. Let me now try to tell you something about what to do when you have increased levels of LDL. Should we focus only on LDL all the time to reduce the problem of atherosclerotic cardiovascular disease, particularly focusing attention on diabetic dyslipidemia? The good old study, the CART study with the no baseline cardiovascular disease, these people were recruited. One arm received only 10 milligram of atorvastatin, the other arm received only placebo. People were followed up for a period of 3.9 years. Amazing to see the reduction of cardiovascular events to the extent of 37%. In fact, the study was prematurely closed at the end of 3.9 years because the investigators wanted to give the benefit even for the placebo arm. Surprising to see that the levels of LDL cholesterol, what was seen as 110, 118 had come down to 82 milligrams. That is the one which is responsible for the reduction of cardiovascular events. In fact, the CART study people did not identify the ideal LDL target value beyond which one can get the benefit. The second study which was conducted in people with hypertension, even in people with diabetes also, with associated hypertension, the ASCOT study, which has gone to prove that if you're bringing down the LDL cholesterol to the levels of 83 milligrams, you get a benefit of reduction by about 23% in people with diabetes and hypertension. But now, recently, last year, there is a publication which had come out. 20 years follow-up of the same people who were recruited for this ASCOT study. The investigators were lucky to get those people under their observation. It is clearly seen those people who were very strict in controlling not only diabetes, hypertension, but also in addition they were taking the atorvastatin 10 milligram had gone to show that 19% reduction in non-fatal MI, fatal CHD by about 19% and cardiovascular mortality by 14%. It is clearly seen with this evidence that underscores the importance of early statin initiation in high-risk hypertensive patients, including people with the diabetes. Even short-term LDL lowering may yield the decades of cardiovascular protection. Apart from these two studies, I need to tell you that there is another study called TNT, Retreat to New Target. This study was conducted in people with the chronic stable angina. Till that time, only about 10 milligram of atorvastatin was given to those people. But these investigators wanted to identify one arm received 80 milligram of atorvastatin, the other arm received only 10 milligram of atorvastatin. Surprising to see, there is a 25% reduction in the cardiovascular events in those people who received high dose statin, particularly in people with the diabetes. The other one is a heart protection study, HPS study. 20,000 people were recruited in this study. 6,000 of them were having diabetes, both type 1 and type 2 diabetes. All of them were given this high simvastatin dose of 40 milligram, which has shown that there is a good reduction of cardiovascular events, not only in people with no baseline cardiovascular disease to the extent of about 33% reduction, but those people with diabetes, including type 1 diabetes, there is a reduction of cardiovascular events to the extent of 22%. So, in fact, the investigators of heart protection study, who were the first one to say, we were not able to identify what should be the lowest level of LDL cholesterol beyond which the benefits are not seen. The concept of that particular lower the better concept started emerging. Prove It To Me 22 trial was conducted in acute coronary syndrome. Go to the last level, that is less than 40 milligram. You get a benefit of nearly reduction of 40%. 40% reduction in cardiovascular events. So, if you are reducing it to lowest levels, even in acute coronary syndrome, you get the maximum benefit. So, if you are reducing the LDL cholesterol to the extent of 50% reduction, you get a benefit of 50% reduction in cardiovascular events. Very, very simple information, very simple message. 50 milligram reduction in LDL cholesterol probably will lead to a reduction by about half. But surprisingly, in the real world scenario, this is not happening. Many of them are not able to control the LDL cholesterol even to the levels less than 70 milligram. Nearly 40% of them are lacking behind. This is an excellent data. Suppose somebody receives the drugs at the age of 30 years and you have a good follow-up. The number of cardiovascular events in those people who received the drugs at the age of 30 years is less compared to people who are given drugs at the age of 50 years. Please remember that. Early initiation is most important information that I should share. So the evidences as far the LDL lowering is concerned, one, earlier the better. Number two, lower the better. With that in mind, let me now try to take you to our understanding about the residual risk. Okay, you started treating LDL cholesterol, but you need to remember further reduction of LDL cholesterol by giving a combination of drugs. Will that be in a position to help us to reduce the cardiovascular risk? So cholesterol risk, triglyceride risk, LPA risk, diabetes risk, pro-inflammatory risk, and then the thrombotic risk. Now I'll take you only to the cholesterol risk. You have good data with respect to the PCSK9 inhibitor as well as the ezetimibe. Ezetimibe was tried in a trial called Improve-It trial, where only about 10 milligram of ezetimibe combined with the simvastatin has shown 53 milligram drop to that level. That got reflected to 14% risk reduction in those people with the diabetes when compared to people without diabetes. So people with the diabetes, when they received ezetimibe plus statin combination, they did better when compared to people who did not receive this combination, thereby forcing us to prescribe this particular drug in those people with the diabetes, in those people in whom you have a polyvascular disease. The next trial is the evolocumab. 4-year trial has shown at the end of 4 weeks, 1 month, you get a benefit of reduction of LDL cholesterol, which touched about 30 milligram. This 30 milligram reduction LDL cholesterol to that level had got reflected to the levels of reduction of cardiovascular risk by 15%. Investigators found even those people who reached the levels of 10 milligram at the end of 4 weeks, 1 month after evolocumab injection, they were followed up. They had seen double the benefit. What was seen as 15% became 30%. Thereby telling you that you need to start early, you need to give a reduction of LDL cholesterol as much as possible. The other study is about aliricumab, which had again shown reduction of the levels of atherosclerotic cardiovascular risk in this group of patients who received aliricumab is about 15%. Even aliricumab study, that is ODC trial, people had reached 15 milligram, 1.5. They have shown double the benefit when compared to the people who reach the levels up to 70 milligrams. Look at the one that I put a red line. Baseline value 116. The last one, high dose of statin plus a PCSK9 inhibitor. You give a combination. What is going to happen? Just look at the level. What was seen as 116 milligram of LDL touched 23 milligrams. Touched only 23 milligrams. So ladies and gentlemen, I have already told you, earlier the better, lower the better, even lower is even better. And then we'll now take you to the extended study that is called long-term evolocumab in patients with established atherosclerotic cardiovascular disease. What happened here in this, the original drug, parent drug, evolocumab was given, followed up. The placebo arm people, at the end of 12 weeks, they were asked to take evolocumab, and that resulted in reduction of events. Okay, so the mean LDL cholesterol values here 29 milligrams. People were shifted from the placebo group to the evolocumab group. They were all followed up. People who received it later, from placebo to evolocumab, did not show good. Whereas the people who originally received right from the beginning evolocumab, they have shown benefits with 8.4 years of follow. 8.4 years of follow. Again, a very, very strong evidence to tell you that the PCSK9 inhibitor evolocumab has shown a maximum benefit, that longer duration of treatment is most important. In patients with atherosclerotic cardiovascular disease, long-term achievement of lower LDL cholesterol levels, even levels less than 20 milligram, has shown the maximum benefit to the lower risk of cardiovascular outcomes with no significant safety outcomes. There is no increased hemorrhagic stroke, there is no new onset diabetes, only injection site reactions. Rest of the things are all not there, are not encountered at all. So now tell you that earlier the better, lower the better, even lower is even better. The last one is the longer the better, longer the better. So ladies and gentlemen, please remember these 4 things. 1, earlier the better. 2, lower the better. 3, even lower is even better. And the last one, longer the better. I think that is the message, what I thought I should show you, line after line, so that you will get an impression that how important it is to reduce LDL cholesterol to get a maximum benefit for your patients in reduction of atherosclerotic cardiovascular events. In this 4-year trial, it is also seen those people reach the levels of 30 milligram, still they have an event rate about 14.4%, thereby showing you need to go away from LDL. What is the one that you should talk now? TG levels. So LDL levels over. Look at TG. Are there evidence? Prominent trial failed to show by using a pimofibrate negative study. Is there a study to say that we can use some drugs to reduce not only triglyceride to some extent, but get a maximum benefit? Yes, reduce your trial, which had used icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given for these patients, had shown a benefit of reduction of cardiovascular events to the extent of 25% the primary endpoint, and then to the extent of 26% the secondary endpoints. The ADA today tells you that those people with the diabetes, with one risk factor, those people with the ASCVD, those people in whom you have already reached the LDL cholesterol levels less than 70 milligrams, those are the people who can receive the icosapent ethyl ester for 2 grams in the morning, 2 grams in the evening, to get the maximum reduction of atherosclerotic cardiovascular events beyond LDL cholesterol reduction. That's the message about non-HDL. You should concentrate on non-HDL. It is much more important in people with diabetes when compared to people without diabetes. There are any number of studies. Odyssey studies started showing there is a reduction of non-HDL cholesterol to the extent of 32.5% in those people who received alirocumab. It is a PCSK9 inhibitor. Can we go it? That is the one aspect of the question that I raised was over. Can we decide it as per the risk categories? The ESA guidelines started telling us that it should be high risk people or very high risk people should keep the levels less than 55 milligram. The Lipid Association of India came out with the recommendation of only 50 milligram in this group. There also they mentioned about diabetes, first type 1 diabetes, type 2 diabetes, lesser duration, longer duration, more than 20 years, high risk, less than 10 years, not a high risk, moderate risk, like that they divided. I don't want to confuse you by giving all this information. Suffice to say, their recommendation only 55 milligrams, very high risk. But we were recommending 50 milligrams for very high risk people. This is about our recommendation, not a crowded slide, but I'll tell you, I will make it simple for you. This is from Lipid Association of India, which had come out with the recommendation that low risk, moderate risk, high risk, very high risk. Low risk, no risk factor or 1 risk factor. Moderate risk, 2 risk factors. High risk, 3 risk factors. Very high risk, polyvascular disease or people with recurrent attacks. Extreme risk, polyvascular disease with recurrent attacks with homozygous familial hypercholesteremia, this B. So we started reducing it to the levels of 30 milligram. Extreme risk group people, B category, should receive the drugs to get the level of LDL cholesterol down to 30 milligram. So we need to focus not only on LDL levels, but also to decide about the risk categories. So find out what is the baseline LDL. Find out how much of reduction of LDL is required. With these two, you arrive at absolute reduction of LDL cholesterol. Find out the baseline risk. What should be the relative risk reduction that is obtained in the studies? Obtain the absolute risk reduction. So you are arriving at one absolute risk reduction, then absolute reduction in LDL cholesterol. Both are required for you to see whether the patient is showing a good response to LDL lowering. So this is the one important slide, what I thought I should show it to you as a slide from Lipid Association of India, divided into 2 groups. One is diabetes without ASCVD, the diabetes with ASCVD. Suppose somebody is diabetic, no zero risk factor or only 1 risk factor, he comes under the category of high risk, in whom you should keep the levels less than 70, not even 100. So people who have target organ damage, more than 2 risk factors, very high risk, keep it less than 50. People in whom have established ASCVD, acute coronary syndrome, diabetes, category A, category B. Category A, bring it down to levels of 50, optional 30. Category B, very high risk, extreme risk, recurrent attacks of stroke, peripheral vascular disease or a polyvascular disease, diabetes with established atherosclerotic cardiovascular disease, homozygous familial hypercholesterolemia, or a heterozygous familial hypercholesterolemia, keep the levels less than 30 milligrams. That's the recommendation. The recent drug is inclisiran. I don't want to dwell here because of the time, which is not sufficient for me. Bempedoic acid has come to the market. Again, an important drug which can be added down to the statins. The last trial, we started a trial with a small number of patients, 122 patients recruited. The acute coronary syndrome were all going for a PCI. Those people were taken into consideration for the study. We used high-dose statin, two PCS in the acetamide. The third drug is a bempedoic acid, so one is the rosuvastatin 40 milligram, acetamide 10 milligram, bempedoic acid 180 milligram, has shown a reduction of LDL cholesterol even at the end of 6 weeks. It is maintained much more. So we are actually thrilled to see these results, which was released by the Lipid Association of India. Most recent, this year, 2025, released by the American College of Cardiology. You need to have a good discussion with the patient. Patient interaction is important. Family history, very important. Hypertension, lipids including lipoprotein little a, tobacco use, subclinical atherosclerosis by calcium score, diabetes and its complications need to be taken into consideration. Use any calculator or look at only our algorithm. You identify the patient's risk and then the medical history. If you go by these things, it is possible to treat this patient. Lifestyle modification, statin, non-statin drugs. So ladies and gentlemen, we need to move away from the high-dose statin to tolerable doses of statin plus acetamide plus PCSK9 inhibitor or bempedoic acid. That should be the strategy. Try to use the available lipid-lowering agents to make the LDL cholesterol to come down further to reach the levels as you want in your patient to give him a maximum relief of reduction of cardiovascular event. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, Professor S.N. Narasimhan, sir, for the insightful presentation on treating dyslipidemia and diabetes. Because diabetes is a vascular disease, and treating dyslipidemia is very crucial. Thank you for the wonderful awareness on treating dyslipidemia, sir. Sir, when you start the PCSK in any case particular instead of statins, in your PCSK inhibitors, any special usage in a OPD patient, outpatient?
See, in those patients in acute coronary syndrome, don't worry about the LDL cholesterol values. If the patient is having a familial hypercholesterolemia as per the LDL values, there is a strong family history, premature coronary artery disease and death, he is a candidate who is going to get recurrence of events. So levels of LDL cholesterol may be high. You use a high dose statin plus an acetamide plus a PCSK9 inhibitor straight away. You should give it. Patient, diabetes, hypertension, smoker, long duration of diabetes, with the CKD problem started, patient has developed acute coronary syndrome, never hesitate to use these drugs, including a PCSK9 inhibitor. Familial homozygous hypercholesterolemia, use PCSK9 inhibitor. Heterozygous, no problem at all, there is no coronary artery disease, but there is a family history, try to bring down the cholesterol values, use PCSK9 inhibitor. This morning also I received a message for one of my patients in whom I wanted a LPA. She was asking me, what is this LPA? And I discussed about the LPA. I just told her, she is a very educated lady. This morning I received a message saying that her LPA level is 185. Just like that, I took my father for the laboratory test, what he wanted. Incidentally, I also wanted my cholesterol level. Surprisingly, sir, my cholesterol level is 185. That correlates with the patient's father, our father history. He had aortic valvular stenosis, operated, number one. He has got a coronary artery disease, number two. His cholesterol levels are also high. I wanted an LPA. This lady also went and gave the sample. LPA levels were raised. Then indication for PCSK9 inhibitor is to use in that situation where LPA is markedly raised.
Thank you, sir. We invite Dr. Chandrasekhar, sir, for the stage. Any questions to Dr. Narasimhan sir and Chandrasekhar sir?
I'm not able to hear you, ma. Every time I get this question in any meeting, cytoregulators are both the PPR alpha and gamma agonist, number one. It can bring down the blood sugar to some extent, number two. HbA levels probably can come down in a long duration of therapy. It is recommended only for diabetic dyslipidemia. No doubt it brings down the triglyceride levels, but there is no cardiovascular outcome data as on today.
Sir, my respectful wishes to Dr. Narasimhan, who was my teacher in Stanley, 1985-87, the ER unit.
Okay.
Sir,
so nice to see you here. Please, please.
Sir, diabetics with the normal LDL, can we start strategy early, sir? Normal LDL, normal lipid profile in diabetics.
In diabetes. The recommendation from Lipid Association of India, the moment you make a diagnosis of diabetes in an individual, type 2, start statin also simultaneously. That's the recommendation. ADA tells you above the age of 40, you can give it. Between 20 and 39, see whether the patient has got a high cardiovascular risk. Use the calculator in the United States, ACC AHA calculator. Identify whether the patient has got a risk of developing a cardiovascular disease in the next 10 years. If the risk is more than 10, you try to start statin. That's the recommendation from the ADA.
Sir, is inclisiran better than the PCSK9? Because inclisiran, because it's yearly, because we pay our patients, they cannot afford the PCSK9 inhibitors. Why inclisiran? What is your opinion?
This is a very good drug. In addition, I need to tell you that it's a recently introduced drug. It is actually stopping the, it is actually a small interfering RNA which goes and stops the production of PCSK9. So it gives advantages. When compared to PCSK9 inhibitor like avalokimab and adalimumab, inclisiran also has shown good results in the form of reduction of LDL cholesterol. But the reduction of LDL cholesterol is much more with this when compared to this. Maybe about 5 to 6 milligrams lesser, number one. Number two, in acute coronary syndrome, only avalokimab and adalimumab were tried and not inclisiran. We need to wait for the studies. Patient-centered data that is available with the inclisiran also shows that there is going to be some sort of cardiovascular benefit as per the data available today. Yesterday, FDA has approved inclisiran to treat any patient who is willing to take this particular drug without any complications, without any comorbid conditions. If the fellow wants to take this problem, this injection of inclisiran, he should be allowed.
Sir, Chandrasekhar sir.
But there is no, you are lipid authority, sir. Phenofibrate, in the lecture there is no phenofibrate usage.
The drug has been there with us for the past 5 decades. There is no acceptable cardiovascular outcome. It can be used only in those patients in whom you have more than 500 milligrams of triglyceride, with or without diabetes, to prevent pancreatitis. That's all.
Sir, Chandrasekhar sir. Sir, role of melatonin supplementation for this sleep.
Yeah, melatonin, there are only 2 studies to support its use in insomnia. Mainly we use in certain situations when there is a jet lag, we can use the melatonin, not for the social jet lag, but in patients who have some difficulty in initiating the sleep, where the sleep latency is increased, where we can use. So that is the 2. And number 3 is in pediatric thing people with neurodegenerative diseases, particularly involving the children and adolescents. We have some trials with melatonin.
Sir, regarding LPA, sir. LPA. I got a couple of patients with a high LPA, 50, 55, 60. And so far I have not seen any problem in them. So will they be likely to get a problem in the years to come by? or there is no other molecule. Right now there is no molecule to treat for LPA.
It is a genetic disorder, autosomal dominant type of inheritance. There is a strong family history of coronary artery disease and the premature coronary artery disease or death in the family. Think about LPA as a cause. Try to ask the patients, relatives to go for LPA screening. Okay. If LPA is between 20 to 49, 20 to 49, consider as a moderate risk. Above 50, there is a risk. Above 100, definitely risk is there. Those patients you need to intervene. At present, there is no recommendation to treat LPA. The drug that has been tried is aspirin, can reduce the LPA. But aspirin has got disadvantages in the form of hemorrhagic tendencies, better not to use it. If you are able to reduce the LDL cholesterol sufficiently with the drugs that are available with you, that itself will take care of the injury that is going to be created by the LPA. Because LDL, when you measure, it not only gives the cholesterol content of LDL, it also gives the cholesterol content of LPA. So reduce that. Statins can increase the initial increase in the LPA. But people say it is only the large buoyant LDL cholesterol which are going up and not the small dense LDL cholesterol. If you have a combination like this, for example, LPA is increased. I had a patient who had myocardial infarction. He came with a stroke later. Till that time I did not do LPA. I wanted him to go for LPA. 185. Acute coronary syndrome. He survived. You gave him all medications. No PCSK9 inhibitor. I told him there is no recommendation from FDA for PCSK9 inhibitor, but I can give you. Please tell me whether I can give you because you have got a thoracic cardiovascular disease in both areas. Can I give it? He could not afford, so I had to stop.
So right now there is no molecule. Right now there is no molecule to address LPA.
Yeah, correct. Perfectly correct.
We had a study telling that if you take inclisiran right from 30 years of age, once inclisiran, sir, inclisiran from 30 years of age, once a year, you will not get heart attack. Is it true, sir? Inclisiran from 30 years of age, once a year if they take. Those who are having, it was told in
I don't think that should be taken as a message.
No, sir, that was told. They are claiming whether do you have a drug that will prevent diabetes. The cardiologist was asking the diabetologist. So I am just inquisitive about it.
No. Because it is not at all recommended like that. The drug is not recommended like that.
Yes, sir. Thank you, sir. Sir, to Dr. Chandrasekhar, sir, we were telling about one 46-year-old man, RTA, that microsleep. I didn't catch it. Please kindly explain to me, sir.
Actually, the patients who are having less duration of the sleep with fragmentation, sleep fragmentation, in the daytime they may have a microsleep. So somebody is feeling sleepy is different, and they'll sleep for microsleep. Microsleep by definition is when sleep intrude into the wakefulness. Somebody is wakeful, but transiently, just for 3 or 4 seconds, they close their eye and sleep, and they wake up. So that's the thing. So somebody is driving. That gentleman was driving and he hit another vehicle. So that is a microsleep that can happen with the people who have sleep fragmentation.
Excuse me, sir. You were telling about the night shifts and the risk of CVD. So what is the remedy for that? Because we cannot ask them to, all of them to take a day shift. So what should be done for them?
So that has to be individualized, because everyone is doing night shift, even the doctors are doing night shift. Somebody is preparing for the examination. They also sleep for they don't sleep for 2 or 3 days and having less sleep kind of thing. So that's becoming a very common thing. For that, changing the job is not the answer. Changing the lifestyle and adopting. Even when they have that night shift, morning they should have an uninterrupted sleep, and they should have the control of the other risk factors. Say, for example, they should not indulge in the binge eating, maintain their weight, maintain optimal control of the blood pressure, other lipid parameters, glycemic parameters. all those things, including the stress management, is more important.
That
It's not that like somebody who is doing night shift, all are at risk of developing some kind of thing.
Okay, but does that to reduce the risk of CVD if they compensate it with day sleep and almost with the diet pattern, good diet pattern and healthy lifestyle?
The thing is the other way around. People who are doing night duty and the next day, if they don't sleep, if they have a fragmented sleep, they are at risk of developing CVD.
Okay. How many hours of
Excuse
sleep you
me,
need?
may I request the chairpersons to kindly conclude the session because we are running far behind the schedule. I am very sorry, speakers. Ma'am, you can ask your question during the lunch break. Thank you so much, madam. Sir,
Thank
please.
you,
Thank you so
Dr.
much.
Narasimhan sir and Chandrasekhar sir for your valuable inputs on dyslipidemia and sleep. And we thank TRAC organizers and RSA and faculties and the delegates for attending this TRAC. Thank you very much. The lunch will be followed on.
Thank you very much, chairpersons and speakers. It was a very delightful session and sorry for cutting it short in between because we have to run the quiz prelims now. So I request all the students who are participating in the quiz to kindly come into the front area. So you can take the front now. I request all the students participating in the quiz to please come up in the front without delay. I think you people didn't have your lunch yet. So if you want your lunch, you come early. Quiz. Quiz is only for the students. Sir, it is your responsibility. I cannot take care. Sir, it is your responsibility. I do not know. No, I don't think so. Somebody would have kept it somewhere down or something maybe. So we really do not know. I was sitting here only behind. I didn't notice. So how many teams are there? May I know? Please, there should be 2 in a team. You should be clear with the rules. 2 in a team. All should be students. So I will request you to please write your names, team 1, 2, 3, 4. Just write team 1 and 2 names and from which college. Excuse me, you are participating, right? So write team 1, your name 1 and 2 and just pass it to the next team so that I have an idea how many people are participating in the quiz. So please sit in teams of 2. Don't sit nearby. Keep a good distance so that if you are discussing, the other team may not overhear you and write your answer. They may, even one single answer difference will make a lot of difference. So please sit a little wide apart. You can use that side also. You people, all 4 are participating. So I'll suggest 2 sit here, 2 sit on that side. No discussion. 2 teams. Please. I don't want 2 teams on the same table. So we have so much of space. Please come over there. Yes, there are tables over there. So each team in a different table. These 2 can go another table. 2 here. You 2 are participating? Yes, they're writing their names. So I'll pass you a white sheet. Again, you have to write your team name or number or at least your names. And I would request each one of you, I'll come to each table and you have to show me your ID card. Proof that you're a student. Proof of student. Yes. You're from which college? Yes, good. So Ramesh will vouch for you. MMC official group. This is a new way. Okay. Show me the proof of great ways. Huh? They may say yes, even if you are not. Yes, you bring it. I have time. Okay, take this paper. Write your names. If you don't write your name, I will not be able to judge. Each one has got a paper now. So before I start the quiz, anybody who has not got the paper sheet? Okay. So now we have team 1, Aditya and Sudarsh. Team 2, Ilambirai and Sasidharan. Team 3, Priyanka and Syed Mohammed. Where are you? Yeah. Team 4, Swaroop and Wasim. Yes. Team 5, Kabilan and Prakash Raj. What of the other teams? You have not written your names here. Please write your names. So we have team 5, team 6 onwards. I have asked you to sit on the other side, not on the same table, please. So we have 1, 2, 3, 4. Written your names? No, you pass it. So we have 8 teams, right? No, it's okay. 6, 7, you have written your name? So you should write your name alone. And you should find a partner by tomorrow. You have time. You have written. Okay, so all 8 teams are here now. So a very warm welcome for this quiz prelims and wish you all the very best. Where did I leave my phone? Okay. So are you all ready? Next slide. Slide changer irka? Slide changer vachirkீங்களா? Okay. So these are the rules of the quiz. There will be only 20 questions. Each question has 1 point. If a question has 2 parts, then it will be divided into 2, 0.5, 0.5 for each. Right? Now we have star questions, that is 1, 5, 10, 15 and 20. So these star questions are for tiebreakers. So if I have two teams with the same score, the tiebreaker will be these questions, right? And how will I, if the tie persists, like suppose both the teams have given all these answers correct, or equal number of answers right and equal number of wrong in the star questions also, then I will go by sudden death. That is, I will start with question 1, both are correct, all right. Question 2, both are correct, all right. Question 3, one team has done correct, second has done wrong, they are eliminated. Okay? Right, sudden death, because I cannot keep on coming again. Now I want you all to have fun while you are writing your quiz, and if you are not having fun, I will deduct again 10 marks. Okay? So people who are not having fun, if I feel you're not having fun, I'll deduct 10 marks. All right? Yes. No, it's just kidding. All right. So you have to write your answers in the sheets provided, and if you write it anywhere else, I'll not give marks for that. And spellings really don't matter, but it should not be like, it should be sensible, right? Even if there is an error, I, E changes and all, I don't really mind. And then I should be able to understand what is written, right? And if I'm not able to understand what is written, again it will be wrong and you have a negative marking for that. And it is preferable to write all your answers in caps, right? Usually when we write in caps, it means yelling. I'm not yelling, and my decision will be final, right? So we'll move on. Everybody ready? Anybody has any doubt about the questions? And I don't want the other audience to please, I mean, I request the audience to not say the answers loud if you know, right? I think the audience will help me. So now the first question, tirzepatide, a very new drug. So which incretin hormones or receptors it is acting? So it's a agonist. So on which hormone receptors it acts? Moving on to question 2. Look at the picture carefully. Now there are 4 drugs written here. Out of these 4 drugs, which of the drugs can cause the condition which is shown in the picture? So now first you have to identify what it is showing. Look at the arrow mark carefully. And then you have to tell which drug will cause this problem. Is it pioglitazone, cana, lisinopril or istradipine? I will tell you after the quiz is over. Okay. So if you know, you will answer. Moving to the next question. Which glut is responsible for glucose transport in the sperm? Very important and very simple. Now look at this person. He's John Shore, right? He has developed an invaluable tool which is used in neurological assessment. And he was a small 2 more things about him. He was a trumpeter and lutenist at the Royal Court, and he did this. This invention was in 1711. So what was the tool which we use in neurological examination? What tool did he invent? So trumpeter and lutenist may give you a clue. So that's why we teach you history also. You should read history. Right. So what is this structure? Certainly it is some molecule, something related to diabetes. Structure of something. Guess if you can. If you know, please write. Next question. What contribution was made by this person to the field? So first is you should know who he is, and then what contribution he made. And I'm hoping that no one is using your mobile phones and trying to find the answers. Usually, actually for the finals, I will collect the mobile phones. So moving on to the next question. What? What was this? Why was this? Why was this? No, why was this? They're all attending a conference on diabetes. So this much they should know. Why was this? What is the leading cause of mortality in children with DKA? Very straightforward question. In children, pediatric age group. Now here's a question on an elderly man who was brought to the hospital with confusion and drowsiness. His son says that he had been urinating more than normal and eating very little over the past week. Blood sugar 800. Which of the following will not be seen in this patient? So when you see this patient, which of the following is not there? Serum osmolarity more than 350, small breathing, normal pH, pre-renal azotemia, hyponatremia. Which of the following is not seen? So if you feel that all of this will not be seen, you can mark all the answers. If you feel only one will not be seen, one, two will not be seen, two, three will not be seen, three answers, but you should write. Moving on to the next question. Which type of renal tubular acidosis can develop in individuals with diabetes mellitus? So they can develop any type, but which one is more common? 1, 2, 3, 4. So halfway through, from which cell is the hormone leptin derived from? Now there is a twin cycle hypothesis which proposes that type 2 diabetes is driven by two interconnected cycles of fat accumulation. I want to know, where do these two cycles take place? Thirteenth question, in fetal life, insulin secretion begins at which week? How many parts are there in an insulin receptor? This is a very direct question. You would have all seen the picture of the receptor. Just think, how many parts? This is the star question at 15. An experimental rat is injected with a drug that causes all of its pancreatic beta cells to die. After 14 days, which of the outcomes is least likely? A rise in plasma hydrogen concentration, fall in amino acid concentration, rise in amino acid concentration, or a rise in plasma osmolality. So looking at the question now, you are only left with two options. So if all the beta cells are gone, if there is beta cell depletion, which will not happen? What is the maximum daily dose of repaglinite? There's a clue in the question. For those who have a very good observational skill, there's a clue in the question. If you all are smart, you'll all get this right. Next question. Oil drop cataract is seen in patients with what? Which drug was the focus of SELECT trial? There was a trial called SELECT trial. So diabetes drugs, they will keep having different names, different named trials. So this is one such trial. So for which drug? SELECT trial for which drug? Second last question. The increased incidence of rhinocerebral mucormycosis in patients with DK is due to increase in which metallic ion? Valency doesn't matter, just name of the metallic iron is sufficient. So moving on to the last question. Your aunt is living in Florida, or maybe uncle, ask you to find out if she needs to alter her insulin dosage before boarding her flight back to Kolkata tomorrow. Does she need modification? And if yes, how should it be modified? Traveling from Florida to Calcutta, Kolkata. So this is a case of transatlantic flight. So with this, we finish the prelims. Thank you everyone, and thank you from Dr. Abhideep, who's not able to come personally to conduct the quiz because he's busy with another anime quiz in Chennai. Thank you so much. So the finals will be tomorrow afternoon after the lunch session, and I hope all of you will be there, because that time only we will be announcing the results, and then only I will tell you the answers to these questions, right? Right now even I am hungry, and I am sure you all will be hungrier. So we will wind up for lunch. So please attend the conference. Questions will be from the conference. So if you would have attended sessions, there were questions from the sessions today. Can I have the answer sheets? Finished? You have written your names? Yes. And the college? Names, your names, and from which college you are coming from. Thank you, thank you. I need 8 sheets. So we are already getting late. The session has started on the nearby hall. So we'll move to our scientific session 11 today. And I request Dr. Dharmarajan sir and Dr. Jeevan Chandra to kindly come and chair the session, please.
Good afternoon, everybody. So, this post-lunch session, the first one is tackling insulin initiation hurdles with premixes, particularly LISPO premixes. I call upon Dr. Madhavan, the speaker, to the dais.
Professor Madhavan is our teacher. He is the former director and HOD of the Institute of Diabetology at Madras Medical College and Rajiv Gandhi Government General Hospital, and is a very popular, renowned speaker and teacher for all of our diabetologists throughout the state, well known throughout the state, and would like to invite him for the talk. Over to you, sir.
Good afternoon, and thank you, Dr. Devaraj, Chairperson, for the nice words of introduction. So, this is my disclosure. This is a corporate symposium. I'm doing it for CIPLAB. Because all of you agree that type 2 diabetes is a progressive disease. By the time you make a diagnosis of diabetes, 50% of the beta cells are already lost, and the remaining beta cells are also likely to die by a process called beta cell apoptosis, ultimately leading to the so-called beta cell failure, when very often, in spite of the fact that we have molecules like SGLT2 inhibitors now, we may be forced to introduce insulin. So insulin still, even today, after 102 years of its discovery, remains one of the most important drug in the management of type 2 diabetes. But unfortunately, initiation of insulin is very often delayed. In fact, many patients remain in poor control of diabetes for almost 7, 8, 9 years before insulin is initiated, making the patient remain in poor control for very long years, which is one of the most important driving force for micro and macrovascular complications of diabetes. So why should we start insulin very early in a timely fashion? One, insulin is the only molecule which can produce A1C reduction of about 5%. All the other drugs, both oral and injectable, can at the maximum produce A1C reduction of about 1 or 1.5%, whereas insulin can produce A1C reduction of almost 5%. And it does it immediately. Within a short period after starting insulin, you can see the results reduction in A1C. We know that beta cell preservation is very, very important. So by giving insulin, you are going to give rest to the remaining beta cells so that they get revived and the native insulin secretion is maintained. So it is also important for beta cell preservation. And then of course, it is the only molecule which is going to give long-term control of diabetes. The durability of insulin is very best compared to all the other drugs which are used in the management of insulin. But unfortunately, there are a number of hurdles in initiating and intensifying insulin. This study looked at the Indian context, what are the values, the glycated hemoglobin, fasting and post-meal blood sugars before the physician start the patient on insulin. And you will be surprised to see that most of the time the A1C is above 9 for long periods of time. Fasting is around 170 to even 200, and the postprandial blood sugar at any time of the day is about 300 sometimes. We know that especially in the Indian context, postprandial blood sugar is very, very important because our carbohydrate intake is very high. And we know that postprandial excursion can result in very high glycemic variability and poor time in range, which can again result in endothelial injury and precipitate cardiovascular morbidity and mortality. So, what are the hurdles? You can broadly classify them into two categories. One is the patient-driven hurdles. The misconception about insulin, myths that insulin can cause complications of diabetes. Many people would have heard patient coming and telling you that insulin can damage the kidney. Psychological insulin barrier, the pain of needle, that is also one of the important reasons. Hypoglycemia and weight gain, these are all days when patients go and look at the online information and say, this can produce hypoglycemia and weight gain, which is true, but appropriate use of insulin, definitely we can avoid hypoglycemia and weight gain. You have to tell the patient that. And of course, there is always a stigma, social stigma of taking insulin at 2 or 3 times a day. And of course, sometimes the regimens are complex. That also makes the patient difficult to follow insulin regimens. And of course, there are certain religious and cultural beliefs about insulin. Unfortunately, it is not only the patient, but even the physician has certain misconceptions about insulin. They try to delay it unless it is absolutely necessary. Negative attitude and lack of confidence towards insulin initiation among primary physicians. They don't know how to initiate insulin, how to intensify. That involves more investigation, more monitoring of blood sugar, more frequent visits. They are also worried about hypoglycemia. Then if there is hypoglycemia, the patient may call you at very odd hours. All these things make the physician also a little worried about initiating insulin. And of course, physicians also believe that insulin can result in weight gain and hypoglycemia. And of course, patient education forms a very important component whenever you initiate insulin therapy. And very often, unfortunately, in a very busy clinical practice, we may not have the time to sit with the patient and educate the patient. So failure to initiate insulin when it is appropriate is called therapeutic inertia. So whenever you feel that insulin is essential, you must start it. If you don't start it, that is therapeutic inertia. That is a problem with most of the physicians. So what are the causes of therapeutic inertia for initiating and intensifying insulin therapy? In fact, provider-related, that is the physician-related hurdles are 50%. And then patient-related is 30%. And there are also certain social factors like economic factors, family support. All these things again can result in not initiating and intensifying insulin therapy. So what has been shown in several studies is that the median years before you start insulin in a type 2 diabetic patient who has been in poor control of diabetes is almost 7 years in a large percentage of patients. What happens when you delay insulin initiation? If you delay it for 5 to 7 years, the A1C level is maintained between around 8 to 9% for a very long period. Microvascular complications of diabetes, especially retinopathy and blindness, can be initiated and accelerated if the A1C remains around 9 and you are hesitant to start insulin. And of course, it has been shown that it can also precipitate and aggravate macrovascular complications of diabetes. Delayed initiation can result in heart failure by 64%. We now know that heart failure is present in 50% of the type 2 diabetic patients 5 years after diagnosis of diabetes. Asymptomatic heart failure, ejection fraction preserved heart failure. So that can again be aggravated if you are doing delay the initiation of insulin. Myocardial infarction can be increased by 67% and stroke by 51%. So both micro and macrovascular complications of diabetes can be aggravated if you are going to delay the initiation and intensification of insulin. So how do you overcome these barriers. So one of the most important thing we have to understand is that Indian patients respond very differently to a carbohydrate meal compared to the Caucasian population. For the equal amount of carbohydrate, the postprandial rise in blood sugar is much more in the Indian phenotype compared to the Caucasian population. So any type of insulin regimen you initiate should take care of not only the fasting but also the postprandial hyperglycemia. Unless that is done, we cannot achieve glycated hemoglobin targets. This is about the Monier's concept. Monier felt that whenever the A1C is very high, 9, it is the fasting hyperglycemia which contributes to A1C. And as the A1C comes down to around 8, 7, then postprandial contributes equally. But it has been shown in several studies that in the Indian context, in the Indian phenotype, it is the postprandial hyperglycemia which contributes to A1C across the spectrum of A1C, from 6, 7 to even 9 and 10. So even at higher levels of A1C, it is a postprandial hyperglycemia which majorly contributes to the A1C. So what is the solution for this? So we have to choose an insulin which takes care of both the fasting and postprandial blood sugar. So the need is for a combination which takes care of, controls the fasting and also takes care of the postprandial. And of course, we can start with once a day and make it twice a day. And these days, we can even give pre-mixed insulin 3 times a day. That has been internationally accepted. So sometimes you start with once a day dose, the injection numbers are less. So it is better compared to the basal bolus or basal plus, and those adjustments can be individualized. The patient himself, once you educate them, they can go on, because the same type of insulin they are going to take once or twice. They can go on, monitor the blood sugar and adjust the dose of insulin, and it simplifies the regimen. You give one type of insulin in the morning, the same type of insulin can be in the night. They need not have 2 pen types or 2 vials of insulin. So that is a complex insulin regimen which many patients may not understand. So the efficacy, how do you, because if you look at the literature, most of the world bodies and literature says that whenever you initiate insulin, start with a basal insulin. Continue the oral agent, start with basal insulin, fix the fasting first. That is the concept. You fix the fasting, then controlling the postprandial with oral agents is very easy. But unfortunately, in the Indian context, this is not true. Only about 30% of the type 2 diabetic patients who are on maximal dose of OHA, sometimes 3 or 4, and then you give a basal insulin, ultimately achieve A1C targets. Others require control of postprandial hyperglycemia to achieve A1C targets. So this is a trial by Melon et al. He compared glargine with metformin with twice daily pre-mixed insulin and looked at its efficacy and adverse events. What happened? So you look at the glucose profile. This is a continuous glucose monitoring. You can see that the patients who were on mixed insulin twice a day had much lesser fluctuation. So that the inter-day variations in blood sugar and thereby the glycemic variability was much better when twice daily pre-mixed insulin was given compared to the upper one. Yellow one is the glargine with metformin. You can see that the inter-day variations is much higher when glargine alone is given with metformin. And look at the A1C reduction. A1C reduction was around 0.9 at the end of the study for those cohort of patients who were on metformin with glargine, whereas the A1C reduction was 1.3 for those cohort of patients who were on pre-mixed insulin twice a day. So if you look at the efficacy, how many patients achieved target A1C levels, how many achieved fasting glycemia, control of glycemia, and how many achieved postprandial. Again, you can see from the bar diagram that patients who were on mixed insulin achieved a better control of all the parameters like fasting, postprandial, and glycated hemoglobin. And of course, whenever you start insulin, hypoglycemia is the limiting factor. One has to be very careful about hypoglycemia. And this study looked at hypoglycemia. You can see that overall hypoglycemia was not statistically different between the 2 groups, because there was little less in the mixed group, but little more in the glargine group. But if you look at the nocturnal hypoglycemia, that was naturally little more in the glargine group. That is understandable. You are going to give insulin at bedtime. Sometimes sleep time hypoglycemia occurs. But again, this was not statistically significant. So the overall hypoglycemia was not different between twice daily pre-mixed insulin and the glargine given at bedtime. So this study concluded that
the combination insulin given twice a day is associated with significantly greater A1C reduction at the end point, enabled a larger proportion of patients to achieve target A1C, that is less than 7, improved glycemic control after breakfast and dinner. That is very important. Your basal insulin given at bedtime may control the fasting, but may not control the postprandial excursions in blood sugar and result in higher overall hypoglycemia rate, but similar in nocturnal hypoglycemia. And Mix 25 provides optimal insulin starting regimen for patients because the regimen is very simple and the patient can intensify later from 1 to 2 to even 3. So what we arrive at the conclusion. The premix combines rapid and intermediate acting insulin, effectively control both fasting and postprandial. And that is very important in Indian context. It achieves A1C reduction comparable to even basal bolus insulin. I will be showing you some more data to show that even compared to basal bolus, where you cover each meal with a bolus insulin and give basal insulin once or twice a day, this regimen is better and then typically given once or twice daily. So the number of injections compared to the basal bolus, where you give at least 4 injections, is much less, and simple schedules of fewer injections, same type of insulin given in the morning and night. So the complexity of regimen is also removed. The patient can easily follow it. So who are the patients who are suited for this type of insulin? So individuals with typical Asian Indian phenotype, where the carbohydrate content is very high, the postprandial excursions are very high, where basal alone may not be enough. So such patients may be started even at the initiation of insulin with premix insulin. Patients who for convenience, the same insulin morning and night. So that can be given both in the morning and night. That is also another reason why you should choose premix insulin. And there has been a delay in starting insulin, and the risk of failure to basal insulin is very high because the patient has been diabetic for 10 years, 12 years, have been remaining in poor glycemic control for long periods. It is very, very unlikely that he is going to be controlled only with basal insulin. So the duration of diabetes, longer the duration, then it is always better to start a premix insulin once or twice a day. And prolonged uncontrolled hyperglycemia, I have already alluded to that. Symptomatic diabetes, where the patient has got symptoms of diabetes, polyuria, polydipsia, then vulvovaginitis or balanitis, all those cachexia. So those patients are suitable for premix insulin twice a day. And whenever there are associated comorbidities like diabetic foot syndrome, again these patients are suitable for premix insulin. Lifestyle.
Thank you, sir. The time is up.
Time is over? Can I take 2 or 3 more minutes? Okay. So irregular meal patterns, high carbohydrate load, all these patients are very suitable for premix insulin. So this is again about the focus of today's talk, insulin glargine versus insulin lispro. This was again a durable trial. The results were published very recently. Looked at, compared the lispro mix to glargine. Again, you can see that the change in A1C from baseline was better with lispro mix compared to glargine, and the durability of the combination was also much better compared to, durability is very important, how long it maintains the A1C target. So these are all the, so what we have come to the conclusion is that LM50 is better, it reduces the postprandial sugar. Bedtime blood sugar is also reduced when you give twice daily mixed insulin, and the mean SMBG excursion, which ultimately leads to glycemic variability and poor time in range, is also better taken care of by a combination of short-acting and long-acting insulin. Then there is always a question, what about 50-50? Yes, sometimes you can also use 50-50 in the morning and 25-70 in the night. Suppose you feel that the postprandial hyperglycemia is more with breakfast and lunch. You can always give 50-50 in the morning and 25-70 in the night to control the fasting hyperglycemia, and also to avoid the nocturnal hypoglycemia, because nocturnal hypoglycemia is very serious. It can even result in cardiovascular morbidity and mortality. You want to avoid nocturnal hypoglycemia.
Sir, final concluding.
Shown. Thank you, sir. I think last slide, sir.
Yes, sir. Final concluding.
I'll come to the conclusion.
Yes, sir.
So this is again the quality of life about the two combination. Again, it showed that the quality of life
is good with premixed insulin. And like this is the last slide. Switching from basal insulin to premix is a viable alternative to adding prandial insulin, simpler than basal bolus and suitable for patients unwilling or unable to manage the complexity of the insulin. And these are all the recommendations by the world bodies. The ADA, the IDF and our own RSSDA says that if basal insulin is alone is not enough to achieve A1C target, you can always go for premixed insulin. I think this is the last slide. Thank you. Summary, patient-related advantages, simple to understand, no complex carb counting and isolated, one point pen for both basal and prandial insulin, fewer injections and less frequent intensification. So there are also certain physician-related advantages. Thank you very much.
Thank you, Professor.
Sir, thank you, Dr. Madhavan, sir. Thank you very much for explaining vividly, sir. Thank you very much.
Yeah, we can move on to the next topic, sir.
I call upon the next speaker, Dr. Arun Kedia, who will speak on diabetes and bone health. Welcome, sir.
So good afternoon to everyone. This is my first visit to Tamil Nadu, and I express my gratitude to all the organizers for having me here. So since morning we've been hearing on various aspects of diabetes, right from weight control, then we talked on lipid control, we talked on management of sleep, and now in the next few minutes I would discuss on management of bone disease, especially the rising osteopenia and osteoporosis in patients of type 2 diabetes. Can I have my slides? So bone health is one of the neglected aspects of diabetes. The reason is that despite knowing that there is definite skeletal fragility in diabetes, it is a very poorly understood phenomena. And the major problem is that we still do not have ways of proper assessment of skeletal fragility in our patients. So if you see the epidemiology or the availability of DEXA machines, which are the primary requirement for assessment of bone disease, in India, if you see the average, we have one machine for almost 10 million population. So it's almost not available for majority of the population. And more so, there are pitfalls in BMD assessment in patients of diabetes, which I'll come to my talk till the slides.
Sorry for the technical delays, a few seconds.
Yeah, sure. So I'll carry on.
Yeah, sure. We are pleased.
Yeah. So there are differences in type 1 and type 2 diabetes also, because type 1 has a very early disease onset, while type 2, we all know, has a slightly later onset. But then the target for both hyperglycemia is the bones. And that is where we need to understand how we assess skeletal fragility in patients of diabetes and what can be done to prevent them. At the same time, we also need to understand the various factors other than hyperglycemia which affect the skeletal fragility in patients of type 2 diabetes. So, if I could have my slides.
Yes, yeah. We are there. We are almost there, sir.
Okay. So I've already given an introduction, and I said it is increasingly recognized but poorly understood. So the outline of my presentation would be, I discuss on the prevalence and outcomes of skeletal fragility. We'll see how is it different from non-diabetics, whether the skeletal fragility is specific for type 1 or type 2, and if yes, then why. We'll also discuss on the effects of anti-diabetic medications on skeletal health, then how to assess and how to manage. So if you see the pathophysiology of skeletal fragility or any fracture in our patients, we either have to have a decreased bone mineral density or a decreased bone quality, and the third contributing factor would be a frequent fall. So if you have any of these factors, probably you could have a patient of diabetes who lands up in fracture. And the fracture risk in diabetes, we have different epidemiological studies which have shown that Compared to non-diabetics, that is 32% increased risk of any fracture, and this risk is highest in type 1 versus type 2. In type 2, we have again higher risk for all sites in men compared to women, and we have very few data from Indian studies which shows that almost 30 to 40% of patients of type 2 diabetes have osteoporosis in their life. This is probably one of the longest data where we could compare the fracture risk between various population. It was a population-based data of more than 65 lakh patients with a mean follow-up of 7 years. And what they found that the risk fracture at all sites for diabetes versus non-diabetes, it is 1.32. And this high risk of fracture at all sites in type 1 versus type 2 with highest for hip. Now, when we say highest for hip, you have to take this with a pinch of salt because many a times the vertebral fractures go unnoticed compared to the hip fractures, and that is why there is more reporting of hip fractures. So it's not like that hip fractures are more common. Interestingly, in type 2 diabetes patient, it has also been found that long-term type 2 diabetes increases the risk of fracture, but for a newly type 2 diagnosed patient, there is a decrease in the fracture risk, probably because of obesity. So there is an opposing effect of overweight or obesity versus long-term diabetes complications which contribute to the bimodal presentation of fracture risk in patients of type 2 diabetes. So if you see the evaluation of risk factors for fractures in diabetes, it is type 1, they are continuously at risk for fractures. Then type 2 diabetes patients more than 5 years, poor glycemic control, presence of microvascular complications, and if you have a patient on certain drugs like insulin, sulfonylureas and thiazolidinediones, they are at a higher fracture risk. And what are the outcomes of these fractures? You can have increased mortality. We have seen a large number of patients, once they develop a hip fracture, they never get up and they'll land up with complications. At the same time, we have a poor prognosis after a fracture in diabetes because of delayed wound healing, more frequent infections, longer hospital stays, higher post-operative cardiovascular events, and greater rates of readmissions. And that is why we are concerned about preventing fractures in our patients. So coming back to understanding the bone strength now, bone strength has two components. One is the mineral content of the bone, and the other is a bone quality. So we talk in terms of quantity as well as quality. When we talk about quantity, we measure it with the bone mineral density, and that is what a DEXA machine gives. But just remember that only 70% of the variability in bone strength is determined by BMD, which clearly makes you understand that not everything can be calculated with the help of BMD, and that is where we underestimate the risk of fractures in type 2 diabetes patients, because there the problem is not bone mineral density, but it is the bone quality. So we need to address both bone quality as well as bone mineral density. Now coming to the pathophysiology, we all know BMD becomes lower in type 1 than in type 2 because type 1 patients are lean and thin. But if you see the fracture risk, both type 1 and type 2 have increased fracture risk, probably because of both bone poor quality, bone mineral content and microarchitecture. Diabetes patients are prone to frequent falls, contributed by mainly the peripheral neuropathy and of course then the medications. But if you see this cartoon on the right hand side, you can see that when you have diabetes at a young age, especially for type 1, they have a difficulty in achieving the peak bone mass. And the concern now is that we are having more and more younger patients with type 2 diabetes, and there we have a still more concern that probably when we have these patients at the age of 40-45, they would be at risk of severe osteoporotic fractures. So hyperglycemia leads to advanced glycation products, and that leads to decrease in the collagen content. There is a cross-linking of collagen which is faulty. At the same time, you have hyperglycemia which increases sclerostin, and thereby it reduces bone mineralization, and there is an increased osteoclastic activity which ultimately leads to increased risk of osteoporosis. And this is in more detail and more molecular pathway who would be interested. So on one hand you have hyperglycemia which directly affects increase in adipocytes, which increased adipose tissue deposition within the bones, also leads to osmotic diuresis causing electrolyte imbalance, especially the calcium and magnesium, and then there is a loss of incretin effect. At the same time, there is increased adiposity leading to leptin resistance and brown fat leading to increased sclerostin, and then you have the inflammatory pathway which leads to increased cytokines and increased bone resorption. So as I was saying, that DEXA recommendations we have for type 1 diabetes, and for type 1 diabetes it starts from late adolescence or for any patients with poor glycemic control. But as I said, DEXA does not estimate the bone quality, and that is where 30% of the cases are missed. And this bone quality, the biggest tool that we have presently is the trabecular bone analysis or the score. Apart from that, you can do a hip structural analysis, you can do a high resolution peripherally quantitative CT, or you can do a bone histomorphometry. But these are more invasive. What is available readily in higher centers is a trabecular bone score. So trabecular bone score is nothing, just it is done using a special software which is based on the pixel gray variability of spine exam images. So if you see these images, you can see that there is a uniformity in the porosity in the first image compared to the second image, and the machine calculates this porosity and the uniformity of porosity, and what it gives a calculated score. It gives an overall score which is calculated after transforming the 3D structure and projecting into a 2D plane. So this score is calculated only at the lumbar vertebra. So the guidelines say that you have to do trabecular bone score only at the lumbar vertebra, and there are reference range, but this is not validated by WHO as of today. But for all practical and academic purposes, more than 1.35 we take it as normal, and less than 1.2 we take as a serious degeneration. And there have been multiple studies in type 2 diabetes. One of these studies where you can see that the comparison of bone mineral density versus trabecular bone score in the same patient, you see that the trabecular bone score is 2.6, which scores on higher when you compare it with the BMD. So what are the correlates of trabecular bone score? So trabecular bone score would negatively correlate with BMI, waist circumference, insulin resistance, fat mass, and HbA1c. So considering all these risk factors also as one of the aggravators for metabolic syndrome, and it positively correlates only with lumbar spine BMD, and that is why trabecular bone score is done only for the lumbar spine. We promote a lot of weight loss now in diabetes, and at the same time we also have spontaneous weight loss in diabetes. But remember that with weight loss you also have bone loss, and there have been studies that if you increase weight loss, you have increased fragility of the bones. At the same time, patients who have been on GLP-1 receptor agonists, patients who have undergone bariatric surgeries, they are also prone to osteopenia and osteoporosis, and that is why when we try to promote weight loss, we need to also promote at the same time resistance exercises along with the weight loss. So that is one thing which we need to keep in mind. Also, we need to have quite a good knowledge on effect of diabetes treatment on skeletal health. So if you look for neutral or positive effects, then you have metformin, DPP-4 inhibitors, and GLP-1 receptor agonist. If you see the negative effects, you have with thiazolidinediones, sulfonylureas, and insulin. And then we need to have other consideration, like you need to have HbA1c target to the best possible control. At the same time, you need to prevent hypoglycemia related falls, because I said frequent fall could be one of the other risk factor for osteoporotic fracture. Do we have serum markers to diagnose osteoporosis? As of today, no. But we do have serum markers now to study the efficacy of the drugs and for follow-up of a patient who is on anti-osteoporotic treatment. But to diagnose skeletal fragility, we still do not have any serum biomarkers. So how do we approach a type 2 diabetes patient? So either if the patient presents to you with fragility fracture, or the patient presents to you with a clinical risk factor for fracture, you need to calculate their BMD, do a thoracolumbar X-ray, especially if you find your patient having a reduction in the height, and then you can use fracture risk calculators like TRACs, which we have online availability. Look for the T-score. If the T-score is less than minus 0.2, 0.0, then that patient is at a higher risk, and if the patient is having less than minus 2.0, then you have to go for 1 or 2 yearly assessment. I'll come to some specific risk factors for diabetes, but in general, if you have to go for approach, you have to go for lifestyle interventions with medical nutrition therapy and exercise, which includes a moderate weight loss. But at the same time, this weight loss should be associated with intense walking and weight-bearing exercise. We need to limit alcohol and stop smoking. For treating type 2 diabetes patients, try to prefer metformin, sulfonylurea, DPP-4 inhibitor, and GLP-1 receptor agonist wherever required, and avoid thiazolidinediones in patients who are at risk for osteoporotic fracture. We need to check and treat blood pressure, vision, neuropathy. This has to be a continuous assessment. And if we really find out that there is a need to treat osteoporosis, then we need to prefer bisphosphonates in majority of the patients, and we need to keep monitoring these patients. Few important tips that we need to keep in mind for management. We need to identify diabetes specific risk factors. So type 2 diabetes, if you have a duration more than 5 years, presence of micro and macrovascular complications, persistent HbA1c more than 8%, patients at severe hypoglycemic risk, and patients on high dose of insulin, thiazolidinediones, and canagliflozin. These are the major patients of type 2 diabetes who are at high risk of osteoporosis. And when you consider anti-osteoporotic treatment, you need to give it to all patients who present to you with either a fragility fracture or a BMD T-score less than -2.0 on a DEXA scan. We need to consider fracture risk above country-specific thresholds. And for type 2 diabetes, we have different calculators like FREX Plus or Q fracture score. On the FRAX, again, you have some modifications that you need to do for diabetes, because FRAX does not account for diabetes as a risk factor. So what are recommendations? You reduce the T-score by 0.5. So if a patient has 1.5 on DEXA score, for that same diabetic patient, you will put it as 2. Or you increase the age by 10 years. So if you have a patient of 50 years, when you enter on DEXA score, the FRAX calculator, you put it at 60 years. Or you select rheumatoid arthritis as a comorbidity, or you include trabecular bone score adjustments. So this is the way that you can actually find out what is the risk for your patients. Then which anti-osteoporotic pharmacotherapy? So if you have a hip fracture, preferably you go for IV zoledronate or injection denosumab. For vertebral fractures, we have found that teriparatide scores over IV zoledronate and denosumab. And for maintenance therapy, you can use oral bisphosphonates. And for those patients who have no fractures, you can use either oral or IV bisphosphonates to reduce the fracture risk. Calcitonin has no role except for some pain relief in the fractures. Certain precautions that you need to keep in all your patients: select glucose-lowering medications with neutral or beneficial effects on the skeleton. Maintain adequate vitamin D, because this is something which we can practically do in all our patients. And remember, if your patient is obese and if your patient has malabsorption or your patient has gastroparesis, then probably these patients might require a higher dose of vitamin D than what is recommended. Also, we need to supplement adequate dietary doses of calcium for these patients. Ask them to maintain an active lifestyle with weight-bearing and balancing exercises. Limit alcohol, quit smoking, and keep on assessing the patient's false risk and improve their physical function. This is very, very important that we need to holistically approach all our patients. So for skeletal fragility, as I say, the mechanism is still poorly understood, though the problem is increasing. So that is why I always say our knowledge can only be finite, while our ignorance must always be infinite. We need to keep researching on this aspect of diabetes and the risk on the bone health. And with that, I thank you all, and I'll be happy to take your questions.
Sir, Dr. Arun Kedia, thank you very much.
Thank you, sir.
Clearly explaining the effect of diabetes on bone health.
Thank you, sir.
And now,
Please be seated,
the
sir.
floor is open for questions.
Dr. Arun, sir, please be seated there. Over there.
Yeah.
Yeah. Please be seated.
Sir, come here.
Sir, in the case of supplement of calcium, whether it should be given daily or whether it should be given on alternate days, because there is a stacking effect is seen in calcium as well as in iron. So the absorption is not as rapid as expected. So we give it on alternate days. So what is your take on it, sir?
So I think with calcium, we do not have any such guidelines for giving it in alternate days. But definitely there are studies coming up for iron. Iron should not be given every day. But as of today, we don't have any study which supports the idea that you should give calcium on alternate day.
Because some years back I was attending some webinars and online meetings as well as in-person meetings. So that's what they were telling us, because it has got a stacking effect in the large gut. So it is better to give on alternate days. So that is why I raised up this question, because you are talking on the bone health.
So dosing of calcium has always been a matter of controversy. In fact, a few people also have the concerns of calcium being given daily, and it causes increased atherosclerosis also. Then there are issues of calcium increasing in patients with cardiovascular disease who have high calcium scores also. But dietary calciums do not affect much on these aspects, sir.
So whether this calcium intake daily, whether it will be contributing to the renal calculation, whether the patients who are having a recurrent renal calculation, whether it has got any impact on that?
So definitely in those patients who have hypercalciuria, they are at risk for calcium stones, but not all patients.
What about the trabecular score you are talking, sir? Is it available in the corporate hospitals, or whether it is freely available and you can assess the risk score?
It's readily available in most of the research institutions now, and in a few corporate hospitals also they are available, where they have dedicated setups for managing osteoporosis. So those centers who have dedicated centers for endocrinology and rheumatology, they have made it mandatory to keep DEXA machines. And you have good DEXA machines in all educational institutions, especially the premier ones in our country now.
Any other question from any other delegate?
Sir,
Yes, you can go.
Perimenopausal and postmenopausal ladies are definitely, they need calcium. Even 1000 milligram they are giving along with vitamin D3. My question is, the diabetic perimenopausal and postmenopausal women, they need more calcium, or 1000 milligram is enough?
So 1000 to 1200 milligram is the upper limit that we need to give to them. But at the same time, we often forget to assess their vitamin D levels. And second important thing is that the assimilation of calcium and vitamin D within the bones is also directly proportional to the amount of physical activity that you do. So it's not enough to just supplement them with calcium. It's more important that they need to be active, because the bone strength only increases with activity. There's a crosstalk between muscles and bones. So you have myokines, you have osteokines. So if you activate your muscles, the myokines, they act on the osteoblasts. And if you activate your bones, they secrete osteokines, which activates the myocytes. So it's a two-way process. So it's more important to have increased physical activity along with calcium supplementation. That is where we often forget to give the advice on.
Most of the Indians are vitamin D3 levels are very low. But my question is, any particular diabetic patient are related to the vitamin D3 level is very low?
Thank you, sir. You can shortly you can.
I couldn't get your question, sir.
Or we will
Most of the Indians are vitamin D3 level is very low. Diabetic patients are vitamin D3 level is very low. Any reason behind that? Vitamin D3 level is very low in diabetic patient. Any reason behind that, particularly in diabetic patients?
So there is no such definite reason for this.
Thank you, sir. Anyway, thank you. On behalf of my co-chairperson, I thank both the speakers for their excellent lectures on the respective topics. And because we are already running ahead of time,
yes,
we would like to close the session. Thank you for the organizers for the opportunity given. Thank you, sir. Thank you.
Thank you both the speakers. Thank you, Chairperson. Now we will move on to the next session. May I request Professor Dr. Shivakumar and Dr. T. Ravikumar over to the stage, please, for the next session. So, Professor Shivakumar. Dr. Ravi Kumar. Over to you, sir. Please, sir.
So over to chairperson, we can start, sir.
Good afternoon all. I thank the organizing committee for giving me the opportunity for chairing this session. So gut is described as the second brain. The enteric nervous system acts independent of the central nervous system, and it influences our mood, our behavior, and even our cognitive facilities. And the basis of the enteric nervous system is this gut flora. And any changes in the gut flora will result in various metabolic disturbances and many diseases of the abdomen. With this, I invite Dr. Vetrivel from Vellore. He's an eminent physician and he's going to talk on this topic.
Good afternoon, everybody. Respected chairperson, my affectionate seniors and colleagues and others. It gives me immense pleasure to be with you in this afternoon to talk on a rare subject which is budding now. I owe this topic to my mentor, Dr. Samji Moses and Dr. S.K. Rajan, sir. At the outset, I thank profusely the organizing committee of TRAC 25. You know, this chapter, which is going to deal with the gut microbiota and is imbalance with the most prevalent diabetic scenario in the world. Type 2 diabetes is a common metabolic disorder, you all know, characterized by insulin resistance and pancreatic cell dysfunction. Emerging evidence suggests there is a link between imbalance of the gut microbiota and the ongoing process of metabolic milieu in diabetic arena. Gut dysbiosis is an imbalance in the gut microbial ecosystem, which is dense and diverse, increasingly recognized as a crucial factor in the development and progression of this disorder. Changes in the composition of gut microbiota can affect metabolism, inflammation, and integrity of intestinal barrier, potentially contributing to less insulin secretion, insulin resistance, and other diabetic-related matters. See, diabetes has reached epidemic proportion, but there are so much of, fuss is attached with who is maintaining HbA1c less than 7. So we are searching for a new avenues for that. Studies have shown that gut inflammation, compromised gut permeability, impaired glucose homeostasis, lipid metabolism, insulin sensitivity, increased fatty acid oxidation, and interaction with the dietary components are the mainstay of this talk. There is clear growing evidence that a close relationship between these two is there, and it's worthy of future investment and research efforts, because this topic, whenever we talk in forum, it is undermined and overlooked. In a research I have found that the Indian guts have been damaged much due to the unwanted lifestyle measures, including the blunderbuss dietary schedule, and creating a lot of raft of disease condition, both physical and psychological. We have to salute our forefather Hippocrates, who said 2.5 millennium back, all disease begins in the gut. Health is written by gut microbiota. Death sits in the bowl. Yeah, bad digestion is the root cause of evil. After this 2.5 millennia, we just now starting to recognize the importance of it, and we are the doorstep opening the important vista. This gut microbiome, the science is exploding like anything. We carry 2 kg of a suitcase in our gut. People are sampling their own stools for the process of science and taking lot of probiotics in the form of yogurt, kombucha and kimchi and trying to foster good health. The science is exploding like anything, but we are just at the gate of it, as I told you. This hidden forgotten organ, which is the allobionant, is having nearly about 100 trillion microbes comprising of bacteria, virus, archaea, and the fungi. 3 million genes are there. Almost these species control all bodily functions. What are they? Before that, one has to differentiate between what is microbiome, what is microbiota. Microbiota is the organism itself. Microbiome comprises of organism and the genes, genomics, and the living environment, biome, and the theatre of activity, that the metabolites, which are called as postbiotics. So all the four comprising of microbiome. So in our gut, we have got 4 classes of microbiota. What are they? Firmicutes, Actinobacter, Bacteroides, Proteobacter. Each one imparts their function whenever they are healthy or whenever unhealthy. See, Firmicutes, which is the major portion, 47%, consists of Lactobacillus, Roseburia, Clostridium, Faecalibacterium, and others. In Bacteroides, we have got Prevotella and Alistipsis, and in the Proteobacter sector, we have got so much of Klebsiella, Pseudomonas, etc., which are gram-negative. In Actinobacter, we have got potentially good Bifidobacterium, Actinomyces, etc., and in this side, we have got the Akkermansia, Mucinopili, and Saccharomyces boulardii, which is a fungus. So, what are the various functions it performs? It performs immunomodulation. It performs preservation of epithelial intestinal integrity. And it prevents pathogen by secreting various metabolites like defensin, bactericin, etc. Not only that, it modifies the neurodevelopmental neurodegeneration. And it's not only that, it helps for digestion and metabolism of drugs, food, and xenobiotics. And also, it is useful for biosynthesis of vitamins. We all know about that. But the pity is that modern civilization pay that there are a lot of modulation factors like diet. Diet is the crucial factor. Whatever we eat, that's not going to preserve the good bacteria. It is going to create an imbalance, which we'll see. Then drugs like antibiotics, proton pump inhibitors, statins, steroids, geographical location. Life stages, what the children is having, they are not be possessed by elderly people. And birthing process, when the cesarean section, no good bacteria, dense bacteria or diverse bacteria. In normal delivery, there's a lot of good bacteria is acquired by the infant. So the feeding, the milking process, the lactation process, milk-fed babies, the breastfed babies are having good bacteria, whereas the bottle-fed is not having good bacteria. We are subject to much stress, psychological, metabolic, etc. These are the factors which modulate and produces imbalance in this. So gut biosis, the normal flora, when it's disturbed, we call it a dysbiosis. An imbalance in the between commensal and pathogen is known as gut dysbiosis, which lead to various diseases comprising of cardiometabolic, gastrointestinal, and neural, and pulmonary, and skin, etc. In this, we will be discussing about the important metabolic condition known as diabetes mellitus. See, gut dysbiosis in DM, decreased abundance of beneficial bacteria like Faecalibacter prusinici, Roseburia industrialis, Roseburia insulanevorus, and Akkermansia mucinophila. These are the important bacteria which cannot be disturbed. But in the diabetes, it is disturbed. Shift in the ratio of Firmicutes and Bacteroides, a decrease in the short-chain fatty acid producing organism, which will be important for prevention of leaky gut syndrome, which we will be alluding to, and it's going to impair the intestinal epithelial barrier integrity. The leaky gut syndrome allows certain things which we will be seeing, which is going to put havoc and create finally inflammatory state insulin resistance. Metabolic changes like a reduced short chain fatty acids production impacting glucose metabolism, insulin sensitivity, barrier function as I told you, then altering the bile acid profile, altering the branch chain amino acids, aromatic amino acids, and creating havoc. In addition to this, the pathogens producing TMA, trimethyl alanine nitrous oxide, and the branch side amino acids, and all are going to impact on the insulin resistance and produces finally CV risk. So these are the, this table depicts the decrease and increase which was discussed in detail. Gut microbiota in the pathogenesis and therapeutic approaches in diabetes is well dealt. You know, between 1995 up to 2005, there were about 9,000 papers released in the leading journals, but still the knowledge here in India is in the rudimentary stage. Now only we are making it, we will see. Bacterium like Bifidobacterium, Lactobacillus, Clostridia certain specimens, comprising of the gut microbiota complex, they are digesting non-digestible carbohydrates found in the dietary fibers, producing short chain fatty acids. These short chain fatty acids going to get the expression of G protein coupled receptors 41, 43 and 10A on L cells of the intestine, which will be emanating GLP, endogenous GLP-1 and P peptide, PWI, and decrease the PPR gamma activity, which enhances oxidative metabolism in the liver and adipose tissue, decrease the fat accumulation, mitigating the fat accumulation, thereby the lipotoxicity is reduced. When the lipotoxicity is reduced, there is an absence of cetramide, the triacylglycerol and diacylglycerol, which will clear a good liver function, though the insulin sensitivity will be more. Insulin resistance is not there. So this GLP-1 polypeptide WI decreases appetite and prolongs the gastric emptying, increases the peristalsis, and insulin sensitivity increase, insulin secretion increase, beta cell apoptosis prevented, and there is a lot of beta cell regeneration and good amount of beta cell function. So butyrate promotes the expression of tight junction. You know, butyrate is also one of the short chain fatty acid. It promotes the expression of tight junction proteins, occludin, zona-occludins and singulins, etc. And they will produce more expression of mucus secreting goblet cells. So thick mucus is produced, and they will close the gate of the junctions, which is guarded by these proteins, and prevents leaky gut syndrome. So butyrate, not only that, because of certain action on the epithelial integrity, prevents the entry-exit of LPS, which we lipopolysaccharide, which is an endotoxin, will be alluding to, which will be cause for the emanation of cytokines and chemokines and lipokines, especially IL-6, tumor necrosis factor alpha, thereby producing inflammatory milieu and increased insulin resistance, which is prevented by this short chain fatty acids, butyrate. When short chain fatty acids meet type 2 diabetes, how many minutes or more? 1.5 minutes. So, short chain fatty acids not only produces the expression of the protein coupled receptors on the L cell, producing more GLP-1 and WI, they will be producing more amount of beta cell function and prevents the formation of LPS. You know, whenever there is a gram-negative bacteria is more in the intestine, you could understand the wall of the gram-negative bacteria secretes LPS, lipopolysaccharide, which is an endotoxin. This LPS, when it expressed on the toll-like receptors 2 and 4, which are transmembrane receptors, they kindle the endocannabinoid system 1 and 2, traverse through the junction, and when the endotoxin traverses through the junction and enters the circulation, there is a condition known as metabolic endotoxemia. This metabolic endotoxemia is a root cause for pro-inflammatory state, which will be producing abundant amount of insulin resistance, thereby producing this thing, diabetes mellitus. These are the things. Secondary thing, the common salts are protection against conversion of bile acids to secondary bile acid, and prevention of the disposal of the emanation of branch-chain amino acids, aromatic amino acids. So these two processes will be prevented by common salts, which are simulated by the production of the branch-chain amino acids, aromatic amino acids, which are caused for intestinal. So, dysbiosis, decreased butyrate secreting organisms, increased permeability, changes in the bile acid pool, decrease in the bile acid catabolism, increase in the production of branch-chain amino acids, increased chain of amino acids, which will be producing insulin resistance. So, absence of gut microbiota, which are very good for internal milieu, they will be producing insulin resistance, leaky gut syndrome, and the decreased immunomodulation, thereby producing exorbitant insulin resistance and production of the diabetic milieu. This can be mitigated by the prudent use of what we call it as prebiotic and probiotics and good dietary fibers. The prebiotics are the food to the probiotics. Probiotics are living organisms which will substitute the deficient organism in the gut. So, naturally occurring prebiotic and probiotic, you have to know tomatoes, artichokes, onions, garlic, chicory, dandelion greens, asparagus, leeks, berries, bananas, flaxseed, legumes, and pitta, white or red of this dragon fruit. They are all very good prebiotics and probiotics. Probiotics, when you come, here the naturally occurring probiotics, sauerkraut, kimchi, kombucha, yogurt, cottage cheese, and miso soup, and all the fermented bread, which we call it as sauerkraut, and this bread all will help for preservation of probiotics. So when the prebiotics and probiotics join together, we call it as symbiotic. So prebiotics, probiotics, symbiotics are heavily available nowadays for usage along with the regular treatment of diabetes mellitus. Microbiota metabolites like short chain fatty acids, strong influence in diabetes mellitus. So there are various relations with the host metabolism impact on several pathways. There is a bidirectional relation, whether the diabetes mellitus impairs gut diversity or robustness, or the gut dysbiosis produces the diabetic milieu.
So I
There
think
are
we
lot
can
of
conclude the session,
ongoing
sir.
research is going on. There's going to be a couple of international conferences. One in Venice, another one is in Japan, in October, November, and in our own country, AAG Hospital of Hyderabad, under the head of Dr. Nageswar Reddy, is doing a lot of research on the gut microbiota, which will be paving way for future arsenal, therapeutic arsenal.
Thank you, sir.
Very much.
Thank you.
the outset, I'd like to thank the organizers for having invited me to deliver this talk on very important topic of today and today's world. We have just finished a sumptuous lunch. I would like to ask how many of us looked at what we ate? How many of us looked at what was minimally processed, whether it was processed food or was it an ultra-processed food? My previous speaker just now explained so well that, the microbiota is the cause, or maybe the one of the causes for insulin resistance and also diabetes. And I am going to talk about more on this subject. So when you look at this picture, don't you feel sorry that the first man and today's man with Coca-Cola, modern humans affected by obesity epidemic, that's what we are facing today. So the overview of my talk would be I would first describe the understanding of what food is, what is ultra-processing, and etc. Then next is how to identify different types of foods based on processing levels. The next would be health impacts associated with high consumption of ultra-processed foods and how to reduce consumption of UPFs and also what we can do. So coming to the definitions, processed foods are any foods that have been altered from their natural state through the various methods like washing, cutting, cooking, canning, freezing, or adding any ingredients such as preservatives, flavorings, or nutrients. This alteration can range from minimal processing like washing vegetables and to more extensive processing like making ready-to-eat meals. So examples of minimally processed foods are fresh berries, cut vegetables, and roasted nuts, which are simply prepared for convenience to eat. Foods processed at their peak of ripeness to lock in the nutritional quality and freshness include canned tomatoes, tuna fish, frozen fruits, or vegetables. Then there are also the highly processed foods with ingredients added for flavoring and changing the texture of the food. In other words, the matrix of the food, the content is different. It is not the same as the original matrix of the content. So that is called highly processed food. Now coming to the NOVA classification, when I was preparing this talk, I was really surprised to see that there is a classification called NOVA classification for different types of foods that we have. The number one is minimally processed food. Number two is processed for culinary ingredients. Then third, group 3 is processed foods. And group 4 is ultra processed foods. I'll come to the various types. Group 1, minimally processed foods. These are foods that undergone processes such as cutting, freezing, cleaning, and pasteurizing. Okay? So that do not substantially alter the nutritional composition. For example, fresh fruits, vegetables, milk, whole grains that are only cleaned or packaged without changing the substance. Group 2, processed culinary ingredients. These are, I'm sorry, it is changed when I changed it to this. The slides. These are, examples. These are culinary ingredients are ingredients which are necessary for our food to make it tastier, to make it edible. Example are sugar, oil, and butter from milk, ground spices, salted butter, iodized salt, and vinegar. So these are the culinary ingredients, and they are known as processed culinary ingredients, but we use them in a small quantity. Processed culinary foods are ingredients that have been slightly altered from their natural state to be used in the cooking. So these are not typically consumed on their own, but are added to the other foods to enhance flavor, texture, and appearance. They are derived from whole foods through the process like pressing, refining, grinding, milling, or spray drying. Now, added to dishes, these are components in the cooking, not usually eaten on their own. Purpose is to create more varied dishes and bring about a change in our day-to-day diets. So these are the examples that are mentioned there: fats and oils, sweeteners, flour and grains, seasonings, and these are the examples of processed culinary ingredients. Now, coming to the group 3, these are processed foods, which are more than minimally processed, but they are processed, but not highly processed. So these are usually prepared from group 1 foods, by group 1 foods by adding sugar, oil or salt. They are preserved, pickled, salted or fermented. As my previous speaker said, fermented foods are good. They can be probiotics, so they are also required for us in smaller quantities. Now coming to the most important group, and that is ultra-processed foods. Ultra-processed foods are usually made in factories. At least one ingredient we don't use or rarely in domestic kitchen. Example are carbonating, firming, whipping, bulking, and anti-bulking, defoaming, etc. As you can see on the side of my slide, that these are all the ultra-processed foods which are very easily available and in plenty around us. So ultra-processed foods are industrial formulations typically containing little or no whole foods. They are designed to be hyper-palatable and convenient. Okay. So they often include additives such as preservatives and flavor enhancers. The common examples are soft drinks, packaged snacks, and fast foods of all kinds. So eating processed foods occasionally is fine. Okay. So however, look for hidden sugars, fat and salt, especially those added during the processing. So every time you eat a processed food, you please look at the content. So most nutrition facts labels now include added sugars. So look for maltose, brown sugar, corn syrup, honey, and fruit juice concentrates. If they are among the first 5 contents, then please do not accept that, and please do not eat it. So as I already said, salt, sugar, oils and other ingredients which are used in the ultra processing types. So what are the characteristics of the ultra UPFs? So UPFs are heavily promoted through various media channels, so usually advertised, then celebrity endorsed, ready to eat and consume, convenient for today's youngsters particularly. They buy the ready to eat food and then microwave it in the evening and eat. So pitched as anytime, anywhere foods and designed to be over-consumed. So what is the mechanisms of ultra-processing of foods and their links to the health outcomes? We just had a talk about dysbiosis of the gut. So ultra-processing foods are industrial formulations with ingredients rarely used in the kitchen, have an average higher energy density of 2.3 versus 1.1 kilocalories per gram, and they are lower in nutrient density than minimally processed foods. So high in saturated fat, added sugar and sodium, then greater intakes of total energy, free sugars, total and saturated fat are more, lower intakes of fiber, protein and some micronutrients as well. So high palatability promotes a faster eating rate and energy overconsumption with daily energy intake. So there are some pros as well. This is a busy slide, I'm sorry about that. But frozen, pre-chopped and canned ingredients, they save time in the kitchen. The fortified foods provide important nutrients sometimes which are not available in the foods that we eat. So, and all the processing, even ultra processing, retain the proteins naturally throughout the processing, and others such as B vitamins and iron may be added back if they are lost during the processing. So that has to be taken care. Now cons are, we already said, coming to there is a rapid nutrition transition urbanization, transition, global food availability and affordability of food products. Because of that, there is a greatest transition, that is fastest transition that is happening, especially in our country. One cannot think well, love well, sleep well if one has not dined well. This is what we follow Indians. We Indians take this seriously, and we, for every occasion that we have, which we do, there is no lack of occasions for us, and food is the main item in our festivals. Indian foods, be it any part of India, any season, any festival, any occasion, or any family gathering, food please. So this is what we follow. And high intake Indian foods are again drivers of obesity, not only diabetes. High intake of sugars, intake of soft drinks, meat, sweets and fried foods, high fat intake and high intake of carbohydrates. So what is the link to obesity? UPFs tend to be energy dense and low in fiber, leads to overconsumption. Several large-scale studies have found that high consumption of UPFs is associated with excess total calorie intake and weight gain. So this is sure. So satiety and eating patterns change. The moment a person gets used to the processed foods, they are engineered to promote rapid eating and reduce satiety signals. So this will lead to overconsumption and over the course of the day. So throughout the day, we, even when he is watching the phone, he is eating a ultra-processed food. So this is a study done with the inpatients, where one group of inpatients was given ultra-processed foods and the other unprocessed diet, and they found clearly that the red is ultra-processed food and the blue is ultra-processed food and the red is unprocessed food, and there was definitely weight gain as well as obesity. Weight gain and the ultra-processed caused increased libitum energy intake, and weight gain despite being matched to the unprocessed diet for presented calories, sugar, fat, sodium, fiber, and micronutrients. So there was a great difference found in this group of people. So ultra-processed diet led to increased body weight over time, and unprocessed led to progressive weight loss, and body fat increased with the ultra-processed diet and decreased with the unprocessed diet. So links to diabetes, we all know here. There is an inflammatory effects, nutrient imbalance, glycemic control and insulin resistance, and high GI causes blood sugar spikes. So this is a known fact. Then prevalence of diabetes, obesity and diabesity in India has been studied by our own group. So there is a 11.4% diabetes today, and obesity in the general population is 44%, 6.6%, and diabesity is about 8.1%. And the ultra-processed foods has a major role to play in this. Health risks of consuming ultra-processed, to tabulate in one slide, it's obesity, type 2 diabetes, heart disease, cancer, depression, and digestive issues. So gut microbiome, just now we heard that gut microbiome, there are trillions of them supporting digestion and immunity, metabolism, and preventing of inflammation. So ultra-processed foods, industrial products, high in sugar, salt, unhealthy foods, additives, and low in fiber, all of them, they are linked to increased risk of obesity, type 2 diabetes, gut disorders, and low-grade inflammation. So better choices are diverse plant foods, fermented foods, and minimal processing. This was a slide I took from the status of Dr. Manohar KN, which I was just looking through my slides and came across this. We are getting closer to burger house, cola house, pizza house, and sweet shop, and chips, and all these ultra-processing foods. So India is growing health crisis. India's growing health crisis. 1 minute, the rise of junk food culture loaded with sugar, salt, and unhealthy fats is fueling the epidemic of obesity and type 2 diabetes across India. And from burger joints to sweet shops, our traditional diets are being replaced by processed fast foods, especially in urban and semi-urban areas. The result, blood sugar levels soaring and childhood obesity is increasing, and higher risk of insulin resistance, PCOD, heart disease, and more. So choose fresh, local, fiber-rich foods, reduce sugar, cola, chips, and refined carbs, move more, sit less, educate, and act. This should be our slogan. So diabesity, this also is known to all of us. Public health actions are very necessary in India. Propose cigarette-style warning labels on high-fat sugar snacks. CBSE schools introducing oils and the campaigns for healthier school canteens. Emphasis on replacing UPF with minimally processed and nutrient-rich foods should be done by us. So WHO definitely recommended diet with the minimally processed foods. What can we do? Choose group 1 foods, group 2 foods should be minimally used, group 3 foods, limit the use of processed foods and avoid totally the ultra processed foods, especially for our children. So coming to the conclusion, taking action against ultra processed foods is most important. Choose whole foods. Advocate for change. Support policies that limit UPFs and promote healthy eating. And educate yourself, spread the awareness of, share knowledge with family and community, especially around us. So it's not only for ourselves, to all those who come across as we are health givers. Thank you.
Good evening, everyone. At the outset, I sincerely thank God for having made me this possible from the first track to this particular track. And I thank the organizing committee for having given me this opportunity and to talk about a very difficult topic, the biology of muscle and its relevance to diabetes mellitus. I will take you through a little bit of introduction. I'll touch upon the role of muscle on glucose and mainly dwell on the impact of diabetes on muscle, which includes sarcopenia also, but with a little specific reference. And we'll go to the current treatment strategies, what are the treatments in the pipeline, and end up with a summary. Skeletal muscle, as you know, is a main target of insulin and the largest organ that uses blood glucose for about 80% of the entire glucose. Skeletal muscle accounts for about 40% of the body weight, and it's a very dynamic and a plastic organ or tissue in the human body. The link between the skeletal muscle and diabetes has always been bidirectional, and a combination of muscle atrophy as well as muscle dysfunction is termed as sarcopenia. Now, what is the role of muscle on glucose? The insulin sits on the insulin receptor, and this activates the glucose transporters or GLUT4 from the intracytoplasmic pool to go up to the extremity or the periphery, pick up the glucose and take it in. This is metabolized by the mitochondria to produce ATP, and once ATP-ADP ratio is high, it automatically depolarizes a cell, leading on to calcium influx, and finally, calcium acts on the actin and myosin filaments, producing the contraction. This is not the end of the story. The other part of it is that from the blood glucose, the muscle has taken up almost the entire 80% of glucose, thereby achieving euglycemia. The impact of diabetes on muscle could be listed as follows. Role of insulin on skeletal muscle in euglycemia, the missing action of insulin on muscle in diabetes with insulin resistance on mind, and muscle mass, strength and function, inflammation and oxidative stress. Even muscle fiber alteration has to do a lot of things. Impaired skeletal muscle regeneration and mitochondrial dysfunction, and the last one is satellite cell impairment. In diabetes, what happens? There is a lower muscle mass, abnormal lipid deposition, slow to fast fiber type transition, and fiber gets atrophied, and lower capillarization, not much of microvascular supply to the particular muscle fiber, and impaired mitochondrial respiration, morphology, as well as increased RAS production. All these things lead to a lower skeletal muscle strength, so exercise intolerance happens, and this leads to increased mortality. Now, what is the role of insulin on skeletal muscle in euglycemia? As I've already alluded to, the glycogen formation happens in the particular muscle cell with the aid of the molecule, the insulin molecule sitting on the receptor, opening the glut and entering of glucose, which is converted into glycogen by glycogen synthase. This glycogen is stored, but is used only for the benefit of the muscle, not for the whole body. So even in an episode of hypoglycemia, this does not come for rescue. Maybe it's almost like my cash in my hand, which I would not probably spend for you or for the other person. I will spend it only for myself. It's the same, the muscle has it only for its own use. The second thing is lipid accretion, wherein you have the LPL, or the hormone sensitive lipase, opens up the amino acid, gets into it, the fatty acid gets into it, and is utilized for the welfare of that particular cell in cell wall building, the repair process, or hormone synthesis if necessary. And lastly, the protein aspect of it, it has a insulin-like growth factor receptor, wherein the insulin molecule also has and sits on that and opens a channel for amino acids which enter into the cell and forms a protein. When insulin is adequately present, this happens well. At the same time, there is no protein breakdown. When insulin deficiency, it causes a reduction in the protein formation, at the same time a reduction in the or increase in the protein breakdown. What are the missing actions of insulin on muscle in DM with insulin resistance in hand? Insulin resistance and impaired glucose uptake causes mitochondrial dysfunction, ectopic fat accumulation, and increased intracellular lipid deposition, muscle inflammation with protein degradation in muscle tissue, oxidative stress and formation of RAS, and formation of toxic advanced glycation end product, or AGE. And insulin resistance also downregulates muscle contractile protein synthesis, at the same time upregulates the protein degradation, and also translocation is not there, so even the muscle is starved of glucose. This is just to show you that there is an insulin resistance here, hyperinsulinemia, and not effectively handling this particular issue. So less of GLUT4 reaches the periphery, less of glucose entry, so fatty acid is being metabolized, a lot of reactive species is produced, and also this particular palmitate also produces a reduction in the blood formation. So ultimately the cell is starved with more of ROS. What does the muscle mass and strength tell you? Type 2 diabetes on one hand and skeletal muscle atrophy on the other hand. Both of things are a vicious cycle. The crux being the insulin resistance. So when you develop type 2 diabetes, this causes hyperglycemia, and this hyperglycemia acting on the skeletal muscle atrophy produces further breakdown of the protein and also reduction in the production of protein, muscle protein. Thereby that also again causes diabetes. So this goes on and on. What about the inflammation and oxidative stress? Diabetes itself is an inflammation, and denervation or any such thing mediates through NF-kappa B as well as the UPS, and finally produces increased proteolysis. On the other hand, oxidative stress, which is in the cytoplasm, also enters into the nucleus with FOXO pathway and produces proteolysis. So proteolysis happens, muscle atrophy is achieved. Moreover, oxidative stress also causes a decreased protein synthesis by mTOR pathway. Ultimately, these inflammations cause muscle atrophy. What does this muscle fiber composition to do with this? Normally, the type 1 fiber is a dominating area, whereas in diabetes, it becomes a transition from 1 to 2, as well as non-specified fibers are also there. These fibers are responsible for the poor effect as far as the muscle regeneration is concerned. So this is a picture or cross-section of the muscle fiber. The left half of the muscle fiber is a healthy fiber, and the right half is a type 2 diabetes fiber. When you look at this, you see here the common factor or denominator is glycogen, which is almost felt equally on both sides. But to achieve this amount of glycogen in a diabetic patient, there is a lot of glycogen synthase are required. Cytosolic GPB, GRB also is important. GDE as well as GP are important. So all these things try their best effort to improve the production of glycogen and stores it. So what little glucose enters into the cell is stored as a glycogen, wherein the glucose is not even used for metabolizing or energizing that cell. So thereby, our patients come with fatigue as well as tiredness. All these things probably could be due to this particular lack of glucose for its utilization. Of course, there is some amount of storage as glycogen. Now, what about the mitochondrial dysfunction? The skeletal muscle atrophy itself causes mitochondrial damage. So when this damage occurs, what happens is there is a reduction in the ATP formation, there is a reduction in bioenergetics, biogenesis of mitochondria, as well as increased oxidative stress and ROS activity. And also the normal pattern of mitochondria's life is little altered by becoming a mitochondria which does not get cleared off when it is diseased. That is called what is called autophagy or mitophagy, as well as apoptosis. So all these things interfere with the particular muscle atrophy leading on to other complications. Probably the only way out would be in later days a mitochondria targeted antioxidant as well as maybe a mitochondria transplant. What about the impaired skeletal muscle regeneration? If you see on the left half of the panel, that's the healthy muscle. On the right, it is the diabetes muscle. And on the bottom, you see a same cell in the different colors. What is that? This is a important progenitor cells, which is also called as MUSCS. So this particular cell, when it is sleeping, it is in a violet color. It is depicted that way. And when it is activated, it becomes little yellow. And when it is really differentiating into myoblast, it becomes a little more pink. And finally, when it becomes a muscle, it becomes the rest of the colors. Now, look at this particular injury. Injury or assault is same for both. But on the diabetic side, there's a reduction in the pro-inflammatory macrophages. So not much of macrophages coming into play. As well as blood supply is not there, adequate capillary is not there. Moreover, this is what the degeneration and inflammation stage. Now coming to the regeneration should be energetic, but it is not so. The anti-inflammatory macrophages are also reduced. At the same time, angiogenesis is also reduced. And finally, you come to a stage of maturation and also the recovery period, wherein it appears to be the same, but if you look at the fiber, it's narrow. What happens? There is fibrosis instead of entire replacement. And if you look at the progenitor cell, it is sleeping all the way in the diabetic sector, the pink color. Whereas in the other one, it becomes yellow and becomes active and then comes to rest. So all these abnormalities do happen in the muscle fiber, and this might also contribute to the formation of diabetic myopathy. Coming to satellite cell impairment, this is what we have been just now discussing. The satellite cell or the MUSCS are the same, and they are the cells which are quiescent initially, gets activated, then differentiates into myocyte, myoblast, then myocyte and myotubes. It is really shocking to see that diabetes suppresses at all conversions. So regeneration or recovery becomes very, very difficult. And the good news is that physical activity or exercise is able to help all these things. So in that way, we should understand one more advantage of exercise. In a nutshell, talking about what all I've been talking so far is atrophy on one end and metabolic dysfunction on the other. When these two are again a vicious cycle happening, it is mediated through insulin resistance, poor glucose intake, as well as poor protein intake and protein formation, more damage to the protein, and mitochondrial damage. And this also is associated with lipids settling down along with the muscle fibers, and which produces again further inflammation. And this inflammation produces reactive oxygen species and also advanced glycated products. So all these things put together cause the continuation of this vicious cycle. Coming to sarcopenia, as I told you, muscle atrophy and poor muscle function is diagnosed as sarcopenia. And this can be worsened by intramuscular deposition of fat leading to poor muscle function. I'll tell you, fat which is entering into a muscle cell is beneficial for the cell. but the fat is not entering into it, but lying by the side of the muscle in a different layers. What you see it in the broiler chicken, this is what is seen in the broiler chicken, and they create insulin resistance. That is why you have the bulk. And here, this particular fat is always dangerous, and that is called sarcopenic obesity. Undernutrition and loss of body weight hastens a decline in muscle mass and strength. Sedentary behavior, age, due to illness, disability, or lifestyle, further increases the risk of muscle loss. Decreased muscle strength, reduced working speed, fatigue and impaired balance, and also increased risk of falls are the symptoms of sarcopenia. How do you diagnose sarcopenia? Very simple test I'll just mention. You just measure the calf circumference. If it is going to be less than 34 in men, less than 33 in women, probably they are sarcopenic. There is one more correlation with waist. So it's called waist-calf ratio. If it is going to be more than 2.4, it is a drawback that is they are going in for sarcopenia. And one more chair test is also easier. Within 30 seconds, the person should sit, stand, sit, stand, sit, stand for at least 5 times. If he is not able to do that, that means he has got sarcopenia. So this can be diagnosed with a single pie. Probably what you need is a knowledge. And what are the mechanisms potentially contributing to sarcopenia that may be amenable to modification with drugs? You look at various pathologies, and the good news again is we have drugs to combat all these things. So coming to the current treatment strategy, exercise acts on the muscle, releases a lot of myokines, and all these myokines showed in the green arrow are favorable, except myostatin, which reduces the muscle bulk. Thanks to the liver, which again mediated through exercise, helps by polystatin, and which is able to suppress myostatin. Thereby, with exercise, you get the best benefit. What about sleep? Better quality and quantity of sleep at the right time. It is not a 2 a.m. to 10 a.m. It should be the stipulated time. It is important for a muscle balance. Food, MUFA-rich and SAFA-rich should not be used for reducing insulin resistance. Adequate protein intake with 1.2 grams of protein per day, and should contain leucine, isoleucine, argine, mainly non-vegetarian food like meat should be a little less, fish, chicken, and then nuts, dark chocolate. All these things contain all these needed entities. Coming to pharmacological intervention, insulin, GLP-1, DPP-4 inhibitors improve muscle mass. Sulfonylureas, negative weight. Rest of the things not very sure, but this is along with exercise and euglycemia. These are the drugs that we routinely use, and they have several mechanisms of action. And vitamin K2 is again a drug which alleviates insulin resistance. ARB, SEI inhibitor, we have always been using it, but the recent study on rats say that irbesartan is better than even exercise in reducing insulin resistance. Probably if that is so, I would just gulp irbesartan and lie down peacefully and do not do any exercise. What are the pipeline treatment options? Mitochondrial transplantation. You see on the left a young lady walking around, and you see another person with sarcopenia on the right with a defective or a dysfunctioning mitochondria. Change it, very simple, and then probably in days to come, the mitochondria restores the muscle bulk, muscle health, and then you can be like this particular lady. So, little limited data at present. Hexaprotein, or the hexosaminidase A, is again a rat model which has been showed with increased glucose uptake. And lastly, myo-DN. This is a muscle-forming oligo-DNA. So you inject into that particular muscle, it binds to the target protein, nucleolin, in myoblast, and improves differentiation of myoblast. What diabetes does is stop the progression of myoblast to muscle cell, whereas this improves it. So in that way, probably we could bypass the effects of drawbacks of diabetes. So dear friends, to summarize, skeletal muscle and diabetes have bidirectional relationship impacting each other. The role of insulin on skeletal muscle is vital, without which a lot of derangements happen. Inadequate or inefficient action of insulin on muscle in diabetes causes hyperglycemia and also muscle dysfunction. With good muscle mass, strength and function, achieve freedom from sarcopenia. Inflammation, oxidative stress, satellite cell impairment, mitochondrial dysfunction are some of the pathogenic mechanisms in muscle dysfunction. Simple muscle fiber alteration from type 1 to type 2 itself causes poor muscle regeneration. And not only damage to muscle, but impaired skeletal muscle regeneration happens in diabetes. Lifestyle modification with adequate exercise, quality sleep, sleep in the right time to the right duration, and healthy diet with more protein is useful apart from glycemic control and other health hazards. So most of our routine medications do help in the correction and prevention of muscle involvement in DM. Hence, my takeaway message is simple. Exercise, 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 and contribute as much as possible to a healthy diet. That will definitely take us up from diabetes, as also from sarcopenia, and probably from the cardiovascular assault. Thank you. Thank you for the opportunity once again.
Thank you, sir. Thank you for your wonderful speech. For want of time, we cannot do the question answer thing here. We can ask your questions during the tea time. And I thank all the three speakers whose speech was so wonderful and insightful. Thank you.
Thank you so much, chairpersons. For the next session, I would like to call upon Dr. Aravari and Dr. Gopinath to chair the session, handing over the session to chairpersons.
Good evening, everyone. For the cardiology session, we have three leading cardiologists with us. The leading cardiologist of Coimbatore, Dr. Vaidyanathan sir. Over to him for the talk.
Let me thank Balamurugan and the other organizers for this opportunity. Having listened to recent developments like gut biology, processed food, so many, and sarcopenia, etc., we are back to basics. We are going to discuss how to control blood pressure in a diabetic. Is there a choice of drug? Should you always be on ARB, or can you use diuretic as the first line drug? And where do we stand? So, increasing incidence of blood pressure or hypertension is something which expect, because aging population, diabetic, so many obesity, all of which will make that more people are hypertensive. And the saddest part is it is silent. For every hypertensive who is diagnosed to have hypertension, there will be 2 or 3 people in the community who don't know that they are a diabetic, and the abysmal control rate of hypertension, which leads to cardiovascular outcomes or problems like ischemic heart disease, stroke, renal failure, etc. So vascular diseases are more. We know that even minimal control or reduction in blood pressure improves the outcome in this. So control of blood pressure is something very important. And so most of the, I'm not going to the classification of blood pressure, hypertension, etc. The Indian guidelines tell you that the drug of choice can be an ACE, ARB, CCEB, or diuretic, and newer beta blockers. The JNC 8 again says ACE, ARB, or hydrochlorothiazide as the first line drug. Most of the recommendations are the same. There was a time when we were students, diuretic was the first line to be recommended. Then came beta blocker, step care approach came. The diuretics fell out of favor over a period of time because we were concerned about the side effects of hypertension like hypokalemia, sudden cardiac death, electrolytes imbalance, uric acid elevation, diabetes, etc. So this is at present the current recommendation. Start with ACE, ARB, CCB, or a diuretic, and add on as per the blood pressure control. And finally, your aim is to achieve a level which is good. So diuretic can be a thiazide diuretic or a thiazide-like diuretic. What is the difference? The three components, hydrochlorothiazide, chlorothalidone, indapamide. The difference is basically in the duration of action, and you are very, chlorothalidone got the first place because basically we thought a longer acting diuretic will have a smoother control of blood pressure and the trough to peak ratio will be lower. With the results that it is better. And it also showed that there is pleiotropic effects like platelet aggregation, vasodilatation, so many factors which made it a diuretic of choice. But in spite of all this, the mechanism of action of all these diuretics, whether it's thiazide or thiazide-like, is at the distal convoluted tubule. It acts as the sodium chloride transport. So hyponatremia is the initial, or volume depletion is the initial cause of blood pressure control. Over a period of time, vasodilatation sets in. So in spite of all this, should we always prescribe chlorothalidone or indapamide? Should you move away from hydrochlorothiazide is one big question. Even in the West, the prescription pattern showed that hydrochlorothiazide is more commonly prescribed than chlorothalidone or indapamide. So what are we supposed to do is the question. Evidence of diuretic in CV protection. Let me compare a diuretic with the other group of drugs, not the other diuretics or thiazide-like diuretic. Evidences say that in calcium channel blockers, the outcome is much better with a diuretic compared to calcium channel blocker. 37% less, less cardiac failure, 5% less risk of CV events, etc. So definitely the diuretics favor, better. Even in Alhart study, diuretics were better compared to CCB or amlodipine or even AC inhibitor. So there has been a comparison. See, the basic problem with all these hypertensive trials are on diuretics are, it's not a head-to-head comparison with other drugs. These are all compiled data. That is the drawback of all these data. So primary outcome is based on medical health data around 4 lakh odd patients. And the events were myocardial infarction, hospitalization for heart failure, stroke, and effective safety outcomes were considered. And what did it say? Compared to AC inhibitor, diuretics fare better in cardiovascular outcomes. And again, the thiazide and thiazide-like diuretics give you a protection from MI 30%, heart failure 42%, risk of stroke is reduced by 22%. I'm a little surprised because blood pressure reduction invariably translates to stroke reduction, especially the hemorrhagic stroke. So my personal impression was the stroke reduction should be much more, but this is the data available. And safety data, there is no drawback for any of the diuretics. Diuretics are as safe as any of the drug or better compared to AC inhibitor and CCB, whether dihydropyridine or non-dihydropyridine. And safety outcomes, chlorothalidone were hydrochlorothiazide, there was nothing to differentiate. This is the problem. Even though we have some data on chlorothalidone being better, when you do a meta-analysis on these groups, hydrochlorothiazide provides equal or better CV reduction, and the safety outcomes are as good with hydrochlorothiazide compared to the thiazide-like diuretic. And so, what do you choose? The diuretic comparison project, people who are on hydrochlorothiazide were shifted to chlorothalidone. A group of people were shifted to chlorothalidone, and it was compared what were the outcome. The outcome was non-fatal adverse cardiovascular events and non-cancer related deaths almost equal, or hydrochlorothiazide fared better. Non-fatal adverse cardiovascular event, again, head-to-head comparison, chlorothalidone and hydrochlorothiazide. There was nothing to choose between both of them. They were almost equal, or hydrochlorothiazide was non-inferior to chlorothalidone in most of the study. The meta-analysis also showed some of the trials were favorable for chlorothalidone, but the whole meta-analysis said that chlorothalidone is as good in reduction in all causes of mortality, heart failure, hospitalization, or CV outcomes. So when you do a meta-analysis on various diuretics, there is nothing really to say that chlorothalidone or indapamide is better, even though there are individual trials where some of them have shown that this chlorothalidone or thiazide like diuretics are better. BP control chlorothalidone was more effective, no significant difference in cardiovascular outcome, but adverse event hypokalemia was more with chlorothalidone. So all said and done, when you really do a meta-analysis of the entire pool data, there is nothing much to, and even in those with a renal dysfunction, understand, the minute you say renal dysfunction and the eGFR is less than 30, thiazide and thiazide-like diuretics are not the drug of choice. So in people with a higher GFR, it was shown that the comparative outcomes were the same. In fact, the myocardial infarction was lesser with hydrochlorothiazide, revascularization requirement was lesser, heart failure was better, atrial fibrillation was better. So chlorothalidone use was associated with a higher risk of eGFR decline, CV events, hypokalemia. Excess risk of hypokalemia with chlorothalidone was attenuated in participants with reduced kidney function. These results suggest that there is no evidence to prefer chlorothalidone compared to hydrochlorothiazide. Then the fixed dose combination, what is a rational combination? We know the minute we use a diuretic, the renin-angiotensin level goes up. So anything which blocks that will be a better combination. So probably an ARB. We know that one of the ARBs which is so popular in India because of its 24-hour action is telmisartan. So this will be a very rational combination. To summarize, hydrochlorothiazide is an effective first-line antihypertensive for control. Chlorothalidone does not have much of an advantage over hydrochlorothiazide. When you analyze the pool data, combination of telmisartan is a good combination with diuretic. Thiazide or thiazide-like diuretics outperform ACE or CCB individually. So the choice of a diuretic, you are not harming your patient by choosing a diuretic, and even hydrochlorothiazide you are allowed to choose. I think you don't have to feel bad when you give that drug and think that the other diuretics are better. So basically I think the case is rested and hydrochlorothiazide is a good antihypertensive, even though better chlorothalidone has better hypertension control program. Head-to-head meta-analysis has not shown it to be a better drug in safety outcomes, and compared to other drugs like ACE or ARB, equally potent, equally effective in safety precautions is thiazide diuretic. Thank you.
Thank you very much, sir, for keeping time also.
I was asked to take away 1 minute of mine. That's okay.
You are welcome to take the chair. Here.
Now we invite Professor Nambirajan from the CMC Medical College here, an eminent cardiologist and very famous, popular here. And I'd like to share the dais.
Thank you, sir. Governor, sir, for your introduction. Good evening, respected seniors, friends, and colleagues. At the outset, I would like to thank the organizers for this wonderful opportunity. So today's topic will be the failing heart in diabetes. As we are all aware that diabetes is increasing day by day. India has become the diabetic capital of the world. So we'll be seeing more number of heart failure patients in diabetes. So these are some of the headings in which we will be looking in this session. So heart failure, by definition, it's a clinical syndrome with signs and symptoms of structural or functional cardiac abnormality with the evidence of increased natriuretic peptides and evidence of pulmonary or systemic congestion. And there is a strong association between diabetes and heart failure. In 30% of the diabetic patients, they have heart failure. In all the RCT trials which have been conducted for heart failure, there were, in DAPA-HF, 40% of the patients were diabetic. In Emperor Reduced, 45 to 50% of the patients were diabetic. But you should need to understand the staggering statistics. As the diabetes patients increases, they have a 2 to 4-fold increased risk of heart failure. Especially in young adults, it mounts into 11-fold. This has been studied in the DCCT trial, 30-year follow-up of DCCT trial and UCP trials. And now there is 22.3% of prevalence of diabetes. This is the most important one. You need to understand there is 32.7% heart failure mortality in a diabetic patient, whereas in a non-diabetic it is 3.7%. So the type 1 diabetic patients also are not spared. The prevalence is much more, the diastolic dysfunction is higher. The worse the glycemic control, the chance of heart failure is also high. So the two things, the longer the duration of diabetes and the glycemic variability and the increased HbA1c. So any 10% increase in HbA1c, 1% increase in HbA1c has a 8% increase of chance of heart failure. This is from DCCT trial, 30-year follow-up. So when you have a longer duration and the glycemic variability, especially increase HbA1c and fasting blood glucose, per se it's a high risk factor for your heart failure. So the global incidence, it's increasing, 578 million projected in 2030. So you can imagine how much heart failure we are going to face. There are two entities, you are all aware, ischemic cardiomyopathy by means of atherosclerotic cardiovascular disease, that everyone are aware about that. I am not going to touch that. Today we'll be looking into the new entity called as diabetic cardiomyopathy. This is not a new entity, it has been in vogue. The definition was formed by all the associations since 2014. It's defined as a myocardial dysfunction without associated coronary atherosclerosis, hypertension or valvular disease. So the pathogenesis is a much complex one. It includes lipotoxicity, polyol and oxidative stress, AGE and microvascular dysfunction and autonomic dysfunction. As the insulin resistance and the increased glucotoxicity, there is impaired energy metabolism, shifting of energy metabolism from glucose to fatty acids, and there is excessive lipid deposition. And also this polyol pathway, by increasing the sorbitol, it causes fibrosis, and this AG, advanced glycation, causes endothelial dysfunction and vascular impairment. Of course, autonomic dysfunction increases the sympathetic activity, and this is the main reason for your heart rate variability and your silent myocardial infarction. So in a nutshell, to say there is an increased, decreased glucose uptake, increased oxidative stress, endothelial reticulum stress, and by means of various pathways, the abnormal glucose metabolism and insulin resistance goes for cardiomyocyte apoptosis and finally myocardial fibrosis, thereby resulting in systolic and diastolic dysfunction, further resulting in end-stage heart failure. So hyperglycemia in a nutshell causes myocardial hypertrophy, fibrosis, cardiac remodeling and heart failure. So the diagnosis, it's a challenging. No specific markers, patient will be silent and the complications overlap. So you need to find it early in the disease. You need to find out when the patient, you can see from the slide, the asymptomatic individuals you need to identify. Because the transition from the asymptomatic individuals, stage A is the risk factor. Diabetes per se, it's a risk factor. Apart from that, diabetes, obesity, all the stage A. And stage B, you can see the transition from stage B. Immediately, from stage B to C and D is very rapid with the diabetic population. So we can catch hold of these patients earlier by means of scores, risk scores. There are two scores, ARIC score and Watch DM score. You can have a calculation and you can catch them early so that you intervene them with the tight glycemic control as well as the newer SGLT inhibitors, which I'll be discussing in the forthcoming slides. So you need to catch them very early in order to prevent them going from a stage B to stage C and D. You should catch hold them as early as possible in asymptomatic diabetic patients, high risk category, as you identify them by the risk scores. There we have this newer modality of echocardiography, GLS, global longitudinal strain, because diabetic cardiomyopathy can cause subclinical LV dysfunction long before the symptoms or the ejection fraction decline. The EF will be normal. the patient will not have any symptoms. So when you do a common echo and say the ejection fraction 60 to 65, even though they have a ejection fraction normal, they will be having a GLS can pick up very early. So it detects the subtle myocardial contractile abnormalities even before the LVEF fails. The longitudinal fibers are, the more negative the GLS indicates early dysfunction. So this helps us to identify earlier identification of the patient who are prone for cardiac failure. And these are all some of the studies. You can see from this, the patient has a very nice contractility of the myocardium, and even the diastolic function is normal. But you look at the GLS, global longitudinal strain, it is in the abnormal side. So with this newer mode of echocardiography, this is available in all the machines you can have. So just to awaken the sleeping side, you need to keep your heart happy. Especially when you are having an agitated mind, the hyperglycemia goes. So be happy and make your heart feel happier with happy hormones. Okay. So symptomatic individuals. So we can classify two phenotypes. One is heart failure with reduced ejection fraction, when they have a ejection fraction less than 50%, and you have another phenotype called as preserved ejection fraction when they have a LVEF of more than 50%. So this preserved ejection fraction, you need to, this is the new entity, you have certain echocardiographic parameters you can easily do. This is the scoring system for identifying the heart failure with preserved ejection fraction. Do we need to routinely screen CAD in all diabetic patients? This DIAD trial has thrown to light. There is no need to no significant benefit from routine screening in asymptomatic diabetic patients. Then what to do? So there is another trial, BARDA trial. In this, when the patient has a low exercise capacity and the patient has a signs of peripheral artery disease and baseline ECG changes, then you need to go in for the next mode of investigation, the role of biomarkers. The BNP and high sensitivity troponin play a very important role in identifying early heart failure patients. So when you have a BNP of more than 125 in a normal patient, or when the high sensitivity troponin is more than 99 percentile, you can subject them for further investigations. The cardiac microRNAs and the MMPs and the tissue IMPs indicate the myocardial fibrosis. They are upcoming biomarkers. This is a novel biomarker. You can have a NT-proBNP along with your albumin ratio, NTR ratio, along with red cell with glomerular filtration ratio. It can easily risk stratify the patients in chronic heart failure. So the management only, we have four pillars, especially the time-tested drug AIC or ARB for the past 3 to 4 decades. Beta blockers, of course, MRA and SGLT inhibitors. SGLT inhibitors, it has been proved beyond doubt in all the RCTs, emperor reduced, emperor preserved, DAPA HF. You can name any number of trials. They have proved beyond doubt it can work in all spectrum of heart failure, right from your reduced ejection fraction, mildly reduced or mid-range ejection fraction, and in preserved ejection fraction, and of course your RNI. So SGLT inhibitors with all these possible mechanisms, they have a wonderful, they can even prevent your progression of heart failure from stage A to stage B, and it can halt, and it has its own nephroprotective effects also. So this heart failure with preserved ejection fraction also, you can give the same drugs, but SGLT inhibitors again comes as a class 1 and followed by your MRA, spironolactone, class 2B. And when the patient, your heart failure progresses, you have to undergo certain LV assisted devices. Apart from that, you have this ICD, CRT when needed for an appropriate patient with a severely reduced ejection fraction in order to prevent ventricular tachycardia. And this Barostim and MitraClip and other things are upcoming treatment to alleviate the repeated hospitalizations. V-wave intraarterial shunt helps to reduce your left-sided pressures, and CardioMIMS is the latest one. You are monitoring the pulmonary artery pressures. So in a nutshell, final message is avoid use or caution with thiazolidine ions because of fluid retention. DPPOs, saxagliptin, and high-dose insulin fluid retention NSAIDs you need to avoid. Preferred agents are SGLT inhibitors and GLP-1 receptor agonists. They have a weight and cardiovascular benefits. The GLP receptor agonists have a 14% reduction of cardiovascular death, 9% reduction in heart failure, and because of the weight reductions. This tirzepatide is a dual agonist GLP and GIP analog. It has emerging promising. It's in the phase 3 trial. It has also been a drug for heart failure with preserved ejection fraction. In summary, when the horse is down, you put him on inotropes, and if it is loaded, you give them diuretics. If it is having an arrhythmias, you slow down the horse with your beta blockers, and if it is needed, you assist with the LV assisted device. If the possibilities, nothing is working, go for a new heart transplantation, or by means of your gene therapy, stem cell therapy, heal the horse. Thank you. In the silent struggle between the sugar and the heart, let knowledge be the bridge and compassion the heart. Thank you very much for the opportunity.
Thank you, HOD sir, for the wonderful lecture. We welcome you, occupy the chair, sir, and thank you for saving the time also. Over to next speaker. Dr. Magadevan from Chennai.
Good evening outside. I thank the organizing team for giving the opportunity. I'm going to talk a trial that was conducted in the Indian population using a fixed drug combination of metoprolol and telmisartan in people with hypertension with ischemic heart disease by using a ambulatory blood pressure monitoring. It's a phase 4 trial, prospective multi-center trial that was conducted in the Indian population by Indian drug. So hypertension at a glance, we know that hypertension is the largest disease, chronic disease across the globe. Nearly 1.3 billion people are being affected. In India, nearly 21% of females and 24% of adults suffer from elevated BP. And hypertension is leading cause for stroke by 57% and acute contrast syndrome by 24%. Ambulatory BP monitoring is one of what we use CGMS for diabetes, revitalized the treatment strategy and protocols by using this tool for day-to-day assessments. So ambulatory BP monitoring is very effective in evaluating the hypertension in patients with significant variations. And there is significant variations between the home monitoring of BP and in-clinic BP. So ambulatory BP monitoring becomes a standard tool to assess the exact picture where the patient is. And also it can be used to set the target for the individuals and also therapy based upon his BP surge and downs. So accuracy of BABPM is very good. It predicts the cardiovascular events much more far. It correlates much more with the CV events in the individuals, and also identify the masked hypertensions, white coat hypertensions, and dippers and non-dippers, which is very vital in diabetic individuals. Because diabetic individuals are non-dippers, they are at risk of developing CV events, maybe vascular, at the level of the renal or at the level of the brain and heart, so on. Also guides the therapies, which drug shoots for these patients, what the drug, what the dosage can be extrapolated by assessing the ABPM tool. And fixed drug combination, any chronic ailments recurrence, fixed drug combinations. The drugs should be very complementary in actions and synergistic in actions without any inducing side effects. So any fixed drug combinations, if you put together, they reduces the pill burden and reduces the dosing frequency, also improve the compliance, which is very, very vital when you treat chronic ailments. So metoprolol 6-night works at the level of the beta blocker. It's a cardiac selective beta 1 blocker, and telmisartan works at the AT1 receptor, which is having synergistic combinations without any adding adverse events. By combination for the drug, what we used in this trial was metoprolol here. How it differs from the other competitive brands, it have a unique patented wrap matrix technology that makes the deliver the two drugs at a different angles. That makes the control and consistent release. You can see this is the picture of the metoprolol. So the pink color, it is encoded by a partially permeable polymer coating. The pink color is a telmisartan, which is incorporated in explodable polymer. So it releases immediately into the bloodstream. And next is the metoprolol was incorporated in a controlling polymer. So that stands for its 24 hours profile of the molecules. Let us focus on the study what was conducted in Indian subset of population. This is a control study, was a phase 4 trial, open label, multicentric, non-comparative treat to assess the efficacy as well as tolerability of this molecule in patients with angina, stable coronary artery disease and hypertension. So 88 patients were enrolled in the studies. A number of sites incorporated in India was 7. the study period is 10 weeks, of which screening period 2 weeks and treatment period is 8 weeks. The primary objective is to assess the efficacy of the molecule, and the secondary objective is to assess the tolerability of the molecule in patients with the hypertension ischemia disease. The molecule used in this study is metosertan 25 mg as well as 50 mg. The initiation of the molecule as on the discretion of the physician, based upon his BP, based upon his pulse rate, this molecule was started. So the study design is the first visit was screening period that was allotted for 2 weeks, and the next visit there's a day one for the initiation of molecules. The second visit the patient was started on metosertan 25 or 50 depending upon the patient's pharmacodynamic profile, and next visit was followed by 14 to 28 weeks where they will assess what is side effect happening because of the drugs, whether the drugs needs much more titration, or when you want to rescue therapy to push the BP control to less than 130/780 as per the ESC guidelines. And the fourth is the early termination or end of the treatment or the study results. The inclusion criteria is any adult, female or male willing to give consent for the participation, hypertension with established CAD, stable CAD, and BP should be in the higher range of more than 130, 140 for a systolic and 90 for a diastolic BP. Either you do it clinical or ambulatory BP monitoring. And patients already taking these molecules can be incorporated if they are willing to participate in the studies. Exclusion, all the renal impairment, other hepatic impairment, patient in metabolic acidosis, thromboembolic episodes were excluded. And this is the primary endpoint. The primary endpoint to check the mean 24-hour ambulatory BP monitoring, both systolic and diastolic is taken into consideration from the baseline to 8 weeks. The second endpoint is responders time, how much amount of people are responding to the target therapy of target of less than 130/80, and subdivision is what happens last 6 hours of therapy, because you are going to give the medication in the morning, what happens the last 6 hours to assess the shoulder effect of the molecules, and also they compared what happens first 6 hours and last 6 hours, any peak or trough effect is there. So last 6 hours were incorporated, and people with the first 6 hours, last 6 hours BP difference was computed for these patients. The efficacy aspect, the short-term variability assessed with so much of parameters which you are going to deal, maybe are more statistical significance. The short-term variability, long-term variability of these molecules in terms of BP control. This will be told in a nutshell. Now, last, in addition to that, what happens, the BP happens when you increase the dose from 25 to 50 mg, and what will mean 24 hours BP with people taking high dose in the start of the drug itself, and what happens for the escalation of the molecules. So determination of sample size, many of you may ask why 88 was chosen there. Incorporating the knowledge from the similar cohort, a similar prototype study, they found that standard deviation to optimal have a standard deviation of systolic BP and diastolic BP of even 10 millimeter change. They incorporated to keep the type 1 error as 25. Nearly 66% is a number of 66 patients sufficient to conduct a study. To the dropout of 25, they incorporate 88 subjects can be needed for this study. So the number of people incorporated is 88 mainly because of arriving the statistical analysis and the previous knowledge we had from the previous similar prototype study conductor. This is demographic which mimics as what we see in day-to-day practice, 50-year-old male or female coming with high BMI or high waist ratio with uncontrolled diabetes. So primary endpoint is clearly told. The change in 24 BP monitoring with this fixed combination will phenomenally have statistical reduction of more than 15 millimeter of mercury in systolic BP and 10 millimeter mercury in diastolic BP. This research was obtained from ambulatory BP blood pressure monitoring. What happens in clinical BP monitoring, this also shows statistical significance. So even clinical BP monitoring has incorporated this fixed combination. There is a drastic fall of BP by 13 systolic and 7 diastolic BP parameters. And rate responders, many people are able to achieve the target BP of 130/80. When you go by ABPM, nearly 36 patients are able to achieve the BP control. In clinical BP, it comes around 10. So the drug is safe, the efficacy has been proved. The people on this combination had able to achieve good, large number of people are able to achieve the target rate. So when you analyze the amount, the number of recordings for 8 weeks is 4168. Out of 4168 recordings, nearly 32 recordings were within the heart rate of 70, and more than 56% of BP is under control. So other way around, many number of people are able to have the less controlled heart rate, and many readings of the individuals are less than target BP of less than 130/80. So what is the secondary endpoint? We want to assess the short-term variability and long-term variability. In short-term variability, they took 5 parameters. One is weight, mean, BP parameters. that is nothing but the average of daytime BP with the nighttime BP over 24 hours. So there should not be any change. The morning BP and the evening BP, the average BP should not have any difference. So when there is no much difference, it shows the drug is very good. It acts 24/7. There is no variability at all. Another is coefficient of variation. They are assessing the standard deviation to the mean BP level, which what we have statistical analysis. That also should not have any much difference. The standard deviation is different from mean BP. Then the study is not, the BP is not well under control. Both the things shows it is a standard deviation. Then the BP, standard deviation of the BP measurements to the mean BP, there is no much difference at all. And 24 weight BP, that is nothing. What happens in the morning BP, 9 o'clock, 11 o'clock? What happens is nighttime BP, 9 o'clock, 11 o'clock? There is no much difference. There is no difference at all between these two. So secondary endpoint, whether the weighted mean of daytime or weighted mean of nighttime or even 24 hours, there is a drastic BP. That it directly shows the molecule works 24/7. There is no peak or trough in the BP level, so keeps the BP at target level, and that can be monitored by the ambulatory BP monitoring expressions. Another parameter that was used as a short-term variability is average real variability. So average real variability, they will watch along with BP parameters. What happens at 8 o'clock? What happens at 9 o'clock? What happens at 10 o'clock? And even every hour they will record. There is no much difference in the BP levels by 9 o'clock or 10 o'clock or 11 o'clock. It shows the BP has been kept under the control, under the well level. And it's a delta statistical BP is a difference. What is the maximum BP of the individual? What is the minimum BP of the individual recorded on the daytime? So they want to assess what is the difference levels. The difference is not much wider. It shows the molecule is very good in terms of reduction all the parts of BP control. So the short-term variability is well under control. It speaks the molecule. The BP variability is not that much when you use these molecules. So here you can see that what happens in the last 6 hours compared to that of early morning BP can clearly show that there's a drastic, even the molecules works at the later part of the REMS. Even if the patient is taking the BP molecule by 8 o'clock in the morning, even early morning 4 o'clock or 6 o'clock, you may expect a trough level. That is a shoulder effect of the molecules. At this time, many of the CV events happens. So it's not so. If you give this molecule extended release along with the telmisartan, the drug profile is very well. Even the early morning BP surge has been very optimized as comparable to the early 6 hours of the BPs. This clearly shows what happens the profile. You can see the upper column is the baseline. You can see that 148 was the mean BP in the morning, and late hours is 144. But after adding the medications, both BPs well under control. Early, the first 6 hours, 133 is at par matchable with that of the last 3 hours, 131. It also incorporated the diastolic BP counterpart also. So the molecule is going to be justified in terms of reduction of both 24/7 control without any variations. How we are going to long-term variability? These also has been some sort of index has been used. One is the Tovey index, another is the smoothness index. It is nothing but they change the calculate hourly BP with the standard deviation of the BP reductions. At the same thing, the Tovey is calculated by mean BP reduction towards the standard deviation of reductions. They have clearly found out there is a statistically significant improvement in the Tovey index as well as smoothness index. It speaks about the good quality of the molecule. Even the long term, the BP control will be maintained. No need for escalation of the medications or no need for rescue medications into play for optimal BP control. Subgroup analysis, they want to know what happens for the BP when you want to go for 25 mg, when you want to go for 50 mg of metoprolol. They are clearly told, with respect to the drug molecules, the BP reduction, both the systolic and diastolic, is well under control, whether you use 25 mg or 50 mg based upon this. And heart rate also, the heart rate control, achieving heart rate of less than 70 is also well narrated by giving whether for low dose or high dose. Both the drugs works in angle. And adverse events is very minimal adverse events. What is skin related, subcutaneous related insurance documented in 5% of people. None of the major adverse events is noted. In study conclusion, the ambulatory BP monitoring is very vital as what we do CGMS to assess the exact picture of the BP of the individuals. What is the diurnal variations is there? What is the mass type condition? What is the white coat effects? Where you want to intervene? So much of things. And this is one of the states that uses ambulatory BP monitoring for a 6-8 weeks period. They found out this fixed combination of metoprolol succinate with telmisartan had drastic BP reduction. There is no day-to-day variability. The primary endpoint has been suffixed. The tolerability profile is very good, and side effect profile is very minimal and part compared to the placebo effects. Thank you for this is published in World Hypertension Congress 2025 held in Chennai. Thank you for the patient listening.
Thank you, sir, for an excellent description about the control of the BP with the fixed dose combination of the TRAC beta. Now the forum is open for discussion. The diabetes and cardiology always co-associates because MedPub Cardiology and Cleveland Clinic address diabetes as caramel cluster disease, comprising the cardiovascular, renal, adipometabolic, eye and liver diseases. So we have this forum where the diabetologists, cardiologists have spoken. And any discussions, we are open to. Thank you very much, sir.
Thank you so much, Chairperson.
Sir, for
mechanism of release of the two drugs, that only helps today. Otherwise, can you advise telmisartan metoprolol without this technology to have the same type of BP reduction in all patients? And I feel that telmisartan bisoprolol BP reduction is better than this telmisartan with metoprolol. Bisoprolol is better, no?
No, there is no head-to-head comparisons of telmisartan, this combination, that combination.
Yeah,
As
that is
rightly
what I
pointed
thought.
out, the preparation of metoprolol is the major concern to prove the mortality benefit. That is, initially metoprolol was given as metoprolol tartrate. That
Yes.
doesn't have any CV benefit. They moved to metoprolol succinate.
Succinate,
That may be the reasons for the CV benefit.
The benefit is because of the metoprolol succinate
Yes,
and the type of release of the metoprolol and the telmisartan.
Yeah, they're using different technology in this metoprolol. They want to assess the efficacy of the molecule.
If no more questions, we thank the organizers and scientific committee for the opportunity, and to thank both all the three speakers for a wonderful lecture, and thank Professor Dr. Arul Varmar, Director of MMC, for active interaction. Thank you, sir.
Thank you so much, Chairpersons. For the next session, I would like to invite Professor Dr. A.P. Ramaswamy and Dr. Suresh Khanna and Dr. Suguna Priya to chair this session.
The next session is going to be on clinical calculations in diabetic. Is that? Sorry. Sugar's deadly legacy, diabetic epidemic. Dr. Aravinda, please.
So good evening, everybody. At the outset, I thank the Tamil Nadu RSSDA team, Dr. Valamurugan sir and team for making me a part of this conference. So sugar's deadly legacy, the diabetic epidemic. So I'm just taking through the simple aspects of diabetes, how the things are going on in India and across the globe. That is what we'll be discussing. Greetings to all of you from Bangalore. So this will be the table of contents. So we all know the diabetes varieties are there, but how the things are going on across India, across the globe, this is what we are worried, why it is being spreading like an epidemic. So it is spreading like a tsunami across the globe, especially in our country. So diabetes is becoming the biggest epidemic of the 21st century. It is the fourth leading cause of death in developed countries. Complications like cardiovascular disease is 50 to 80% of diabetes related deaths. Peripheral vascular disease, stroke, neuropathy, amputations, renal failure and blindness. And we know that diabetic neuropathy is the most common complications. Retinopathy is the major cause of blindness and visual disability. after 15 years of diabetes, 2% become blind, 10% develop severe visual impairment. Kidney failure is among the leading cause. Severity varies by population and disease progression. So around the world, if you take the diabetes around the world in 2021, 537 million, approximately, are living with diabetes. 643 million by 2030, that is the total number of people living with diabetes is projected by 2045. 3 in 4 adults with diabetes live in low and middle income countries. So 830 million worldwide have diabetes. More than half of the people living with diabetes are not receiving the treatment. This is a major concern. 3 in 4 adults with diabetes live in low and middle income country. People with diabetes and the number of people with untreated diabetes have been steadily increasing over the past decades. So what are the population at risk? You can see across the globe, starting from the left hand side, by projection is between 2021 to 2045, there is a 24% increase in North America and Caribbean. In South and Central America, it is by 50%. In Africa, you can see that it is increased by 134%. In Middle East and North Africa, it is increased by 87%. Western Pacific, it is increased by 27%. Southeast Asia, where we come, like it is 68% increase, and Europe is more 13% increase. So it is not only in India, across the globe, the diabetes epidemic is going on and it will keep on increasing. So we need to take action about this so that this disease can be halted. So overall and area-wise weighted prevalence of diabetes and pre-diabetes, if we see in this study, that is ICMR India National Cross-Sectional Study, reported the overall weighted prevalence of diabetes as 11.4% and pre-diabetes as 15.3%. The maps you can see on the right hand side illustrate the prevalence of diabetes and pre-diabetes across different states in India, characterized by overall urban and rural population. So diabetic prevalence in IA is highest, that is more than 10%, as seen in the graph, in states like Maharashtra, Karnataka and Tamil Nadu, particularly in urban areas, whereas rural areas have lower prevalence. This is a 2-year back study. So the pre-diabetes is widespread, with many states showing a prevalence of more than 15%, indicating a high future risk of diabetes. So if you see the exploring diabetes epidemic in India, the bar graph shows the increase in prevalence of diabetes from 2000 to 2017, with the case rising from 32 million to 73 million. A sharp increase in projected, with an estimated 134 million people affected by 2045. You can see on the extreme right that how the sharp increase is happening from 2017 to 2045. So the trend highlights the growing burden of diabetes, emphasizing the need for preventive measures and effective management strategies. When it comes to age-wise incidence of diabetes in India, you can see it can be seen from 10 years up to 60 plus. As the age advances, as shown in the graph, the incidence of diabetes goes on increasing. You can see by 60 plus, you can see approximately 35% of the incidence of diabetes is seen in India. If you see the comparative diabetes prevalence, India versus the global, you can see from 2000 to 2025 year, you can see the India is far ahead compared to the global average. So India is spreading like a major epidemic in our country. So the global versus Indian trends, higher type 2 diabetes prevalence among Indian youth compared to Western countries. South Asians are more insulin resistant due to genetic predisposition, urbanization and increasing obesity rates contributing to the epidemic. So diabetic projections and the key drivers. Diabetes projection is, like you can see, by 2025 is 1 in 8 adults will have diabetes, that is 46% increase. Type 2 diabetes, more than 90% of the case influenced by socio-economic, demographic, environmental and genetic factors. You can see in the bottom the key drivers for type 2 diabetes, that is urbanization, aging population, reduced physical activity, rising overweight and obesity rates. We know the traditional complications of diabetes, that is diabetes kidney disease, retinopathy, peripheral neuropathy, coronary heart disease and heart failure, stroke and peripheral vascular disease. So what is the burden? You can see this slide, and next few slides I will be talking about the global burden and the Indian burden. When it comes to macrovascular disease, it is around 20 to 30% globally. When it comes to microvascular disease, retinopathy is 35%, nephropathy is 30 to 40%, peripheral neuropathy is 30 to 50%. See, this is the global prevalence. Now, when it comes to Indian prevalence, like, are we any different? Yes, we also see the macrovascular disease is around 25%. Microvascular diseases like retinopathy is 18% to 25%, nephropathy is 20 to 40%, peripheral neuropathy is 26 to 35%. So that the traditional complications of diabetes, cardiovascular complications is the leading cause of death in diabetes, affecting 30% of type 2 diabetic patients and responsible for 50% of diabetes related deaths. Key issues are atherosclerosis and heart failure. So what are the emerging insights? That is exophers, which helps the cardiomyocytes dispose of damaged mitochondria. Dysregulation contributes to complication. Novel therapeutic targets include QQI7 protein epigenetic pathways and nitric oxide signaling. When it comes to diabetic kidney disease, it affects 30 to 40% of diabetic patients, responsible for 30 to 47% of end-stage renal disease. Pathophysiology, we know that key changes are the podocyte dysfunction, glomerular basement membrane thickening, and glomerulosclerosis due to excess ECM protein. When it comes to emerging therapies, the promising target is latent TGF-beta-1 and ceramide 1 phosphate to address fibrosis and lipotoxicity. Next, when it comes to retinopathy, it affects up to 45% of the diabetic patients with early pericyte loss, causing vascular instability and blood-retina barrier disruptions. The key drivers are hyperglycemia and VEGF-1 signaling leads to vascular leakage and disorganized neovascularization. Next is the inflammation and oxidative stress. What are the emerging insights? Biomarkers like SEMA4D predicts an anti-VEGF therapy response. Circular RNase that regulates the vascular health by modulating signaling pathways. The therapies, DPP4 inhibitors and the protective lipids like omega-3 fatty acids show potential benefits. When it comes to neuropathy, it affects about 50% of the patient. What is the mechanisms? It activates the polyol pathway, depletes NADPH, GCH and generates AGs and impairing nerves. Ion channels, dysfunction of sodium 1.8, HCN2 and TRPA1 causes hyperalgesia and allodynia. The most important is the neuroinflammation. When it comes to the emerging insight, genetic risk, insulin resistance and Schwann cell dysfunction. Now this is one important aspect, that is what are the emerging complications of diabetes mellitus. Like, one is the cancer, infections, liver disease, functional disability, cognitive disability and affective disorders. Because the bottom line is the most neglected things we tend to forget in our day-to-day busy practice, which has to be addressed. So if you see the prevalence, cancer, like global prevalence, the people with diabetes have a higher risk of various cancers, particularly colorectal, liver and pancreatic cancer. So cancer is now the leading cause of death in people with diabetes in certain countries. Next is the cognitive disorders and dementia. Up to 20 to 30% of individuals with diabetes are at increased risk for cognitive decline and dementia, with the diabetes doubling the risk of Alzheimer's disease. Next is the affective disorders like depression and anxiety. So depression affects approximately 25 to 30% of people with diabetes, and the risk of anxiety is also elevated, contributing to poorer diabetes management. Most important is the sleep disturbance, which accounts up to 30% of the individuals with diabetes, such as sleep apnea, insomnia and poor sleep quality. In our country, the socio-economic impact of diabetes plays an important role. First one is the access to healthcare. cost of care, poor glycemic control. Next is the reduced productivity, disability and unemployment, educational attainment. Social consequences like social isolation and increased mortality. Next is the addressing the socio-economic disparities. You can see the bottom, that is the targeted interventions, improving access to healthcare and promoting healthy lifestyle. So we know the screening of diabetes has to be done in any age group. If the patient walks in, one of the things has to be kept in mind, like as you check for the pulse, blood pressure, temperature, body weight, oxygen saturation, the glucose has to be done in a routine day-to-day practice, so that we come to know what is the basic things. Then the further assessments can be done as per the protocol. The most important preventive strategies is like weight management. If I aim for 5 to 7% weight loss, following a reduced calorie diet, physical activity of 30 minutes per day, that is 5 days per week. Start with low impact exercise, increase intensity gradually. Eating healthy is very important. Portion control and calorie reduction. Choose low fat, high fiber foods. Replace sweetened beverages with water. So key lifestyle, plan healthy meals and snacks, engage in a regular physical activity, get enough sleep, quit smoking and tobacco. Benefits of healthy living, we all know that it controls the blood sugar, pressure and cholesterol, prevents or delays diabetes related complication. To summarize my talk, ladies and gentlemen, the rising prevalence, the number of diabetes cases is rapidly increasing, with projections reaching 783 million by 2045. Serious health complications leads to heart disease, stroke, kidney failure, blindness and amputation, significantly reducing quality of life. High mortality rate that is responsible for 3.2 million deaths annually, with 50 to 80% of diabetes deaths due to cardiovascular disease. Economic burden causes enormous healthcare costs due to long-term treatment, hospitalization and loss of productivity. Preventable yet under control. Lifestyle changes, early screening, proper management can reduce the risk, but awareness and implementation is the key, which has to be done in every day-to-day clinical practice. Thank you for your patience hearing.
Thank you, sir, for your wonderful lecture. Thank you very much, sir. We'll call the next speaker, Dr. Pradeep Jatwani is going to speak about the Swayambhi phenomena, facts or fiction. Over to you, sir.
So, good evening, dear friends. Let me first thank the TRAC organizing committee and Tamil Nadu State Chapter team for inviting me to be part of this annual event. I will be speaking on Somogyi phenomenon, fact or fiction, some controversy related to Somogyi phenomenon. We all know what is Somogyi phenomenon. So there is nocturnal hypoglycemia, which is followed by morning hyperglycemia, and this is related to the release of counter-regulatory hormones, which result in morning hyperglycemia. That is the basis of Somogyi phenomenon. It was named after Michael Somogyi, who is a Hungarian-born professor of biochemistry, who first described this phenomenon. And he is the person who developed variety of tests, including one of the most important, that is cost-effective method for screening for diabetes and monitoring its control in urine by using sodium carbonate and heat. So he was the person who devised the way to diagnose as well as to treat diabetes, and the monitoring at that time was with the help of urine glucose monitoring, and that was devised by this person, that is Professor Michael Somogyi. We also know the amylase. Previously we used to report it in terms of Somogyi units. This was also invented by this Professor Michael Somogyi. This is the seminal paper based upon which the Somogyi phenomenon was described, and we all are stuck with that word. Whenever there is morning hyperglycemia, everybody thinks of that it might be Somogyi phenomenon, and very much wary of intensifying treatment, particularly insulin therapy and candidates where it needs to be intensified. So what they have done at that point of time, they have admitted 3 people, young people, who were on high doses of insulin and who were having fluctuating diabetes, and as per the roster of their clinic, they were considered most severe, unmanageable diabetics, and they were not able to lead their daily routine life. So they were admitted on several occasions, and they have tried to find out what is happening to their sugars by measuring their urine sugar, because that was the standard of care in 1959 when this paper was published. So this is one of their patients where admitted on several occasions. Every time they calculate how much total glucose is available to the patient through protein, fat and carbohydrate per day, and they calculate urine sugar. From breakfast to lunch they collect entire specimen and what is the total urine sugar in that. From lunch to supper, from supper to breakfast, and that way they calculate what is the total amount of urine glucose and what is the total amount of glucose that is utilized. Most of these people, they were on very large doses of plain insulin, 30-30 or 25-25, 2 times a day only. So probably the low sugars and subsequent hyperglycemia which was occurring was more related to the physiology or the action profile of insulin rather than to hypoglycemia, than contributing to hyperglycemia through counter-regulatory hormone release. So this is the way they manage each patient there, and they formatted this kind of graphs, and they've shown that the days where urine glucose are less, these smaller bars, they are followed by days where the urine glucose is very high. So from that, they made an implication that low urine sugar is always followed by a high urine sugar. So this, that is hypoglycemia, is always followed by a hyperglycemic episode. And they concluded this that this is a paradoxical effect of excess insulin. And the title of their paper was Exacerbation of Diabetes by Excess Insulin Action. So what they have termed, excess insulin results in hypoglycemia, that results in counter-regulatory hormone release, and that results in hyperglycemia. And this is based on this paper that the Somogyi phenomenon, which we now routinely use the word in our literature, in our practice, is based on this primitive urine testing, showing that low urine sugar is followed by high urine sugar. There was a big controversy related to that, and many of the people, they were not believing in Somogyi effect. So this is the first paper which was published in 1980, where 15 patients who had 17 episodes of asymptomatic, untreated hypoglycemia between 11 p.m. and 3 a.m. Their morning blood glucose was measured, and those who were having morning hyperglycemia, which was observed only in 6 of 15 patients, there they were trying to find out what happened to their various hormone levels during night, that is growth hormone, cortisol, glucagon, and at the same time what happened to their free insulin levels during night. And they clearly shown that as the insulin level goes down, the blood glucose level goes up. So they concluded that the morning hyperglycemia was not because of counter-regulatory hormone, but it was because of lack of insulin action. There was a lot of trials which were going on to find out, or studies. They were trying to find out what happens to hypoglycemia in non-diabetic individuals. And Cryer has done a lot of work related to that. And he has clearly shown that if glucagon secretion is inhibited, then recovery from hypoglycemia is markedly impaired during adrenergic blockade and fails to occur in the absence of epinephrine. So adrenergic hormones and glucagon, these are the two things which are very much important in counter-regulation of hypoglycemia, that is insulin-induced hypoglycemia in non-diabetic individuals. Cortisol growth hormone role is not that critical, and this is not sufficient to increase blood sugar to the normal range. don't think of hyperglycemia. What Somogi proposed, hypoglycemia, counter-regulatory hormone release, and then it results in morning hyperglycemia. Here the sugar will not even rise to the normal level, even with the secretion of counter-regulatory hormones. And this was again summarized very well in this review article in 1985 by Philip Ruskin, that under most circumstances, unless food is taken to relieve symptoms, nocturnal hypoglycemia does not lead to a rapid and marked increase in the blood glucose, despite the release of counter-regulatory hormones. And fasting state, insulin-treated patient, hypoglycemia can persist for hours, and most of the time it is because of lack of insulin action and not because of counter-regulatory hormone release. If hyperglycemia occurs, then it is because of lack of insulin action. With the advent of glucometers and blood sugar monitoring, this is the study which was conducted in USA in Washington University Diabetes Research and Training Center, where they have identified individuals who were having nocturnal hypoglycemia, and then they have compared their sugars at 7 o'clock, 11 o'clock, 4 p.m. and 9 p.m. day before and day after the nocturnal hypoglycemia, and they concluded that nocturnal hypoglycemia does not commonly result in morning or daytime hyperglycemia in patients with diabetes sampled while using their usual therapeutic regimes. This was hospitalized patients. In 1987 in USA, this trial was done. This is the only trial which was published in NEJM, very well designed, very well conducted trial, where the patients were on subcutaneous insulin infusion continuously, and then they were given extra intravenous insulin to develop hypoglycemia. One group developed hypoglycemia, allowed to develop hypoglycemia, and second group hypoglycemia was corrected with the help of dextrose infusion. And they concluded that there is Somogi phenomenon, there is release of counter-regulatory hormones, and probably this should be thought of in people who are on intensive insulin therapy. So only one trial to support Somogi phenomenon, whereas all other, they have refuted this concept of counter-regulatory hormone contributing to morning hyperglycemia following nocturnal hypoglycemia. But still, we believe that Somogi phenomenon exists, and we are wary of intensifying insulin therapy whenever the patients they develop morning hyperglycemia or present with high fasting plasma glucose levels. We all know that now we have advanced from the plain insulins to the ultra long-acting basal insulin analogs with rather flat profile and action profile of more than 30 hours, and we have also moved away from urine glucose monitoring now to the era of continuous glucose monitoring. So continuous glucose monitoring can very well give an idea whether Somogi phenomenon is there or not. And this is the first trial which was published from 262 patients with type 1 diabetes, retrospective analysis they have done. And if you see this graph, this is morning blood glucose which is written here, and the dark bar it presents that the people who were having nocturnal hypoglycemia. So the people who were having nocturnal hypoglycemia, the morning glucose was generally less than 5. In most of the individuals, up to 80% of individuals, it was less than 2. It was never beyond 8, 9 or 10 millimole per liter. So morning hyperglycemia does not exist with nocturnal. If there is nocturnal hypoglycemia, the fasting plasma glucose will be low. It will not be high. The another trial which was done by Professor Pratik Chaudhary and Simon Heller, where they have tried to compare fasting capillary glucose values with the overnight lowest sensor glucose throughout the night. And if the nocturnal hypoglycemia was there, then the fasting glucose was also on the lower side. If there is Somogi phenomenon, then here the blood glucose, fasting capillary glucose should come here, but it was also low. So those patients who were having nocturnal hypoglycemia, most of them, their fasting glucose was less than 90 as compared to only 2 patients who were having fasting glucose more than 180 with episode of nocturnal hypoglycemia. Again saying that nocturnal hypoglycemia does not result in morning hyperglycemia. This is not related to Somogi phenomenon, but this is a trial where they have tried to find out patients who are on insulin degludec. we consider degludec, ultra long-acting basal insulin analog, and the chances of asymptomatic nocturnal hypoglycemia should be lowest with this insulin, because that is the best insulin which is available currently. And if you see here, and then they have tried to find out, can we predict asymptomatic nocturnal hypoglycemia? Again, they have shown that if the bedtime glucose is less than 90 and fasting is less than 70, there are 80% chances that your patient is having asymptomatic nocturnal hypoglycemia and you need to reduce the dose of insulin degludec. Again, this is against the Somogyi hypothesis of Somogyi phenomenon, that nocturnal hypoglycemia results in morning hyperglycemia. And this is very large database analysis of 2,600 patients with type 2 diabetes, retrospective analysis who were on stable treatment of insulin. Again, same way, less than 70 sugar between 12 midnight and 6 a.m. in the morning, and then their fasting sugars were compared, and they have clearly shown that if fasting glucose is less than 70 in the morning, 100% risk of nocturnal hypoglycemia, while fasting above 9.6, forget about nocturnal hypoglycemia. So morning hyperglycemia is not reflective of nocturnal hypoglycemia. Low fasting plasma glucose, it gives you a hint that there may be asymptomatic nocturnal hypoglycemia and you may need to modify the insulin dose. So this is proof of concept, a very large meta-analysis clearly showing that Somogyi phenomenon does not exist in real clinical practice. These are few cases from my own clinic. One patient, overall nighttime sugar, if you see, it is low, but the fasting glucose is again normal on 2 consecutive days. This is type 1 diabetic patient. This is another patient. Here you will say that there is a hypoglycemia at midnight and then there is sugar is rising in the morning. Is this Somogyi phenomenon? No, because the patient has taken snake here, a large snake, which resulted in high glucose, and then he has reduced his morning dose of insulin and took a large snake again because of fear of hypoglycemia. So the blood glucose has increased, and modifying the insulin dose, just reducing the basal insulin, everything is suffice. So whenever there is morning hyperglycemia, Somogyi phenomenon is very rare. It is mostly either because of dawn phenomenon or because of under-basalization or low intensification of basal insulin dose. CGMS will help you in deciding that. If it is not available, then you check blood glucose at bedtime, at 3 a.m. and morning glucose. Bedtime glucose will be normal in all 3 categories. 3 a.m. glucose, if it is low and morning glucose is high, this may be Somogyi phenomenon. If 3 a.m. glucose is high and morning glucose is also high, that means you need to increase the basal insulin dose. If 3 a.m. glucose is normal and fasting glucose is very high, then it is generally because of dawn phenomenon. To conclude, I will quote this take-home message from a beautiful paper by Professor Pratik Chaudhary and Simon Heller. The title of paper is also same, The Somogyi Effect, Fact or Fiction. So they have clearly given 5 important take-home points. First, low fasting glucose, always think of nocturnal hypoglycemia. Upper limit, we always say, whenever the fasting is more than 130, increase insulin by 2 units. You need to counsel also about low. So if it is less than 90, you need to reduce insulin by 1 or 2 units, because people who are having fasting less than 90, they are having more risk of having nocturnal asymptomatic hypoglycemia. 3 a.m. glucose test and CGM can very well help you in understand the overall pattern, whether it is dawn or Somogyi or under-basalization. The Somogyi effect is very rare. Asymptomatic nocturnal hypoglycemic episodes, they are unlikely to produce a sufficiently strong counter-regulatory hormone response to raise blood glucose in the range that is being termed as hyperglycemia. Somogyi effect, you should not think of Somogyi effect if the patient is having high fasting plasma glucose. You have to intensify insulin therapy, because mostly it is because of under-basalization. Thank you very much. Again, I thank the entire organizing team and Tamil Nadu State Chapter team for inviting me to be part of this important annual meeting. Thank you for kind attention.
So we are inviting Dr. Manoj Chawla for presenting monitoring patients on new incretin therapies.
Thank you, Chairs. Thank you, Dr. Shanmugavellu sir, Dr. Rajendran, Dr. Balamurugan, and the entire Tamil Nadu RSSDI team for inviting me here and allowing me to speak on a newer topic. Very often we'll end up speaking for some of the drugs. So today my disclaimer is I'm not contracted for this talk, and these are my thoughts as we move ahead in important times of using the newer incretin therapies. There are certain aspects of monitoring that are becoming important. I'm not covering all the aspects that one should monitor, but certain important aspects that we are now learning may become clinically relevant. Well, GLP-1s, of course, the way they work, we're understanding that better. By decreasing appetite, food intake and satiety at the level of the brain, has an impact at the level of the liver, decreases gastric emptying, improves insulin secretion, and reduces the alpha cell overactivity. Tirzepatide, which is a dual analog, does more. It is essentially a molecule on the GIP background, so has high affinity for GIP and low affinity for GLP. So it does everything that GLP does, but on top of that, also because of its high affinity GIP action, increases insulin secretion, increases beta cell survival proliferation, and has an anti-inflammatory impact, which is why we see the benefits of this GIP-GLP molecule, which is getting popular day by day. Now, let me essentially, when you talk about monitoring, there have been a lot of expert consensus. This has been part of the RSSDI expert consensus for glucose monitoring, where essentially this paper published last year, we did speak about monitoring, which included every aspect, right, from SMBG to HbA1c and CGM, and we spoke about special situations in this paper. Dr. Pratap referred to CGM when he spoke about Somogyu phenomenon, how important it is to monitor, and how difficult at times it's to do a 3 a.m. SMBG, which is where CGM has made a lot of changes. So advantages of CGM over traditional blood glucose monitoring is today the real-time data. We no longer use those blinded professional CGMs much. It is all real-time CGMs. And of course, a lot of these CGMs today have alarms for highs and lows. So people who are using it, unless you put those alarms off, most of the systems now are going to offer you the alarms. And especially with the reduced gastric emptying and GLP-1 or the dual peptide usages, the chances of hypoglycemia are actually higher when you're using it with the other drugs. So let's understand what I'm saying. On one front, these drugs used alone claim to have a glucose-dependent action. However, when you use them today, very often you're using them on top of other drugs. So the chances of hypoglycemia is increasing, and I'll show those in the cases. Benefits for patients and clinicians for CGM is going to be hypoglycemia management and enhanced treatment adjustments as you start using these drugs. Now, this is a wonderful paper which is achieve individualized treatment goals in insulin-treated people with type 2 diabetes. Now, if you look at this on the left side of this paper, they spoke about for patients who are on basal insulin, how do we go about improving their metabolic health, and they've strongly recommended the use of GLPs. Now, if the A1C is more than 8 to 8.5, it says you initiate a GLP receptor with no reduction of the basal insulin. However, if the A1C is less than 8 today and you're starting any of the GLP-1s, especially the more effective ones, you need to reduce the insulin by 20%. Continue titrating slowly to the maximum tolerated dose of these drugs, When fasting readings are dropping less than 100, further reduce the insulin by 10%. And for those whose insulin or fasting sugars are dropping less than 70, decrease insulin by 20 to 25%. On the right hand side is wonderful points for additional best practices for clinicians today. Consider placing a CGM as far as possible. Initiate at the lowest dose. There have been times that we try to initiate at a higher dose or patient has told they'll tolerate, and sometimes that leads to problem. Ensure that patients are instructed to initiate insulin reduction on the same day when you're starting GLP. So a very important part today that when you're starting GLPs and somebody is on insulin, the response can be much better than anticipated. So reduce the insulin. Those adjustment of other medicines may be needed. Provide anticipatory guidance about antiemetics, your proton pump inhibitors, and so on. So let's look at some of the case scenarios that I've gotten for you today. The first one, a 58-year-old male, type 2 diabetes since 9 years, persistently high A1C over the previous 4 to 5 years, was not regular with his medications, had comorbid hypertension and dyslipidemia. 18th April 2024 last year, he sees me with the sugars of 142, 339 and A1C of 14.8%. The fact that this patient came in that day, it was because of the high sugars, and said that no, I want to change things. I have not been careful. His medications at that time was Idagas twice a day 20/20, vildagliptin, metformin, glyclazide, metformin, dapagliflozin. So the works, I think everything except a glitazone was there with 40 units of insulin. And yet the A1C was 14.8%. So you know something's amiss there somewhere. So patient, we recommended, okay, you're motivated, you're going to be more compliant with the medication, let's start monitoring. Let me put you onto a CGM. And we said, fine, let's get you onto a GLP-RA and insulin combination. So Iglar Lixi was available last year. We switched this patient from 40 units of Idagas to 30 units of Iglar Lixi. We continued the DAPA metformin and changed from the glyclazide metformin to glimepiride metformin voglibose. Again, the recommendations I showed you earlier says be wary of sulfonylureas also when you start these drugs. This was last year. I wasn't aware of these recommendations. I started the patient on this combination. Patient, of course, started getting more adherent and on the CGM could track things. Now this is in April 2024 itself. Look at the CGM tracks. There is variability that you can appreciate. You can also see is the hypo. TIR was 63%, but the problem was 8% of TBR, out of which 4% was level 2 TBR. That means dropping below 54 milligram %. Now this patient was handling things because of the hypoglycemia. He was advised reduction of insulin. Dietary and lifestyle modifications were further promoted. The patient's TIR improved. So from 63, from April to June 2024, the TIR improved to 81%. You can also appreciate the band becoming narrower, so the variability decreased. But the TBR, as you can see, increased to 18%. So this patient, because he started getting more careful with the diet, started taking medicines regularly, the response was super. And he started reducing the medications, but the TBR increased, and which is where we have to be extremely cautious of monitoring these patients when you start these drugs, the GLPs and the GIP-GLPs. The patient's A1C decreased over a period of time from 14.8 to 7.9 over a 5-month period. Which gets me again to the other RSSDI consensus that we was part of SMBG. Again, in this consensus, we've strongly emphasized on the recommendations for SMBG. In India, SMBG still remains relevant. Everybody can't use CGM and can't use it continuously. So we talk about those who can use CGM also in between the CGM periods to still do a structured SMBG, which is helpful. And on the right side is one of the earliest consensus and recommendations of CGM that we did. Was published in 2019. So that gets me to the case number 2. 44-year-old businessman, type 2 diabetes for 10 years. Again, has uncontrolled sugars, has weight gain, demanding work schedule, travel, all of that, has dyslipidemia. This is somebody that I would call as the yo-yo person, going up and down. 13.6% again HbA1c. This is 2022. Patient at that visit is advised to start insulin glargine. a glyclazide metformin voglibose combination and a sitagliptin metformin in the afternoon. If the dapagliflozin was or EMPA was not given, it was because of the patient's symptoms or GU infection at that time. After starting this, patient reported occasionally feeling low while on insulin, had concerns about hypoglycemia, and hence we said, okay, let's stop the insulin. That happens at times. You look at a 13.6, you will start insulin, you want to give that. But some of the people with the change of OHAs, getting more involved in their care, within a few weeks they start getting hypo. So you want to knock off the insulin, fair enough. But we told, okay, let's start doing the CGM again to observe what is happening. This is the November to December 2022 snapshot. Already the patient was doing a 93% in target. So obviously telling us that except for those initial weeks, insulin was not required and monitoring was important. Patient's estimated A1C was 6.1. Jan 23, the patient came to us, said, I want to lose weight, I have heard about GLP. So at that time we started on dulaglutide, 1.5 milligram. Glyclazide metformin dose was reduced, sitagliptin was of course removed because you were starting a GLP dulaglutide. This is January 23. Patient's A1C improved to 7.8, weight was 101.2, this is again March 23. What happens after that? Well, so in March 23, when the patient improved and was doing CGMs, patient was brought down because of hypos to only metformin and dulaglutide. Well, they said, doing great, we should see the patient in May or June of 23 to see whether we are touching a 7% and what's happening to the patient's weight. But what happened was, patient disappeared for a year, which happens to many of our patients. And during that course, again with travel, with other aspects getting complacent, patient's A1C went up to 9.4. On his own, patient started glargine again and stepped up the oral tablets. In our country, you don't need a prescription. You can call up the chemist and say, send me glargine and send me these tablets, and they'll send you. So, and then he came to us in February 24 because his own efforts was not helping him. A1C was 9.4, he was gaining weight again. We said, okay, let's look at other treatment options. Let's start looking at the CGM again. At this point, we had tirzepatide last year available in the grey market, at least in Mumbai and other places. And this individual who travels and was well aware said, no, I have a source, I know I can get my tirzepatide, tell me to start. And he said, in the past I've had no issues when I've taken Iglar, Lixi and others. You give me, start with a higher dose, I don't want to start with 2.5. As I said, something that I would not do today, but this was last year. So started on 5 milligram. He was already taking glargine and sugars were still 9.4, so he said, okay, continue glargine. And patient was taking this glyclazide metformin voglibose, so we continued. Again, a big mistake. As I said, I wasn't aware how these drugs work, and it would work to that extent. This is use of tirzepatide in 2024 February. So there is glargine, there is glyclazide metformin voglibose and tirzepatide 5 milligram. Look at what's happening on the day that he has taken this dose and then the days following that. The number of hypoglycemia the patient experiences starts on his own reducing insulin. Of course, these is connected care. So he messages our clinic, I can see the CGM on my laptop and advise the patient, yes, start decreasing. Very soon we discontinue the insulin. And over a period of time, not only is the insulin gone, the sulfonylurea has gone, everything else is gone. Patient is only on tirzepatide, has lost weight 6.5. December 2024 is when I saw the patient last at my clinic, which was 12.5 milligram. Patient had gone up to 12.5 milligram. Look at the GMI or estimated A1C, 5.3. Look at the sugars. This patient is only on tirzepatide without any other medication. What are you noticing? The lows. And that's another new learning for all of us. When you have your patients on these drugs without any hypoglycemia causing drug, and you do a CGM, you will see a lot of sugars in the 60-65 range. Patient is absolutely comfortable. This is not hypoglycemia. It's hypoglycemia if there are symptoms and if the patient is on hypoglycemia causing drugs. So if you start reacting to it, patient will reduce the drug and not get the advantage of weight loss. So when you're using in a lot of patients who achieved remission or are non-diabetic and you do a CGM, you'll see 60s. One, start looking at time in tight range and don't worry about the lows as long as they have no symptoms of the same. So that's important learning. These were our papers again on time below range, which is so important in today's times. Quickly in the last 2.5 minutes, two more case scenarios. This is an individual history of pre-diabetes. CT angiography reveals certain blockages. A1C is 5.7, so at the cusp of pre-diabetes. Essentially, patient wants to lose weight. We start this patient on tirzepatide. This is March after it's been officially available. What I want to show here is the body composition analysis, and that's another important part to monitor. In body composition analysis, you're seeing the skeletal muscle mass at 32.2. The overall score is 48, which is poor. As this patient follows up in June 25, gradually it's been stepped up to 10 milligram tirzepatide. A1C came down from 5.7 to 5.3. Substantial fat loss. The fat has gone down significantly. What we have to watch is the muscle mass. Fortunately for this patient, the muscle mass has not reduced much. It was 30, I'll go back. It was 32.2 and now it is 31.7. So 0.5 kg muscle loss, which is fine. So that's important aspect to monitor. Similarly, in another case scenario where we have used in a younger individual, 17-year-old, 101.4 kg. Initially started on metformin, vildagliptin, but wanted to lose weight. He of course became an adult. Oral semaglutide was initiated for his sugars and for the weight loss benefit. What do you see here? 107.8 kg, a skeletal muscle mass of 30.6. Over a period of time, a year later, his weight is down to 96.1 on oral semaglutide. 11 kgs this boy has lost. A1C is down to 5.6. Fortunately, the skeletal muscle mass, which was 30.6, has improved to 32.5. So when you use these drugs, protein supplementation and resistance training for the muscle is extremely important. And that's the message I want to leave all of you with, is that we need to learn newer monitoring aspects when we use these drugs. The future of CGM and incretin therapy is extremely important. So wherever possible, when you're adapting to new drugs, use CGMs to monitor. It helps you, it helps the patient see better. With that, these are of course where the lot of references were drawn from those couple of papers. And let me wish all of you happy Raksha Bandhan, and I welcome you to the DRS conference 2 weeks from now in Mumbai. Would be happy to see any of you joining us there. Thank you, organizers, once again. Thank you.
Thank you for your enlightening lecture, sir. Thank you, sir. We'll call upon the next speaker, Dr. Alok Modi. Is going to talk about residual risk reduction after LDL correction.
A very warm good evening to everybody, and my humble regards and respects to the respected organizers and the respected chairs and the stalwarts of the dais. So my topic is a very interesting topic. We keep treating patients and we keep focusing on lipids, LDL, but we forget that there is a huge ecosystem beyond LDL. What is that? I would like to play this video. Maybe you can just have a look at this. There's no noise. Can we get the sound? Is it okay? Sound is there? Should I switch on?
He takes his daily medication, a small aspirin and a 40 milligram atorvastatin tablet with a sip of water. His recent lab results reassure him. Total cholesterol at 140, LDL at 70, both well within normal range. Smiling, he heads out for a jog in the park, breathing steadily and moving with confidence. Suddenly, pain grips his chest and he collapses. Paramedics race in, illustrating a crucial truth. Heart attacks can strike even when numbers look perfect.
So that is what is important. We forget that Titanic plays a role everywhere in our life. Titanic makes Shah Rukh Khan say Kiran. Titanic makes our hospitals suffer. Our patients die because we do not see the ice under the sea. So this is the same thing, residual risk after LDL correction. We do not see the huge burden which lies under the sea and which causes a lot of problem. This is the hook in India. 68% myocardial patients have LDL below 100. 68% have LDL below 100. Residual risk is 52%. Because of that, the economic burden is 2.17 lakhs. And there is a 3 times higher risk in the Indian patients compared to Caucasian patients. Question is, we are Indians, we are treating Indians. Why are we missing this huge lipid burden that we are not aware of? Something very unique for India. Very typical Indian pattern. High triglycerides, 42% prevalence, low HDL cholesterol, 72% Indians have less than 40. A small LDL is 35% higher than Caucasians. We get diseases early, we get myocardial infarctions much earlier. We get most of the infarcts which LDL is below 70. And we get a premature coronary artery disease with 12% prevalence. And we are treating our patients with statin as a monotherapy. We keep treating it and we look beyond that. So I've gone through a lot of literature for this presentation. I went through umpteen amount of presentation, and we realized over there that there is a lot of work already existing since 2008, and a lot of research has been talking about a lot of issues which are present in a lipid ecosystem beyond LDL. In spite of the best of benefits offered by statin therapy across various populations, the mortality levels have not come down. Ischemic heart disease still today remains the #1 killer across the entire planet, in spite of the fact that they are on 40 milligram and 80 milligrams of atorvastatin. A huge chunk of diabetics, we know that diabetes is a big risk factor. 14 leading statin trials, absolutely renowned leading trials, when a meta-analysis was done, they were shocked to see that the mortality and morbidity ratio was very high, in spite of the HbA1c being under control. So what are we missing here? We are missing a huge bus, because we are very happy to treat our diabetics and non-diabetics with good dose of statins. So there are a lot of other risk factors. You're looking at low HDL cholesterol. This is a risk factor for dyslipidemia. The problem is it is an independent risk factor. The point to be noted is it is not just a risk factor. It does not matter what is your LDL cholesterol. Non-HDL cholesterol is an independent risk factor. This is a huge study from the Framingham study. Let's see something very important over here. Look at patient 1 with LDL cholesterol of 100 and the HDL cholesterol of 65. The risk is 0.4. Patient 2, LDL cholesterol 100. HDL cholesterol 45, risk is 0.6. Important, pay attention to patient 3 and 4. LDL cholesterol in both, one is 100. HDL cholesterol is 25, the risk is 1.2. Whereas when the LDL cholesterol is 220 and the HDL cholesterol is 45, the risk is yet 1.2. Moral of the story is, though your LDL cholesterol is under control, the risk remains very high because the HDL cholesterol is not under control. So though we know that VLDL cholesterol and triglyceride-rich lipoproteins are able to enter the arterial wall, look at these 5 quintiles, and that tells you very clearly that there is a huge amount of passenger traffic and business that we are missing because we are focusing on very limited traffic. So look at the chylomicron remnants, look at the cholesterol remnants, look at the triglycerides, look at the VLDL, look at all these things. When patients' triglycerides were less than 150, they were independent recurrent cardiac coronary events, recurrent coronary events that showed very clearly that triglycerides play again an important role. So non-HDL cholesterol, triglycerides, chylomicron remnants, all of them play a very important individual role. Moral of the story is you need to treat them separately and not as a family. If you look at this data very clearly, if you look at the LDL cholesterol, which is less than 130, you look at the death rate and the cardiovascular risk, and you look at the non-HDL, when you combine it with more than 190 with an LDL below 130, the risk is as much as when non-HDL was less than 160, but LDL was more than 160. So moral of the story is LDL cholesterol management does not really benefit your patient in any way. So understand this concept of non-HDL cholesterol. It is now being recognized as an independent risk factor and a separate ecosystem of lipid management which has got nothing to do with statin. This is the blueprint of the Janam Patri where everything is happening. The entire ecosystem of lipidology is lying here. You're seeing the liver over here, very busy slide. Multiple lipid remnants are there. The entire therapeutics of lipid management, whether it is statin or what, is all over here. I'll move out. You can take a snapshot of this. This illustrates where different drugs are working. a huge pharmacology arsenal is present. If we just go through this file, you have omega-3, fibrates, PCKS9 inhibitors, antisense, anti-inflammatory molecules, ETC molecule, PAPA, alpha and gamma agonists. And if you see the LDL is reduced more by PCKS9 inhibitors to the tune of 60%, but we are thinking of statins. If you look at the ezetimibe, the LDL is reduced by 24%. These are drugs that we do not give importance to. Look at the MACE. The MACE is decreased by omega-3 fatty acids. MACE is decreased by, again, PCSK9 inhibitors. And if you look at the anti-inflammatory drugs like colchicine, it reduces MACE maximum. Have we thought of prescribing these drugs to our patients? Have we paid importance to these drugs? What is available in India? Those drugs are not available in India. At least PCKS9 is probably not frequently prescribed. But if you look at the statins, fibrates, the agonists, the nicotinic acid, bile salts equivalents, look at the dosages, you look at the cost, not so expensive. But if you look at the figure on the right, the LDL reduction, triglyceride reductions, MACE reduction, phenomenal and huge with drugs which are not statins. So let me just encapsulate you certain drugs. Saroglitazar, one of the best drugs in the market, produced in India by Zydus, an Indian molecule, a very cheap molecule, fantastic drug, dual inhibitor, works very well in atherogenic dyslipidemia and glycemic control, 45 to 55% TG reduction within 12 weeks, improves non-HDL and apoprotein B, reduces the residual cardiovascular risk, fantastic drug for NALFLD and MFLD. Glycemic control is a boost, is an add-on. How much? 0.7 to 1 grams of HbA1c, which is fantastic, which is unheard of. Indian molecules are very cheap and easily available. The only reason it is not popular is the Western world has not given it credence because the FDA has not approved it. There is not large CV outcome data. There is some amount of alpha gamma inhibitor risk like edema, feet and osteoporosis, etc. Because of lack of global acceptance, we also blindly follow the West and we don't use it. So long-term uncertainty, NASH approval not officially done on paper, little interaction with statins and narrow evidence base as of today is preventing us from writing it, though it is a fantastic molecule. Look at the bempedoic acid. This works a little upstream of HMG coenzyme A reductase inhibitor. It's a prodrug which is activated in the liver, no activation in the skeletal muscle, so none of the myopathies of statins is there. So if your patient is having a myopathy, you can replace it safely or you can give it as an add-on. The reduction is 38%, which is huge. Clear outcome 2023, fantastic reduction, very good for intolerance, once a day, safe in kidney disease and fabulous for residual risk. Problems? LDL reduction has got little limitations, hyperuricemia and gout, little costly, but in the elderly people, there is a little risk of tendon rupture. Look at the PCKS9 inhibitors, evolocumab, alirocumab, and inclisiran. Very good drugs, fantastic drugs off the, in the labs, not yet very much popular in the doctor's prescription in his chamber. And if you look at some of the newer kids on the block, you can see some fantastic drugs like ANG-TPL3 inhibitors, the evinacumab and the solbinirisan, some new molecules, and there are some chai molecules which are coming out through the artificial intelligence pipeline. This is an area which is very close to me. It's not yet got clinical approval. The trials are on the way, but the initial results are absolutely promising. If you look at olezarsen, which is an ApoC3 inhibitor, it's an antisense oligonucleotide. It reduces it to the tune of 60%, unheard of, 60%. And if you look at this drug, which is the ANGPLT inhibitor, it reduces your LDL gene producing LDL permanently. One shot, you're permanently out of LDL increase. It's a permanent cure. So now like we are looking at GLP agonists as a permanent cure for obesity, we're looking at some of these drugs which could be a permanent cure for dyslipidemia. So I've been giving you a lot of 2030 and 2040 telescopic views. Let me come back to 2025, and this is what your current guideline, CSI 2024 guidelines and the LI guidelines. Very clear, you need to start fibrates, you need to look at non-HDL, you need to look at pancreatitis, you need to look at triglycerides below 500 and above 500, you need to assess, give lifestyle measurement, but do not forget to add fibrates and omega-3 fatty acids beyond statins, beyond ezetimibe. Do not forget to do that even if your LDL is under control with 70. Now these are position statements and guidelines by our own forefathers, by our own people. Very important that we don't forget it. So this is the 3P framework. Predict dyslipidemia and infarctions in your patient, prevent it from happening, and give precision medicine. Personalize your prescription to that patient. So it's not that one code suits all. You can't just take a statin, an acetamide, a fibrate, or a niacin and push it on all your patients. No. You need to work out the pathophysiology and give real personalized care. So let me just walk you through what is precision medicine and beyond LDL in 5 or 6 cases. Patient A, 48-year-old executive, type 2 diabetes mellitus, post angioplasty, Rosova 40, LDL 58, TG 285, LDL 32. You predict the lipid assessment, as you can see over here, with apoprotein of 125. You put him on a fenofibrate 160, which will prevent further increments in triglycerides as per the field and accord trials. And you can personalize it by giving it over 12 months. And you can see that the HDL has boosted up to 40. No CV events, fantastic drug, below the 2 references. Second case, 55-year-old teacher in Chennai, postmenopausal, hypertensive, LDL 65, HDL 28. You can predict the HDL quality assessment. The only drug you consider here is saroglitazar 4 milligram once a day. The benefits are HDL came down from 28, boosted up from 28 to 38, TG reduced by 35%, absolutely no cardiac events. Third case, 42-year-old professional from Bangalore or maybe Coimbatore, lipid A assessment 85, screening to affected siblings, residual risks of 2.5-fold, Indian prevalence 25% have got this elevated lipoprotein A that we hardly check. We actually check because our patients come from ThyroCare and other labs getting a 50 or 60 analysis done, and then we pick up our eyes and we see, yes, something like that has happened. We just put this patient on 1 gram of nicotinic acid. I'm sorry, it's not easy to tolerate nicotinic acid, so I'm giving this as an example, and 1 gram twice a day is a huge dose. The practical approach is titrate to 3 gram if it is possible, and add your Rosova and acetamide, add an aspirin, get his hypertension under control, fabulous control of lipoprotein A. So here I'm managing only lipoprotein A with nicotinic acid. 60-year-old businessman from Delhi, stable coronary artery disease, LDL 62, high resolution CRP 5.8, interleukin 6 elevated. What I need here is an anti-inflammatory drug. Did you ever check CRP? We do not check CRPs for our cardiac patients. Time we start checking CRP because inflammation is another marker. We have been hearing a lot about inflammation as a pathogenesis of diabetes. We need to understand that inflammation is a pathogenesis of lipidodysgenesis. So high resolution C-reactive protein can be brought down not by rosuvastatin but by colchicine. And after following up after 6 months and adding a curcumin, which is your haldi, these things have been shown by these 2 trials that I have given you. Results were good, no cardiovascular events after 2 to 3 years. Fifth case, I'll go a little fast, 52-year-old homemaker from Hyderabad, type 2 diabetes, 10 years, diabetic retinopathy, LDL 68, TG 380, very high, HDL 30. Small dense apoprotein A and LDL is what we are looking at. We are looking at the remnants of cholesterol. We prescribed fenofibrate, acetamide and saroglitazole. We got fantastic controls, 380 to 145, HDL 30 to 45, HbA1c is 8.2 to 6.8, and retinopathy stabilized. What more can you ask for? So what's important is to understand that these drugs are available in the market. Costs are 2,500 to 3,000 per month. 72% reduction, 47% reduction, 28% reduction, and I'm not discussing statin at all over here. So we need to sort of plan out an algorithm. We achieve our LDL first through a statin, then we assess what is the residual risk beyond LDL, and then we pick out the pathophysiology like Harrison says, and then we individualize the therapy based on the different markers that we have. And if we do that, we have a lot of drugs in the pipeline that will be coming in tomorrow, like Vascepa, bempedoic acid. I think bempedoic was released. I've given a couple of bempedoic. I don't know if it's available today. We have obesity tariff. So those are a couple of the drugs. Few take-home messages. Residual risk is not something that we're discussing in conferences. It is very much there in our patient in spite of very good statinization. Indian drugs are available and cheap, and they are going to give benefit. Don't look down on them. Be target specific and be pathophysiology specific. Start giving a combination of different non-HDL drugs and give them a better life. Some of the references here, some of the clinical challenges and implementation that we can discuss. I would leave you with this slide that we can optimize our patient. We mostly optimize with one, HbA1c, sugar, LDL and all, we get very good control. We optimize 2 or 3 risk factors, we get very good control. But we get real control when we optimize across the spectrum. So in short, it's a huge topic. I just wanted to highlight things. We need to go beyond LDL and see that there is a huge ocean of sharks sitting outside LDL and giving you a lot of trouble and biting you and giving you multiple problems in the eye, diabetes and cardiovascular area that we need to address as responsible clinicians, and I'm sure especially relevant to India, and I'm sure that would make a huge difference in our patient ecosystem for tomorrow. So again, I would like to thank you, the respected organizers, for this talk, and I hope we can change our prescription habits a little bit after hearing this. Thank you very much.
Thank you very much, sir. I thank all the 4 speakers. Any questions from the audience?
Sir, this is to Dr. Pratap, sir. Patient experiencing nocturnal hypoglycemia with hyperglycemia, and the patient experiencing nocturnal hypoglycemia with the normoglycemia, I mean fasting is normal and next day morning. How do you titrate the dose of insulin?
Morning hyperglycemia, if it is there, it generally ruled out nocturnal hypoglycemia. In the current era of longer acting basal insulin analogs, if you are using NPH insulin, then this may occur because it is the action profile of this insulin is like that. So if patient is on NPH, I will tell you to shift that to a longer acting basal insulin analog that will prevent nocturnal hypoglycemia, and at the same time the morning hypoglycemia will be covered better way. You can adjust the dose in a much better manner. So that is my message.
With normoglycemia, fasting is normal.
Fasting is normal, and nocturnal hypoglycemia, you need to reduce the dose of basal insulin analog.
You need to reduce
it. Generally it doesn't occur. Fasting, when it goes below 90, the risk of nocturnal hypoglycemia is high. But if the patient is having normal sugars, fasting 110, 120, and still they are experiencing nocturnal hypoglycemia, this may occur with conventional basal insulin like glargine, which has got a peak at 6 to 8 hours, a small peak. I will suggest to shift them to a newer basal, ultra long acting basal insulin analog, either degludec or glargine 300.
Sir, Dr. Manoj, sir.
Yes, madam.
The first example case which you showed was on idagasp with some 20 units.
That's right.
With so much of OHDs and around 52 years was not controlled with 14 HbA1c. Why do you want to change the drug and then do glucose monitoring?
So, no, this patient,
You had changed the injection to Glarlexi.
that was later, madam. So when we started the ICGM, this was later. So there are 2 different cases, right, which I showed you. There were 2 cases which I showed you, right? So the one which was the first one, which was on idagas 20 units, we at that time didn't make drastic changes. It's just that this patient was non-compliant, said himself that I'm not being taking it, and I would want to get more compliant. We put him on a CGM, and we saw the sugars coming down, because not because the medicines changed, because the patient started taking it. Patient himself said that I was taking it sometimes, missing out, not very serious with my dosages, and which is where the sugars had touched whatever, that 14%, as you said. So this patient later on, at the first instance, we didn't start a GLP for him. It was later on that we have shifted from idagas to Iglar-Lixi, because he wanted to then get into a little weight loss. So at each and every instance, your CGM has been done. The first time the drastic reduction was purely because patients started taking the injection and the medications regularly and started following the diet as well.
Okay. If the same patient, as you say, is on CGM, is put on CGM, can we titrate with the same dosages and OHDs if he is adhering to the...
So 2 aspects. I largely, if I understand your question right, your question is, why do you want to make changes in the medication if you're putting the patient on CGM? Sometimes you may make changes in the medication because you don't agree with the kind of medications and you have faith in other medications. So you may want to make that change when the patient sees you the first time. irrespective of whether you're changing or not, the larger aspect there is monitoring. So for a patient who says, I will start taking it, I'll be more compliant, I want to follow my lifestyle better, again, we don't know how they responded. So I show you a drastic case. Everybody will not be like this who will come down from 40 units down going to hypo. But there will be enough instances that when they start following, they can go into hypo. Of course, the larger part of the conversation was on those where a GLP or a dual was started. Their response is something which was unprecedented. And that now, that it's officially available in the last 3-4 months, we are seeing a lot of those cases happening. Thank you.
Anybody you can clarify this question. Recently, glimepiride 2 milligram, metformin 500 milligram, Oglibos 0.3 milligram. They banned it. What is the reason? They are allowing glimepiride 2 milligram, metformin 500 milligram, and Oglibos 0.2 milligram.
So no idea. I have no answer to this. I don't know if any of my colleagues have an answer.
Anybody can answer means
we have to ask the CDSE or DCGI. Maybe if Professor Das was here, we could have asked him what would be the thought behind. Yeah, Alok has an answer.
I just heard it in some meetings, and this is what I feel. I may be wrong. See, Voglibos, these drugs are to be taken just 10 minutes after the food. They are not absorbed.
They are allowing 0.2 milligram Voglibos with glimepiride and metformin. They are not allowing the 0.3.
Yes, sir.
So then what is?
2 milligram plus 500 milligram, 0.3 milligram, they are not allowing.
Sir, is right. If you are taking 3 milligram of glimepiride
Yeah.
and metformin, then 0.3 of Voglibos is allowed. But with 2 milligram of glimepiride, so that is the funny thing that
Yes,
we
yes.
don't know the rationale.
They are allowing 1 milligram, 500 milligram, 0.3.
Absolutely.
But 2
But 2
milligram
and 0.3
glimepiride, 0.3 they are not allowing. What is the rationale behind this?
The pharma
No idea,
people are
sir.
telling, sir,
Brilliant
they
question,
appeal
but no
it to the
answer.
TCGI and they will get mostly to the above prescription soon. The pharma people are now telling that. They don't know how, what for they banned the drug. They return the clearance for these things and they are expecting it for clearance.
Sir, patients are,
Pharma people are claiming that.
patients are so aware that, sir, you are writing a banned medicine.
Sir, but for that matter, many of us use 7.5 milligram of pioglitazone and we were using it with metformin. Now they removed the 7.5 and metformin combination. So for many of your patients where you want to use it, you are using it separately and adding to the pill burden. So I really don't know the rationale behind some of those decisions.
Thank you,
But
sir.
Great,
Thank you
great
very
question.
much. Thank you.
Actually, if you are supposed to take glimepiride or something like that, it should be taken 15 minutes before food. Metformin, rational, it should be after food. Voglibos, in between. So, combination will interfere the at least suboptimal effective dose you will not get with these three combinations. That is why first time when glucored was introduced, there was a long debate. No one followed glucored. After 3 or 4 years only, second drug came following glucored. That is the reason, and maybe slowly 0.22 also they might withdraw, because the kinetics they will observe, the absorption erratic should not be more than 90%. It comes to 60 to 70%. That is why they have stopped.
Absolutely right, sir. I think the rationale that you explained was beautiful. It's just that, you know, the question here is they're allowing one particular dose combination and not, so which is what is baffling, right? And in any case, these combinations are only for convenience, sir. They are never ideal. All these combinations, most of them will have an insulin secretagogue and will have a sensitizer. So, you know, all our traditional learning was use this before, use the other one after. But when it comes to combinations, it is purely based for compliance and improving adherence.
So this is to highlight the fact that the phenofibrate and this thing, niacin. Sir, regarding this lipoprotein.
I didn't get that.
Wonderful, wonderful. Actually, very happy to see the message that the niacin 1 gram per day for 1 year. Patient, actually cluster of patients, or group of patients, the family, they came with the lipoprotein of more than 100, all 3 patients. you started on the niacin for 1 gram. They came after only 1 year. They are in abroad. Then all this from 100, it came to 35. I was very surprised. First time seeing from 100 to 35 lipoprotein. But so that's what the point also mentioned by you. So I was really glad to share this information.
Actually, we have used niacin when I was doing my MBBS. We used to use it a lot at that time. And it is actually a very cheap and a very good drug. The only problem is in certain class of patients, because of flushing and palpitations, and some of them had loose motions, people, for keeping commercially the patient happy, you end up stopping the drug because some people can't tolerate it.
Yes,
but
fine.
actually, I feel it is a very good drug, very cheap, very effective, and very powerful. But side effects are there. Very robust, but side effects are there. Many people can't tolerate it.
Thank you, sir.
Thank you very much, sir. No other questions, we will go for the next session. Thank you.
Thank you, sir. Thank you, Chairperson. Now we will move on to the next session. I would request Dr. Krishnan Setti and Dr. Syed Sultan Ibrahim to take over the next session, please.
Good evening, everyone. At the outset, I thank Dr. Balamurugan and his team for giving me this opportunity, and I congratulate them for excellently organizing this TRAC program. The topic to be discussed now is first new generation insulins, scientific breakthrough beyond human insulins. As we know, by Speaker Dr. Suresh Prabhu, as we know, the insulin remains the drug of choice for the past 100 years, since its discovery 100 years ago. Major milestones in the journey of insulin therapy that include animal insulin to NPH insulin, then moving from animal to human recombinant insulin, and now analog insulins. But efficacy-wise, both analog and human insulins are same, but the difference lies in the lesser incidence of hypoglycemia and better safety and better flexibility in timing and dosing. In current clinical practice, even though the analog insulins, their usage is increased, but still lot of patients are still using only human insulin, probably because of cost factor, especially among poor and middle class, who form the majority of our diabetic population. So with this introduction, over to the speaker.
Thank you. At the outset, I thank the organizing team of this chapter and also respected chairpersons. And the next 15 minutes, I'll be discussing about the newer insulins. It's not newer, they're already there for almost 10 years. This is my financial disclosure. So as our chairperson explained, almost 100 years back, we know that when the insulin was discovered, we have to give at least 5 to 6 times per a person, and then we need to have a glycemic control. But for every 2 to 3 decades, we have a shift or paradigm shift in terms of the glycemic control and insulin discovery. So in 1936, the NPH was introduced. We know that NPH is a neutral protamine hegeron, which makes the insulin as a long-acting. And then in 1950s, we have a pure or monocombinant form of animal insulin was introduced. And then in 1980s, the human insulin has been included. And after that, we have what we call it as a second generation designer form of insulin, where we have ultra short acting and also long acting insulin. I still remember during my college days in 1990s, we used to have the animal insulin, and there is a sudden shift in the government policy to procure human insulin. So animal insulin, they fare well, but they have higher immunogenicity, and because they are sourced from animal, it has limited availability, and it has some impurities. In some patients, we have seen autoimmunity and also the hypertrophy that happens in our patients. So as in 1980s and 90s, the human insulin has been introduced. We found the production of this insulin can be scaled enormously because of the recombinant technology, and they have lesser immunogenicity. The conventional insulin, we know that we have three types of insulin. One, the short acting, the intermediate acting, and the premixed insulin. The premixed insulin is, as the discussion happened later, like the metformin and the voglibose, it is for convenience. It's not physiological. It's pure convenience we use this insulin, but it is the most commonly used insulin in our clinical practice. The conventional insulin, as the chairperson has mentioned, it has its own inconvenience, even though they are human insulin, because after getting injected in the subcutaneous tissue, they causes the hexamer formation, and then the peak is not related to the peak of the glycemic control. The peak happens almost a hour or at the time of the glucose peak, around 2 to 3 hours the peak happens. So that what happens, the insulin will be there when the glucose is started going down. We get hypoglycemia probably 3 to 4 hours after giving that insulin. So I still remember when I was doing my the post-graduation and super specialty, the first thing we write in the patient thing will be the 3 meal and 3 snack pattern. So in the meal means we have to give 3 meal and 3 snack to overcome the hypoglycemia that happens with this form of insulin. You remember insulin 30-70 given at night 8 o'clock or 9 o'clock, it peaks at around 3 o'clock, and then it causes hypoglycemia. So we need to bring down the hypoglycemia to give a late night snack in our patient. And there are certain changes. One thing, we need to change the lifestyle according to the insulin. So we have to carry the insulin, we need to change the diet pattern, and also we should concern about hypoglycemia, and every time after injecting we have to wait for 20 to 30 minutes before having our meal. So this restricts our activity. When you go for a marriage, we have to wait and then inject and then go and wait, so we cannot have it. When we take that one, that actually changes the glycemic variability in our patients. So my agenda will be, I'll be discussing about 2 newer insulins, one the IDEC ASP, and second will be the long-acting second generation Tresiba. So this is a conventional patient what we come across in your clinical practice. It's a 54-year-old patient, BMI of 24, diabetes for 11 years, on 3 drugs and a premixed insulin. In spite of that, this patient HbA1c is 10.3, postprandial is very high, 286, fasting is also high, frequent episodes of hyperglycemia, and lack of quality of life. So how to approach this patient? So what is the co-formulations available? We have 3 co-formulations, one low mix and high risk. Low mix will be 25 or 30-70, or high mix will be 50-50. So we have both basic insulin, which is mixed hard, biphasic analog insulin, the Novomix and Humalog mix, and also the degludec aspart. So degludec aspart is I'm going to discuss. The degludec component is a long-acting component. It acts more than 24 hours, and the soluble part of insulin acts for a shorter duration of action. The conventional insulin has its own, premixed insulin has its own limitation. Because of the absorption, it has variable glycemic control. You need to resuspend, and it has a shoulder effect. That's what I mentioned. When the peak of the one insulin happens, the peak of the other insulin also happens, leading to the shoulder effect that causes hypoglycemia prior to the meal. So that is more common with this premixed insulin. So what is the ultra long-acting co-formulation, the IDEC as per Rysodec? So the Rysodec contains two separate molecules of insulin. One is Degludec, 70%, and short-acting insulin 30%. The Degludec is present in the dihexamer. Two hexamers are attached, and the short-acting aspart is present as a monohexamer. So what happens when we inject into the subcutaneous tissue? The IDEC hexamer and the IDEC aspart is actually separated, and because the subcutaneous tissues, the aspart actually immediately dissolves and enters into the circulation, and because the IDEC dimers have a single side chain, it forms a long multi-hexamer, and it releases slowly because of the resorption of the phenol. So there are several studies has been done, a non-inferiority study, and the common is switch 1 and switch 2 trial done in type 1 and type 2 diabetes patient. In that, the outcome is they are not inferior to the glargine U100, and also they have increased safety things in terms of hypoglycemia, particularly nocturnal hypoglycemia in our patients. So even though the glycemic controls are almost same, but it is better in terms of hypoglycemia in our patient. And this is switch from the older premix insulin to Rysodec. This was published in 2014, and if you see patients who are on premix insulin, when they convert to Rysodec, what happens? It's the HbA1c after 6 months from 7.8, a further reduction to 7.1, which is statistically significant. Fasting blood sugar of 7.9 to 6.9 millimoles per liter, it is statistically significant, and postprandial from 10.3 to 8.9. So all the three parameters are better after changing on from the premixed insulin to Rysodec. And if you see, the dosage also reduced after 6 months from 5.7 unit per kg, the dosage have come down to 0.49 unit per kg, which is also statistically significant. So this, the dose reduction in Degludec component of Rysodec, in this trial, they have given the Degludec and the aspart as a separately. So what has they found? The dose at 3 months and dose at 6 months, there is a reduction in the dosage of Degludec component by 21%, and after 6 months, the Degludec component is reduced by 19%. So on the safety profile, as we already discussed, there is a 54% reduction in the confirmed hyperglycemia, and also 75% reduction in the nocturnal hyperglycemia compared to the biphasic aspart 30. So this is very much important when a patient, elderly patient who have higher risk of hyperglycemia, or patient who have other risk factors like cardiovascular disease, when the hyperglycemia is important, there is almost more than 50% reduction in the hyperglycemia that happens with this combination. So switch from Rysodec to older premixed insulin have improved the efficacy in terms of glycemic control, lower dosal requirement, lower injection frequency, and also improved safety. That's what I feel is more important in our patients, in our high-risk patients. So move on to the second case scenario. I have another 4 minutes. This is a 54-year-old patient, businessman, BMI of 24, type 2 diabetes mellitus of 11 years, 3 drugs, and Rysodec of 10 unit. This patient, the first patient, what we see, the HbA1c was achieved without hyperglycemic episode, and patient have a very good quality of life. So moving on to the second case, this is our second patient, Ramesh, 55-year-old, teacher by occupation, BMI of 23, diabetes for 7 years, fasting of 182, postprandial of 208, HbA1c of 9.8. Patient is on 3 drugs including pioglitazone and a basal insulin of NPH, faces difficulty in injecting insulin at fixed time of day, and CGM report shows high variability. So problem with the NPH insulin is, even though they are long-acting insulin, they still have a peak at around 6 to 8 hours, and then it lasts for around 12 hours. So that causes increased risk of hyperglycemia in those type of patients. We know that basal insulin are the preferred insulin at the onset of insulin initiation in our patients. Almost all of them, the guidelines have recommended the basal insulin. Ideal basal insulin should have a flat glycemic profile, long duration of action, minimal variability, and low risk of hyperglycemia. So this is what the parts of the NPH insulin. The initial NPH insulin have half-life of 5 to 10, and then the first generation U100 glargine have half-life of 12 to 19, and then the second generation insulin have a duration of 25. So the unmet needs with conventional first generation analog insulin, they are not truly 24 hours, sometimes it lasts only for 22 hours. They have a higher variability, fixed time dosing, it has to be given at the specific time and not truly peakless. So this is the action profile of the Tresiba. And then if you see the glargine, even though they don't have they are long acting, they still peaks at certain time of the day to causes sometimes hyperglycemia in our patient. And the precipitation is the way how glargine acts, because of the pH difference between the insulin, which is 4 pH, compared to the neutral pH of the subcutaneous tissue, it gets precipitated and then it gets dissolved slowly and enters into circulation. If there is any change in the pH of the patients, like in patient, sick patient, there may be some difference in the absorption of this drug. And this is the efficacy of Tresiba versus glargine U100. The Switch Pro trial is a latest trial in terms of the comparison of the glargine with Tresiba, and they have included the CGMS in this trial, and they found that patient in the Switch Pro trial have a better outcome in terms of the glycemic control in that trial. Several trial, the once long flex, low volume, T1 flex and switch trial done in both type 1 and type 2 diabetes patients have clearly shown that apart from reducing the nocturnal hypoglycemia, there is a better fasting glycemic control in Tresiba compared to that of the glargine U100. So this is Switch Pro what I discussed. This patient, when a CGMS was done, the estimated time in range was slightly higher in the Tresiba group of around 20.6 minutes per day in favor of the Tresiba over glargine. So more number of patients have attained the glycemic control within the time in range in patient who on Tresiba compared to the glargine. And the Tresiba overall trial, so this is include not only that trial, overall the real world study and other trial have shown that it is better in terms of hypoglycemia. The overall hypoglycemia is reduced by 30% in the Switch 2, severe hypoglycemia by 51%, and nocturnal hypoglycemia by 53%. So consistent proven hypoglycemic benefit with Tresiba has been shown, and then it has a dosing flexibility. Even when we miss the morning dose of Tresiba, we can give it in the afternoon, sometimes in the evening also we can give, because of its very long duration of action. And it is approved in almost all the conditions like pediatric, adults, renal, elderly and hospitalized patient. And when we start, we can switch over from the naive GLP-1 receptor agonist to Tresiba at 10 units recommended as initial dosage. When the patient is already on basal insulin, we can convert to 1:1 basal component to the premix. We can 1:1 we can convert. When the patient is on glargine or basal BID, we can reduce the dosage by 20 units because it is slightly better in terms of glycemic control. Now the patient themselves can have the insulin dosage done by this app which is available. So this patient, after starting insulin, they have a better glycemic control over a period of time and have control over the injection timings because of the timing variation that can happen. So this is my summary. The Ryzodec and Tresiba are designer insulin, and then they are analog insulin. They have a greater HbA1c reduction and target achievement, low risk of overall nocturnal hypoglycemia, lesser glycemic variability, and wider window of dose flexibility, and improved quality of life in our patient. So with the newer generation of insulin, it improved the pharmacokinetic and dynamics, improved quality of life, low risk of hyperglycemia, less injection press, and also more predictable effect in terms of glycemic control. Thank you.
Thank you, Dr. Suresh Prabhu, for your practical information. I now call on the next speaker, Dr. Vidya Raju. She will be talking on semaglutide, 2.4 milligrams, stepping into the realms of high efficacy obesity medications. Over to Dr. Vidya.
A very good evening to everyone. It's an honor to be invited here to give a talk on semaglutide, 2.4 milligram. I'm grateful to be in an era where we have options for managing obesity with anything apart from just lifestyle modification. So I'll be discussing the evidence we have for semaglutide in the management of obesity. This is my financial disclosure. This talk has been supported by Novo. I do not have any conflict of interest. Most of the time, our patients are losing a battle with weight management, and almost all the time, we judge our patients telling them, you're probably not eating the right kind of food, you're probably not exercising enough, and probably you should try harder. But obesity itself is not as simple as you eat less, you lose weight. It's much more complex. There are more than 100 different genetic polymorphisms that have been described that define how big a person will be. And apart from that, there are several centers in the brain, the hypothalamus, arcuate nucleus, and tractus solitarius, so many centers in the brain that control our appetite and satiety. But more than that, we have several hormones as well, not just the leptin and the ghrelin, but there are other hormones like agouti-related protein, neuropeptide Y. All these hormones and the neurohormonal pathways are all linked, and they send signal to the different parts of the brain, and that makes a person crave for food or to stop eating. So it's not as simple as telling the patient, go and change your lifestyle and you will lose weight. We need to be aware of the various pathophysiologies that involve obesity, and then try and tailor the treatment to our patients. So introducing Wegovy, that is a semaglutide 2.4. It's similar to the human GLP-1 analog. It works as a direct activation of the hypothalamus and also direct activation of the hindbrain. That is the nucleus tractus solitarius. So it works at parts of the brain where there is incomplete blood-brain barrier, and aims this molecule, what it does is that it increases the satiety, making your patient feel less hungry, but at the same time it does the hedonic regulation, reduces the food craving. So hedonic regulation is that where you feel like eating a pizza and then you end up eating a pizza, or you want to eat biryani and then you end up eating biryani, that is eating for pleasure. So that part of the brain that craves for certain kind of food, that part of the brain is again targeted by the GLP-1 receptor agonist. So it acts both at the homeostatic centers of the brain and also the hedonic centers of the brain. There are several trials looking into the semaglutide in weight management. We are aware of the pioneer trials that looked into the oral semaglutide, and also the sustained trials that looked into semaglutide 1 milligram in patients with diabetes. But what I'm going to be focusing on is the STEP trials that looked into management of patients with obesity without diabetes. So the patient profiles were almost similar in all these STEP 1 to select trials, is that patients were not diabetic, they were just obese with one or more comorbidities, and these patients were selected and randomized to receive placebo or semaglutide, starting at a smaller dose of 0.25, and they were gradually titrated up to 2.4. More than 3,500 participants were from India. So that is something we should make note of, is that Indians also were part of this trial. So step 1 is the patients with overweight or obesity, and nearly 2,000 patients were enrolled in this trial. Male and female more than 18 years of age, but what is interesting is that nearly 76% of the people who were enrolled into the trial were women. Their BMI is more than 30 or more than 27 with more than one comorbidity. They should have had a stable body weight for more than 90 days, and their HbA1c should be less than 6.5. So they could be pre-diabetic, but not diabetes, and if they develop diabetes during the trial, then they get treated with standard care. So they compared the effect of semaglutide 2.4 milligram with placebo, and the trial objective was look into the body weight, also the cardiovascular risk factors, the glucose metabolism and other factors related to body weight. And also they looked into the safety and tolerability of semaglutide 2.4 milligram versus placebo. So primary endpoint was to look at the percentage of weight loss and 5% responders, and also to look at the confirmatory secondary endpoints of what percentage had 10% or 15% weight loss. And also they looked into the waist circumference, the blood pressure drop, and also of the physical functioning quality of care questionnaires as well, based on the quality of care questionnaires. So what they found is that the placebo group at the end of 68 weeks, they lost only 2.4% of their weight, while the semaglutide group lost 16.9% at the end of 68 weeks. So the participants experienced significant weight loss with Wegovy compared to lifestyle intervention alone. So all these patients, we should remember, who were enrolled into the semaglutide trial continued to be on lifestyle intervention. Semaglutide does not work on its own. Most patients think that you go on this weight loss medication and then automatically you should lose weight. That is not the case. Lifestyle intervention should continue in parallel with the weight loss drug. So in that case, in clinical trials, there's nearly 17% reduction from week 0 to week 68 on the semaglutide group. And when we look into what percentage responded to weight loss, nearly 92% lost 5% weight. More than 10% lost 75% of weight. So 3/4 of our patients lost more than 10%, which is enough to reverse a lot of comorbidities. More than 50% lost more than 15%, and more than 1/3 lost more than 20% of weight. So that's a significant weight loss in a significant percentage of our patients. So this weight loss should be in combination with the lifestyle intervention, which, as defined by this clinical trial, is 500 kilocalorie deficit per day and 150 hours of moderate intensity exercise per week. So what are the confirmatory secondary endpoints? The waist circumference decreased by at least 15 centimeter, systolic blood pressure by 7 and diastolic blood pressure by 3, the HbA1c reduced by 0.5%, and the physical functional score increased by 2.5, and the C-reactive protein, which is considered as a marker of inflammation, reduced by 58%. So there were other markers apart from just weight loss that they found beneficial in this trial. Step 4 is to look into the effect of maintained Wegovy versus treatment withdrawal. So what happens to these patients when the treatment is withdrawn after a certain period of time? So these patients had a run-in period of nearly 20 weeks, where the dose was titrated from 0.25 milligram to 2.4 milligram, which is the maximum tolerated dose or the maximum available dose. And those patients who were able to tolerate 2.4 milligram continued to be on the trial, and they were compared with the placebo. The inclusion criteria was similar to what was there in the step 1 trial, and also the baseline characteristics. Nearly 79% of these individuals who were enrolled in the trial were women. Usually women are underrepresented in these kind of clinical trials, or they're nearly half the percentage of women, but in these trials the predominant population were women. Mean age of 46, mean body weight of 107 kilogram, and the BMI was much higher, 38 kilogram. Mean waist circumference was 115. So the endpoint at week 68 was to look at change in body weight from week 20, that is when they go on the maximum dose of semaglutide, and also to look at change in waist circumference, systolic blood pressure and physical functioning score from week 20. So what they found is that patients who did not adhere to the semaglutide, they did not adhere to the weight loss strategy, gained weight nearly 7% from week 20 to 68, but patients who were on semaglutide continued to lose weight. and they lost about 18.2%, and the percentage weight loss was similar to the step 1 trial. Step 5 is to look for long-term maintenance on Wegovy, and again the study inclusion criteria was same. Nearly 304 participants with overweight or obesity were enrolled in the trial, and again 78% were women, and the baseline characteristics were almost similar, and they looked for change in body weight and more than 5% reduction in body weight, and the secondary endpoints were to look for more than 10% or more than 50% reduction in body weight, and the trial was conducted for 111 weeks. So the participants experienced sustained weight loss over 2 years with Wegovy. So it's not something that is temporary. So you continue Wegovy, and as long as you continue semaglutide 2.4 milligram, the weight loss will persist, and the weight loss was about 16.7% reduction, and that's at the end of 104 weeks. And again, this is the trial that showed that Wegovy, this weight loss is achieved and it can be maintained at the end of 4 years. So to summarize step 1, 4 and 5, looking into the safety profile, the most common adverse effect or the side effect the patients complained was GI side effect of nausea and diarrhea, but these could be managed symptomatically. The most symptoms were described in the step 5 trial, but step 4 nearly 40% experiences symptoms compared to 26% in the placebo. Not a lot of serious adverse effects. There's nearly less than 3% of pancreatitis and gallstones, cholelithiasis described, and adverse events leading to discontinuation was 7% in step 1 compared to 3.1% placebo. In step 4 it was only 2.4% compared to 2.2%, and in step 5 5.9% withdrawal adverse effects leading to discontinuation compared to 4.6%. SELECT is one of the largest cardiovascular outcome trials conducted in 41 countries, more than 800 sites and more than 17,000 participants, of which a small number from India participated in this cardiovascular outcome trial. And what they did was they selected patients who were obese with more than 27 of BMI, age over 45 years, and established cardiovascular disease, and there's no prior history of diabetes, but they could have pre-diabetes. The primary endpoint was to look for the first occurrence of composite endpoint consisting of CV death, non-fatal MI, and non-fatal stroke. They want to also look into the confirmatory secondary endpoints, time from randomization to the occurrence of CV death. Composite heart failure endpoints consisting of heart failure hospitalization, urgent heart failure visit, or CV death, and all-cause death. So they compared these patients, 1-to-1 randomization of nearly 17,000 patients. They compared Wegovy 2.4 with placebo along with the standard of care, which would be adequate medical treatment with for lipids, high blood pressure, antiplatelet therapy were indicated, and also glycemic control for those developing type 2 diabetes during the study. And also healthy lifestyle guideline including weight loss were appropriate, increase in physical activity, smoking cessation, and limiting alcohol consumption. And these were all suggested to all the centers who participated in the trial. What they found is that there is nearly 20% reduction in the risk of MACE. That is CV death, non-fatal MI, and non-fatal stroke. There was a significant reduction, and what we can see in this graph is that the reduction in risk was quite early on, even before they found significant weight loss. This could be because of the pleiotropic effect of the GLP-1 receptor agonist. Hence, the drive to consider GLP-1 receptor agonists like semaglutide with proven cardiovascular benefit in patients with obesity and increase in cardiovascular risk. The separation of MACE, as I said, was achieved before maximal weight loss was achieved, and 80% of the MACE risk reduction with Wegovy is mediated by factors other than body weight loss, and the MACE risk reduction was independent of the change in body weight. And the maximal weight loss was achieved by 14 months in this study. And Wegovy showed consistent beneficial effect across all CV outcomes that were measured, including the composite heart failure outcome. There was an 18% reduction and 15% reduction in the risk of CV death in the Wegovy group compared to the placebo. These are the other cardiovascular outcome trials for other anti-obesity medications in the past, and most of them have not been really successful, either because of increased CV risk like in sibutramine, the SCOUT trial in the early 2000. The Crescendo ribonomab stopped early as the drug was withdrawn. The naltrexone buprenorphine trial, the LIGHT trial was stopped because the interim data was leaked. The naltrexone buprenorphine trial, again the CONVENE trial, was stopped early because the drug ownership changed. With locazepine, the non-inferiority was demonstrated, but the drug was withdrawn because of excess cancer found in animal studies. So after that we have the SELECT, which looked into the semaglutide 2.4. This is the relative risk reduction compared to the non-users. The MACE3 reduction 43%, revised MACE3 57%, CV related mortality was 73%, and all-cause mortality was reduction by 86%. Summarize, Wegovy 2.4 mg is suitable for adult patients from a BMI of more than 27 in the presence of at least one weight-related comorbidity or more than 30 regardless of any comorbidity. From these clinical trials, we found that there is more than 20% weight loss seen in at least 1/3 of our patients, and nearly 50%, more than 50% loss, more than 15% of weight. Sustained weight loss was found in more than 4 years, and there was a 20% significant reduction in MACE. Thank you for coming here, and questions are welcome.
Thank you, Doctor, for your excellent presentation. Now, both sessions are for open discussion. Madam, one question to you. What about the oral semaglutide, madam? Is it available? Whether it is, because the side effects are, it seems side effects are lesser in oral semaglutide, especially the gallstones. Then what about diabetic retinopathy? That is slightly higher in that is injectable semaglutide than the oral semaglutide. What is your opinion?
Okay, diabetic retinopathy getting worse has been described in other GLP-1s as well, and mostly it is related to the rapid reduction in the blood glucose, but not a significant difference found in the latest trials. But this has been described before even semaglutide or or any the latest GLP-1 molecules. But I don't think so. I've found a difference in Rybelsus, which is the oral semaglutide, and Wegovy, which is the injectable one. When it comes to side effects, GLP-1 as such are not really well tolerated if the patient does not take their food the way we ask them to take. They're supposed to take it in small quantities but more frequently. But most of our patients are used to dumping a lot of carbohydrates, and hence they get those symptoms of GI intolerance. But when we advise them to take in small quantities, they tolerate it better, and the GI intolerance like dyspepsia can be managed with antacids.
So, madam, still the practitioners are hesitating to use this GLP-1 receptor agonist in non-diabetic obese patients, fearing hypoglycemia. So, actually, the semaglutide can be used for non-diabetic also, isn't it, madam?
Yes, that is what this trial shows, that Wegovy can be used, and all these trials that I presented is non-diabetic obese patients. It can be used, but we'll have to select our patient and introduce the molecule. It's not for everyone. The patient has to be really, really well motivated to go on GLP-1 because they'll have to put up with the side effects to some extent.
Can it be used for a non-obese diabetic? A non-obese, a normal weight, normal BMI diabetic, can we use this GLP-1?
You can still use this molecule because the primary aim is not just weight management. It's got good cardiovascular outcome. So it has got, because of the pleiotropic effects, patients with high CV risk, this comes even before any other oral hypoglycemic agent. So that is what the AACE and ADA recommendation is. Even in a lean diabetic with high cardiovascular risk or established cardiovascular risk, you can still use the GLP-1.
The patient, how long we have to use? You said even if we discontinue, the benefit lasts for 4 years, then only. So the patients, when we suggest to the patients, they ask how long I have to take this drug, sir. What answer we can do?
No, this trial actually showed that the benefit was maintained as long as the patient was taking it. When you stop, the benefit is gone. They all gain the weight back.
So it's a lifelong one.
Yes.
Lucid presentation, both the presenters, your presentations are extremely good. Right. My question, it's a tricky one. Right. You have oral formulation, Ribelsis. So cardiac safety has been established with reference to Pioneer 6. Pioneer 6, cardiac safety of oral semaglutide. Next SOUL trial established the cardiovascular efficacy of Ribelsis. Right. We have Wegovy. So this SELECT trial clearly shows the benefit in terms of risk reduction of cardiovascular event much more greater than oral semaglutide. Okay. Now the question is, which patients you will prescribe Wegovy, to which patient you will prescribe Ribelsis?
That comes to discussing the options with the patient. If the patient prefers an injectable or doesn't mind going on an injectable, Wegovy. If the patient is happy to take an oral semaglutide and is compliant, because with the oral Ribelsis, the compliance is the main thing. They don't take it with the smallest amount of water, they don't keep it in empty stomach. But if the patient is able to adhere to all that and does not want an injectable, oral Ribelsis is still an option.
No, the patient has a BMI of 27 plus multiple risk factors. And you want to put the patient on Wegovy. But the cost is very high.
Yes.
Will you convince the patient to go for Wegovy?
Sir, in our Indian system where the patient has to pay from the pocket, we'll have to be very careful looking into the financial status of the patient. I don't want to lose a patient completely. I don't want to say go and take a molecule that's so expensive and the patient completely disappears from my radar. I want to make sure the patient is compliant with the medication that is useful. So when it comes to financial implications, of course Ribelsis is less expensive than Wegovy, but I'm hoping things will change and we'll have more affordable injectable semaglutide. So in that case we can go for the injectable. At the moment Ribelsis is less expensive and hence we can use Ribelsis in a patient who is conscious about the cost.
Actually, madam, I have a patient, BMI more than 30 with established cardiovascular disease. Patient has been already on some other brand. So I convince the patient in such a way that this particular drug will prevent the cardiovascular events. You are going to spend 17,000 rupees per month. On the other hand, if you develop one cardiovascular event, this will fetch you not less than 4 lakhs. Not less than 4 lakhs. The thing is, the benefit is real, so why don't you put? Patient accepted.
I would just like to add one thing to Dr. Shanmugavelu's comment, that convincing is not may not be the right word. So I think as a physician, we should be informing the patient that yes, you have this disease, there is a trial, there is a benefit, and if you take this, then these are the additional benefits. then we leave it to the patient's choice. If he is not affording, obviously we cannot push the patient to take the drug. But if he can afford, then obviously we know the benefit. So I think informing the patient is the right answer for this.
These drugs are known to cause muscle mass loss. Is it the loss of muscle fiber or intramuscular fat loss? What is your opinion?
I think there is loss of both visceral and muscle mass. But if the patient does not take enough protein, then there will be actually loss of the muscle mass itself, not just the fat. So whenever you encourage your patients to lose weight, the general idea is that they lose 2/3 of fat and 1/3 of muscle mass. So there are ongoing studies, I think by Dr. Nitin Kapoor at CMC Vellore and a few other centers looking exactly into what you are asking, looking into if it is just the fat or actually the muscle mass. There are ongoing studies to try and look into it.
One more ongoing study with semaglutide and monoclonal antibody, bimagrumab, that is combination. This will stimulate muscle protein synthesis, bimagrumab, prevent the muscle mass loss in a patient already on semaglutide. Because this trial, they are using 7.2 milligram of semaglutide, currently ongoing.
Yes, there are much higher, I think it's step-up trial, looking into much higher dose of semaglutide.
Any other question? If no further questions, we could conclude the session by thanking both the speakers and for having given me the opportunity to chair the session.
Thank you.
Thank you.
Thank you, speakers. Thank you, Chairperson. Now we will move on to the next session. Can I ask all the people who are standing behind to come and be seated, please, as we move on to the presidential oration. I'll hand over the mic to Srikanth, sir.
Good evening, ladies and gentlemen. The next program is the RSSDI State Chapter Chairman's oration. And to do the same, I request the following dignitaries to kindly be on the stage. Dr. G. Vijay Kumar, I request you, sir, to please go on to the stage. Dr. V. Rajendran, Dr. Muralidharan, Dr. Bhavatarani. May I, on behalf of everyone here, request Dr. V. Rajendran, the chairman of the organizing committee of TRAC 2025, to read out the citation, please.
Good evening, one and all. I think this is the second TRAC meeting where the chairman's oration is happening, and I was privileged to give the first oration. For TRAC 2025, the chairman oration is going to be given by Dr. G. Vijay Kumar. The Tamil Nadu chapter of RSSDA has the privilege of welcoming Dr. G. Vijay Kumar, the current chairman of Tamil Nadu chapter of RSSDA, to deliver the TRAC 2025 chairman's oration. Dr. Vijay Kumar is a distinguished diabetologist with over 4 decades of service in patient care, teaching, research, and professional leadership. He is a graduate of Sri Venkateshwara University, Tirupati. He specialized in diabetology at the University of Madras and further trained at the WHO Center, University of Zagreb. He is the founder and director of Diabetes Medicare Center in Chennai and serves at the Apollo Specialty Hospitals and St. Isabel's Hospital. He is renowned for his evidence-based, patient-focused approach. He has touched thousands of lives through compassionate and effective care. Dr. Vijay Kumar has held key positions in Diabetes India, the Diabetes Association of India, the Research Society for Study of Diabetes in India, and the International Diabetes Federation. He has organized major scientific events including the World Congress of Diabetes India 2015 and the RSSDA Golden Jubilee celebration in 2022 and continues to lead high-quality CME programs and workshops. His academic contributions as faculty from WHO, WDF projects, member of the Senate at the Tamil Nadu Dr. NGR Medical University, and joint editor of the Asian Journal of Diabetology, have advanced diabetes education across the country. Among his many honors are the Best Doctor Award from Tamil Nadu Dr. MGR Medical University, the Blue Ring Award from the International Diabetes Federation, the Ugadi Puraskar, the Sudigali Award, and several prestigious orations. In recognition of his exemplary leadership, lifelong dedication to the advancement of diabetology, and his outstanding contributions to patient care, research, education, and professional service, the Tamil Nadu chapter of RSSDA is privileged to confer upon Dr. G. Vijay Kumar the Chairman's Oration at TRAC 2025 with deep respect, sincere appreciation, and warm congratulations.
May we request the speaker, the oration speaker, Dr. Vijay Kumar, to kindly come to the center of the stage. May we request the other dignitaries also to join. And may we request Dr. Balamurugan, the Secretary of the Organizing Committee of TRAC 2025, to adorn the doctor with a shawl. The speaker. May we request Dr. Bavadarni to kindly adorn him with the medal. And may we request Dr. C. Muralidharan to give the memento. The citation will now be handed over by Dr. Rajendran. Thank you, Doctor. Over to the oration lecture.
Good evening. I'm really overwhelmed with the honors that I got. I was never expecting this to happen to me. Thank you, my colleagues in Tamil Nadu chapter of RSSDA. And it's more than honor, it's more of an affection and recognition. And I'd like to say one thing about the RSSDA Tamil Nadu chapter is that when it comes to matter, all of us are together. And that's the biggest quality that we have amongst our diabetologists, physicians, and endocrinologists, whoever it may be, a part and parcel of Tamil Nadu RSSDA. I'm very happy to be with here actually. Now, I also, at the outset, I would like to congratulate our organizing secretary of the conference, Dr. Balamurugan, and Chairman Dr. Rajendran for effectively and extremely good conference today. And I know how difficult it is to make a meeting, definitely. And I would like to also thank especially Dr. Shanmugavelu, Dr. Balaji, and Dr. Muralidharan for pushing me to become a chairman. And it so happened it's unanimously elected. That indicates that the love and affection that everybody has got for me. And I would like to thank for everything. Now, as far as the oration is concerned, I thought diabetes in India, challenges and solutions. Whatever I faced during my 37 years of practice in diabetes. So, but there are challenges are too many, but the solutions are not easy to implement. That's what we face in our day-to-day practice in diabetology. Now, the worst challenge that we are going to have is that the Indian scenario for diabetes, we have 10 crore diabetics and then about 13 crore pre-diabetic patients. So total about 23 crore people with dysglycemia. That is the ICMR INDAP study is created. But look at this, the mean HbA1c of all our people with diabetes is 8.9 and only 1/3 of our patients are having a good control of less than 7 and 2/3 are yet to be under control. This is another interesting study by Dr. Ramchandran et al. What they have shown is that when somebody is found to be clinically diagnosed with overt diabetes, the HbA1c is about 9.1, and while before diagnosis it's overt diabetes diagnosis, when they are screened for diabetes, the HbA1c has been 8.3, indicating that the moment they have found to have diabetes does not mean that it's come overnight, and there is a long delay in diagnosing diabetes as well. So they had asymptomatic disease quite even before getting into that. That indicates that they more than almost 1 HbA1c indicates that probably we have to screen more and then detect them early, because you could see here in our diabetics there are so many 10 crore population with overt diabetes, but there are so many people who are undiagnosed with diabetes. I think screening plays a major role so that we can screen them early and diagnose them early, and so that we effectively treat them early. This is one challenge. What I also face is this is a unique way of looking into an Indian phenotype of a diabetic. We are different. Our diabetics are different compared to other populations. You could see that the Asian Indians tend to have earlier onset of diabetes, at least what it is said to be that at least 1 decade early compared to other races. And then you can see there is longer duration of diabetes and lower BMI with a high waist circumference and high fat percentage. And they're totally different. The same BMI, what we have the fat is something a lot, especially the waist circumference, and ectopic fat and visceral fat is very, very high. And also we have a problem of higher triglyceride, higher HbA1c and a lower HDL when compared to the Europeans and others. So we are a unique population of diabetes, and I think that is the reason it's a big challenge that we have to follow so many guidelines, but that's not sufficient. We need to adjust these guidelines whatever we learn, say from RSSDI guideline, recommendations or ADA, whatever it is, whatever you follow, IDF, whatever you follow. But they need to be adjusted to our type of population, and that's a big challenge that we have to think about. And then another study which has come is that according to the Lipid Association of India criteria, it is said that the 40% of the people are classified as high risk and 60% are classified as very, very high risk. So you could see that almost nobody is non-risk patient, and that is to be kept in mind. The reason is that there's no such thing called mild diabetes or severe diabetes, like something like a pregnancy. There's no mild pregnancy or severe pregnancy. Similar, diabetes is diabetes, and we need to look into that. And I think people should also understand that every patient is a high-risk patient, and we need to take care of them holistically. Now, this is what happened when a long time ago, Hafner et al. Said that mere presence of diabetes is equal to cardiovascular disease. That's what he said about almost 3 decades ago. Now, there's another problem what we have. If you look into that MASLD, that fatty liver, worldwide incidence is 25%. Look at India, it's 38.5%. So it's almost 20% more than what we can think about. And then you can see that the most important thing is that pediatric age group of people, they're going to have a lot of fatty liver amongst them. And apart from this, we can see that the microvascular complication, the form of DKD, diabetic kidney disease, recently published site study, which I'm also part of it actually, we found that 35% of them have got pre-KD in our population. And then this is, the risk is associated with long duration of diabetes, higher HbA1c, male and non-vegetarians. This is what we found in that site study. And indicating again that we should not, we need to control diabetes as soon as possible so that we can reduce the incidence of DKD as well. And this is another problem. Apart from microvascular complications, the challenge that we have is that 1/3 of our population in type 2 diabetes have got symptomatic cardiovascular disease, and we investigate, there is another 1/3 of the people who found to be having asymptomatic heart disease. So it looks like that about 2/3 of our population are having either symptomatic or asymptomatic cardiovascular disease, and this is again a big challenge that we need to face. And then why I'm trying to say is that it is very essential for us to look into these aspects, and so that what we can do is that we can design our treatments towards that, reducing that. And no doubt why the Ministry of Health and Family Welfare have committed that we need to reduce as much as possible the deaths that can happen with NCDs, that is non-communicable diseases, because nowadays the infection rates have come down, and all the other things have come down, but NCDs are increasing. And we'll find out why this is happening. NCDs are increasing, and then why we need to look into reduction. This is not a small challenge, it's a big challenge again. If you look at the solutions, probably for all the microvascular complications and macrovascular complications that can happen, what we need to have is a holistic approach towards diabetes. It's not just enough to have a good just control of diabetes. Only the best control of diabetes and control of lipids and hypertension should be there. And most important thing is emphasis on lifestyle modifications, which we usually our patients doesn't do. And then awareness amongst our patients and healthcare professionals about all the problems that we are facing and the solutions that we can give. And then regular follow by the patient. We need to educate them at least once in 3 to 4 months at a come. This is again, if you can do that, if you can assure that they are coming for follow, we can do a lot of things for them, because we know that diabetes is a progressively deteriorating disease, and then we have to change our strategies over the time, each time they come. And that is the reason we should be ensure that, because they may be asymptomatic, but that is the reason they may not come back to follow. But we need to ensure that we have to have a regular follow. Screening of diabetes, and also screening to detect early the complications and try to reverse, especially microvascular complications, reverse or slowing the progression of the complications is a big duty that we have to have. And in that way, I think mortality, morbidity will come down. And most important is, where in India we are a pocket-friendly nation, and then for all these things that we need to have, we need to select a cost-effective therapies so that patients will adhere to the disease, to your prescription. In that way, I think the idea of global type 2 diabetes clinical practice recommendation just recently, but a few months ago, which has come down, that very clearly said that there is a division between optimal care and basic care. Optimal care is best therapy that is available when cost is not an issue. And basic care is the one where we can see that we need to select the drug so that the cost will also come down. Now, for example, apart from that, we can see that we can go for metformin and SGLT inhibitors and DPP-4 inhibitors, which are now quite economical in our country, thanks to that. And then we are in the best phase, best period, where we got therapies for even complications reversal as well, and at a affordable cost. And that is what is the best thing that is happening. Now, look into that, the people who have got no complications or low cardiorenal risk, and with cardiorenal risk, we can see that in optimal care, we have an expensive drug such as the GLP-1 receptor analogs, and we have even SGLT inhibitors, whereas if both for renal disease and cardiovascular disease. And then if in basic care, we can go for metformin, and SGLT inhibitors will do the job. It's indicating that we don't need to go only for most expensive therapies. If they can afford, they can do that, optimal care. But for the basic care, if you look into that, we have options as a low cost therapies that are available at metformin and SGLT inhibitor. Now, never, whatever therapies that you use, you need to have lifestyle modification. And all persons with type 2 diabetes, they have to do at least about half an hour walking or do some exercise. And the most important thing is that it's not an easy implementation, but we can see that it is a 5 to 10% reduction in body weight, will enhance the quality of life, reduce all-cause mortality, and lower rates of hospitalization, reduce healthcare costs. So this is what we need to aim. This is one of the solutions that we can think about. And even RSSD recommendations, if you look into that, I recommend all of you to go to the website, RSSDA Clinical, to the RSSDA, and look into the RSSDA Clinical Practice Recommendations and Management, which is being updated this year. And this is from 2022. You could see that recommendation says that moderate calorie restriction and also having a good exercise pattern every day, and then change the dietary composition for low calorie diet, combination of aerobic and resistance training exercise. Now, why resistance exercise is because as they grow older in diabetes, there is a sarcopenia that can happen, so that we need to replace it with more protein and do some resistance apart from aerobic exercise, and change in behavioral pattern. Now this is not just that. And what we have to see, that we should have also suggest them to have a good sleep, because nowadays that sleep patterns are so bad. I think a lot of people say that the spouse will complain that she or he is seeing the mobile phone and what throughout the night, and he says that I am not able to get sleep, that's why I am seeing. And the other person says that no, he's seeing, that's why he's not getting sleep. I think we need to look into the sleep pattern is very, very important. As I said, that strengthening exercise, extra protein is also a very good idea to do that. Just asking them to do exercise is not enough. A part of it, they should have some resistance exercise itself. Now, what is happening in our country? This is a landmark trial which they followed for 3 years. I am just talking about, this is part of the all over the country, but I am just limiting to the South India, where about 135 sites, that includes Bangalore, Chennai, Coimbatore, Hyderabad, Kerala, Vijayawada, and about 2,354 participants, and they just followed it up with the standard care. HbA1c has come down from 8.1 to 7.5 in 3 years, and blood sugars come down both fasting and postprandial, but still wanting. So I think it also says that we need to do more to get a better control of diabetes. There is some improvement, there is no doubt about that. Now, why is this happening? This issue is happening mainly because we are not able to come under control. And if you remember that I said that the average HbA1c is 8.9 in our country. And what you can see that basically what we need to look into this is that instead of going for stepwise therapy, you need to be proactive and start the combination therapy, appropriate combination therapy from the beginning, so that we can achieve better diabetes control, and which has been a big challenge so far. This is only simple thing. It's a very simple thing. Go for a combination therapy, appropriate combination therapy, so that we get a better control of diabetes as well. And don't hesitate to start insulin when you are unable to control diabetes with three molecules. So this is another thing that is happening. There is definitely the intensification of both oral drugs and as well as insulin is not there. It is said that about insulin therapy started more than 7 years delayed, until the HbA1c is more than 9, and which you should not do that. And I think these are the things that as healthcare professionals need to adopt as a solution to have challenges that we are facing. Now the next challenge that we are facing, the future, is going to be the obesity. You can see that obesity is now a global epidemic, and it's an obesity crisis, and then we are not far away from other countries. And if you can see that the National Family Health Survey, within 4 years, you could see that there is an increase from the overweight and obesity amongst women from 20% to 24%, and in men from 19% to 23%. So there is about 4% increase in just 4 years. And apart from that, it's a big problem that we are facing is that abdominal obesity. 40% of the women and 12% of the men are abdominal obese in our country. This is typical Indian phenotype. And 49% of the women in age group of 30 to 39 and 56% of the women in the age group of 40 and 49 and cross a cut-off mark, and their BMI is not very bad at all. Just 23, but abdominal obesity is very, very high. This is an Indian survey. Now look into the state-wise that you could see that Tamil Nadu is leading for obesity and overweight, and along with Punjab and Pondicherry and Andhra Pradesh. These are the states as of now who are having the maximum obesity. And what I would like to see is that those states which had the least obesity in about 9 years back, like Orissa, and then if you can see that the northeastern states, you could see that the phenomenal increase is being there for obesity and overweight. You could see that. The reason is that the penalty you pay for development and industrialization. Okay. So it looks like that. In fact, Tamil Nadu and Andhra Pradesh and Pondicherry and Punjab advent, but it is also increasing from 36 to 44 today. And this is not, but this is a data about 4 years ago. I think this is the big challenge that we are going to face, and then we need to look into that. And then you can see that the expenses, the moment you have overweight and obesity, the expenses, there is a significant increase in Medicare expenditure. And then look into the GDP, we are spending about 0.8% of the GDP in India towards medicine, and then it is supposed to increase to 2.42% in shortly with the obesity and the overweight trend is going up like what we've seen. But look at this, and if you have any effort that you give to reduce the healthcare costs, you can see that the healthcare also will come down. Now, another problem what we are facing is that apart from having the elderly people who are not that obese or overweight, but the young generation, the younger people and also the adolescents are having a huge amount of increase in overweight, and this is what even the National Family Health Survey says. So there is a call for action. We need to implement school-based interventions, promote active lifestyles, target awareness and awareness campaigns. In fact, it's very dangerous to know that the obesity amongst the children less than 5 years was just 0.5 about 6 years ago. Today it's 3%. So this is about 6 times increase in obesity amongst even children less than 5 years. And this is what in the future is going to be more bleak unless we take care. Now, what are the recommendations that we can have to look into this is that the multi-sectorial collaboration of urban health planning and parent and environment. Now this is one example for adolescents especially. Then what we can do if we can educate them to do more physical activity and reduce the calories and reduce the body weight, and this is a program which is done in Greek. What they have found is that they put them on Mediterranean. Mediterranean diet is nothing but less fat and all, but we don't need to observe that. We need to cut down calories and fat that have to be done, and increase the physical activity level, improve the sleeping hours. Look at this, improving the sleeping hours and sedentary activities, and there is a significant decrease in the total and central obesity in both genders in adolescents. This is what we can do for that. So we have to go for all these things actually. So I think this is most important thing is that our children and grandchildren should know about that, and we need to implement these issues in the beginning itself. Otherwise they'll be landing up at a very early age of into diabetes and other comorbid conditions. Now, I was involved in a community service itself, and I would like to spend 2 or 3 minutes on this because what is it we can do at a community level? And it is possible, and I'm not trying to say that you don't go for community service, but at least part of your time if you can spend for community service, I think we'll be doing a lot of good for our society. And I worked at VHS Medical, that is Voluntary Health Services Diabetes Department for almost 20 years, more than 25 years I spent with legendary Dr. C.V. Krishnaswamy as the head of it. And we used to take care of about 800 children like type 1 diabetes. And then we have seen the improvement. We used to give free medication, insulins, and probably the first institute to give insulin in our country for children with diabetes, type 1 diabetes, and then we have created several welfare schemes for them actually, so giving soft loans to them so that they can stand on their lines. And we have seen a very, very great reduction in morbidity and mortality. But it's also seen that there are so many social aspects. I think in spite of giving so much of support to these type 1 children, when we looked into the mortality, the first cause for mortality has been infections in those days. I'm talking about 25 years ago. And then the second common is suicides. You know whom? Only girls, not men. The problem with this is that social problem is that the parents want to push the girl with type 1 diabetes away from home and concealing the fact that they have type 1 diabetes, and they get married and then they go into marital disharmony and then take an extreme step. This is in spite of you supporting it. This is the fact of life. So that is one thing that we have learned, that and institutionally a service to the type 1 diabetes is a very, very important thing to prevent complications of for the young children who are suffering from type 1 diabetes. And I'm also involved about the last 12 years or so. I was with, started a free diabetes clinic every Tuesday, and we see about 300 patients with the help of some of our friends, like Dr. Kannan, Dr. Sellapandi, and Dr. R.P. Rajesh, and Mohan, and also late Dr. M. Chalamariappan. He passed away about a month ago. So we used to have, and then it is very heartening. In fact, we give free medications for the whole. In fact, we have started giving for 2 months, who's under very good control. So we are able to give that, and we are able to get the medications, including insulin, at a lower cost. So what I am trying to say is that if we can spend some extra time, we can do so many good, especially for the poor people who are unable to afford even the small amount of money that they have to save for food, and one family member with the earning person, so many people to feed and give house rent and all. See, the medical expenses are really, and they are discontinuing the prescription, so they are going into ill health. So we were able to manage that, and then we were able to see a lot of difference in that. So I think as a community service, I think we can do something. That's what I had an opportunity to do that, and I was able to do that and do something to the community. Now my wonderful experience with RSSDI, excellent team in RSSDI Tamil Nadu chapter, members, and those people are not members, but still they are as good as any member in our Tamil Nadu. There's so many people, and good cooperation from the national committee has always been there. And then it culminated into a very good meeting in 2022, Golden Jubilee RSSDA, what we did in Chennai, and then where I had an opportunity fortunate to have an opportunity to be an organizing secretary, along with chairperson with Dr. Anand Moses. So we are able to have a very good meeting there. About close to 4,000 delegates have attended for this meeting actually, and we were able to do. We were able to at least educate as many HCPs, so that they can go back and treat diabetes better. That's the main aim. All the CMEs are mainly intended to do that, and we thought we were able to do some good justice to that. So, and then you have seen so many challenges. So we thought of some solutions as well. So this year, as a chairman, I'm very happy that our committee has accepted to do some of the projects when I proposed it, and they said happily accepted that, and then we are going to do that. Now we have started a few already, and then we are about to start a few more. The things that we have looked into is the research, and especially the obesity, and Dr. Krishna Seshadri is going to take a lead in that and lead us, and then we will give a protocol, a simple Google form, and those who I invite everybody, all the who are assembled here also to participate. We will be coming back to you to do this, and then it's just a Google form, and then so that we'll know what exactly is happening in Tamil Nadu and what are the remedial actions that we can take. That is the basic idea that we look into that. And then there are prescription patterns which are entirely different, and we would like to know about the prescription patterns, what is happening, so that we have an idea how we can conduct CMEs so that the prescription patterns will also improve. And I think our president, our beloved president, Dr. Vijay Viswanathan, is taking a lead, and he'll coming out with how to do that. And then screening for GDM, this is done by, this will be done by Dr. Panil Selvam and Dr. Bavdarani, Dr. Shanmugam, and Dr. Chandrasekhar. And then implications of sleeping and screen time patterns, we are in the process of doing that. And these other three things we are already done, and then we are going to start. And then according to the instructions or requests from the Central RSSDI, now we are embarking shortly into rural outreach program. For this, Dr. Muralidharan and Dr. Bharani from Vellore and Muralidharan from Dindigal are taking care of this, and then we are going to implement it probably in the next few weeks. And then we would like to see that what we can do at the rural level so that we can do that. And of course, we are also thinking of patient outreach programs. That is, basically patient outreach program is that there are so much of, the confusion or misconceptions about diabetes and, the values and other things. So simple things that we want to do is that we would like to know what are the normal values, how many times you do the blood test, and so many things, what is the importance of follow-up, some small things, and we wanted to make posters and pamphlets, and then we like to put it in labs, we like to put it in hospitals, in private clinics, and in pharmacies as well, so that people will look into that, and then they will come back to us. So one of the things that we have done is that one of these is ready, and then more to come, and then those who are interested can write to us or send to us. We will be able to, happy to give it to you, so that you can put it in your clinics and also the other places as well. So pamphlets and posters are being planned. It's already getting ready, and some more to come. And then also what we are planning is that we are trying to educate the parents. So we are proposing, we are going to start shortly, reaching to, we are going to go and address the parent-teacher meetings in schools and colleges. And this is the group of people who would like to educate, and then both the students and as well as the parents. So we thought we'll take a step towards that, and then we are going to educate them about healthy nutrition and importance of lifestyle modification. Also, there are plans, probably we can start a YouTube channel, and that also is in pipeline. We may be doing it. And as far as the academics is concerned, that is the CME programs for healthcare professionals. What we are planning is that as RSSDA names that Research Society Study of Diabetes in India, what we are trying to do is that we are trying to 4-hour program, which is being ready, getting ready. Krishna is going to do it for us, and along with Dr. Vijay Viswanathan. And then what we are trying to do is that research methodology for postgraduate young physicians, just a 4-hour program, so that they can do some work in their own clinics, the small clinics itself. So I think the contribution to that is going to be great. And also they will find out what is it they are able to do, that unless there is some information what they are doing is correct or not, so that they can improve the care further, and also contribute to what is happening in our state, and so that we can also take it forward. And then we also planning to do a district level CMEs, district level CME programs. And last year we have already done about 10 or 11 programs we have done last year at the district levels. So some of the committee members also will go there, and we take help of the local physicians, and so that we can educate people there. And at every district we are trying to do that. And this year we are going to increase the number to almost 40 or 50 meetings. That is our plan of doing it. So I'm sure that this is going to be, and no cost involved from the association also. We are everyone has been happy to do that on their own, and they will create their own finances to the meeting. That's on a half-a-day meeting, and so that simple things that we tell about the healthcare professionals, what to do, what not to do, and diagnosing early and screening for that, and all those things, small things we are going to tell them. And it's going to be very, very practical for a simple way of looking into that when they're trying to take care of the patients. we're not trying to, so that they can take diabetic patients better. So that's what our idea is. So now, as far as I am indebted to many people in the last 37 years of my practice, if at all I am here today, I owe my mentors, Professor Vishwanathan, has allowed me to learn diabetes. And then Dr. Ramachandran and Dr. Mohan have told me ABCDs. And these people are still supporting me in many ways, and I keep going along with them. And then legendary Dr. C.V. Krishnasamy, with whom after finishing my post-graduation I started my career with him. And then he has taught me what is life and how do we treat people, how do we be passionate to people and be courteous to people. Now we need to behave, everything, the philosophy, life, he has told me about that in practice, and owe a lot to him as well. And of course, along with me, both Dr. S. Venkatraman and Dr. Anand Moses took me as their own brother, younger brother, and then also helped me in stabilizing whatever I learned, and then they also taught me how to go about. And so that definitely, so my thanks to my mentors, my colleagues, RSSD Tamil Nadu chapter. It's not only, I'm not talking about only the committee members. We have people like Gauri Shankar is there, Anbu Chelvan is there, Raj is here, and so many people. N.S. Prasad is here, and so many people. They have been very, very, very cooperative. If I missed any names, it's not intentional, please pardon me. But what I'm trying to say is that I've been fortunate enough, and rather Tamil Nadu chapter is enough, is very fortunate enough that we have an excellent team here to do things. Only thing is we need to start and keep it rolling, and then it can go on. And my people with diabetes who trusted in me, I have to be very thankful to them, and of course my family. Thank you for your patience.
Thank you very much. May we all stand up and give him a lovely standing ovation for the wonderful chairman's oration. Thank you, Dr. Vijay Kumar.
As it's an oration, there are no questions. Would you like to take some questions? Okay.
Thank you, gentlemen. We're now moving on to the formal inauguration ceremony of this TRAC 2025. It was 5 minutes, we'll get the stage ready. Ladies and gentlemen, may I now have the privilege of requesting the following dignitaries to kindly come over to the stage for the formal inaugural session. First, we would request Dr. V. Rajendran, the Chairman of the Organizing Committee of TRAC 2025, followed by Dr. R. Balamurugan, Secretary of the Organizing Committee. The third would be the President of this evening, Professor Dr. Vijay Vishwanathan, National President, RSSDI. May I request you, Doctor? This will be followed by the chief guest of the evening, none other than Dr. Muruganathan. May I request you, Doctor? Doctor. And then Dr. M. Shanmugavelu, the Chairman of the Scientific Committee. Dr. G. Vijay Kumar, the Chairman of the Tamil Nadu chapter of RSSDI. Dr. N. Bavatarni, Secretary of the Tamil Nadu chapter. Dr. A. Shanmugam, the Treasurer. And Dr. R. Srinivasan, if he's here, Treasurer of the Organizing Committee. He'll probably be joining us in a short while. May I request the Secretary of the Tamil Nadu chapter, Dr. Bhavadarni, to adorn the Chairman's collar. Ladies and gentlemen, we begin the program with an auspicious prayer, Tamil Thai Vaalthu. May I request Dr. Bhavadarni to join us in singing it.
Check.
നീരാരും കടലുടുത്ത നിലമടന്റെ കെടിലൊഴുകും സീരാരും വദനമെന തിരപരത കണ്ടമിതിൽ തെക്കനമും അതിൽ സിറந்த ദ്രാവിഡ നൽ തിരുനാടും തക്ക സിறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை திறமியந்து செய்ய மறந்து வாழ்த்துதுமே
Thank you. We now have the symbolic lighting of the lamp. May I request the dignitaries to kindly join us for lighting the lamp. May I also request the presence of Srimati Vijayalakshmi Balamurugan and Dr. Usha to kindly come over to the lamp. Dr. Bhavadani, all of you, Doctor. Dr. Usha, please. Dr. Vijay Vishwanathan. Thank you, doctors. May we have Dr. V. Rajendran, the chairman of the organizing committee, immediate past president of the state RSSDI, to offer the welcome address.
Good evening, dear brothers and sisters. I am delighted to be present here to extend a formal welcome to each and every one of you for the 16th annual conference of Tamil Nadu chapter of RSSDI. At the outset, let me welcome the president of this inaugural function of TRAC 2025, Professor Dr. Vijay Viswanathan, President, National RSSDA. On behalf of everyone present here, we extend you, sir, a hearty welcome. I also would like to welcome the living legend amongst us, a man standing tall among the physicians of this nation. I know with this description everyone will be able to guess it. A person with several multicolored feathers on his cap, none other than our beloved Dr. A. Muruganathan as the chief guest of TRAC 2025. I welcome you, sir. I also welcome the office bearers of TN chapter of RSSDI. Dr. G. Vijay Kumar, Chairman, Dr. N. Bavadarani, Secretary, Dr. A. Shanmugam, Treasurer, Dr. M. Shanmugavelu, All India EC member RSSDA and the Chairman of the Scientific Committee of TRAC 2025 needs a special mention here. He has worked tirelessly for this. I welcome you, sir. I extend my heartfelt welcome to all the EC members. Now, the team which has stood shoulder to shoulder in the run-up to TRAC 2025 with me, our Secretary Dr. R. Balamurugan, namely the pharma people, pharma friends here, his staff, and also our family members who were generous enough to allow us to invest a lot of time and lot of late nights for organizing this conference. I extend a hearty welcome to you all. My heart goes out in gratitude to our senior professors here, faculty members, who have all been the continued inspiration for the growth of RSSDI. I welcome all of you gentlemen. I also welcome Dr. Shrikant, the master of this ceremony. Last but not the least, let me extend a hearty welcome to all our dear delegates, for you are the soul of this conference, TRAC 2025. Welcome you all from the bottom of my heart. Thank you.
Thank you, Dr. Rajendran, for that wonderful note of welcome. We now have to honor the dignitaries on the dais, and to do the same, may I request the chairman of the organizing committee, Dr. V. Rajendran, to kindly adorn a shawl on the president of the evening, Dr. Vijay Viswanathan. Thank you, Doctor. May I request the secretary of the organizing team, Dr. Balamurugan, to adorn a shawl on the chief guest of the day, Dr. Muruganathan. Thank you. Now it's over to the presidential address of this evening. To do the same, may I request Dr. Vijay Viswanathan to kindly come over.
Dr. Rajendran, the organizing secretary, and Dr. Balamurugan, the organizing chairman. I think it's the other way. The organizing chairman and secretary. It's not a presidential address for 10 minutes. It's only for 30 seconds. I would like to, first of all, tell you that RSSD is a great organization with 12,000 members across the country. It's a great organization, and we have 23 chapters, state chapters. And I am the president. I'm very happy to be the president, current president of this great organization. I would like to thank Dr. Rajendran, the organizing chairman, and organizing secretary, Dr. Balamurugan, for this great conference and for making Tamil Nadu proud. And Tamil Nadu is one of the best RSSDA branches, state chapters. I would like to end with a small thing about foot care, which is close to my heart. The Save the Feet and Keep Walking campaign is finished 800 people who have registered in a registry, and I'll be presenting it in the Kochi conference. I invite all of you to the Kochi conference, which is going to happen between 6th and 9th of November. I would like to thank all of you for taking up this mantle, Dr. Vijay Kumar, G. Vijay Kumar, Dr. Bavadarni for winning the election, and for the Pannisalvam sir for the chairman-elect post. Thank you for your attention.
Thank you, Dr. Vijay Viswanathan. May I now request the chairman of the Tamil Nadu chapter of RSSDI, Dr. Vijay Kumar, in your capacity as the chairman once again, to say a few words here on the inaugural session. Chairman's note.
Good evening. I will not come back again. I have nothing to say but to say that again repeatedly that the wonderful team of Tamil Nadu RSSDA, not only the members but everybody around who have supported. And then at this moment I would like to also congratulate and appreciate the efforts that have been taken by our chairman of the organizing committee, Dr. Rajendran, and also the secretary, organizing secretary, Dr. Balamurugan, to organize a wonderful meeting. No, I know it's not that easy to do a program, and how much of efforts, how much of thinking, how many sleepless nights that you have gone through, and then mainly from financial aspects to expenditure, and then looking into logistics, and it's not a simple thing to do. And then I think your team, both of you, were able to do extremely well, and I would like to appreciate about that. And then Tamil Nadu RSSDA is going to be with all of you, and even the national committee, I'm telling that we are going to be with you. Definitely whatever we could do from our side, accordingly we will do it. And also we request you also to do something for whatever we want actually. I hope it's a win-win situation actually. I mean, yeah. So I think Professor Dr. Muruganathan, who is going to be an excellent orator, and we are waiting to hear to him. And then I would like to thank also Dr. Shanmugam, Dr. Bavadarni, Dr. Shanmugil sir, and also President, National President Dr. Vijay Viswanathan, for taking part of this meeting and also helping us to do so many things during this conference. Thank you.
Thank you, Dr. GVK, as you are affectionately called, for that wonderful talk of 2 minutes. May I now request Dr. Bavadarni for the Secretary's note.
Respected Professor Dr. Vijay Viswanathan, the National President, the Chief Guest of Honor, and Dr. Muruganathan, the living legend, who is our Chief Guest today, and all the dignitaries on the dais and off the dais. And we took over in April 2025, and we thank the past members, that is the Chair, Secretary, and Treasurer, for giving us the legacy, and let us follow the same, and we'll move RSSDA to great heights. And last year we had the wonderful research retreat to be conducted at Madurai, and it was a benchmark in the history. And we appreciate Dr. Shanmugavelu, Dr. Muralidharan and Balaji for having done that in a wonderful manner. And of course we also had the BP campaign, in which Tamil Nadu was standing almost coming first, and at the last moment it came third. Thank you all. And now we are continuing with the Save the Feet 2.0 campaign. Of course we have finished the first, now it is going. We request all the members who are interested in diabetes to join this campaign and give your food cases, enroll your food cases. Then of course we conducted in the last year many regional updates at Krishnagiri, Tanjore, Nagarkoil and Chengalpat. And of course we are planning so many in the coming years. We have appointed almost 10 coordinators and many more who are interested to join with us to have updates in each district and spread diabetes education. And we also have the village outreach program and also the patient outreach program, and all others our chairman has very well discussed in his chairman's address. And we need all your continued support to conduct all this and take away diabetes from its roots by 2047. Make India a diabetes free and diabetes care capital by 2047. And those who have not become RSSDA members, I request everybody to become RSSDA member and achieve more many things in diabetes. Thank you.
Thank you, Dr. Bhavatarini. May we request Dr. R. Balamurugan, the organizing secretary, for 2 minutes, please.
Good evening all. The most respected our chief guest of the evening, Dr. Muruganathan, and our national president, Dr. Vijay Vishwanathan, and the office bearers of the Tamil Nadu chapter of the Research Society for Study of Diabetes in India, and my organizing chair and treasurer, and all, I can see all my senior professors are here, Dr. Rajendran and Dr. Narasimhan, and all our, we have national executive members here. Welcome you all. And just a few words about these, how the conference has evolved, how I came into RSSDI. And in fact, I've been a member of this Research Society for Study of Diabetes in India almost for 20 years. But in the Chennai meeting, national conference, Dr. Vijay Kumar and Dr. Periyandavar, they put me in the local organizing committee, and I came and stayed in Chennai for 3 days for the conference. That only I got interested to come into RSSD. I worked as an organizing committee member, and so the last 3-4 years, I was very much interested, and I contested in the last election, and I became a governing council. I thank all the members of our Tamil Nadu RSSDA for imposing the faith on me to select as a governing council member of Tamil Nadu RSSDA. That's how I got involved with these activities, and when the opportunity was given, when they been asked to take, when my chairman, Dr. Rajendran, asked, can we do the program in Coimbatore this year, I immediately said yes, and that's how things started moving. And I would like to thank here firstly, as he said, Rajendran said, my family members, because last 1 month, almost every other day I was going, we had a meeting from almost 7 to 11, and I went home by only 11:30, almost 15 days in the last month. And every meeting we used to address. So I thank my family first of all to allowing me this time. And many a time in the home also, I keep on talking to various people. Rather than speaking to them, I speak to all our EC members, all our organizers, everyone, and all our faculty. So that is very, very important. Second, I thank all of the faculties, national faculties, as well as our senior professors here for having accepted our invitation to come here. Third one, very, very important thing I would like to mention here is the scientific agenda, which was very much appreciated, and I would like to congratulate and thank the chair of the scientific committee, Dr. Shanmuga Velu, very ably supported my younger brother, Dr. Krishna Sheshadri. Krishna, please stand up. Krishna nicely crafted that scientific agenda, and Dr. Shanmuga Velu and me have we have tried to modify the agenda, and we brought it. And overall, it was very much appreciated by everyone. And also we have Dr. Dharmarajan, who is also part of the scientific committee and all. I don't want to name everyone. And Professor Dharmarajan, Director, Department of Diabetology. So he helped us. And we had our, this first time in the TRAC, I formed the district coordinators for this conference itself, not for the Tamil Nadu RSSDI. This TRAC conference, I just try to, because I want all the delegates to come from all the districts. So I first introduced the concept of district coordinators for this conference, and all our EC members have given a concurrence, and my chairman is ably supported. And again, the local organizing committee is very strong, because you might think that how the conference is getting on well, and it's not me or Rajendran alone. The local organizing committee, all our doctors, we have the joint organizing secretary, Dr. Venko Jayaprasad, Dr. Palani Kumaran, and we have Dr. Chandrasekhar, and we have Dr. Ravindranath, joint organizing chairman, and I'm not able to name everyone, but all the people, all our friends, all our younger colleagues have shared all my responsibilities. Dr. Venkatesh, Dr. Ramesh, Dr. Yamuna, Dr. Usha, everyone, Dr. Pushpa, Amala, everyone shared the responsibilities. And the two halls were managed effectively by all our younger colleagues. So I'd like to thank all our younger colleagues for helping us. Thank all the delegates, because whatever we do, only if the delegates come and enjoy it, it becomes a big feast. Otherwise, no. You make whatever feast, there are no guests, there's no use. So the scientific feast nicely created by the scientific committee and attended by everyone. And thank you very much. And again, the pharma people have really made a real support getting the doctors and registering the doctors, because we will not be able to reach everyone. So I thank the pharma and our hospital organizing committee. They really supported me very much. And mainly, we have mainly the clinical research coordinator, we have Mani Meghalai and team, Ranjit, Jagan, and all the team, Sri Vashini, Pavitra, and all the team of my, and Dr. Rajendran's office team, because very important, because these people worked last 1 month fully, and we just come and get the appreciation in the stage. So I just would like to thank every one of you who has helped me to organize this conference to whatever best manner, because I cannot give an opinion on our work. We try to do our best. Thank you very much. We'd like tomorrow also, I'd like everyone to come, and after this there's a dinner for all the delegates. Kindly join for the dinner with music also. Thank you.
Thank you, Dr. Balmurugan. Ladies and gentlemen, now to the much awaited lecture address by the chief guest, Dr. A. Muruganathan. May I request you, sir?
Most lovable president of this function, my brother, Dr. Vijay Viswanathan, chairman of Tamil Nadu State RSD, Vijay Kumar, secretary, Baudarni, organizing chairman, Rajendran, organizing secretary and scientific chairman, Dr. Balamurugan, Shanmugam, and my dear brothers and sisters. I request all my sisters to stand up, please. Today is a Raksha Bandhan day, please. So, virtually, please stand up. Virtually, I would like to tie Raksha Bandhan, though I don't have so many Raksha Bandhan. I had 2, 3 today, some sisters. Thank you very much. So really I meant sisters. Now luckily my wife is not there, that's why I said all ladies sisters. And the organizing committee, Dr. Balamurugan and family, Rajendran and family, all these organizing committee of Coimbatore, they are capable of conducting a national conference. I repeat, Why I said because all the future leaders are sitting, and it's high time in Cochin, maybe Balamurugan and Rajendran will bid for RSDA National Conference to be held in Coimbatore. I think so. Definitely the leaders here will have a say, and you could have seen the capacity, capability and ability of all the organizing committee. So please consider Coimbatore as one of the good venue, because when I was the president of All India API, we did the Epicon here, and I think Coimbatore has got full resources, though academically, financially, everywhere. And of course my congratulations, compliments, appreciation, applause to all the scientific committee. Excellent topics they have given, and one of the topics Balamurugan gave me is, to talk about the lessons learned in my practice. Thanks to Krishna Sheshadri, because these things only he'll only think and then do. Friends, we have gathered in this revered medical conference. It has got profound impact of human chemistry. You are the champions. You are the warriors. You are the chief superheroes. You are the ambassador of compassion. And you are the ambassadors of hope. You are the beacons of hope. Your work is a testament for the human spirit. Your work is a testament for resilience. Your work is a testament for the human kindness. We always educate, innovate, collaborate, advocate. We also screen, detect and cure with care. Why educate? Because knowledge is the best drug for diabetes. Why advocate? None of us should battle alone. Why innovate? We need more advanced research. Friends, here the science meets hope. The science meets service. Science meets determination. Science meets good willpower. Science meets devotion. And science meets action. So this is a conglomeration of science and all these things. That's how the scientific committee and the organizing committee has done excellent work. Every diagnosis is a puzzle. Every treatment is a beacon of hope. Every interaction is the breast of the human canvas, humanity. Friends, when we say collaborate, we must also harness the technology, also various innovations, and we must discuss about this in the conference. And we always, come here and then do a lot of other activities. I'm very happy to see, normally in an inauguration, the hall will not be full. The hall is full. I think we must give a round of applause for all of you. Because the people from other places must also see, you must stand up and see, the hall is full. See, Anuj Maheshwari in the morning, who is going to be the president-elect of the RSDA, told me, whenever I come to Coimbatore or anywhere in Tamil Nadu, the crowd inside the hall, they maintain decorum and dignity. They don't make noise. Whether they listen or not listening, they will always be silent. The atmosphere is very good. So I'm not exaggerating, that's what he said. So we are very proud that we are a good audience and good delegates. I think that's also very important to see. Jokes apart, whenever we come, we make a lot of plans. I always say coming together is beginning. Beginning together is progress. Progressing together is work. Working together is a challenge. Challenging together is achievement. Achieving together is success. So I agree, I hope you agree, this is a successful conference in all the aspects. I am a speaker who learns to speak since my childhood. So whenever I give a pass, you must clap. That's why I give a pass. Friends, see, in a diabetic conference, we must think something new, something innovative. I was just talking to Vijay. In Tamil Nadu, we got lot of diabetologists. Diabetic clinics are there. But Krishnan Seshadri also will agree, we don't have a obesity care center, OCC. OCC. I think some people, some youngsters think about obesity care center because now people say a lot of definitions have changed for obesity. Obesity is no more a lifestyle disorder, it's a chronic disorder. So unfortunately, in Tamil Nadu, at least as far as I know, there is no obesity care center who specialize in obesity. So this is what I thought, I'll put a seed in your minds. Not Krishnan Sethi will not do it because he's a senior man, but he can guide somebody in Salem to start a obesity care center. Our Aarti is there in Thoothukudi. Maybe they can start a obesity care center because lot of problems are there in obesity. Believe me, this MONO, metabolically obese, non-obese, in India, in India is 43%. It is as equal as rural and urban. So there is no difference. Especially between 18 to 43, if you see 33% of the people with MONO. After all, this is a related disease. So diabetes and the MONO is related. So I think and I request youngsters to come forward. Maybe we can give you guidelines. The Professor Rajendran, Dharmaraj, Chandrasekhar, so many people are there. So we can always guide you. Narsigan is also there. So youngsters must start this as an obese specialist. I always fond of talking about hypertension clinic. For the last 10 years I have been shouting and making noise, but some impact is there. Same way, think about obesity care center, OCC, and where you can have a role of dietitian. Krishnan Seshadri gave beautiful anecdotes and poems and reference quotations from Tirukkural. Tirukkural also there is a good advice on diet and medicine. So we always say in Tamil, Udal Paruman Uyirukku Yaman. So I think about this, and then this one thought I thought I will leave it to you so that you can discuss among your colleagues and friends and see whether you can start a obesity care center, OCC, because a lot of newer drugs are coming in the pipeline. No, everybody talks about semaglutide, some Manjaro, so many things are coming. So I think how you should use it, how you can utilize this. And I told you there are now definitions: subclinical obesity and clinical obesity, according to Western. And now we are saying, I had recently delivered a talk on metabolically obese, non-obese, MONO. That is the biggest villain, not the regular obesity, this MONO. So I think somebody should take this specialty. This is the message I thought I will give during the inauguration. And also, we will give a protocol, what all should be done to start this obesity clinic. So let me conclude, because Balamurugan told me speak only 10 minutes, I think 10 minutes over. There is no bell for a chief guest, but still, I know, I wanted to, normally I give a message and then conclude. So this is the message. A bell is not a bell until you ring it. A song is not a song until you sing it. A tree is not a tree unless it yields. Love is not love until you give it away. A healthcare professional, a diabetologist, is not a diabetologist unless serve and care, search and share. Godspeed, good luck, thank you.
Thank you, Dr. Muruganathan, for that wonderful message, which you have stuck home very strongly. To give a formal word of thanks, may I request Dr. A. Shanmugam, the Treasurer of Tamil Nadu Chapter of RSSDI.
Good evening, one and all. I will not take more than a minute. I must thank Vijay Vishwanathan sir, the President RSSDI, and our Chief Guest Muruganathan sir for giving the excellent oration chief guest address today. And I must thank organizing chairman Dr. Rajendran and organizing secretary Dr. Balamurugan for making this conference a successful one. I must thank our scientific committee chairman and Dr. Shanmugam sir and the entire team, particularly Krishna Sheshasri sir and Dharmarajan sir, for making this scientific program as a beautiful and most scientific one. And I must thank our RSSDA chairman Dr. Vijay Kumar sir and Secretary Bhavadharani madam and entire EC members, but not only state EC members, national EC members. Many of national EC members are here. I thank each and everyone for making this time and effort to attend. I must thank our Tamil Nadu RSSDA past presidents and past secretaries are here. Our patrons are here, Tamil Nadu RSSDA patrons are here, and my teachers, everyone here. There's so many senior faculties are here. I thank each and everyone for making your time and effort to attend this. I must thank all the faculties for the wonderful deliberation, particularly throughout the day, and going to talk tomorrow also. I must thank the delegates. Without delegates, any conference will not have much success. So our chief guest also mentioned that until the inauguration that happened in after 8 o'clock, around 8 o'clock, the hall is almost full. Thank you all the delegates. I must thank the pharma for their enormous support for making this conference wonderful one, and the organizing team and the local organizing team, and particularly the staff and the family members of our Dr. Balamurugan sir and Dr. Rajendran sir, particularly the COVID Diabetes Specialty Center and the hotel team for wonderful venue, and the audiovisual support team and the media press, and all the support from all the members here on RSSD members and everyone. As our secretary also addressed that, I welcome everyone to make member of RSSD. I thank each and everyone. Thank you one and all. Thank you.
Thank you, Dr. Shanmugam. May I request Dr. Balamurugan and Dr. Bhavadharani to join us for singing the national anthem, where we all will rise and sing in unison.
Janagana Manahadinayaka Jaya He Bharata Bhagya Vidata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchala Jaladi Taranga Tava Shubha Name Jahe Tava Shubha Ashisha Mahe Gaye Tava Shaya Gata Janagana Mangala Dayaka Jaya He Bharata Bhagya Vidata Jaya He Jaya He Jaya He Jaya 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 He Jai Hind.
Thank you.
We request all of you to join for the German's dinner, and we are having the general body meeting in the next hall. Please do join for the general body meeting, and the chairman is requesting you all to join for the German's dinner.
Wait. The general body meeting is in the hall B only for the Tamil Nadu RSSDA chapter members. All other can join for the dinner and music, which is in the first floor pool site. Okay. Second floor, sir. Second floor, the pool site dinner. All of you join. Only the RSSDA members can join for the general body meeting, which is in the next hall, hall B. Looking forward to see you all early morning. The morning tomorrow at 8 a.m. The session started at 8 a.m. sharp with workshop. Today, we had a little thin crowd. So I would like to remind all the delegates to come at sharp 8 a.m., 7:45, so that we can start at 8. Thank you.